That it's there live on
Okay,
YouTube.
thank you. Thank you.
Yeah.
It's live now, ma'am.
Perfect. Yeah. So all set to go, doctor?
Yeah. Shall
Okay.
I say share
No,
my
no, no,
screen?
no, no, no. Wait. We will start with the whole address, then I'll give you the speak. We still have 5 minutes to go ahead. Team, should I go ahead with the start? Should we start, team? Start with the. Okay. Good morning, everybody, delegates, patrons, architects of orofacial pain medicine, and each and every participant who has been glued to us for the past 2 days. This is our third day of International Orofacial Pain Congress, Season 3, and I'm glad that this season has come together with clinicians who have not only created a foundation and created a skyscraper yesterday, but today we are going to touch new heights in orofacial pain management from a molecular mechanism of synapse to the 3D mechanism of architecture of airway to knowing what, when, why to do, and why are we doing this? Why are we facing these complex clinical conditions in our practice? This season has been phenomenal, and today is our grand finale. As you all can see, I am dressed in red. Red symbolizes many colors. This year, we have seen red symbolizing a very heartfelt gratitude towards our country. Red symbolizes pain, red symbolizes fear, and most importantly, red is also a color of strength. I believe pain is a guarding mechanism, and red color symbolizes that. And on a lighter note, it's Christmas week. It's my 21st wedding anniversary coming up on 25th of December. So I've started celebrating early, and now my husband gets the hint from here that he's supposed to start showering with gifts to me.
Congratulations.
So, welcome to International Orofacial Pain Congress Season 3, Day 3 Finale. As we begin our final session, let's carry forward the spirit of interdisciplinary respect that has defined this Congress. The tooth, the joint, the nerve, and mind speak the same language. Let's not forget that everything is connected to the body and systemic factors play an important role. Dentists are just not tooth doctors. We are physicians of the stomatogasthic system. So let's keep that in mind next time a patient walks into your practice. My Sundays are generally a cooking day or relaxing day when my husband cooks and I relax. So today also the scenario was the same. I'll be intruding into your Sunday life. I am sure whoever has joined in today has a keen interest in learning. That is the reason they are sacrificing their Sundays and they are here. So thank you so much, participants, for being a part on a Sunday morning and joining us and listening and learning something new. To our speakers, in fact, thank you would be a small little word, I would say, because they have been phenomenal. They have contributed so much. They have gone beyond their boundaries. It is not a monetary gain they are looking at. They are here to share knowledge. Though it is said that orofacial pain practice as such, the term as such is not yet a specialty in India. I've been hearing this very often. But let me tell you one thing. Aren't we practicing orofacial pain management since the day when we started our dental practice? What comes under
Yes.
orofacial pain practice? It's the structure innervated by the trigeminal system. Can we
Yeah.
separate the trigeminal system and can we work without considering orofacial pain practice? If you all can say that you have never practiced orofacial pain practice, then you have not practiced dentistry. The day one you thought about practicing dentistry, that is the day one you started doing orofacial pain practice, because the classification of orofacial pain also considers the odontogenic part of it. Temporomandibular joint disorders, neuropathic pain conditions, and other conditions, and access to conditions come as an adjunct to all these things. And we as dentists, we cannot keep a closed eye and have a tunneled vision towards our practice. We are not doing our diligence if we don't do this study. My urge and my request to each and every dentist out there: you have done phenomenal job as a dentist. Now time has come to check get back to your cases and see, do they really needed a root canal treatment, or was that really needing an extraction? Was I diligent in doing my practice? Because that is what has happened to us. When we started learning this, all of us, we have gone back and checked our cases because they never had an odontogenic cause. Understanding what not to do, that was the theme of this congress, and that's still it at heart. So welcome to this wonderful Pandora's box. Once you start opening this box, I am sure you will never stop. It gets more and more confusing. Here, I would say in India, the so called orofacial pain board specialized dentist, or board specialized, or maybe calling themselves as orofacial pain specialist, are maybe 300 to 400 of them here. We are confused. We are here to confuse you all more. So welcome to this whole Pandora's box of orofacial pain and this complex phenomenon, which is a need of an hour, and every dentist should take participation in understanding these painful conditions. Otherwise, we are not doing our diligence towards our patients. And on a lighter note, today being Sunday, I'm going to be intruding in my speaker's life also, asking them what is their lunch, breakfast, dinner plans, and party plans later on. Because I have a gala party week ahead coming, and I'm already geared for it. So let's begin our finale with our first speaker, Dr. Jyotsna Jain. She is she always calls herself a clinician. So yes, we are clinician first, academician later, or whatever it is. At the end of the day, she is a person who I found very, very impressive. The moment I met her, I was like, no, I need to know more about her, because the way she carried herself, it's the aura that she carries, that she is a healer. So that's what is Dr. Jyotsna to
Yeah.
me. She is also a founder and a founding member of Indian Orofacial Pain Association, and thanks to them, the this whole orofacial pain community is taking shape in India, and very soon we will be a specialty. On that note, let's welcome our first speaker for the day. Welcome, Dr. Jyotsna, ma'am, and
Thank you.
this is your first presentation with us in orofacial Indian Orofacial Pain International Orofacial Pain Congress 2025. Pardon me for that. And I would like to extend our congratulations to you to becoming a part of our team. Ma'am, I would like to ask you one question that I'm asking each and every speaker. What is it, that one thing in your practice, one habit or one mistake, I would say, that changed you to becoming a, or inspired you to become a orofacial pain specialist or a pain specialist?
Yeah, very good question. So I did not make any mistake, but I was always intrigued by reading it in the book that a dentist can treat and actually tell anybody what is going on in the body. The dentists are the first ones to recognize and diagnose any kind of disease in the body. That intrigued me to get into orofacial pain.
Ma'am, welcome to International Orofacial Pain Congress. You may
Thank
start
you.
sharing your screen, ma'am. Today,
Yeah.
Dr. Jyotsna is going to be enlightening us about the whole architecture of orofacial pain in as an overview.
So can you see my
Yes, ma'am. Please go on the presenter's mode.
uh, yeah, sure. Yeah, correct.
Yes, ma'am. Please
Better?
go ahead.
Great. So my icon is coming here. So, hello everyone. Good morning. I'm Dr. Jyotsna Jain, a BDS from Sharad Pawar Dental College. This is my beautiful college. It is decorated every year on Ganpati like this. And I am a diplomat for American Board of Orofacial Pain. Today I will talk about orofacial pain and temporomandibular disorders as an overview. I will try to include the most of the knowledge I have gathered. I want to thank my gurus, Dr. Davis Thomas, who actually brought orofacial pain to India, Dr. Gary Hire, Dr. Shankar Iyer. Through Smile USA, we actually entered into this specialty, Dr. Jeffrey P. Okeson and Dr. Soumya Ananthan. I salute these noble gurus who have opened my eyes, blinded by the darkness of ignorance, with the colorium stick of knowledge. How can I reduce this thing which is coming? these Sonal, how can I reduce this thing on the side? This is taking a lot of space.
1
Okay,
second.
okay, cool. Now it's okay.
Yeah.
Right. So I will talk in brief about all the components. The skeletal components are the skull and the mandible. You know everything about this thing. So let's go further. But I only want to focus on the condyle. You have to see the condyle is oval. It is not round. So it has a very different way of moving. Uh, and then we have the coronoid process. Why I'm mentioning these points is important that you will understand later. So the ligaments of the temporomandibular joint. The first picture shows us the articular disc AD, which is marked as blue. Then comes the capsular ligament, which has two parts, the lateral discal ligament and the medial discal ligament. It is right mentioned here. And then comes the uh, capsular ligament, which is actually encapsulating the entire articular surface. Then the third ligament is uh, temporomandibular ligament, which has two parts again, the outer oblique portion and the inner horizontal portion. I am telling you all this, though you know about all this, but orofacial pain is revolving around all of these. And a ligament, once it is stretched, it cannot come back to its original position. The muscular components, muscles of mastication first, the elevators. So the elevators are the masseter muscle, which elevates the mandible and helps in protrusion. The medial pterygoid muscle elevates the mandible and helps in protrusion. Temporalis muscle elevates the mandible and contributes in retrusion. The lateral pterygoid muscle has two bellies, superior and inferior. That is, uh, the superior one takes care of the laterotrusive movements and inferior one again contributes in protrusion. So why did I tell you all this? This is important because if you know the right function, then you will know the right muscle which is involved in the dysfunction. The depressors are the anterior and posterior digastric muscles. They are the depressors of the mandible, and even the inferior lateral pterygoid is one of the depressors too. Now the superficial neck muscles. This is the platysma, the sternocleidomastoid, and the trapezius. Why I have marked them separately is that they actually encapsulate the whole neck and are responsible for the head, neck, and shoulder movements and the postural control. There are 30 more neck muscles which we actually need to know. So let's take a brief touch on these 30 muscles. So deep anterior neck muscles, you don't need to memorize these, but we just need to know what is their function. Their function is cervical flexion, fine head and neck movements, retraction, crucial for maintaining balance of the head and the cervical spine position. Now the deep posterior neck muscles. There are so many of them, which is mostly not known to everyone. These muscles, if they are in disbalance, they will cause headaches, myospasm, myositis, and the entrapment neuropathies. They are originally help us to provide postural support, enable head and neck movements like extension and rotation. This is my favorite slide, which Dr. T had taught us through and through. So what do we need to recognize? We need to recognize the non-odontogenic tooth pains, and we need to recognize the red flags, and we need to stop where we don't need to do root canals for all these teeth. We need to find the real etiology behind the pain. So what do we look? We look that if there is no obvious dental caries or periodontal disease, we need to stop and ponder further. So if there is a stabbing, shooting, burning, electric pain, then also we need to stop. It's a red flag for odontogenic treatments. If there are multiple teeth hurting, then we need to think more and more about the muscles. So if it is not odontogenic, then first we'll always consider it will be myogenic. And then if we have an equivocal or no response to local anesthetic, again we will look for some other entity. According to Dr. Weldon Well, pain is far more than a simple sensation. Pain is an experience. Dr. Jeffrey P. Okeson said, pain is an unpleasant sensory and emotional experience that motivates the individual far more than perhaps any other life experience. So all the pioneers of orofacial pain are talking about sensation, experience, unpleasant sensory feeling, and emotional experience. So let's understand the pain mechanism. So what actually happens when we are hurt? This picture is showing only hurt in the extremities, but when we are hurt, like in dental, as in caries, periodontitis, or any inflammation. So nociception starts right there, and this injury activates the nociceptors, and finally we have peripheral sensitization. This peripheral sensitization transmits the signals through the spinal cord to the brain, creating central sensitization. And through ascending modulation, all the information comes to the brain. And from there, the brain is now influenced by all these emotional and cognitive factors, resulting in the subjective experience and trying to initiate a warning system. Here, now this warning system now starts the descending modulation and serves as a protective function by altering the body to potential harm. And the cortical plasticity has happened. Now here, the information will start to store into the brain. The physical and emotional reaction will withdraw from the stimulus and protect the injured area. That is the beliefs and the previous experience. So what will happen? Our body will give a jerk and move away from the offending trauma. So now this information, how it is actually it again comes back from previous experiences. It is stored in as the neurotags. And now you understand that we can produce stress in present and future injuries. So this is the culprit, the stress. Sorry, guys. So the stress is most important to understand. We actually follow this classification given by Jeffrey P. Okeson. It is axis 1, physical conditions, and axis 2, physiological conditions or psychological conditions, pardon me. Now, if we do not take care of the axis 2 and we only want to follow the axis 1, we will never come to a correct diagnosis. So talking shortly about these axis 1 and axis 2 situations, these are somatic pains and deep pains. Somatic pains will be superficial, mucogingival and cutaneous pains. Deep pains will be musculoskeletal and visceral pains. Somatic pain. What is somatic pain? Somatic pain is, it originates from the skin, muscles, connective tissues, bones, or joints, and it may or may not have autonomic symptoms. It is well localized. The patient will be able to pinpoint his pain, and the quality is sharp, aching, throbbing, or cramping. And it is what is the cause of this somatic pain? It will be injury, inflammation, or pressure. What about the deep visceral pain? It originates from the internal organs and it has always an autonomic phenomena. Pain is felt in a location different from where the pain originates. That means the source and the site of pain will be different. It is a very difficult, these pains are very difficult to manage because the source is mostly ignored. Quality is dull, aching, gnawing, and cramping. The cause of these pains is dysfunction and disease. Neuropathic pains have a long list. We will talk only about the episodic and the continuous. What in a general way, what do they actually mean? The episodic neuropathic pains are they come in episodes. And they are characterized by abnormal nerve sensations like burning, tingling, or electric like pains. And the cause is primary dysfunction or lesion of the nervous system. The continuous neuropathic pain is continuous, but the characteristics are absolutely same to episodic burning, tingling, or electric sensations. The only thing is they are continuous nature. Background pain will always be present. Pain cause is the nerve damage or the disease. This is access to psychological conditions, mood disorders, anxiety disorders, somatoform disorders, and many more other conditions. But the correct diagnosis will be only reached by evaluating axis 1 and axis 2. We only, as dentists, cannot treat any patient of orofacial pain by ourselves. It has to be a multidisciplinary action. Sources of non-odontogenic toothache: neurovascular, neuropathic, myofascial, and through sinuses. Again, mentioning that interdisciplinary or multidisciplinary actions are required here. Now, talking about some cases so that you have a brief information about how to deal with such patients. This is a 21-year-old female presenting complaint is strong pain in the right mandibular area from last 6 months. Multiple visits to various dentists, which was absolutely not required. Pain is spontaneous, lasts for 20 to 60 minutes. 6 to 7 attacks typically in 24 hours. We reached all these things by taking a very elaborate history. 3 to 4 times a month, and it takes 1 to 3 days for the pain to go away. It is of a throbbing quality and wakes the patient up from sleep. Pain is evoked by cold and hot drinks. The pain has increased with time. Autonomic features are present like redness, tearing, and blurred vision of the right eye. On examination, we found that oral structures are WNL. Cold application evoked pain lasting for 20 to 30 seconds in most of the mandibular teeth. There was an overshoot of pain and the vestibular area. The TMJ was normal, the muscles were normal. So our differential diagnosis was reversible pulpitis, paroxysmal hemicrania, and NVOP. What is NVOP? That is neurovascular orofacial pain. So what is actually neurofacial orofacial pain? It is characterized by localized unilateral pain in the teeth, jaw, and the face. And it is usually of a pulsating quality. So, Sonal, can I just ask a question from everyone here?
Yes, ma'am. They'll reply in the chat box.
Yeah. So, what all you have faced, which actual pain has come to your mind here when I told you this, that it is of a pulsating quality and it is in the face, jaw, and the teeth? In daily life, what is the most common situation here as dentists? Can anyone reply? I can't see the chat box.
Ma'am, there is a response saying pulpitis.
Yes, exactly. Reversible pulpitis is the most common. And then irreversible pulpitis also has similar symptoms. So what do we do to manage this patient? We gave the NSAIDs, naproxen, for abortion of the pain, but it did not go away because there was high frequency of attacks and the residual background pain was present. So we gave a prophylactic of propranolol twice daily for 1 week, and we had a follow-up of the patient, and which had definitely improved the pain. But again, I want to ask one more question. In which cases propranolol is not given to the patients? Any answers in the chat box, Sonal?
I'll get back in case if there are answers.
So if there is none, no issues.
Glaucoma. Glaucoma is the answer that has come up.
So basically, to asthmatic patients,
Asthma.
asthmatic patients, we cannot prescribe propranolol. So no dental intervention is required in such cases. So we have to look beyond the teeth. Next case, there is a 43-year-old female patient complaining of mild to severe continuous dull aching pain diffusely located in the left maxillary and mandibular teeth, jaw and ear. So the teeth is okay, but when the patient says, I have pain in the jaw and the ear, please open up your horizon to think beyond teeth. There is nothing to be treated here. Odontogenically. The pain is minimal in the morning, increases with movement, that is chewing and grinding. Patient feels that the pain is increasing. It started 2 months ago when some dental procedures were done. So dental treatment, what did the patient went through was a endodontic procedure with second premolar, fixed partial denture with teeth number 35, 36 and 37. So the prosthesis was again occlusally adjusted because the pain was not going and the prosthesis was remade. So in the wake of this situation, now the original familiar pain had begun. So what actually happened? This was straining her muscles. Again and again, long dental treatments were actually creating this problem. The prognosis, pain has continued in spite of all these treatments, and the second molar endodontically was again treated and antibiotic prescription was given. So on examination, there was no evidence of pain, clinical and radiographic, in the teeth. Temporary crowns with mandibular second premolar and second molar were present. No pain on palpation. Electric pulse testing was negative for teeth which are not endodontically treated, left maxillary teeth. So local anesthetic blocking on the left side was negative. No result of the pain did not go away. TMJ was WNL, acute tenderness in left masseter muscle, and a slight decrease in mandibular range of motion. So by the pictures, can anyone say what am I getting through? Differential diagnosis: bruxism, myositis, sinusitis, myofascial pain, or myofascial pain with referral. What is exactly this thing? Can anyone write in the chat box, guys?
It's Sunday morning. They're seeing trigger points, and I can understand it's a Sunday
Exactly.
morning. But guys,
So
have
trigger
your
points
cup of
is
tea,
okay.
coffee and sit here.
Trigger points is okay for an answer, but it is
Myofascial pain with
myofascial pain
referral.
in the left masseter muscle with the referral producing muscular toothache. So management was trigger point injections in the masseter muscle and NSAIDs for the myalgia, and the pain definitely went away, 100%. So next case, it's a beautiful case to understand. So this is a 56-year-old male. Patient complained is left facial pain, excruciating and sharp. Now, when it comes to sharp, please again widen your horizons from odontogenic. Located intraorally over the eye, preauricular region, and the neck region. So since 8 months, all this was happening, and multiple visits to various dentists had happened. Before this pain starts, it is felt in the teeth on the left side. So what happens when these pains start on the teeth first? So the patient thinks that I need to go to a dentist, but the dentist need to be well vigilant and have complete knowledge of orofacial pain to start with the odontogenic procedures. So there is pain in the alveolar bone also around the teeth. So pain occurs number of times in the day. The pain lasts for about 15 to 20 minutes. So past treatments were endodontic interventions of maxillary second premolar and extraction of the mandibular first molar. Because patient was actually pointing out, I have pain here, I have pain there, sometimes in the maxilla, sometimes the mandible. So dentist who is not well versed with the orofacial system and the temporomandibular joint disorders, this dentist kept treating the teeth only. So the prognosis was the pain has increased with time. So this dentist had finally referred this patient to us, and when we did the complete history, we saw that there were autonomic features as well. There were bloodshot eyes, nasal congestion, conjunctival injection, and ptosis of the eye. So this picture is, please always remember this picture when these patients come. So differential diagnosis were all trigeminal autonomic cephalgias or a sinusitis condition. But our diagnosis was the chronic paroxysmal hemicrania. The management was absolute response was endomethacin was present and the patient was better. So no dental interventions were required in the first place. My last case for today is a 47-year-old male. The picture shows itself. What is the diagnosis? So presenting complaint is pressure felt below the right eye. Symptoms are positive since 15 days. Multiple teeth are aching on the right side. But you can see in the picture, the right side sinus, maxillary sinus shows a fluid. Even the frontal sinus shows the fluid. So on examination, pain increased by applying pressure over the sinus area and teeth were sensitive to percussion. But they were not painful, only very sensitive. The toothache is increased by lowering the head and walking down the stairs. This is a typical sign of uh, sinusitis. So local anesthetic was negative response. The differential diagnosis, periodontitis, apical granuloma, myofascial pain syndrome, or a mucus retention cyst. Our diagnosis was acute sinusitis of the right maxillary sinus, and the management was detected as bacterial sinusitis, treated by the ENT specialist. No dental intervention was required here as well. So guys, this is a very small presentation I tried to do because I had only 30 minutes. I did not explain much on the features of the cases, but I tried to show 4 different cases which will make you understand what is actually going on with our patients and where we need to reach. My take home message is always remember when managing pain, listen carefully, consider all possibilities, cure if you can, manage if you cannot cure. That means you send them to a proper specialist, and but always console your patients. Since 2 days we are talking about empathy and towards patients. So in Jeffrey P. Okeeson's words, here I conclude my lecture. Thank you so much for
Thank you,
patient
ma'am.
listening.
Thank you so much, ma'am. And it was really an very good start to day three because you have opened their eyes, and I'm sure the rational wheels have already started churning because they'll go back to their cases and look into it. I always say that, ma'am, you can stop sharing your screen so that we can have a
Yeah,
full
please.
picture with you also. Hi, Dr. Akshay. Uh, just a second.
Hello.
Hello. Yeah. Just a second, Dr. Akshay. I'll just
Yes.
finish with Dr. Josna first. Dr. Josna, can you just say hello to us? I'll just take a picture with you.
Hi.
Yeah, 1 second. Smile for the camera. Yeah,
Thank
thank you,
you.
ma'am. Thank you so much, and a very good start to day three, I would say, because this is the need of our this eye-opening statements from you. Definitely will have a great impact on our participants here. I always say the most dangerous tool in orofacial pain is the drill in the hand of a dentist who doesn't know what they are doing. So the next time you pick up a drill, have a differential diagnosis always with you that this may be a non-odontogenic case. So on that note, I would like to welcome our
Thanks.
next speaker for the day. Thank you, ma'am, for being a part of International Orofacial Pain Congress Season 3.
Thank you.
And looking forward to many more sessions with you in next season also.
Of course.
Yeah. So our next speaker, Dr. Akshay. Dr. Akshay, say hello to us.
Hello. Good morning, everybody.
Good
And
morning.
happy Sunday
Yeah.
to all of you.
Yeah. Dr. Akshay, just smile for the camera. Yeah, thank you so much. Dr. Akshay is a well-known name in orthodontics. He is the pioneer, I would say, who is training dentists to become orthodontist. He urges everybody. Whenever I speak to Akshay, he's like, orthodontist ban jaya, sab kuch theek ho jayega. So that is what is his statement. So Dr. Akshay is an orthodontist, as I said, and he is exclusively practicing in Juhu, Mumbai. He's consulting visiting orthodontist from Oman, editor of Gonian, course director at Ortho Train, a multimodal course in clinical orthodontics from for general practitioners, and recipient of Bite-In Award in 2015. He doesn't need an award to know become famous. He himself is a machine, I would say, for generating orthodontist in India. Awarded best orthodontist in India by Indian Health Award 2016. Currently pursuing fellowship. No, you are already a fellow, I think. So this is your old CV. You've sent it to us. Anyways, so he is a fellow, and we completed our fellowship together. Akshay, I call him Akshay for everybody. Is Dr. Akshay. Sorry for that, but Dr. Akshay is the one person who motivated me and always guides me that you do it, we are there to support you. So anything, if there is something in my life, if I have to go back to some person and ask if I can do it or no, it's Akshay, because Akshay will always be the one who guides me. And always the first thing he says is, bindas kar, I'm there. So it's this kind of confidence, this kind of friend, a backbencher friend, I would say, is always needed. We were backbenchers in our fellowship batch also. We were the ones, the masti wala batch. So I always have, when I'm sitting here also, I still have a chair behind me that is empty. I always keep a chair empty because those are all my back supporters who are supporting me, and Akshay is one of them. Akshay, virtually, you're always there
Thank you.
behind me.
Thank you so much,
Thank you
Sonal.
so much for being there. And on that note, I'm asking a personal question. I'm intruding in all my speakers' life, and I'm asking them a personal question. That is, what is that one mistake or one thing that changed or motivated you to become a pain specialist?
uh, a pain specialist, actually, pain is not created universally. The pain has various components, and so we have to be aware of it. And there's not any single incidence as such, but alleviation of pain is the major factor.
Yes, that's very well put, Dr. Akshay. So, welcome to International Orofacial Pain Congress. Last year also you were a part of this congress, but I think because of some family emergency you could not join us. So
Yes,
this year you have double the duty for the previous year and this
definitely.
year also. So
Yes,
you may start by sharing your screen. Welcome to International Orofacial Pain Congress Season 3, Dr. Akshay.
yes. More. Sonal, where is the option? Sign in, view.
There's a green button down, share screen.
Yes, yes.
It's a regular Zoom only. So just
Yes,
start sharing with this thing.
yes. Is the screen visible now?
No, it's not visible yet.
This is a tremendous work you're carrying on, Sonal.
Thank you. Thank you
And,
so much.
yes.
As I say, I am not alone here. I have supporters like you all.
Uh, 1 second.
Dr. Akshay's second generation is also in dentistry now. So very soon we will have him also on panel.
Yes, yes.
Are you stuck somewhere? You want to reshare because your
Uh,
screen is not shared.
yeah, I know that. I'm also in the system itself, trying to unlock this. It's like,
Yeah, we'll give you 2 minutes for that.
yes.
So with our first speaker, Dr. Jyotsna, one thing is clear that, a negative MRI or negative finding on any of your reports or in your clinical condition does not mean that the patient is not suffering. So once a patient says they are in pain, believe them that they're in pain, and you should always treat the pain first.
Yeah, the patient is always right about pain.
Yes. Yes, throughout the day, I know it is going to be a long day. I guess it is going to be 8 or 10 hours of lecturing today. And throughout the day, whenever you guys are stressed or you feel that, this is going over the top, just do one de-stressing technique. Yesterday, I was talking about the same. So suppose you are stressed or your patient is stressed in the clinical chair, or you feel you or yourself are stressed. Just raise your hand up with the index finger. Try tracing the fingers. As you go up, inhale. As you go down, exhale. As you go up, inhale. And as you go down, exhale. So you can do it very slowly. And by the time you reach your little finger, I'm sure the stress will be gone, and you'll be in a better position to diagnose such cases, or your patients will be in better position to take the treatment also. Most of the times patients are scared of injections. They are scared of what will happen or why this pain is not going. So this kind of de-stressing techniques help a lot. So if you all feel that you are stressed throughout the day or any time in the conference also, just do this technique. And I'm going to be talking about one more technique, that is EFT tapping technique. That is also a very wonderful de-stressing mechanism, or maybe it's just a small little tips to so that you all can use it in your daily routine. That can help you a lot. Dr. Akshay, I think he's rejoining us. He's our second speaker for the day. And let me tell you all some things about MedSkill and National Health Academy. National Health Academy and MedSkill are organizations which they hold medical conferences, but for some reason they are very intrigued by the fact that dentist and medicine, the bridge is getting. We are trying to bridge this gap between dentist and medicine, and that's when this concept of International Orofacial Pain Congress started. I think 4 years back it was NOPCON, that was National Orofacial Pain Congress. Then we started with International Orofacial Pain Congress, and this is a third season. Over the past years we have had multiple speakers, most of them Indians and international speakers also, who have been an active participant, and they have shared certain insights into this whole complex orofacial pain specialty. My concern over here was always that when I started this practice, there was no standardization of care. Everybody were doing whatever they could do their best. See, I'll tell you one thing. I believe and I trust that each and every dentist at heart wants to relieve the patient of their pain, but ignorance cannot be taken as an excuse for not doing your diligence towards patient. And here the ignorance played the most important part, as we all were ignorant about certain painful conditions that manifested in patients. And we are trained to drill our tooth, we are trained to extract the teeth, we are trained to do certain procedures, and we are tunnel visions. We were tunnel, at least I was tunnel vision. I never wanted to check it that the other way around. Maybe there is some non-odontogenic cause to it. This whole practice changed. My whole setup has changed now. I'm answering I'm questioning myself. I'm checking for the reason for the pain, why, how, when it started. Things change the moment you start and having open mindset towards your practice. People are requesting for YouTube link. I am sure I have shared in the beginning itself. Can somebody from the first chat message share it? I think we are seeing Dr. Akshay, your screen is visible. Pardon us for this small little glitch, technical glitch, I would say, because This happens to the best of us. Can somebody help me out by sharing the YouTube? Yeah, thank you so much, doctor, for sharing this YouTube link.
Yes,
Actually,
and we'll have
generally,
to share Dr. Vyom also.
yes.
Thank
Hi,
Dr.
Dr.
Vyom
Virom.
also.
Hello. Yeah, the second generation of Rathis are here.
Yes.
Dr. Vyom, your party is still pending. Huh? I still need to take the party from your father. Okay.
Most welcome always.
Yeah.
Yeah.
Am I audible? Am I
Yes,
visible?
yes. Please go
Yeah.
ahead, doctor.
Yes. So, as we move ahead, one thing we realize that as the technology is becoming advanced, you need to keep yourself updated with what is happening in the scene around you. Today, I'll be speaking to you about orthodontics and TMJ. Till now, what we were saying is what is orthodontics, and when you were in BDS, and most of us would be scared of this to make the wire roll and make the use V's, circles, triangles in our uh, pre-clinics. Then there was the growth and development thing, which took up a lot of our time. Orthodontics essentially involves tooth movement. And we are going to look at a perspective of TMD beyond aesthetics. The life and work of an orthodontist was
Dr.
typically,
Akshay, can you go to the presenters mode? It is on the PPT mode still.
okay, one second. Uh,
Click it the view.
Click in the, hello,
View.
okay, yes, view, and speaker, gallery, multi-speaker.
No, team, can you somebody help him with that? We don't want to change his view. We want to make it a presenter's view, doctor.
Okay,
So click it the view. Actually,
okay,
zoom
speaker,
by zoom button. View mode.
view mode, okay.
There's somebody saying press play. Is there a play button, Dr. Akshay? Just check. Play करके देख. हाँ बस.
Yes,
ठीक है.
yeah. Are we good?
Yes, please go ahead.
Yeah. So previously, the life and work of an orthodontist was simple, but now it is beyond aesthetics. It's with function, and it's with the form, how it affects the function. So design is not just what it looks like and feels like. Design is how it works also. What I would love to teach, but the topic of TMD in reality is much more complicated. What causes temporomandibular joint disorders? So presently we are of the view that it is a biopsychosocial disorder. When we were in college, it was stress which used to give rise to TMD, and TMD is a lifestyle disorder, and it gives rise to the stress even to the lives of our dentists. So as we go ahead, we want to restore form and function, and now we are seeing beyond aesthetics to end orthodontic cases with proper anterior guidance, to restore canine guidance in a known case of TMD where night bruxism or sleep bruxism gives rise to the canine tips getting treated and the canine guidance now gets converted into a pathologic group function. We also want to see to it that we are having a proper plane of occlusion in interdisciplinary cases, and this gives us an interference-free occlusion while we are going to do the restoration or prosthetics of a case. So let's start this, and we start with how to end the cases with proper anterior guidance. The 6 keys to normal occlusion were given by Andrews, and the 7th key is to finish the orthodontic cases with proper incisal and canine guidance and no interference in protrusive and lateral excursive movements. So we want that our anteriors protect our posteriors in protrusion, and our canines cause disclusion on both the working side and the non-balancing or non-working or balancing side. A faulty occlusion is a TMD stressor, and it has a potential to either precipitate, to aggravate, or to perpetuate the temporomandibular joint disorder. And this is what we want: the good overjet overbite, but also good guidance anteriorly as well as in lateral excursive movements. So how do we go about doing that? Now, just before debonding, when we are doing ortho, it is necessary to evaluate that we have achieved the canine guidance, and to do this with the braces in the oral cavity. And even though the canine guidance is checked at the end, it starts from the bonding appointment itself, and we keep the vertical height of the canine bracket at slightly gingival as compared to the central incisor, so that we will have the canine tip slightly extruded, and it helps in creating the canine guidance at the end of the treatment. So pre-treatment may look like this, and it is essential that we bond the bracket on each tooth at its ideal position so that we get the proper canine guidance at the end of the treatment. If the bracket has not been bonded properly, as you can appreciate, the lateral incisor bracket, which should have been at 0.5 millimeter less, but it is at the same height as that of the central incisor, and this is causing an interference in the protrusive movement. The lateral is 0.5 millimeter above the central incisor in the normal occlusion to allow the canine cusp tip to glide through in protrusive movements without creating an interference. So all the things which give us the form, they are also associated with the function. And if the bracket has not been properly bonded, then we need to incorporate bends or rebond so that we get the proper canine guidance. Marginal ridge alignment should be good. We cannot end with an improper marginal ridge alignment and a vertical discrepancy, even if the arch form is good. The gingival zeniths have to be at their ideal locations. And one thing I always tell is that you have to understand that a tooth does not move in isolation. When the tooth moves, it moves along with the bone, and the gingiva moves along with the bone. So a tooth does not move in an isolated manner in the alveolar processes, but the tooth moves along with the bone and the gingiva. A lot of us have this question that if a tooth is extruded, it could give rise to canine exposure and sensitivity. Such a thing does not happen. Even if I'm extruding the canine, the bone will follow the tooth and the gingiva will follow the bone. And the gingival zeniths, they can be beautifully controlled by orthodontic treatment. Like this is one of our patients. Her daughter was undergoing treatment and she also felt the need. Of course, we are going to bring about alignment, but here let me show you how the tooth does not move in isolation. This was day one, and this is at the end of the treatment. The blue lines represent the gingival zenith pre-treatment, and now you can see that even though I have brought the occlusion in normal, what you also see is that the gingival zeniths are also in a great position. The bone follows the tooth, the gingiva follows the bone. Second, molar bonding. Sometimes you will have a condition where you have got good aesthetics, the premolar extraction space has closed, the patient is quite happy. But now, when I do a lateral excursive, I see that the distal cusp of the first molar is causing an interference. I do not want to debond with only aesthetics. I want to create an optimization of the function. See, an interference alone will not give rise to a TMD, but an interference with the additional factors can be a factor which we can prevent. And therefore, at this stage, I will bond, and you can see that the archwire and the passive state is lying below the molar bracket. When I will insert it in the molar tube, it will automatically give rise to the intrusion of the distal cusp and prevents it interference in the lateral excursive movement. Look at the deflection created in the night eye archwire, and that is what is going to give rise to the intrusion of the distobuccal cusp of the first molar. So we go ahead, we do this in the lower arch also. The second molar bonding is indicated in the lower arch also when you get the lingual tipping due to an improperly positioned band. And then we can get it corrected. A while ago, when I was treating cases before I got interested into the pain and all the aspects of pain, a case treated previously with ortho and all the 6 keys. But now, when this patient came to me 7 years post for some other dental issues, and I saw that I had ended the case with improper protrusive and improper lateral excursive movement. This patient is not complaining of TMD, but I would not like now to leave my cases in such a manner before debonding. So now what I do is before the last appointment, I would check for the lateral excursive movement and then leave the patient with an ideal aesthetic and functional smile. Same over here, we have a canine in crossbite, but now after correcting this, we are getting the good canine guidance. Patient has laminates on upper anteriors. Again, we need to see. Now look at this and try and see what is causing this interference and what is going to cause your laminates to fail in this patient. Look in the first quadrant at the right, on the right side, and you see that you have in protrusive, the 8 is guiding. Look at this. In protrusive, the 8 is guiding, and the lower 8s will need extraction in this patient to get a proper excursive movement. This patient already came to me with a canine extracted, but I would see to it that now the premolar is doing that work and it is discluding during the lateral excursive movements. A patient whom I'll be treating with upper force extraction, but ensuring that I am giving a proper guidance at the end of the treatment. So this band is essential before debanding. Let me move ahead. And when we give fixed lingual retention in adults, we make sure that we do it in a groove prepared in the adults so that I'm not interfering in their protrusive and lateral excursive movements. The perio procedure has already been concluded. We wait for 6 months and then we go ahead with the ortho. As you can appreciate, the patient has already lost two lower incisors to perio, but uppers are quite good, and we end them with intrusion and a proper excursive movement. Let me move ahead. Yes, the Dental Council of India, it gives you the right to practice all branches of dentistry. And there is this in the DCI Code of Ethics, which says that a dental surgeon may not claim to be a specialist, but however, practice all branches of dentistry. Now, let us see how to restore the canine guidance in known TMD cases. This was a prosthodontist which was referred to me by a TMD specialist. And let us see the occlusion. Everything well aligned, good aesthetics. But this is her protrusive, where only the upper and lower anterior should have been touching. We have got all the teeth touching in protrusive. Let us look at the excursive, the right excursive, all the teeth on the working side in contact, all the teeth on the working side in contact in the left uh, laterotrusive movement. And we design the archwire in such a way that we will be extruding this canine. Once the canine is extruded, we check for any interferences in the centric and do the adjustment on the palatal aspect of the canine, and then we can go ahead and end this patient with a nice canine guidance. Will this canine guidance retain with the bruxism? It won't. So it has to be supplemented with an additional guard which she will have to wear at night to prevent the wearing of the canine cusp tip. Another patient, young child, before debonding, and I see that there are interferences, and we modify the archwire so that we give a good canine guidance. Now, this patient, an NRI, she walks in our practice and she wants anterior laminates. You can appreciate the amount of para function, the heights of all the teeth significantly reduced, where facets on the posteriors, and the excursive movements which are showing a lot of interferences. And here where the patient was not keen on ortho, so we added composites on the lower canines, and we created good canine guidance. Look at this, the left side and the right side. And then you can go ahead and successfully bond the laminates without risking the debonding of the laminates. So, my friends, you will have to believe in magic, and only then you will be able to find it. Will this last forever? No, but this is essential so that we preserve the integrity which is presently there in the dentition. Look at the marking which you will get on the articulating paper, which will suggest that you have gone to the proper canine guidance. Otherwise, you risk this. debonding of high-end laminates. And finally, let me go ahead and show you a case where we create a proper occlusal plane so that we don't have interferences. We don't want to give a saucer-shaped prosthesis. And we use micro implants. Let me move ahead with this. Yes, this is how we place the micro implants. Let me show you a video. 8 to 10 millimeters from the archway at an angle of about 45-degree apically. We will make an osteotomy about 2 millimeters into the bone.
Let's play.
Yes. Jaiva, 8 to 10 millimeters from the archway at an angle of about 45-degree apically. We will make an osteotomy about 2 millimeters into the bone. This is a very thin paper paper, and this is your osteotomy. And then we take your micro implant. Here we are using a 1.4 by 8 micro implant. See the angulation 45 degree. See that I am interdental in between the root, and I put in the micro implant. The micro implant can be loaded immediately. And so which micro implant? It can be any micro implant that you are using, but we can use this with good success when you have to create an intrusion of the molar. And two implants placed below, two micro implants bringing about the intrusion. So you will never reach your destination if you stop and throw stones at every dog that barks. Look at this. When you have an extruded molar, you are not, compare this to a door which is not closing properly because the upper hinge is loose. You do not shave off the upper molar, you do not adjust the occlusal plane, but you do the tightening of the hinge. And similarly, we are not going to do an intentional root canal. We are not going to have a plane which is like this, but we are going to intrude and keep them in the proper place. So here we are intruding the premolar. Here we are uprighting the molar and making sure that at the end we are having a flat plane of occlusion, as you can appreciate in this. So that is how we are creating this, and a happy smile at the end of the treatment. So orchestrate orthodontics into your ideal holistic treatment plan and give the patient a proper plane of occlusion. The mesially tipped 7, 8 is missing. Adult patient We don't want to fully bend her, fully strap her. We just put micro implants, a couple of buttons on the molar, and distally tip the molar so that it achieves its proper plane and does not cause any interferences. So you can upright and give rise to the proper plane of occlusion. And before I leave today, I want to go and show you a new concept, and you might be seeing it here for the first time. This patient walks into your practice. She says that she wants a fixed solution. Appreciate the amount of vertical loss, the closeness to the nerve, and now you feel that implants are going to require vertical augmentation, and vertical augmentation does not have that guaranteed success and is extremely technique sensitive. So look at how I proceeded in this case. We placed a micro implant distally, did only a quadrant bonding, and we distally drove the second premolar from this position slowly behind. And now you are going on creating space, and as the tooth moves, it leaves the bone behind. And now you can go ahead and place an additional implant in between the 4 and 5 after sufficient distalization, of course, or you can give a 3-unit prosthesis which will follow the Anti's law, and you can have up to 2 premolars in between this, or 1 molar over here. And over here you can appreciate that the plane of occlusion is not having very sharp cusps, and you will follow the cusp pattern of the above upper teeth and give rise to a prosthesis. So don't be afraid of being different. Be afraid of being the same as everyone else. So with this, we go ahead and we say that research produces results, not answers. Orthodontic treatment now has been definitely shown not to cause TMD, neither can it cure nor prevent TMD. It is a TMD neutral branch. So with this, I come to an end of my presentation, and if we have time, we'll take in a couple of questions and then have the next speaker join in.
Thank you, Dr. Rathi. This was really enlightening. And your last statement, wherein you covered up that TMD has absolutely, it is related. We are talking about the stomatocathic system, but of course, the stigma on orthodontist can lay apart now that the
Yes.
orthodontists
So
are.
that's it has been a general thing that whenever you have a TMD, the first question you ask your patient, have you undergone ortho treatment? And then you say, oh, that is what has caused the TMD. But to be fair, TMD is seen in patients who have not undergone orthodontic treatment. TMD is very much prevalent in teens today who have not yet undergone the treatment, even though TMD shows an increased frequency with age. Now, sharing with you, Sonal, this all thing started in 1987 when there was a famous case in US. It's there whenever you'll go to the net, Brim versus Malloy, and an improperly consignated jury, they sentenced that the ortho treatment gave rise to TMD, and the orthodontist had to pay $850,000 at that time. So that is how this thing started.
Okay, thank you, Dr. Rathi, for this enlightening lecture. On a Sunday morning, you have a good audience here. If at all, you can stay back and address the question in chat session later on, because I'll call in the next speaker. We are on a tight time schedule here. So can you stop sharing your screen, Dr. Rathi?
Yes, I'll do that.
Dr. Maithili is the next speaker. Dr. Maithili, say hi to all. Yeah, she's already started sharing her screen. Dr. Maithili, can you switch on your camera, madam?
They're on. Both are on.
Yeah, hi, hello. How are you, Dr. Maithili? Good morning to you.
Good
Dr. Maithili
morning.
is currently an associate professor in Department of Orofacial Pain and Temporomandibular Disorders, Eastman Institute of Oral Health, Rochester, NY, USA, and a consultant at Manipal Hospital, Bangalore. She received a dental education from Government Dental College, Bangalore in 2002. She has completed a fellowship in orofacial pain in 2005 in University of Medicine and Dentistry in New Jersey. And she's completed a master's in dental sciences with specialization in orofacial pain at University of Medicine and Dentistry of New Jersey, and she is board certified by the American Board of Orofacial Pain. She has completed masters in dental sleep medicine from USA. She has published several articles and in PubMed and other index journals. She also serves as an editorial board and reviewer board of several prestigious journals. She's on the scientific committee of American Academy of Dental Sleep Medicine. Ma'am, this just sums up, I guess, 1% of your CV, because I've been following your work, and it's an honor and pleasure to have you on board on International Orofacial Pain Congress. I guess this is our third year together that you've been presenting with us, and welcome to International Orofacial Pain Congress Season 3. And the stage is all set for you, ma'am. Your slides are visible. Please go ahead.
Thank you so much. At the onset, I'd like to thank the organizing committee, Dr. Sonal and Dr. Nooral, for inviting me here again and giving me this opportunity. So my topic today is on trigeminal neuralgia and other neuralgias of the orofacial region. To begin with, I'll begin with a small introduction to neuropathic pain, and we'll go into the basic classification of neuropathic pain. I'd like to give an overview of different episodic neuropathic pain conditions, because some of these have characteristics which are very similar across different facial neuralgias, and identifying those would kind of help narrow down the differential diagnosis. We'll go briefly over the clinical features of different neuralgias in the orofacial region, diagnosis of these as well, and a brief overview of management, particularly on the conservative management. So neuropathic pain, the International Association for Study of Pain basically defines neuropathic pain as pain caused by a lesion or disease of the somatosensory nervous system. It could affect the central nervous system, or it could affect the peripheral nervous system. Now, there are a lot of classifications of neuropathic pain. ICHD and ICOP have very good classifications of orofacial pain. ICOP classification is again based on the ICHD classification. And the ICHD is a little more comprehensive in that it includes other facial neuralgias as well, whereas ICOP is more specific towards trigeminal neuralgia. So in my lecture today, I'll be focusing a little more on ICHD because the diagnostic criteria for the other facial neuralgias are more well defined in the ICHD classification. Broadly classify facial neuralgias. There are different criteria that are used. The simplest criteria is based on whether it's associated with a lesion in the central nervous system or the peripheral nervous system. So when it's associated with the central nervous system, it's referred to as central neuropathic pain. And when it's associated with the peripheral nervous system, it's referred to as peripheral neuropathic pain. Post-stroke pain is a classic example of central neuropathic pain, and peripheral neuropathic pain could include a post-herpetic neuralgia as well. Again, based on the etiology, it could be classified into classic, idiopathic, or secondary. And we'll be going into dwelling a little more into the different diagnostic criteria for classical, idiopathic, and secondary shortly. And the third is based on the syndromology. It can be classified as neuralgia or neuropathy. And I think yesterday you had a very good lecture by Dr. Anantan speaking on neuropathy. So today we'll be dwelling a little more on different neuralgias. So when we basically classify it based on the location, it could involve the peripheral nervous system or it could involve the central nervous system. So the IASP defines peripheral neuropathic pain as pain caused by a lesion or disease of the peripheral somatosensory nervous system. The definition has been updated to include both lesion and diseases of the peripheral or the central nervous system. Again, in both central and peripheral neuropathic pain, it could be episodic or it could be continuous. And the clinical features are a little distinct when it's episodic neuropathic pain versus continuous peripheral or central neuropathic pain. Central neuropathic pain, as I previously mentioned, it's caused by a lesion or disease of the central somatosensory nervous system. And again, this could further be classified into episodic or continuous. I also spoke about the second kind of classification where it's classified into classic, idiopathic, and secondary. So a lot of times, the classification could also mention primary and secondary. Primary includes both classic and idiopathic, and secondary is when it's associated with specific underlying lesions or diseases of the central or peripheral nervous system. So classical neuropathic pain or neuralgia is neuralgia developing primarily without any apparent cause other than neurovascular compression of the nerve. And this neurovascular compression, it's primarily to define it as classical neuralgia, you should be able to appreciate the neurovascular compression on the MRI or during surgical procedures. So that is when it is referred to as classical neuralgia. And classical neuralgia, another criteria also is that it's associated with morphological changes in the nerve root, both on the MRI or at the time of surgery. So morphological changes in addition to neurovascular compression is very important to distinguish it as classical neuralgia. The second category is idiopathic neuralgia. And in this, there's neither neurovascular decompression causing morphological changes or the MRI does not show significant abnormalities, and the electrophysiological tests are basically normal. So when there's no significant abnormalities either on the MRI, then it is referred to as idiopathic neuralgias. The third category is secondary neuralgias, and these are conditions primarily caused by underlying lesions or underlying diseases. And very commonly, facial neuralgias, a lot of facial neuralgias, particularly trigeminal neuralgia and glossopharyngeal neuralgia, may be associated with multiple sclerosis or tumors in the CPA angle. So definitely in an MRI, you would see underlying changes and underlying diseases. And such conditions are referred to as secondary neuralgias. So classic primary neuralgias, including classic and idiopathic, account for majority of the cases, and less than 10% of the cases are due to secondary neuralgias. So again, idiopathic, classical, and secondary neuralgias are the three broad categories that we'll be dealing with today. And both idiopathic and classical, again, could be subclassified as purely paroxysmal pain or with concomitant continuous background pain. And the continuous concomitant pain classification may be a little confusing during the diagnostic process, and hence getting a very good history is critical in distinguishing neuralgias from other facial pain conditions. So when we generally sum up facial pain conditions, majority of the facial pain conditions are odontogenic, as all of you are aware. The second most common category is musculoskeletal pain, and the third is neuropathic pain. Uh, However, if you see the severity of the pain, then neuropathic pain and odontogenic pain are probably the most severe facial pain conditions that we commonly encounter in clinical practice. So in general, it's applicable to most neuropathic pain conditions, episodic neuralgias in the facial region. General characteristics are when we describe any pain condition in the orofacial region, we basically rely heavily on primarily the history and the clinical examination. And in neuropathic pain conditions, the history is a little more significant compared to clinical examination. Hence, spending a good amount of time with the patient, getting a good history is critical to arriving at a proper diagnosis. And generally, when we look at the history, we describe any pain condition in the orofacial region in terms of 6 questions. We often refer it to as the magic questions. And they basically look at the location, the duration, the quality, the intensity, aggravating and alleviating factors. So in episodic neuropathic pain, which includes different neuralgias, trigeminal, glossopharyngeal, nervous intermedius, any of these, the characteristic of pain is that it's electric-like, sharp, shooting kind of pain, which basically affects the distribution of the involved nerve. And it primarily lasts from a few seconds to a few minutes. And classically, it's very severe in intensity. And it could be triggered by innocuous stimuli, which we often refer to as allodynia, and it's not counted by any other ICHT diagnosis. I'd like to involve this case, who was a 65-year-old male. He presented with a left facial pain of 35 years duration. So way back in the 1980s, he was diagnosed with neuropathic pain, primarily trigeminal neuralgia. An MRI was done at that point of time, and he was diagnosed with TN, and he was treated with carbamazepine for a decade or more. He then underwent 2 radiofrequency ablations, and at the point, his pain was pretty well controlled for more than 2 decades. When he presented to us, he presented with a flare-up of pain been controlled with carbamazepine. And we'll go over the diagnostic process and thought process in this patient a little later on in this lecture. So like I mentioned, getting a good history and a good clinical evaluation is the key to arriving at a proper diagnosis. And in orofacial pain, diagnosis is the key to a successful treatment. So please do spend adequate time with your patients on getting a good history. So episodic neuropathic pain, again, like I mentioned, the quality is sharp, severe. It could be electric-like kind of pain, and generally it's out of proportion to the stimulus. So a lot of patients would complain of severe pain when they wash their face in the morning, they brush their teeth, particularly ladies when they're applying makeup. they could say that it triggers the sharp bout of pain. The pain classically lasts for a few seconds, and the response generally to analgesics is very poor. And each of the episodic neuropathic pain or neuralgias classically follow nerve distributions. So if it's a trigeminal nerve, it would follow the trigeminal nerve distribution versus glossopharyngeal nerve, which follows the glossopharyngeal nerve distribution. Characteristically, trigger zones are seen in this condition, and it could be extraoral or intraoral. The classic history, particularly in conditions like trigeminal neuralgia, a few people in literature also describe a condition called as pre-trigeminal neuralgia. And there is some controversy regarding this diagnosis because it's always been a retrospective diagnosis. However, as the condition progresses, early on in the disease, both the frequency and the intensity of the pain is very less. And these patients classically have a remission period during which they would not describe the pain. So they would describe that they have periods where there are absolutely no pain, and suddenly, the condition starts back again. In the initial phases of the condition, the remission period is longer. The frequency of the pain in a single day is lower, and the intensity is also lower. So as the condition progresses, the remission periods progressively become shorter. The intensity and the frequency of the pain condition also starts increasing. Now, the second kind of neuropathic pain, which is not purely paroxysmal or episodic, it can be associated with continuous background pain. And getting a good history in patients with paroxysmal with continuous background pain is very, very important, because a lot of times when the patients present, they would say, "Doctor, I have continuous pain, which is very severe." They fail to distinguish that the continuous pain is overlapped by periods of episodes of severe pain. So distinguishing the two is very critical, and because often these can get confused with odontogenic pain conditions. So distinguishing particularly episodic neuropathic pain with background continuous pain is very critical for a diagnosis of TM. So TM can affect different branches of the nerves in the facial region. And most commonly, the trigeminal and the glossopharyngeal nerve are involved. Less frequently, branches of vagus, nervus intermedius, which is cranial nerve 7, lesser occipital and greater occipital nerves could also be involved. It's critical to know the nerve distribution because the pain distribution follows along the nerve distribution. Particularly, certain areas can be a little confusing. For instance, the tympanic membrane, because it has three different nerve supply. The medial aspect is supplied by the glossopharyngeal nerve, whereas the lateral aspect is supplied by the auriculotemporal and nervus intermedius. So knowing the nerve supply of each nerve and the nerve distribution, the nerve course, is critical when you're looking at symptoms and areas to image. It's very critical. You have a good knowledge of basic anatomy and physiology of nerve. So trigeminal neuralgia is the most common condition, and the incidence is about 4.5 per every 100,000, and the prevalence is 0.001 to 0.3%. It's commonly a condition which is seen in middle ages, primarily between the ages of 40 to 60, 4th to 6th decade. And again, it's classified into classic, idiopathic, and secondary. And secondary conditions, like I mentioned, it could account for about 10% of the cases. And in these, MS is the primary condition, which accounts for 2 to 4% of the cases. The characteristics of pain are very similar to the general nature, and generally it affects one or more division of the trigeminal nerve. So it can affect the maxillary, mandibular, or ophthalmic division. The mandibular division is most common, followed by the maxillary division, and lastly the ophthalmic division. Generally, it is unilateral. When it is bilateral or it is accompanied, it involves one or more divisions, it is one of the red flags which necessitates further investigations. So knowing the anatomy and the branches of the trigeminal nerve is critical to understanding the distribution of episodic trigeminal neuralgia. The second confusion is primarily when we are speaking about trigger zones versus trigger points. Trigger points are areas of hyperactivity which are seen in muscles, and they have referral patterns. However, trigger zones are commonly seen in neuralgias, and on brief stimulation with innocuous stimuli, which is referred to as allodynia, they can start an episode of neuralgia. So these could be both extraoral or intraoral. And the lips, the buccal mucosa, the very common areas where you would see the trigger zones. Glossopharyngeal neuralgia is the second most important neuralgia. And I think we again have another speaker who will be going into details of glossopharyngeal neuralgias. So I'll be briefly moving to other pain conditions as well. The epidemiology is again pretty much similar, and it's a little more rare than classic trigeminal neuralgia. And again, it could be idiopathic, classic, or secondary. With glossopharyngeal neuralgia, pain again follows the distribution of the glossopharyngeal nerve. And commonly, patients would describe pain in the ear, base of the tongue, tonsillar fossa, or beneath the angle of the jaw. And it could be pretty confusing and may mimic a temporomandibular disorder. The primary distinguishing feature is that even without jaw movements, it can trigger the pain conditions. So if you have a patient drink ice cold water using a straw and it triggers the pain, in that instance, you're not using the masticatory musculature or the temporomandibular joint, and it's more specific towards glossopharyngeal neuralgia. Nervus intermedius neuralgia is basically neuralgia of cranial nerve 7, and it could present as a complication of herpes zoster and rarely MS or tumors. And again, distinguishing it more commonly affects the lateral wall of the tympanic membrane and the preauricular region. So knowing the nerve distribution is critical in recognizing it and managing it. Occipital neuralgia often involves the greater and the lesser occipital nerves, and very rarely the third occipital nerve. And in this instance, the patient may describe sharp shooting pain, particularly in the posterior part of the scalp and the distribution of the occipital nerves. Patient may also describe, lack of diminished sensation or dysesthesia in these areas as well. And the characteristics of pain are a little different than classic neuralgias, in that in addition to sharp shooting paroxysms of pain, the patient may describe burning pain as well, and there may be dysesthesia as well. So when it's a very young patient, And it's primarily there's lack of refractory period. It's affecting two or more divisions of trigeminal nerve, and it's accompanied by sensory changes, or it awakens the patient from sleep. These are some primary indications which could raise red flags in cases of neuralgias, and they need to be investigated further. So education of the patient is very important, and pharmacological management is the primary mode of management, and there are different interventional managements as well. I will not be dealing with the interventional managements. The next few slides will quickly go over the medical management of cases of neuralgia. But it's frankly very important to know that we need to individualize treatment. There's nothing which works for all patients. Sometimes combination of first and second line treatment may be essential, and keeping an eye out for drug interactions is also very essential. The key is you start slow and you go slow, and remember the medical history of the patient as well. The American Academy of Neurology and the European Academy of Neurology, they have first-line medications, which include carbamazepine, oxcarbamazepine, and lamotrigine or baclofen may be added. However, the evidence for lamotrigine and baclofen is very limited, and sometimes we do use it as a combination with carbamazepine or oxcarbamazepine. Primarily because of the side effect profile of carbamazepine, and hence it's a medicine which is very effective, but which is associated with a lot of side effects, and particularly in elderly and people with medical conditions, you need to be extremely careful in how you titrate the patients. Gabapentinoids are a better option, and with fewer side effects, particularly in medically complex patients with renal failure or cardiac conditions. First-line medications include carbamazepine, oxcarbamazepine, gabapentinoids, and you could also add on lamotrigine, baclofen as well. Surgical modalities, you have different surgical modalities at the periphery and the central, and we'll not be going into any of these in today's lecture. So remember, to solve the case, it's very essential you get a good history. And coming back to a patient with facial pain, we thought of repeating the MRI. And when we did the MRI, we saw that he had bilateral internal carotid artery agenesis and dolichoectasia of the vertebral basal artery. And this was placing pressure on cranial nerve 5, 7, 9, and 10. So it was the entire facial neuralgias that we described today. This patient had a presentation, and fortunately, he's doing very well with medical management. So he had several comorbidities of hypertension, hypercholesterolemia, which were addressed, and that helped relieve the pressure from the dolichoectasia, and he's doing extremely well with pharmacological management. We have switched him to gabapentinoids. Summarizing the entire thing, current practice guidelines, there's no specific clinical feature which will say or exclude secondary trigeminal neuralgia. So MRI is a must in most cases of trigeminal neuralgia. There's a very strong recommendation. And evoked potentials, there's a strong recommendation against it to distinguish primary and secondary trigeminal neuralgia. And if you're looking at surgical options and looking at classic and idiopathic trigeminal neuralgia, looking at morphological changes with neurovascular decompression is essential, because if it is just a plain neurovascular contact with no morphological changes, the current indication is that they may not be good candidates for microvascular decompression. And so you may do better with pharmacological management in these cases. So, concluding, I'd like to thank the organizing committee, Dr. Sonal, Dr. Noorul, my teachers, my mentors, and my colleagues from Rutgers, Eastman. Thanks.
Thank you, Dr. Maithili. It is always a pleasure listening to you because you simplify such complex topics. And if you can stop sharing your screen, because I have not taken the mandatory picture with the speaker today. So yeah, 1 second. Yes, smile for the camera, ma'am. Ma'am, can you share one book that has inspired you, non-medical book? I know you are a reader, so is there any one book that has actually inspired you that is non-medical?
I think there are several. It's hard to pin out one. There are several. There's one called "When Breath Ceases." It is by a doctor himself, and I really like that book.
I'll love to read that, ma'am, if you can share the copy with me.
Sure,
Okay,
sure.
so Dr. Maithili's lecture was a validation that we just manage chronic pain or this neuropathic pain condition into a well-lived life. So managing is most important key here, and think before you intervene into anybody's life and cause a permanent damage to them. So thank you so much, Dr. Maithili. And on that note, I would like to call in our next speaker, Dr. Vijay. This slot was supposed to be for Dr. Divya Dilip Kumar, but Dr. Divya has already presented on the day one, that is 19th. We had a cancellation from Dr. Tara. So we had scheduled her lecture, Dr. Divya's lecture on the 19th. If anybody of you who have missed it can check on the YouTube link which is shared. You can check on the National Health Academy YouTube page. You will get all the details over there. Do we have Dr. Vijay here? Dr. Vijay Katla team? Okay, do we have Dr. Vijay here? We'll give one more minute for him to join.
Let me talk to him, Dr. Vijay.
Yes. Please do that. Till such time, I'm going to be talking more about one more technique or few things like tips for you guys. So we all spoke about myalgia. We all spoke about vitamin D3, B12, and why it is essential in our daily routine practice. So when a patient walks into my clinic, it's more often so that now that I'm seeing these patients so often, it has become a routine for me, not only for my implantation cases or my third molar extraction cases, but most of my cases I just do a general checkup for them with a hematology profile, wherein I am asking them to get their CBC, that is a complete blood count, vitamin D3, B12, and most importantly, if at all I realize that the patient is 55 and above, the HbA1c and the current blood pressure readings, because more often than not, females, most of them neglect their health and they are deficient in vitamin D3 and B12, and they are silently carrying high blood pressure or low blood pressure, and 99% of them are anemic also. All these factors which are deficient or may have any changes in the parameters can lead to myalgia type symptoms, and these patients will have so masking effects, and our treatment plan will definitely change. So next time a patient walks into your practice, like yesterday Dr. Davis Thomas was also emphasizing on the systemic factors that you need to be taking care of. So whenever I go as a consultant, this orofacial pain practice has made me a consultant also, and I feel proud about it, because for almost 15 16 years of my practice, I had consultants coming into my practice, like 17 or 18 odd consultants who used to come in, and I was the owner of a clinic. I was a clinician that time, but orofacial pain practice made me a consultant. Whenever I visit any consultant clinic, the first thing, now they are also tuned, ma'am, do you need these kind of protocols, or do you need these kind of investigations to be done with for the patients earlier on? They also know that I would want to check every parameters first. So let's become diligent enough to bridge this gap between medicine and dentistry, body as a whole. That's what we are treating. Yeah, the team, can somebody call Dr. Vijay? I think there is some miscommunication on from the team. If Dr. Vijay can be contacted. More often than not, whenever we do a uh, complete case history. Okay.
Sonal, this is
Yes.
Dr. Pratibha here.
Yes.
If Vijay is not there, can I have my lecture now?
We'll give him a fair chance to join in, maybe another 2 or 3 minutes. Maybe there is some technical error. Let me get a confirmation from the team side. Dr. Pratibha, till that time, it's very nice of you to proactively come ahead and say that you can prepone your lecture. But just give me 2 minutes. I'll get back to you regarding the same.
Sure,
Hello,
sure.
ma'am. Hello, madam.
Yeah, hello.
I'll get back to you in 2 minutes.
Sure.
Just let the team confirm. I think there is a message. Let the team confirm. Yeah, it is from your. No, this is from Meenal. Okay, anyways. Fine. I was mentioning about some the patient protocol that we follow in our clinic. So these the regular investigations, what we do first, identify the patient, what the patient is pointing at. When the patient walks in and tells me or pinpoints at the area of pain or concern, I'm little happy. But when the patient says it's a diffuse area and I'm confused where the pain comes from, or the patient is using his or her palm to show the area of concern, that is the time my rational wheels start churning, and that's a big red flag. If the patient cannot pinpoint at the location, or if I cannot replicate the pain, that is the time I think about non-odontogenic pain. If at all there is a single iota of difference that this pain is not generated because of odontogenic cause, please check back, do your diagnostic, take a complete history. At times, a complete history taking gives you the diagnosis. So be very diligent in that. The site and the source of the pain could be totally different, and it can create so much of confusion in the patient's mind. Dr. Pratibha, you can start the lecture, because the Dr. Vijay will be joining in some time. So after your lecture is over, uh, ask the committee to we will ask the team to ask him to join. Dr. Vijay's lecture will be later after Dr. Pratibha. Dr. Pratibha, yeah.
Yeah.
1 second, okay. I'll just take a picture, ma'am. I think we have only conversed over WhatsApp messages up
Yes.
till now. Yes. Smile for the camera, madam. Okay, thank you, Dr. Pratibha. Welcome to International Orofacial Pain Congress Season 3. This would be your first lecture with us, right?
I think second one.
Second one.
Last time I was not there. First time I think I was there.
Okay, you could not join us. Okay, fine. Dr. Pratibha is Head of Medicine Unit in Department of Anesthesiology, JSS Medical College, Mysore. Madam Dr. Pratibha, welcome to International Orofacial Pain Congress. One practice that has changed your aspect, or one habit that has changed you to become a pain management specialist, anything that changed in you, or any habit or any incident that changed you to become a pain management specialist here?
Yeah, I think listening to the patient is one of the quality that it has taken a long way for me to develop that trust for the patient and me. And also, when you listen, not only for the patient, but you get a lot of things from the patient. You understand a lot about life, I feel, when you're listening to them very keenly and patiently. So that's
Yes.
something I really enjoy when without interrupting, I really like to listen to the patients.
Wonderful, ma'am. Thank you. So let's become good patient listeners. And the stage is all set for you, ma'am. Can you start with sharing your screen, Dr. Pratibha?
Sure. Yeah. Can you see my screen?
I guess it's loading. We'll give it a minute. Yes, ma'am. Can you go on the presenters mode?
Yeah. So I have already started. Has it
Ma'am,
come?
please go on the presenters mode.
Now?
No, it has not happened yet. Yeah, it's there. Please go ahead, ma'am.
Okay. So thank you so much, Sonal and the entire organizing team of IOPCON for giving me this opportunity. I'm going to talk today about the facial pain relief mastering the ultrasound guided peripheral trigeminal nerve blocks. I'm not sure how many of you are practicing ultrasound in your practice and how many of you are practicing basically peripheral nerve blocks for ultrasound. So this is little bit of a challenging kind of a technique for somebody who's not that much of an expert into ultrasound, but definitely it causes a lot of precision, avoiding complications with the help of ultrasound. So because this forum is also for the majority of the dentists, so I thought that I will also include the landmark guided techniques in addition to the ultrasound guided techniques. So greetings from the Department of Anesthesiology, JSS Medical College, Mysore. And so we have, I think from morning, we have been listening about the trigeminal nerve. The sensory innervation of the face and the neck is supplied by the trigeminal nerve, which is the fifth cranial nerve, which carries both the sensory and motor components. And the trigeminal ganglion, which is also known as the semilunar or Gasserian ganglion, it lies in the Meckel's cave in the posterior cranial fossa, and the postganglionic fibers exit the ganglion to form the main three nerves that is known as V1, V2, V3, that is the ophthalmic, maxillary, and mandibular nerve. And today we are going to deal only with the peripheral nerves, that is supraorbital, infraorbital, mandibular nerve, maxillary nerve, and the mental nerve. These are the peripheral branches. And these branches can be blocked either by the landmark technique or the peripheral nerve stimulator guidance, which is mostly practiced by the anesthesiologist for the orofacial pain surgeries for the post-op pain relief. It could be done under fluoroscopy guidance, and the latest is the ultrasound guidance, which really gives a lot of precision, avoiding complications, intravascular or nerve injuries. So coming to the first nerve, that is a supraorbital nerve. Now, since we are going to deal with these nerves, it is mandatory for us to understand a little bit of an anatomy. So supraorbital nerve is it's a terminal branch of the ophthalmic division of the trigeminal nerve. And it is mostly the exclusively sensory nerve. When the V1 division or the ophthalmic division comes out of the ganglion, it passes through the superior orbital fissure into the orbit. And then into the orbit, it is divided into three branches, that is frontal, nasociliary, and the lacrimal nerve. Frontal nerve is one of the biggest nerve, and then it divides into supraorbital nerve, which in turn divides into the medial and lateral branches. And another branch of the frontal nerve is the supratrochlear nerve, which comes out into the supratrochlear groove and goes medially to supply these two branches. Basically, the supraorbital comes out of the supraorbital foramen, and supratrochlear from the supratrochlear groove, and innervate the forehead, eyebrows, upper eyelids, anterior part of the scalp, and the bridge of the nose. So this nerve can be blocked by the V1. In the indications of this nerve blocking could be the V1 division, isolated V1 division of trigeminal neuralgia, post-herpetic neuralgia, that is herpes zoster ophthalmicus. We get a lot of cases of the herpes zoster ophthalmicus, chronic intractable migraines, cluster headaches, and the trigeminal autonomic cephalgias. So how do we do this? So I have also included the landmark technique. You can see that even if you feel for yourself on the upper orbital rim, towards the medial aspect, you can feel the supraorbital notch. It's very superficial. And then you can introduce a 23 gauge, 1.5 inch hypodermic needle at the notch and advance medially for the supratrochlear part of it towards the bridge of the nose. Subcutaneously, you can infiltrate, and after negative aspiration, you can give 2 ml of the local anesthetic with steroid in a fan-shaped manner. So for the ultrasound guidance, the linear probe has to be placed at the supraorbital notch. And here you can see that there is a breach in the continuity you will be seeing, that is a supraorbital foramen, which will be always accompanied by the supraorbital artery. And here you can put the needle either into in plane or out of plane. I don't know how many of you are understanding these terminologies. In plane is along the beam and out of plane is out of plane approach. The needle is placed into the foramen, and after the injection, it's very important when you do the supraorbital nerve block, it's very important that you give an upward pressure, because most of the patients who are coming, especially we do a lot of cases of herpes, and here it's very important that these elderly patient has a loose areolar tissue. So the drug will seep in down and there will be swelling of the eye. So after giving that block, you give an upward pressure to prevent for the better spread of the drug as well as for the prevention of the swelling. So next one is the infraorbital nerve. Infraorbital nerve is the branch of the maxillary. It's a terminal branch of the maxillary nerve. So when the infraorbital, the maxillary nerve, it's also a sensory nerve. It comes out of the ganglion, the Gasserian ganglion, and it passes, before passing into the foramen rotundum, it gives a meningeal branch of the meningeal branch, and then it passes through the foramen rotundum to go into the space called as a pterygopalatine fossa. So it also gives branches to the pterygopalatine ganglion, posterior superior alveolar branches, and in the infraorbital fissure, it gives 2 terminal branches. One of them is the infraorbital nerve. And this infraorbital nerve then passes through the infraorbital, at the floor of the orbit, passes through the infraorbital canal and then comes out of the infraorbital foramen at the inferior rim of the orbit. So this, once it comes out of the infraorbital foramen, it gives multiple branches, and this innervates the lower eyelid, cheek, upper lip, and lateral part of the nose. So again, the infraorbital nerve could be blocked into the V2 division of trigeminal neuralgia, infraorbital neuralgia, and also the herpes zoster. So you can see that you can clearly see the infraorbital foramen, which is medially directed. It is very important for us to understand the anatomy of all these superficial foramen and these structures. So for the landmark technique, you can put a 23 gauge normal hypodermic needle into the infraorbital foramen, slightly medially directed till the periosteum is reached. And once, you should not enter into the foramen because you can cause injury to the nerve and the patient can really, they will have a shock-like sensation. So once you have reached the periosteum, then and if you have entered the foramen, withdraw the needle, and following negative aspiration, you could give 2 to 3 ml of the local anesthetic with steroids. For the ultrasound guidance, it could be done either in the transverse plane or in the sagittal plane. So transverse plane is the left side of the picture and the sagittal plane is the right side of the picture. And the transverse plane, you have to put the probe at the inferior orbital rim. And for the in-plane approach, the needle can go from lateral to medial direction. You can see that here, you will again see the breach in the continuity with where it is accompanied by the artery, and the needle goes from lateral to medial. For the in-plane approach, in the vertical plane or the sagittal plane, the needle can go from below. You can also have an out-of-plane approach for securing the infraorbital nerve. So next is the maxillary nerve block. So maxillary nerve block, we have already understood, like I have already talked about the anatomy. But once the maxillary nerve comes out of the foramen rotundum, it passes to the pterygopalatine fossa. This is one of the very important structure where the maxillary nerve lies, and you can give a very good pain relief when you give the put the injected into the pterygopalatine fossa. So the maxillary nerve is a sensory nerve which supplies the lower eyelid, along the nose, cheek, upper lip, then upper teeth, soft and hard palate, and the maxillary bone. So the maxillary nerve, there are a lot of indications for doing this maxillary nerve block. It could be the V2 division of trigeminal neuralgia, cluster headache, migraines, trigeminal autonomic cephalgias, the spinopalatine neuralgia, post-dural puncture headache, which is one of the indication used by the anesthetist, and the refractory craniofacial pain, and another important one is the head and neck cancer. So for the ultrasound guidance techniques, the probe is placed in the infrazygomatic area. You can see the probe put in the infrazygomatic area over the maxilla with little bit of an cephaloid angulation. And this will show you the maxilla anteriorly and the coronoid process posteriorly. And in between the space you can see deeper down, you can see the lateral pterygoid plate. And in the space, you can also see the maxillary artery pulsations. So the needle you can see here, the anteriorly you have the maxilla, posteriorly you have the coronoid process, and the needle is advanced into the out of plane approach, looking at the maxillary pulsations and the drug out of plane approach. You can see the drug spread into the pterygopalatine fossa. The needle is put into the out of plane approach. So this is also there is also one another approach which is considered as more safer approach, that is a suprazygomatic approach. Here the needle is placed at the angle of the zygoma, wherein the needle is placed anteriorly and caudally, so that it walks over the bone and enters into the pterygopalatine fossa. By the earlier approach, there is a possibility, if you are not correctly going, then there is a possibility you may enter into the orbit if you go more anteriorly. But with this approach, when you go from the zygomatic angle, then you cannot enter into the orbit, and the needle, since you're feeling the bone, you will be entering into the pterygopalatine fossa, walking off. So the next one is the mandibular nerve block. Mandibular nerve is, we all know that it is a mixed kind of nerve. It has the sensory supply to the lower lip and the cheek and chin, and also the lower jaw and the part of the oral mucosa, and also supplies the motor innervation to the 8 muscles. So once it comes out to the foramen ovale, it gives the terminal branch. One of the terminal branch of the mandibular nerve is the inferior alveolar nerve, which comes out of the mental foramen to give the mental nerve, give rise to the mental nerve, which supplies the, the terminal branch is the mental nerve. So here the mandibular nerve indications would be trigeminal neuralgia. Again, the same set of the indications are there. And it also could be done for the post-op analgesia for the surgery of the lower lip, lower teeth, and the mandible, and the anterior 2/3 of the tongue. So now this is one of the technique. This is a transcoronoid approach which can be done by the landmark technique, which can be done for both maxillary and mandibular nerve. With the patient in the supine position and the head in neutral position, you ask the patient to open and close the mouth and identify the coronoid notch. And once in front of, just put your thumb in front of the external auditory meatus and ask the patient to open and close the mouth. And then you can either an hypodermic needle, but here you may require little longer needle. If the patient is specially obese and then too much of a fat, then little longer needle may be required. Otherwise, a 5 centimeter Stimiplex needle, if you have the nerve stimulator, needle could be placed, inserted to hit the lateral pterygoid plate between the coronoid, transcoronoid approach. And then it is slightly withdrawn and redirected inferiorly for the mandibular nerve and anterior-superiorly for the maxillary nerve. And then if you have the nerve stimulator, then definitely you're going to get the motor response of the masseter muscle contraction, which can be seen in the form of the jaw jerk for the mandibular nerve. And once you have confirmed, you could inject the 5 to 6 ml of the local anesthetic with steroid. For the ultrasound guidance, here you are going to put the probe into the infrazygomatic area, that is below the zygomatic arch, and ask the patient to open the mouth. Once you ask the patient to open the mouth, the window becomes wider so that you can see the structures. Otherwise, it is always covered by the coronoid process. So once you ask the patient to open the mouth, then the window becomes wider, and you can, as you can see, that you have the posteriorly condyle and anteriorly you have the coronoid process, and in between you see the pterygomandibular space. In the pterygomandibular space, you have the masseter muscle above and below, deeper down lateral pterygoid muscle, and in between the space, that is the pterygomandibular space, has the artery and the mandibular nerve. So the needle is inserted at the top of the pterygomandibular space, and you would see the injected of the drug spreading into the pterygomandibular space for the mandibular nerve block. So for the last nerve, that is the mental nerve. So for the mental nerve, as I already told that it is coming out of the inferior alveolar nerve is the branch, one of the branches of the mandibular nerve, which comes out of the mental foramen as a mental nerve. And it supplies the mucosa of the skin of the lower lip and jaw and the skin of the chin. Here you could put the play. Actually, the mental nerve can be actually felt if the patient is very thin, you can feel the mental foramen, and it could be given just by landmark technique as well. But for the ultrasound guided technique, the linear probe is placed either in the transverse or sagittal plane between the upper and lower borders of the mandible, and then you will see again the breach in the continuity, and it is accompanied by the vessel, and the needle could be placed in or out of plane. So one more thing I would like to tell here is if you're wanting to do the block, then if the patient is lying down supine and looking at the roof, then the supraorbital foramen, the infraorbital foramen, and the mental foramen with the pupil. If the pupil is fixed and looking at the roof, then supraorbital foramen, pupil, infraorbital foramen, and the mental foramen, all of them lie in the same line. If you are little confused for the landmark technique, if there is little bit of a confusion, then this could be used as one of the technique to identify the location of all these phenomena. So what are the complications? Having said all these, the techniques, they may look very easy to see, but they can be little bit of there can be a little bit of a challenge depending on, because you, especially for the superficial nerves like the supraorbital, infraorbital, and mental nerves, it is very good to have an hockey stick probe, because they're really superficial, and these even the linear probes can be a little bit of a difficulty to put the probe. And if the patient is already suffering from the neuralgias, then even putting the probe, the gel you are using, that itself can precipitate the pain for the patient. So you have to be a little mindful about all these things before doing the interventions. So what are the complications of all these peripheral nerve blocks? So since the face is one of the very vascular structure, any of the nerve blocks that you're doing, there is a high possibility of hitting the vessel, because most of them are accompanied by the vessel. And that's the reason why the ultrasound makes it more precise. And since you're going to see you have to use the color Doppler. So if you are using a color Doppler, you're going to see the vessel, and you will definitely avoid the vessel injection or the vessel injury. Another thing is the nerve injury. When you're doing a blind techniques, then invariably you tend to go into the foramen, and then you can cause, because you're using a hypodermic sharp needle. So the nerve injury is again a very common possibility which could be avoided by ultrasound guidance. So for the supraorbital nerve block, if you're injecting a steroid, because it's a very, very superficial structure. So if you're injecting a steroid into the eyebrow, then it can cause the alopecia. And if you're using a large volume to anesthetize, then it can anesthetize the levator palpebrae muscle and causing the reversible temporary ptosis without diplopia. So you just have to reassure the patient. There can be also a possibility of oculocardiac reflex resulting into bradycardias and arrhythmias. So you have to be very careful if you're doing or planning these into the clinics and very casually without keeping any resuscitation things ready. Then it may be a very simple block, but it can cause the oculocardiac reflex. Risk of needle penetration into the orbit. Another most important thing is you should not be using, sometimes people do use the spinal needles or long length needles. Then it could be a problem if you're using a longer length needle, because you may not understand that how far or how deep you're going, and this is basically, I'm talking about the infraorbital or the maxillary nerve block that you're giving by the maxillary and mandibular nerve block by the transcoronoid approach. If you're using a longer length needle, and if your needle is not in a good place, or you're not understanding you don't have the knowledge of anatomy, then you can put the needle into the orbit and cause the damage to the orbital contents. Then the internal maxillary artery is another important structure that could be that there can be a damage or there can be an injury and there can be a big cheek hematoma, which has to be kept in mind. After injection of a large volume of local anesthetic, this initial days when we did not have the radiofrequency ablation, we used to give a lot of peripheral nerve blocks for the trigeminal patients. And then when we used to give some 6 to 8 ml of volume because we wanted to last it longer, and most of the patient would have the transient facial nerve block, which definitely resolves spontaneously. It just requires a reassurance. But with the ultrasound guidance, you don't require, this is another advantage, you don't require a larger volume of the local anesthetic because you know that where you're injecting. So now in where can you basically opt for the peripheral nerve block? In my practice as a pain physician, now I have stopped doing peripheral nerve blocks. I don't do it that much except for the herpes zoster ophthalmicus. There I only go for the peripheral nerve blocks. But for the trigeminal neuralgias, I definitely do the definitive procedure, that is a radiofrequency ablation. But in spite of having a radiofrequency ablation, where absolutely the peripheral nerve blocks are indicated. So first is, if you don't have the radiofrequency generator, then it is a great idea to give the peripheral nerve blocks, especially if you are practicing in the peripheries and smaller places, and also the very poor patients who can't afford. So in these patients, I practice in a medical college, so not everybody can afford the radiofrequency ablation. So in the low resource setting, in where the radiofrequency generator is not available, definitely it could be a savior for the patients who are suffering from trigeminal neuralgia. Then these are few cases which are very interesting, which I have come across. Is I had 2 cases of pregnancy. One was this is a patient who was in a first trimester of pregnancy. She literally could not eat anything, and you can see here that she was just not able to talk. Within those 30 seconds, also so many times she was getting the attacks, and she was not able to eat. She was not able to wash her face during the pregnancy. The nutrition is most important, and when she was suffering from this and she was admitted in the actually wards. So we had given the peripheral nerve block here because you don't require radiation, and a simple procedure with the nerve. We had used a pulse radiofrequency ablation for her, and she had a very good relief throughout her pregnancy. And during the lactation period, after her baby became 6 months, she underwent the radiofrequency ablation. This was another patient who was in the 3rd trimester of pregnancy, and definitely she was also not willing for the radiofrequency ablation. So for her as well, we had in the pulse radiofrequency of the V3 division of the trigeminal nerve. Then, as I said, that we do a lot of cases of the post-herpetic neuralgia for the V1 division, that is herpes zoster ophthalmicus. It could be done landmark guided because it's a very simple procedure, or I do prefer a lot of pulse radiofrequency ablation of the SOST, that is supraorbital supratrochlear nerves, because it gives a long-term relief. This is another patient, the 2 patients, basically, the left side of the patient who was an interstitial lung disease. She just could not, she had a V1, only isolated V1 division of trigeminal neuralgia, and she could not tolerate the drug. She was 80 years old and she was on the home oxygen therapy. She was not able to lie down, forget about doing the radiofrequency ablation. So we had, in a semi-reclining position, we had done an PRF of the V1 division of the trigeminal nerve, and she had an excellent response. It had to be repeated because she 2-3 times in maybe 6-8 months duration, after 8 months duration, and with the minimal dosage of the medication, she was doing very well. This right side patient, she was taking, she's a known case of trigeminal neuralgia for past 10 years, and she had never bothered about the side effects, and she was taking the high dose of Tegretol, and she had landed up into the pancytopenia. The counts were very, very low, and she was suffering with the severe pain. So in such cases, we wanted her to recover, and the hematologist was consulted, and meanwhile, she wanted some relief. And in this case, we had, instead of going for the radiofrequency ablation, we had done the peripheral nerve block with a pulse radiofrequency ablation of the neuromodulation of the peripheral nerve. That is, this was the V3 division of the trigeminal nerve. So what is the clinical evidence? There is a lot of literature about the supraorbital, the peripheral nerve blocks. Especially, there is a lot of literature coming on the pulse radio frequency neuromodulation of the peripheral nerves, which is giving a good results. So this is one study where the 4 patients were treated with the supraorbital nerve block, and they had more than 12 months of pain relief with no complications. Then there are 15 patients were treated with the ultrasound guided trigeminal nerve block in the pterygopalatine fossa, and they had a very good sustained relief in the trigeminal neuralgia or the atypical facial pain who had failed to respond to the previous medical interventions. There is also an upcoming literature and upcoming studies are happening on the use of cryoablation for the supraorbital nerve. There is also another study by Dr. Gautam Das and Dr. Hota, Smriti Hota, by using the cryoneurolysis of the mental nerve. So to summarize, I would say that peripheral nerve blocks can be used. It's like a very, I always feel that peripheral nerve blocks are kind of a blessing for the patient suffering from the orofacial pain. It could be typical orofacial pain like the classical or idiopathic trigeminal neuralgia, or the atypical orofacial pains, or the cancer pain syndromes where they have a severe pain. And these nerve blocks, which are not that difficult, but if you have an expertise, understand a good anatomy, and if you have an expertise into an ultrasound guidance mainly, then it can really give very good results, because you can have a high precision and you know exactly where you're injecting, you're avoiding all the vital structures of the face. It's mandatory for you to use a power Doppler, because since it is a hypervascular area and you would want to avoid a vascular injury. And this ultrasound guided interventions definitely can be used as a safe option or a wonderful solution for patients who are not responding to the oral medications. And if you don't have the RF generator, then you could also go for the ultrasound guided peripheral nerve blocks. These are my references. I have taken few of them for the anatomy from the YouTubes, and some of the ultrasound images are also taken from these YouTubes. Thank you so much.
Thank you, ma'am. Thank you so much. And if you may stop sharing the screen and we'll take a picture again. Yeah, smile for the camera again, ma'am.
Yeah.
So your lecture just summarizes that how best it is to refer the case to a pain specialist for a proper care. Thank you so much, ma'am, for gracing us with your lecture, and we hope to see you again in the next upcoming.
Thank you
webinar.
so much.
Thank you,
Sonal. It was wonderful being a part of this webinar series.
We'll keep in touch. We'll keep in touch.
Yes.
Thank you so much, ma'am.
Yeah.
On that note, we'll call the speaker before Dr. Pratibha, Dr. Vijay Katla. Dr. Vijay, hello, sir.
Hello, hi.
So, yeah, we meet again. So, how are you,
Hi.
sir?
Thank you very much.
Yes,
Yeah.
I believe you were busy and we pulled you out of your busy practice. And thank you.
Oh, no, sorry. It's just Sunday and then I had to go somewhere. Yeah. Okay.
Smile for the camera, sir.
Yeah. Okay. 1 second. Yeah.
Smile. Yes, smile.
Thank you very much.
Okay. Yeah, Dr. Bandi Katla needs no introduction actually, because he's been a part of IOPCON and Mediskill since a long time. But for our audience, his relentless pursuit of excellence started with his foundational training from Guntur Medical College, where he earned his MBBS degree. His curiosity and commitment to innovation led him to acquire esteemed qualifications such as FRCA, Royal College of Anesthesia, London, and many others. Sir, if I keep talking about your affiliations, I think the whole lecture will go on in that only.
Oh, no, sorry.
So, yeah,
Please.
it's a privilege always to host you, sir. And thank you for being a part of International Orofacial Pain Congress Season 3 this year also. And thank you for accommodating this spot at the very last moment. You've always helped us with that. So thank you and welcome. The stage is all set for you, sir. You can start with your presentation.
Thank you, Dr. Sonali. Are you able to see my screen?
Yes, sir. Yes, sir. Yes, sir. Is this
yeah, that's brilliant.
Yeah.
Thank you very much. Yeah. So Morning, everybody. On a Sunday, you've been part of this wonderful conference. Thank you, everyone, including Dr. Nurul, who has been instigating me to come for this program every time. Thanks a lot. So I have a little interest in facial pain, and I've done some research into this. Coming to orofacial pain, our topic today is part of neuromodulation in the treatment of orofacial pains. So this is a very fast growing field, as you can see. And in the next few minutes, we will be going through that. So essentially, what we talk about is what is neuromodulation, first of all. It is therapeutic alteration of the neuronal activity by delivering electrical or chemical stimuli to the targeted neurological sites. So this can be either chemical or electrical, anything, or pharmacological. If you're changing it, it is called neuromodulation. So the idea is to alter the irregular activity by stimulating various structures, be it in the brain or for the lower levels. So that is how neuromodulation works. As I said, it could be drugs, electricity, magnetism, optics, or maybe acoustic energy. These days, we are using all of those things to actually deliver that analgesic effect to the patient. So how did neuromodulation evolve in clinical practice? It has been part of pain practice for some time. Before that, neuromodulation has been used in various other specializations. Even in cardiac, you will be using electricity to burn the arrhythmic structures which are present. But then when it comes to pain, it started the first wave of neuromodulation. It started with treatment of failed back surgery syndrome. So after you have a surgery on your spine, if you have a failed procedure, maybe 2 or 3 procedures down the lane, if you still continue to have back pain, no more surgeries. Okay, it is going to be counterproductive. Then you put a spinal cord stimulator, like a pacemaker. You put an electrode into the spine, you stimulate the nerves, you're going to get a pain relief in the affected area, is what a neuromodulation works roughly. This has been very successful, and it has been taken a little further. Things like complex regional pain syndrome, where your arm or a leg is very badly painful, swollen, discolored, disfigured. In those kind of complex pains, neuromodulation has been very effective. So taking it on, in the initial stages, the thought was only when you stimulate the spinal cord, you're going to get a stimulation of the dorsal columns and you're getting an analgesic effect. But then the second phase of neuromodulation started, where the peripheral nerves have been become the targets now for us. In that, peripheral nerves we are using for treating it for pelvic pain, traumatic neuropathies, diabetic neuropathies, or even post-herpetic neuralgia. In all of these conditions, the peripheral nerves are stimulated to give the pain relief. Now, going a little further, as we have more understanding where these the electrical impulses are working on the patient, we've identified various different kinds of electrical signals. Say, for example, a tonic stimulation, we identified a burst stimulation, we've got a high frequency stimulation. All of these newer waveforms, which are getting more benefit to the patient, have been identified, and they are used to stimulate either your brain, as in deep brain stimulation, or a spinal cord, or even various peripheral nerves have been stimulated. So now we have number of targets which are helpful for us these days. Right, I think I've got a couple of lines here on the screen. I don't know where it came from. So yeah, now in this particular topic for orofacial pain, we are more focusing on the peripheral nerve targets. So as Pratibha ma'am was mentioning, so we have certain peripheral nerve targets. Broadly, they fall into 2 categories. One is the trigeminal, which is your main sensory on the face, which has got 3 branches. Ophthalmic, the branches are supraorbital and supratrochlear. When it comes to the maxillary, infraorbital and the auriculotemporal. For the mandibular, it is the mental nerve. So we have identified these things. And then you've got few other things like greater auricular. There is occipital, glossopharyngeal, which is into your throat. And then you've got the autonomic ganglia, which is the spinopalatine. So these are broadly our targets. Sorry, I've got a couple of lines. I don't know where it came from. I think it could be from your side. Maybe you could take it out, Dr. Sonali.
We'll check, sir.
Yeah, please do.
Continue with your lecture.
Yeah. So apart from the peripheral nerves, these peripheral nerves are getting into the spinal cord and the brain. That part is called the trigeminal cervical complex. This is the most important place where actually there is a co-occurrence of headache and neck pain. So there is a term called as cervicogenic headache or headache giving neck pain. So these things coexist. Earlier, we were not very sure why it is happening because cranial nerves are separate from the cervical, but there is this confluence which is happening in the cervical region. So this part is called the trigeminocervical complex. And as I said, it is extending from the medulla into the cervical region. So all of these areas, because of this, the convergence of pain happens. And this, incidentally, it has become a good area for nerve modulation. So now, if you want to do a neuromodulation, what would be your targets? So basically, when you are looking at it, going from bottom to the top. So we've got certain targets. For example, the periaqueductal gray, the thalamus, insula, and the primary sensory motor cortex. These are the 4 important areas. Apart from that, there are a few more, like the prefrontal cortex and various other things. So how are the pain signals reaching there? You have certain chemicals. So the ascending chemicals, there are lots of these, the CGRP, substance P, and all of these kind of things. And there are certain inhibitory ones. For example, the endocannabinoids, opioids, which we try to increase the effect of these things to give an analgesia. So these are all the positive and the negative activating chemicals that are present in your pathways to control. So these are the things that we can chemically modulate by using a stimulus on these things. Similarly, you've got some descending inhibitory pathways where your 5-hydroxytryptamine, again, activation of opioids, dopamine, noradrenaline. These are some of the chemicals which will help in descending inhibition. So these are some of the things, and we will go a little bit further. When we are talking about neuromodulation, these days, we've got a lot of advancements. Broadly, it is divided into 2 categories. Category 1, as I say, it is a non-invasive components have come. And particularly from a dental point of view, these are some of the things that could be used as their name says, non-invasive. Of course, there are certain invasive procedures where implants can be put into the patient. They could be either centrally, like deep brain stimulation, or peripherally, various other nerves could also be stimulated. So we'll go roughly kind of few minutes about each of these things. For the non-invasive, we all are aware of a word called TENS machine. So this is the transcutaneous electrical nerve stimulation is what we call it as TENS. We are all aware of it, where you send small doses of low voltage direct current stimuli onto the respective nerve under the skin. So as you're doing that with tiny doses of electrical pulses, you can activate the gate control theory. That is what it works on. And then in facial pain, it could be helpful in some of the disorders. For example, TMJ, trigeminal, facial nerve pains, or neuropathic pains in various areas. So you could give some relief to the patient. There is certain evidence to that. Some meta-analysis are also available for this. So it says the total number of headache in migraine patients can come down. Similarly, the intake of analgesics also goes down. And there is decent responder rate. Usually we find about 30 to 40% of patients respond to TENS machine, which is decent for a non-invasive technique. So taking the TENS machine a little further, we have what is called an external pulsed RF. If you look at it, the machine is very closely resembling our TENS machine, but along with the TENS waveform, which is a direct current, you also have got a radio frequency current, which is going along with that. Say, for example, if you can see the top on the left-hand side, there is a waveform, which is a direct current waveform. On the bottom left side, what you are also seeing is a pulsed radio frequency current. Now, what this machine does is, StimPod, what it does is, it is overlapping these two things and delivering it to the patient. And this electromagnetic waveform is altering the cellular metabolic activity of the nerve, thereby reducing the neuropathic pain. So you titrate it, you do a 10 to 15 minute cycle to the patient, you select 2 or 3 points, and then you select the right frequency and the current amplitude, and then you deliver about 10 to 15 minutes of treatment to that. And you do it on multiple occasions. Maybe generally what we do, about 5 to 7 sittings to the patient, maybe every alternate day or so. And the results are, there is decent amount of positive response, particularly in patients with migraine and various other situations, like in this particular case, it is trigeminal neuralgia. So the scores have significantly reduced, as it is like almost like 50 to 60% reduction. And even for diabetic neuropathy, I've used it, and that is pretty decent results. Now, another non-invasive form that we have is called as a repetitive transcranial magnetic stimulation. Those of you who have got access to big psychiatry services or maybe teaching hospitals, you would be acquainted with this RTMS. Here, you put an induction coil on the patient. Once the induction coil is put in, you identify the right area on the brain. You put these 2 coils, as you see on the picture, and you locate the particular area. In this particular place, it is a prefrontal cortex. And when electricity is passed through this, as you can see through the induction coil, as current passes, magnetism is generated. This magnetic field is directed into the patient, and the nerves get activated. When the magnetic field is activating the nerves, the electrical signals in the nerve gets activated. So if you look at it, the magnetic field is converted, electrical field is converted into magnetic field, and the magnetic field in turn is activating the nerve, and in turn, the electrical impulses are altered. So this is how RTMS works. It is relatively non-invasive procedure for the patient, and you can choose your targets on your brain. For example, it could be motor cortex, it could be prefrontal cortex, or even various other somatosensory components, including thalamus. You can go much deeper, and then here you use the right frequencies to give good analgesia. This RTMS has got role in various places. If you look at it for cognitive dysfunction, for dysphagia, anxiety, psychiatrists use it a lot for severe acute depression and things like that. And it is also used for so many places it is being used. But we are concerned with pain, and particularly when it comes to headache, what you are seeing it is on the right side. There are so many things for primary headaches, various secondary headaches, and things like trigeminal neuralgia, post-therapeutic neuralgia. In these kind of situations, RTMS has got a good role, right? So what happens in an RTMS? When you send the magnetic pulse into the patient, and that converts the electrical signal, it is basically deactivating the NMDA receptor. It is reducing the dose of the interleukins and tumor necrosis factor alpha, TNF alpha. So thereby your inflammation is reduced. And similarly, the thalamus is deactivated. Thereby your pain transmission is reduced. And your dopamine, the happy chemical in your brain, is also activated. So these are the places where it is going to work. So I think the next one is called transcranial direct current stimulation. So again, this is being used. The results of that are a little lower, but it doesn't require a very expensive equipment as a RTMS, which costs more than 1 crore sometimes. But this is a much more simpler device which you can use. Results are a little, because of the unpleasant sensations, it's not very easily accepted by patients. So now, I have had a good experience with lasers these days. Lasers are another light-based device. Earlier, we were talking about electricity, we talked about magnetism. Now we are talking about light as a source of analgesia. As you know, lasers can penetrate much deeper into the body, and you can choose, depending on the type of laser, how deep it can go. Right? So here, what we are showing is laser, which is a low-intensity laser. So what is laser? It is a single wavelength of light source which can alter the cell and tissue. It can be helpful in quite a lot of peripheral nerves, and it can also have a good role in patients with mucositis or burning mouth syndrome. So laser is something which has been used these days, and I've been using it very nicely. So what is the mechanism of this to work? So basically what laser does is it causes healing and repair of the tissues by activating your ATP release, the reactive oxygen species, and the nitric oxide. So these are the important chemicals which cause nice vasodilatation, oxygenation, thereby tissue healing and repair. So various other theories are there to show how laser would be working, and that's all a complete chapter on its own. So next thing is botulinum toxin. So we're all aware of the onabotulinum toxin A and B and various other things which are coming these days. So botulinum, now we are slowly getting into the interventional part now. As you are getting into the interventions where this neurotoxin is released, I'm sure there would be lots of other talks on Botox, so I wouldn't go into the details of giving more information on Botox. But these things, when you are injecting into the area of pain, be it into the trigeminal V1, particularly in V1, I use it, V2, V3, or even into the intraoral, various other areas around the mouth and face. So botulinum toxin has got a great role. And this botulinum toxin, it travels both anterograde and retrograde along the nerve roots. It reaches to the central parts, and thereby it will give its analgesic effect. And these are the sites that we use for treatment of chronic refractory migraine, the Silverstein points, modified ones. And these days, a little further to migraine, as we talked about it, this is a non-invasive approved device by the US FDA. The device is called as the Kefli, that we use it for migraine, where electrical pulses which will be generated and delivered around the areas, the plexus of nerves which are present in the forehead and on the auriculotemporal region. The episodes of treatment will be about 60 minutes for acute pain and 20 minutes for prevention of chronic migraine. So there is this team study which gave good outcomes for the Kefli device. Still not completely available in India, but can be used. Similarly, other non-invasive vagal nerve stimulation, and that could also be used for various other pain problems, including migraine and cluster headache with positive responses. I'm just running through because of paucity of time. And you have these days the transauricular devices to stimulate the vagus. Incidentally, these were the first devices which are used for vagal, and still it is being used in some centers. And now coming to the more invasive procedures, which is the pulsed radio frequency. Here, at 42 degrees centigrade, roughly around 42 degrees centigrade is delivered around the nerve root or the nerve. When you deliver it, you can alter the signal transmission in the particular nerve. In this particular picture, what we are showing is it is actually going through the foramen ovale, and the needle is traveling through the foramen ovale to the Gasserian ganglion. And once it is stimulated, you can change rather than ablate the nerve and still get a pain relief. So we've done a paper on that. The results have been pretty good with this one. But then if you have an old patient who cannot come many times for you, And I would still go with a radiofrequency ablation or a balloon compression. And then for some of the other patients, particularly if you're talking about the peripheral nerves like supraorbital or supratrochlear or auriculotemporal kind of nerves, you don't want to ablate them, in which cases we would still go with the pulsed RF. Patients, I've had quite a lot of patients who had intracranial lesions where you would not be able to do a complete radiofrequency ablation of the nerve. In those cases, we've used pulsed radiofrequency of the trigeminal for good responses. So next coming is the peripheral nerve stimulation. As you see, as I was talking about the peripheral nerves, you've got the supraorbital nerve, supratrochlear, and the forehead. Similarly, you've got the infraorbital or the mental nerve. Sometimes you've also got the occipital nerves. If these are the nerves which are causing the pain, like occipital neuralgia or a V1 neuralgia kind of thing, so you can place your electrodes around those nerves and get a good stimulation and good pain relief. So I've got a paper on this, which actually shows almost there is a 30% lead migration. This is still an ongoing problem with most of the peripheral nerve stimulation techniques. So you can cause erosion of the skin, infection, or a seroma, because these are present just under the skin, particularly in the occipital region. If you lie down, slowly it can erode through the skin. So you have to keep this in mind. Until the day we get good quality electrodes and the devices, so the uptake would be a little lower. So the third one, as I mentioned to you, is the occipital nerve stimulation. So where you have the greater, lesser, and the third occipital nerves, which are present on the back of the neck. And these nerves with an octrode. Here, this is an octopole electrode. You are stimulating for an occipital neuralgia. So this electrode is connected to an implant pulse generator. And this pulse generator can be adjusted and programmed from outside, thereby giving a good relief. But as I said to you, the movement of the electrodes, the erosion of the leads, infections, these are ongoing problems for quite a lot of patients. Yeah, as I mentioned to you, supraorbital, infraorbital, all of these things which we have done before. So this is auriculotemporal nerve stimulation. Again, this can be used for TM joint syndromes, patients with refractory migraines, where you can put 3 electrodes if it is on one side, which is the supraorbital, greater occipital, and the auriculotemporal. You can use all 3 of them simultaneously. So if you have an autonomic problem and recurrent injections of the spinopalatine ganglion block is not very effective or not long lasting, you would try and do an ablation. And if your ablation is also not very effective, you can actually put an electrode around the spinopalatine ganglion. And here you can see it is going through the that vase-shaped structure, and you are actually stimulating. This is just sitting under the V2 nerve. The maxillary branch of the V2 nerve, it is sitting under, and then you can stimulate that. And you've got a device which can be placed and fixed with little screws here, and it can be operated in remote. So similarly, vagal nerve stimulation, but then this requires a surgical procedure to implant the electrode around the nerve. So this can again be used for cluster headaches and migraines. And of course, previously it was used for the epilepsy and depression. Similarly, trigeminal nerve stimulation. You can put your electrode on the trigeminal nerve root and then stimulate. And generally, you will be able to get the ophthalmic, even the ophthalmic. I mean, of course, maxillary and mandibular, you can always get it. But reaching out to ophthalmic is always difficult for an RF ablation. But this is more effective for that. Without causing complete numbness of your face, these things can be helpful. So earlier, I was talking about the, I've got another 4 minutes to go. So earlier, I was talking about the trigeminocervical complex, correct? So the confluence of the neck nerves and the facial, the trigeminal nerves, they go into the spine, and the junction between the medulla oblongata and the upper spine, it's called as the TCC, trigeminocervical complex. So the whole premise of the high cervical spinal cord stimulation is You put the electrode so high into the spine, and thereby, when you stimulate the upper cervical spinal cord, you are all stimulating the trigeminocervical complex. Thereby, you can give a good control of your facial pains. So very interesting concept. It has been tried and quite successful, particularly in patients with cluster headache and various other facial pains. So these are more of neurosurgical procedures where the areas concerned with the thalamus, globus pallidus, and the subthalamic nuclei that you can see on the right side of the picture, they can be stimulated by putting a little electrode into those areas, specifically stimulated into the targeted areas. And then this is connected to, on the left side of the picture, through a little hole on the cranium, you go and put the electrode, and that is actually connected by tunneling under the scalp. You bring it to an area of convenience. Like a pacemaker, it is placed onto the patient, and it can be remotely programmed. Thereby, you can give good pain relief to the patient. So this is a procedure called as deep brain stimulation. So the electrode is put in deep inside the brain. So yeah, this is what we're talking about. So the electrode is present much, much deeper around the ventricular areas. And yeah, so this is pretty commonly used these days for patients with post-stroke pains or even with Parkinson's disease. The other one is a motor cortex stimulation. So you're putting electrodes on the surface of the cortex. So this is again used for post-stroke pain and, as I said, phantom limb pains, spinal cord injuries. So yeah, broadly, these are more invasive procedures that we were talking about. So we've started from a very non-invasive, minimally invasive to more invasive procedures, low-tech to very high-tech equipment. So there is a lot in the area of neuromodulation. And particularly because the facial nerves are always not very accessible, these are some of the techniques that we could resort to get a good pain relief. I think I'll stop my talk here. So the area is getting very vast these days with facial pain.
Yes,
So
sir.
hopefully you will all get benefit by that. Thank you very much. Any questions?
Yeah, that the whole idea is this interdisciplinary approach that we need to have for pain management. And thank you so much, sir, for gracing us every year with your talk. Thank you so much again. And you can address the chat box later on, maybe if there are any questions, because we'll call in the next speaker. So if you have time, you can check the chat box later on, sir.
Thank you very much,
On
ma'am.
that note, I would like to welcome Dr. Saurav. Thank you, Dr. Vijay. Can you stop sharing the screen so that we can take our mandatory picture with the speaker?
Am I off?
Still not.
Just 1 second. I'm coming. Oh, yeah.
Doctor, those lines, I guess, were from your end only, because we
Is
tried.
it? I'm sorry then. Yeah. I got
Yeah.
it.
Again, smile for the camera, sir.
Oh, thank you.
Yeah. 1 second. Yeah. We see that you're a believer in God. So nice to
Yeah, a
see
lot.
that. Nice to see that, sir.
Thank you.
Okay. So see you next year around, sir.
Thank you
so
very much, ma'am.
And thank you for accommodating this last moment adjustment, sir.
My
Yeah.
pleasure.
On that note, I would like to welcome our next speaker, Dr. Saurav Shah. Hello, Dr.
Yes,
Saurav.
Dr. Sonal. Thank you very
Yes.
much. Hello.
Yes.
Good
One
afternoon.
second. Yeah. Look up and just smile for the camera. The mandatory picture I need with every speaker. Okay, Dr. Saurav Shah, his CV intrudes me because I'm quite impressed by the first line itself, that he chose dentistry over medicine. It's different. It's not heard of. In fact, I also maybe for a month or so I was in a dilemma after getting into BDS, that do I need to go back to medicine, because I had a medical seat at hand, because life would have been different. I would not have been sitting here. Maybe yes, maybe no. You never know. So Dr. Saurav Shah chose medicine over dentistry. That was his selected career path. And
Dentistry over medicine.
sorry, dentistry or medicine. Sorry for that. He graduated from the prestigious VSMP Dental College and Research Center, Nagpur, and he has been in clinical practice since 2010. His core areas of specialization include prosthodontics, full mouth rehabilitation, temporomandibular joint disorders, and in addition, in his to his clinical expertise, Dr. Shah also holds a Government of India design patent for TMJ disorder detection device. We would like to know about this device also, doctor, if you can share a few insights on it. I know it's a patented thing, but still we would like to know more. So, and one more thing, his CV that doesn't include is that he is an avid Facebook sharer of his work, because he wants to share the expertise. And I've seen very few doctors explain everything. He's open to that. Check his Facebook profile or the post he posts over the year he's been posting, and that's how I came to know about him. In fact, I always introduced him as why and what. That's what I always know about Saurav Shah. He is the person who runs behind why it has happened and what to do. So thank you, Dr. Saurav Shah, for gracing us again with, I think this is your second year or third year with International Official Pain Congress. Welcome to International Official Pain Congress Season 3. And I've been asking each and every speaker one question, intruding into their personal space. What is that mistake or what is that habit that changed you into becoming a pain specialist?
Yes. So first of all, let me thank you, Dr. Sonal, and MedSkill team for inviting us over here and getting plethora of speakers, great speakers over here. So to answer your question, what got me into pain? So when you see patients suffering from pain, and at that point in time, when you feel that you're not able to help them, and in search of that uh, answer, how can I help my patient to get relief from pain, got me into this orificial pain learning. And once I got associated with Dr. Davis and his wonderful team, it's an open ocean of orificial pain. So yes, I've learned leaps and bounds in past 2 years, 3 years when I'm associated with him. My special interest. I am basically a clinician, so I started with full mouth rehabs. Those full mouth rehabs, I got to know that they may or may not interfere with TM joints. I began treating temporomandibular joint disorders, and that is how my journey to the orofacial pain began. So yes, Dr. Sonal.
Wonderful. And on that note, can you start sharing your screen? Dr.
Yes.
Meenal Chandra, are you in the chat room or are you in the Zoom room? Just switch on your camera, madam. Okay, Dr. Saurabh, sorry for this interruption. Please continue.
No issues. No issues. So is my screen visible?
Yes, you can go on the presenters mode.
Yeah.
Yes, please go ahead.
So good afternoon and warm welcome, everyone. Uh, I'm Dr. Saurabh Shah. So when I was approached for this pain or facial pain lecture to be taken up, I thought of doing a slightly unconventional thing. So we all physicians assembled over here basically want to know more about pain, and somehow we concentrate more on the management part of the pain rather than learning the physiology, how the pain occurs, why does it occur, and why pain is such a different and a difficult modality in medicine, where we cannot evaluate pain as, for example, if we want to evaluate a temperature, we have a thermometer. 101 fever for a patient would be same for all, but unfortunately we still do not have anything that can gauge a pain, and we need to rely on patient. So that led me to thinking that why not do a short presentation on pain. Can we call it as a boon? Is it beneficial to us, or it pain as a concept is a harmful for us humans as a species? So I have tried slightly to talk on that and try to convey my point over that. So my affiliations, I'm afflicted to SL Raheja Hospital as an associate surgeon to Dr. Taufik, member of AOP, IOP, and accredited member of IACD. So going ahead, pain. So when we first hear the word pain, or I'm very sure we ask patients like, what type of pain you have, or how can you uh, accurately convey your pain. So I'm very sure we can give 5 or 7 on tip of our fingers, like boring pain, lancinating pain, throbbing pain. But I was very surprised to come across this slide that here more or less there are 75 types of pain which patients describe: pulsating, pinching, frightful, punishing. You can pick your one and say those. So there are so many types of words or ways to describe a pain a patient is having. That makes our job as doctors more difficult to understand the condition of patient and how what they are going through. So in search of that, I went ahead and then we go ahead with seeing how IASP, International Association for Pain, defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So here one point is very important, that a tissue need not be actually damaged to perceive pain, for a patient to experience pain. So potential tissue damage is a very important term over here. And we as clinicians generally deal with the pain which can be classified as acute or chronic. So acute pain is any pain which is less than 3 months, and chronic pain can be considered as any pain which takes more than 3 months or has exceeded its normal time of healing. So, and as per underlying mechanism, it can be classified as inflammatory, nociceptive, neuropathic, and nociplastic. So, unfortunately, we as clinicians have been taught only to treat and manage acute pain. Majority of our clinicians, just a second, I'm very sorry. Unfortunately, we as clinicians have been taught to treat acute pains. We dentists, we clinicians, patient comes with a severe toothache. We are the best person to manage those condition for the pain. No other medical fraternity can treat a toothache in emergency as effectively as we can. We can give the patient a block, give him a warm cup of coffee, and within 15 to 20 minutes, patient is absolutely pain free. So I seriously doubt any other medical field can uh, effectively alleviate pain so quickly. But when it comes to a chronic pain, a pain which is being troubled by patient, a low grade chronic pain for over a period of months and years, unfortunately we somewhere lack our understanding and our management part for the patients. So in all, an acute pain can be considered as a boon because it is a response of body from the body from a harmful stimulus. It can be an inflammatory stimulus, a nociceptive stimulus, an infection, or a snake bite, or a threat. But chronic pain beyond healing capacity can be classified as a bane. I'll expand it further as we go ahead. So, yes, this one slide which shows that the education in the curriculum, pain curriculum in our health science is severely lacking. So if we see here in dentistry, only 15 hours is being taught to manage pain, or where comparatively veterinary medicine compares around 87 hours of managing pain for the patients. So somehow we as clinicians need to upgrade ourselves to teach, understand, and interpret the type of pain which our patients are suffering from. So this is a very nice diagram which shows the normal pain response to a stimulus. So nociceptive pain is a pain caused by peripheral nerve fibers in response to a painful or harmful stimuli. For example, touching a hot object helps us to remove our hand immediately. So nociceptive pain can be considered as a useful pain which helps us to prevent damage to our tissues, our body. If the nociceptive pains extends beyond a certain period of time, what we face is an inflammatory phase. To give you an example, a reversible pulpitis is a nociceptive pain where tooth is responding or giving stimulus to the body that it needs some attention. But if we neglect that and it gets converted to an irreversible type of pulpitis, a dental pain which is continuous, it becomes an inflammatory pain and needs immediate intervention. The third type of pain is a neuropathic pain, which is caused by damage or disease to the somatosensory system as a whole. So here, the management of pain, the type of pain becomes tricky, because here this pain which we call as a neuropathic or a nociplastic pain is a pain which becomes very difficult to treat, manage, and to overall relieve patient from it. So yes, I have described this, which can be considered as a nociceptive pain, inflammatory pain, and neuropathic pain. The examples of neuropathic pain we have been hearing since 2 days. Many clinicians have taken on that topic is post-herpetic trigeminal neuralgia, burning mouth syndrome, fibromyalgia. All these come under neuropathic pain. So one thing I would like to point out here is pain is a very vital quality which has enabled our species as humans to evaluate and to extend over here and to progress. Our species viable today. So if imagine if we do not have a pain, we would not reach adulthood. We would do so many dangerous things that would not sustain our species today. So fear and pain are two vital qualities that has kept our race alive today and progressing ahead. So this is a short video where it shows how pain depends upon not only from injury but even from the perception of injury.
Is there some volume being played with it? Because we cannot hear any volume.
Yes.
Is there any video volume?
So yes, so this is an animation made upon a very interesting study that uh, the body perceiving, the eye seeing, and the brain perceiving the situation as painful might amplify the pain as severe as actually having that traumatic event. So the inference with that video is pain can be perceived and amplified. It is basically a trick played by the brain without actual damage to the tissues. So pain is a concept of the brain designed to protect and for survival. Pain does not arise from the tissues but from brain where it is conveyed and interpreted as such. The above video confirms the reason as to why treating pain is a very complex issue. So when it is topped with changes in brain threshold, hormonal influences, pain perception, transmission, conduction, and modulation, each person with similar painful stimuli is ought to react differently. And this is what, friends, makes managing pain very challenging. So, so this is one part of the spectrum where a patient can pursue pain despite of any actual injury. And another spectrum is stress-induced analgesia. Here, if I'm very sure many of us have been through it, a patient undergoing severe trauma or soldiers, for example, soldiers in the duration of war, or sports person who undergoes severe injury, do not realize or do not show symptoms of pain until they're out of that situation. So that is the another spectrum, stress induced analgesia. So here it is again, an acute stress transiently reduces pain perception, producing analgesia despite of ongoing noxious stimuli. For example, a cricketer being hit with a ball on his hand or on his face, at that point in time he would not feel the pain despite being a fractured thumb or nose. So similarly, soldiers in a very stressful situation, they tend to complete their task and then give away to the pain. Again, this is because of the mechanisms of descending inhibitory pathways via various endogenous mediated opioids and enzymes. So clinical prevalence explains reduced pain during trauma emergencies and contribute to chronic pain, anxiety, and orofacial pain disorders. So our evolution of understanding of pain, which has evolved from 16th century given by Descartes to today, has changed tremendously. So initially it was just 1:1 relationship. Pain is equal to tissue damage, which was highly flawed. As we understood the mechanisms of pain, as we understood external influences of tissues affecting the pain, we have come far away to understand the pain model. And the current pain model, which is widely accepted, is biopsychosocial model, which takes not only the tissue, which considered as a bio, it considers psychological aspect and even social aspect of the patient. So here, this is where a person modulates or explains or shows the type of pain varies from person to person. So these are common factors, parameters which affect the severity of the pain. We all know nociception, painful stimulus, descending modulation of pain. For example, in stress-induced analgesia, the descending modulation reduces the pain felt to the person. Peripheral sensitization, as in acute trauma, acute painful situations. Central sensitization, it happens when peripheral or an acute painful stimulus is extended over a period of time and the nerve gets sensitized to it. Neurotag, pain memory. Any past painful memory for a person will elicit higher response and higher pain response to that stimulus. Cortical plasticity or neuroplasticity, neuroimmune, stress, beliefs, previous experiences, all these play a huge role on modulating the pain perceived by the patient. So now coming to our orofacial pain, orofacial region, where trigeminal nerve plays a very important role in modulating pain. It is a mixed nerve, has dual sensory and motor functions. It supplies to such a huge area that it represents almost 30% on the homunculus of the cortex of the brain. So, to understand trigeminal nerve, we have its four nucleuses: mesencephalic nucleuses, principal pontine, spinal, and motor nucleuses. So, the importance of this trigeminal nerve for orofacial pain cannot be understated, because the these nerves supplies right from the dura mater of our brain covering to the tooth, pulp, muscles of mastication, and sinuses, eyes, ocular muscles. So that makes this nerve very important for us to learn, understand in orofacial pain pathways. So yeah, so this diagrammatic representation shows the Gazarian ganglion supplying three V1, V2, V3 divisions. We have been seeing this, the four nuclei. This is the coronal section, and this is the sagittal section showing the coronae and the pathways. So these are the nuclei. Here comes the uh, principal principal nucleus, motor nucleus, mesencephalic nucleus, and the spinal tract nucleus. Spinal tract nucleus is can be considered as most important orofacial pain, relevant for the orofacial pain and the cervicogenic pain. So this is an image which I came across on an internet, shows such a huge complex distribution of the trigeminal nerve. If we see somewhere over here would be the Gazarian ganglion, from where we have this V1 coming out. This is the V2 and its branches: PSA, MSA, ASA. These are the V3: inferior nerve, lingual nerve over here, auricular temporal nerve, and this division supplying the uh, fronto-occipital cortical muscles and the dura mater. So this diagram shows us the vast extent of trigeminal nerve and its supply to the dermatomes. So again, here V1, V2, V3. The important part over here, which we heard on in the last lecture, is the cervical, the co-influence, the co-concurrence of the cervical nerves and the trigeminal nerve near the spinal tract nucleus of the trigeminal nerve. So here we have the convergence of the C5, C4, C3, C2, V3, V2, V1. So this makes us, it is required very important to have an understanding of the spinal nerves along with the facial nerve and the trigeminal nerve. So here again, when we are dealing with facial pains, we generally tend to neglect the facial nerve, which supplies the motor and sensory supply to the tongue and the facial muscles. It plays an equal part of supplying the musculature to the face. And the pain pathways, the regulating the ascending and the descending pathways, where the pain which is perceived travels through via Gazerian ganglion to the spinal tract nucleus to the cortex, where it is perceived as such, and then via inhibitory descending pathways it is uh, uh, response is generated for that pain. Coming to the referred pain part, again, as we saw, trigeminal cervicovagal complex, two types of pains which are very important to understand over here. One is cardiogenic pain and angina pain, which gets referred to the left jaw via trigeminal cervicovagal complex, and the cervicogenic pain, which refers to the muscle or the tooth. So the site of the pain and the source of the pain, I'm very sure, has been taken up in detail for in regards to muscle myalgia, muscle pains. So again, types of pain in orofacial region, we can consider acute pain or a good pain, which is important for us as trauma or dentogenic pain, periodontal pain, myofascial pain, and its referred pain. Chronic pain, which extends beyond period of 3 months, which are generally not always overlapping condition. Systemic conditions like fibromyalgia, arthritis, inflammatory conditions, Lyme's, complex regional pain syndrome, neuropathic pain, and central and peripheral sensitization. So this is a one busy chart, probably towards the end of my lecture, which shows in detail a comparative analysis of the peripheral sensitization and central sensitization. The peripheral sensitization is important because it is useful. It sends the impulse to an harmful stimuli, helps or brings attention of the body to something is wrong over that region of pain and needs to be done upon. Whereas central sensitization is due to repeated stimulus, increased excitability, and synaptic efficacy, which causes nociceptive neurons to continuously be active, continuously shoot, causing up pain, which probably is not useful and becomes very difficult to manage. So typical causes are pulpitis, periodontitis, trauma, TM joint inflammation. The central sensitization examples would be chronic TMD, persistent trigeminal neuropathy, nociceptive pain, glial activation. Pain distribution is in the nerve territory. Here, it is generally very difficult to identify the dermatome which the pain has taken up, the widespread pain region syndrome. Pain quality is sharp shooting stimulus. Here, it is allodynia, hyperalgesia, the aberrant painful sensations. These are the simple diagnostic imaging where we can identify the source of the pain. Here we need to go for an advanced imaging like sensory testing and questionnaire and functional imaging. Diagnostic approaches are clear. Uh, Explain the site and the source of the pain is explained. In central sensitization, pain is disappropriate to the findings. This is a biggest indication of central sensitization. Patient shows symptoms quite exaggerated to the stimulus or the problem that we see. We have pharmacological managements, non-pharmacological managements. So the pharmacologic management generally is NSAIDs for peripheral sensitization, local anesthetics blocking the peripheral nerve. Central sensitization, we need to work on the centrally acting drugs like PCAs, SNRIs, gabapentinoids, pregabalin, and modulation of these medications is required. Prognosis is generally very good if we
Dr. Saurabh,
identify the source.
can you just scroll it up because your prognosis line is not visible on the screen?
Okay, so I guess it's going beyond. So yes, I'll just read out the prognosis.
Okay.
Prognosis is generally good in peripheral sensitization if it is treated and identified early. In central sensitization, it is more challenging and requires long-term multimodal, multi-specialty approach to treat a central sensitization pain. So to bring a point here, we cannot treat central sensitization, we have to manage it. So that's it. So coming towards the end of the presentation, I always keep this slide in my all presentations. as a word of thanks and gratitude to my teachers and gurus to and to we can see beyond what we know only by standing on the shoulders of giants, and these are the giants for me whom I'm continuously learning. And thank you all for patient hearing on a slightly different topic. And yes, these are my contact details. The Facebook page which Dr. Sonal mentioned is the QR code over here. You can scan and would be happy to take your inputs on the posts that I have. So yes, Dr. Sonal,
Thank you.
thank you
Thank
very
you
much.
so much, Dr. Saurabh. And it's always a pleasure hosting you here in International Orofacial Pain Congress. On that note, yes, Saurabh, can you just say hello again? Because I would like to take a picture again with.
Yes, hello.
Just a second, wait. Yeah, smile.
Yeah,
I always take a before and after picture as we are used to.
yes.
Okay, thank you so much, Dr. Saurav, and it was a really enlightening session. And that slide summed it up. So I was like, I was wanting to have more. I was greedy there, so I said prognosis part also. If you could scroll it up, maybe later, next time. But
Yeah,
thank you for running us through the whole synopsis of what orofacial pain practice is all about. Thank you so much.
thank you very much. Thank
Now,
you, Dr.
I would like to welcome our next speaker, Dr. Meenal Chandra. Dr. Karpagavalli is our next speaker after Dr. Meenal. Dr. Karpagavalli had a very hectic night last night because she was having a night duty. So she requested me to shuffle her lecture slot there. So Dr. Meenal Chandra, hello. Yeah, can you unmute yourself, madam? Yeah, just
Hi, Dr. Sonal, how are you?
I'm good, good, good. Just smile for the camera, madam.
Sure.
Thank you so much. Dr. Meenal Chandra is a co-founder of Epion Center for Pain Relief and Beyond. She's based in Hyderabad. And Dr. Meenal, welcome to International Orofacial Pain Congress Season 3. You are no new person here. You have always been a part of our Congress. And thank you for taking out time on a busy Sunday and being here. And our participants are going to love your program. Ma'am, I'm asking each and every speaker one question, and I would like to know one book that has inspired you, one non-medical book that has inspired you to become the person you are today.
Basically, Dr. Sonal, a lot of very good thing to say, but I don't read books.
Okay.
So, but I cannot give you any book because I don't read books. I don't have that habit. But yes, there are people who have inspired me. I work with Dr. Sudhir. He's my mentor. He's the one who got me into pain medicine. And not only pain, he taught me, the journey of how to be a good doctor, how to present yourself, how to carry yourself. So that is the thing which I have also inculcated in myself. So as doctor, we always think he after my PG, I should publish these many publications, and then I should become this, and then have a decent salary and all. But he has taught me that as a doctor, we also need to think beyond our medicine practice, and then he got me into EPON, and then not only the regenerative that we have popularized, but also the entrepreneurship that he got into me. And then you need to discover your other aspect as a doctor, because as doctor we only are into so much of medical practice, learning, publications, patients, but he got me this aspect also. So basically it's a life learning for me rather than a book.
Wonderful, wonderful. Anything that inspires you, ma'am. Okay, ma'am,
Yeah.
can you start sharing your screen, please?
Yeah. So Dr. Sonal, is it?
Yeah, it's
See
getting
now?
loaded, I guess. It's getting loaded. 1 second. We'll wait for a second. Yes, can you go on the presenters mode?
Is it seen?
No, can you please go on the presenters mode? Yeah, please go ahead now.
Yeah. Since last 2 days, we have been talking a lot about facial pain. People have been talking, but the most common thing As a pain physician, as a musculoskeletal specialist, that I see is after back pain, people coming with TM joint pain. And over the years of my experience in regenerative medicine, what I have learned is joint preservation should be the first choice. And that's how my interest in PRP therapy for other musculoskeletal conditions also have grown. And IOPCON Pain Management Center is India's first center where we do an exclusive regenerative therapy for all degenerative conditions. Now, so many speakers have spoken about, just before me, Dr. Saurav was talking, and before that, Dr. Pratibha Mache, Dr. Vijay Bhaskar have spoken about how the era from nerve block to the era of neuroablation to the era of neuromodulation have come. So in these times, we were only trying to overcome the pain, but whatever techniques. But now it's the era of regeneration. And like I mentioned, we talk about joint preservation. So when we come to regenerative medicine, it's a simple branch. It's a simple branch of medicine that only deals with replacement, repairing and restoring the normal tissues and the normal function, what it used to have before it got damaged. Last year, I used to tell that, it is an experimental mode and then we need to do a lot of things. But there were some circumstances where, we got into some certain circumstances where I had to do a lot of extensive research with academically. And I realized that there are more than 20,000 publications proving the efficacy of PRP for various different musculoskeletal conditions. So now it is well proven and well practiced globally. And the aim is always one, and that is joint preservation. So TM joint, just briefing that, after low back pain, TMD, temporomandibular dysfunction is the second most musculoskeletal pathology, which impairs the quality of life. TM joint accounting to more than 5 to 12%, and in that osteoarthritis imparting around 18 to 85% cases of pain. And we know because of the muscular dysfunction, traumatic injuries, hormonal changes during menopause, joint changes, could be a disc displacement, could be just a degenerative changes. So we need to understand what are the changes that has happened inside the joint before we plan any regenerative, especially PRP therapy for the patient, because here we need to aim not only to reduce pain, but also make the corrective changes. So how much is the degeneration? Is there a destruction, loss of articular cartilage? There is any kind of subchondral sclerosis, osteophytes, microcapsule formation, synovial inflammation, there is fluid collection. All those things are there which we need to evaluate. Now, TM joint being a small joint as compared to other rest of the big joints, it is difficult. But we have certain tests, we have certain radiology parameters where we can identify it and make the assessment in a proper way. The symptoms could be joint pain, muscle pain, restriction of the mouth opening, deviation of the mouth opening, deflection of the mouth opening associated with headache, earache, toothache, nerve pain, sometimes mimic like trigeminal neuralgia. Usually the patient first goes to dentist because of tooth pain and they think it's a dental problem. And when all these things have been done and patients have been roaming from places to places and they have not found any kind of relief, a lot of psychosocial factors like stress, depression, anxiety, somatization, and as Dr. Saurav was talking about sensitization, the central and peripheral sensitization take place, and then it becomes very, very difficult to treat. So now here it has to be a holistic approach. Holistic approach, when we talk about, if I give PRP to a patient with a TM joint arthritis, pain is not going to come down immediately. So I need to see, like, through radiology, through examination, when we found out what are the changes that has happened, accordingly, we need to form a protocol. And in this era of treatment, it has to be customized protocol because we cannot follow the same protocol for all the patients. So in a holistic approach, our aim is first to reduce the pain. That is how the patient will be compliant to us. Second thing is we have to normalize the jaw movements and the mouth opening, because again, if the mouth is not opening, patients do not feed well, they keep on losing weight and all those things, muscle sarcopenia keeps on happening, all those things will also happen. Third is to prevent the progression of the joint. strengthening of the muscle supporting the joint, and also whatever damage has happened to the joint, we would want it to come back to near normal, if not normal. So it has to be a holistic approach through medicines, through lifestyle modification, through yoga, through massages, through exercises, apart from also PRP and other pain relief techniques. Now, what I have understood in my practice of a decade is the most important thing in cases like this, where we don't have a sure cut diagnosis, unlike other joint deformities and degeneration, counseling and talking to the patient is very, very important. Explaining the condition to the patient, because these are not things that regularly patients will be discussing amongst their family member. This is not something that patient is aware completely. So explaining the condition, explaining the procedure, what you're going to do, explain the success rate and need for multiple sittings, explain the time it is going to take for the result, explain the need of rehab, explain the lifestyle modification that patient needs to do, what we need to do from our side, what patient needs to do from their side. So giving a clear picture of the condition, of the treatment, the time it is going to take, and it has to be a 50-50 contribution from the treating doctor and also from the patient and the family members. And the thing is, not giving any false hope to the patient. Now coming to the subject of PRP, we understand that PRP, what is PRP? PRP is platelet-rich plasma with 2 to 8 times of the baseline. And platelets will have 30 bioactive protein. Healing hemostasis will happen through these bioactive proteins. Not 30, there may be more than 30, but the active proteins are this much. The active secretion of these growth factors, once we have injected into the joint, will happen within 10 minutes. And it will keep on secreting for the next 24 hours. And 95% of the growth factor will be secreted within 1 hour. Now, what is the mechanism of platelet-rich plasma? Platelet-rich plasma, like I said, lots of bioactive protein and growth factors. But the most important factors, what we have understood clinically and also with the researchers that have come up, is it has antimicrobial action, it has anti-inflammatory action, it has it helps in angiogenesis, promotes fast healing, it regenerates the damaged tissue, it restores the function, chondroprotective. So these are the publications that has been done, and where we come into the images and micro components that are undergoing when we inject PRP. The improvement in the chondrogenic differentiation, the lubricant that is released for cartilage repair, then M1, M2 macrophage polarization, decrease in the interleukins, which can be which helps in catabolic metabolism. So all these parameters have now been studied very well in vitro, where we can get conclusion that PRP is not only for its anti-inflammatory property, but it does restore the normal environment of the joint. And so PRP plays a very, very important role when we treat with musculoskeletal conditions like TM joint arthritis. Now, when we do the platelet-rich plasma therapy, there are various techniques. There are various commercially available kits. It all depends upon how good you are acquainted with which kind of commercially available kit you're using. Also, there are there are test tube methods where we use the PRP, which are done at the lab. But personally, I follow this commercially available kits. There are 4 or 5 commercially available kits which we practice in my clinic, and this is one of them where we use a double spin technique. So we take around 20 ml of blood and then we transfer it into the kit, and then we do the first soft spin separation where the RBCs which are heavier will settle down, which is done at a lower centrifuge RPG, and the second hard spin is done at a higher rate. Now, the settings are done machine to machine. Usually the first spin is at a lower rate and the hard spin is at a higher rate, and this depends on machine to machine. So I'm not mentioning about all this centrifugation things and all, because it depends on machine to machine which you're using. Now we have temperature compensated machines, we have all the settings done for male, female, so that will depend on machine to machine. Now, these are 2-3 machines which we use, Dr. PRP, and then we use Triacell Biologics, because we have been using since long, and we always make sure that, we calculate the baseline platelet count, and so that after preparation we make sure that we have 5 times the value of platelet, so that the effect what we want to achieve is achieved. Now, the technique, the first thing is consent. Monitoring the patient is very important. How small the incision may seem, but monitoring the patient is a rule that we don't miss in our clinic. Has to be done under aseptic condition, because we are going into the joint. Image guided, either CM or ultrasound, whatever you are acquainted with. Identify the joint space under fluoroscopy. We can do a dynamic testing by asking the patient to open the mouth, which makes our entry even more easier. Inject local anesthesia first, superficial needle in the skin, and then once the needle is into the joint, we give the dye and we see the dye spread and we are sure that we are into the joint. Then we can inject our plasma. Joint, it's a small joint, and so 1 to 2 ml of plasma would do a good job. And then again, monitoring the patient. Patient may require multiple sittings depending upon how much the damage is. So this is a case, a fluoroscopic image of a patient where under dynamic monitoring of fluoroscopy, we are doing the procedure. Now, I would like to talk about this very interesting case of a 52-year lady. She came from Dehradun after she saw one of her ad, and then she came to us for her trigeminal neuralgia. So she came to us and she mentioned that she used to have pain on the left side of the face, more while opening the mouth, and sometimes occasionally she would have burning sensation, sometimes electric shock like. And she also complained of headache, and she was on multiple treatment for tablets, and she was not getting any good relief. But because she came from Dehradun, which was a hilly area, which used to be always cold, and so doctors kept on telling that it's because of the temperature, and that her pain is not coming down. And they diagnosed her as left trigeminal neuralgia. She has been put on medications, but it was not relieving her, and she was a teacher by profession, so she has to go take the classes, and she used to be like really worried about her pain. So she came to us, and then we examined her, and her MRI brain FaceTime view did show a vascular loop on the left side. But when we examined her, we also found that there is severe tenderness at her TM joint. The mouth opening was restricted, and then the most, when we asked her to you put your finger and show us the pain, that was the place where she constantly showed us. So we also thought of screening her with MRI TMJ, and it did show the changes of TM joint arthropathy. So now the diagnosis of left right.
Sorry to interrupt you. Is there any other device near you which is echoing your voice?
I have my phone. I'll just send my phone outside.
Yeah, or you can mute it. It is echoing.
Yeah.
Sorry to interrupt.
Is it okay now?
No, the echo has increased for some reason.
No, I don't have any other device except for this desktop, and I sent my phone also.
Okay, maybe we'll check in another 1 minute. You can continue, ma'am.
Yeah. So then the diagnosis were clear for us that it is left trigeminal neuralgia with left TM joint arthropathy. But what we did not was very sure of is what treatment to give, because while we were also discussing amongst ourselves, some were very sure that it is the pain that she is suffering with is because of trigeminal neuralgia, but we thought that it is because of TM joint arthropathy. And so the treatment dilemma was there, but we took a step following, because she was not responding to carbamazepine, which she was put on since so many years. So that was one thing that was going against trigeminal neuralgia. And second thing is, she was having more pain while opening her mouth, which also made it towards the TM joint. So we thought of doing a diagnostic block for her first. So we did a diagnostic block with lignocaine and Kinacot because we were not very sure that, whether the patient will again come back or not. So, so we did, and the diagnostic block was positive. And then we called her after 15 days. And then we did platelet-rich plasma therapy for her. And now it's been 6 months that she is pain relief. We did this for her in July. Her quality of life has improved, and we have put her on good exercises and lifestyle modification and some anti-inflammatory and anti-neuropathic tablets because the sensitization has happened, and so we need to take care it by giving them prescribing her good anti-neuropathic tablets. Now, post-procedure, what we need to explain is about the chewing side preference, because we restrict the patient to chew from the same side for some time. And exercises, because activation of muscle is important. So hard chewing, we ask the patient to be on soft diet for a while. And after some time, we give them exercises so that, the activation of muscles around happen. PRP can cause a bit of inflammation, so ice application is important, and taking care of the say that symptoms like earache, headache, all those things have to be taken care of, so which we take care with the help of pharmacotherapy. Contraindication to our PRP therapy is patient refusal, thrombocytopenia, patient is on anticoagulant therapy, any active infection, any active tumor or metastatic disease, and pregnancy. And after coming to the treatment modality with PRP, going into literature, there has a lot of literature which has been comparing the other modalities of intervention like steroid or hyaluronic acid or macrocentesis with PRP. And we understand that PRP, because of its properties, because of its anti-inflammatory, decreasing the catabolic angiogenesis, all these property, and cartilage repair, PRP is a better option as compared to other modalities of intervention. So again, this was another study in which it showed that the PRP was effective modality of treatment. It did mention that it is used for early TMJ, osteoarthritis, which will give a better thing. But PRP in later stages of degeneration also should be done, because it will also help you in the internal repairing of the damage. So this is again another study where PRP has been proven to be an effective treatment for a TM joint, improving the function and not only relieving pain. So why should PRP be the choice? Because of its scientific underpinning, because we know that it's a natural thing. There is a science behind it. It is not associated with any side effects or complication. So it has a well-established safety record. And it's easy, relatively non-invasive in nature. It is going to correct the internal environment and can be well accepted by the patient. So take-home message when we talk about PRP is the selection of patients is important. The counseling of patients is important. PRP has to be coupled with multidisciplinary approach for better result. How you prepare the preparation and how you inject the PRP is very, very important. So we need to master the skill. Image guided, because now we are in an era where we easily have availability of ultrasound and fluoroscopy. Explain the do's and don'ts to the patient, explain the time which patient will take to recover, and make sure that you explain that there are literatures which says that PRP is yielding better results as compared to other interventions like steroids and hyaluronic acids. So these are my centers across south of India. Thank you so much.
Thank you, Dr. Meenal. That was really enlightening lecture, and I'm sure you will get many referrals now that we know these conditions can be treated very well by you. Thank you for this
Thank you.
interdisciplinary approach that you have shown us. Can you can you switch off your screen share
Yeah.
mode, and then we
Yes,
can
yes.
take a picture again? Yeah, smile for the camera. Thank you so much, ma'am. It's a pleasure hosting you every year. So
Thank
on
you,
that,
Dr. Sonal.
yeah,
It
please.
feels like home now.
Yeah, yes. I think you've been a part of majority of our programs. So thank you so much for your support, and your inputs are equally valued by all our participants. Thank you
Thank
so
you,
much.
Dr.
You can
Sonal.
visit the chat box later on in case if there are any questions, you can answer them. Thank you.
Sure.
Yeah, on that note, I would like to welcome our next speaker, Dr. Karpagavalli. Dr. Karpagavalli, can you just say hello to the audience here?
Hello, good afternoon,
Yeah.
Sonal. Am I audible?
Yes. Can you just camera can be lowered a little bit?
Sure. Is
Yes,
that
perfect. Yes, thank you.
This is fine?
Yes, thank you. Yes, smile for the camera now. Thank you, ma'am. And ma'am, it's a pleasure hosting you. I think this is our third Congress together. You've
Yes,
been a
yes.
part of our last Congress and the previous to that
True.
also. Dr. Karpagavalli has graduated from Annamalai University in 1991 and postgraduated in oral medicine and radiology from Sri Ramachandran Medical College and Research Center in Chennai in 2005. Actually, she's completed a fellowship, mastership. She has many recognitions under DCNA, MCNA publications, and she has published in JADA. Now she recently bagged Best Paper Award in 6th Congress SPDOF Portugal Society of Orofacial Pain, Temporomandibular Joint Disorder and Sleep Medicine, winning a check of, ma'am, should I share the check amount? No, no,
Not required.
no, not needed, right? Okay, we will share the amount later personally. Okay, currently working as Deputy Medical Superintendent and Orofacial Pain Consultant in SIMS Hospital in Chennai, and an adjunct faculty in Oral Medicine and Radiology at DY Patil Dental College, Pune. More than anything else, she is a dear friend, a person, a go-to person whenever it comes to needing any help. Just dial Dr. Karpagavalli and she's always there for you. So such a warm person, and I have always found her, that aura around her. I always say Dr. Josna and Dr. Karpagavalli, they carry an aura around them that is like a healer aura. So welcome to International Orofacial Pain Congress, ma'am. It's a third season. As I've been intruding, I know now whatever amount you have in your account. So going with that, what provoked you to become a pain specialist? What was that mistake or one habit? What changed in you that you became a pain specialist?
Okay, at the outset, thank you so much, Sonal, and thanks to Dr. Nurul also, because I've been knowing him as an oral medicine specialist for quite a long time. And IOPCON is a really wonderful thing that you guys have been doing. Maybe I am a speaker for you for the last 3 years, but I've been associated with you from the beginning as a participant as well. The first time you started, I was really happy to see that a congress or a conference is being conducted exclusively for pain. So that's really nice of you. And hello to all the delegates who are present here today. A warm welcome and good afternoon to all. To the question that Dr. Sonal asked, basically I am an oral medicine specialist, and I really love my subject and I'm passionate about, though it's oral medicine and radiology, I'm more of a medicine person. And in that, we get to see a lot of pain cases referred to us. But I don't think I had been doing justice to the amount of treatment and management I would say that I have been doing now, or the amount of knowledge enrichment that I've done in the last more than 5 to 6 years after knowing Dr. Thomas. So the first inspiration into orofacial pain came to me. As you know, I was working as a professor and head in Seema Dental College, Rishikesh for the last 7 years. And Dr. Thomas was there on a lecturing over there. And the day I met him, I thought we have been doing oral medicine for such a long time, but we have never thought that this pain could be taken as a separate specialty. So he was the one who told that that is a time when American Dental Association had made it as a special branch. So, and that is onwards, because I've been treating TN for a long time, and patients keep coming back, and recurrence and remission, and again they have refractory and all that, and we don't really dwell into the depth of it. So that's the time I decided that I need to first gain knowledge, and I believe in diagnosis as the most important part of pain management. We just don't jump into management or treatment. And that inspired me, and it keeps inspiring me. I wouldn't say that I've accomplished everything in pain. Like, as you know, I'm now pursuing PhD also. I don't know that it's never ending. Education is never ending, and science is something we have to keep updating ourselves and keep going on, like as my mentor does.
Welcome, ma'am, to International Orofacial Pain Congress Season 3. Can you start sharing your screen, ma'am?
Yes. Is my screen visible?
Yes, it is visible. Can you go on the presenter's mode?
Yes.
Thank you, ma'am.
So, as all of you would have been listening to orofacial pain and pain in general for the last, I think, almost 2 days, I could say, starting from 19th. Uh, my topic is something different from everybody. It is related to pain, but many of you, many of the speakers would have told you about in depth about reviews about pain and enriched you the knowledge, and some would have talked to you about their cases and experiences. But I'm just wanting to share to you, because I know that you would have already been enriched so much with all this. So I'm just going to tell you about my experience as a researcher in relation to orofacial pain. So I have taken this study and had completed this with the help of one of my postgraduate. So I would like to say that let's not stop with getting ourselves enriched with it and treating our patients. Let's go a step forward, and let's go on to orofacial pain research, because nowadays, research is a very integral part of our, let it be a clinician or an academician. We all have so much of research material in India, which is lacking in the Western countries. And if you can do a proper ethical research, we could come out with a lot of newer outcomes, because this is a field, this orofacial pain is a field which is not explored much by many. So, not only learning for a clinical background, I would all encourage many of the youngsters and many of you who are both clinicians and also who are doing postgraduates, take up small topics with related to pain and try and see what outcome could come out of it. So, when I was doing my fellowship and mastership, we were told that uh, the Bible that we read is Bell's orofacial pain. Okay, and in that it says that Weldon Bell says that pain is initially you have to think it is odontogenic. If not odontogenic, it is muscular. So muscular pain is what that you will all be coming across to a maximum extent in your day-to-day practice. And next, followed by the neuralgias and neurovascular, and so on and so forth. But as a dentist, okay, not only an orofacial pain specialist, I'm saying as a dentist, there are a lot of speakers who told you don't do wrong to patient. Actually, if you don't know something, stop at it and try and refer, or try and get yourself equipped with the knowledge of treating orofacial pain, and then proceed forward. But all of you would be coming across pain cases, so you can't just refer all the pain cases. So you need to know about myofascial pain or the muscular pain, which is one of the commonest pain next to your odontogenic pain, that is your pulpitis and periodontitis. And you would have come across people talking to you about what is myofascial pain and what are the various modalities. I think Dr. Divya must have spoken to you about in detail about the ultrasound guided trigger point injections and so on. So my study was like, trigger point injection is not the only modality. Okay, some say trigger point injection, some say therapeutics, and some say TENS, and there are so many physical therapy and so many things. So I went on doing a comparative study to see the efficacy of three modalities in the management of orofacial pain, and this is an original study. So before going on to the crux of my study, I would like to give a few introduction. This is an abstract of our study of myofascial pain. So myofascial pain is one of the common condition affecting approximately 30% of the people with regional pain. So when somebody comes to you with dental, and if you don't find any source of dental problems, then please do think about myofascial pain. And this myofascial pain is characterized by myofascial trigger points. So what you must be by now having an idea about what is the difference between a trigger point and a tender point. A tender point is in anatomical continuity, and a trigger point is something which doesn't have an anatomical continuity and it is referred to a different site. So a patient comes to you with the pain of a tooth, but that is not the source of pain. Okay, he says that the premolar is paining, but the tooth is totally fine and sound and healthy. So where is the pain located? So the localizing point for that toothache is your temporalis muscle. So it could be a muscle which could be referring its pain to any part of the body, that is the tooth or the joint or the in the face or anywhere in the area, the TM joint, anywhere in the head and neck region. So these are characterized by myofascial trigger points. So what are these myofascial trigger points? They are nothing but painful taut bands in the muscles. So they are something like a taut bands which are formed within the layers of the muscles. And this pain is usually localized, and sometimes it radiates to other areas and it leads to a dysfunction. Dysfunction meaning the patient is not able to eat, he's not able to talk, he's not able to have a normal quality of life. I won't bore you too much onto the classifications. I hope you must have been dealt about the orofacial pain classification, Bell's classification and all that. Just touching about a bit on the taxonomic classification of TMJ. This muscle pain or the myofascial pain comes under the category part 2. That is, it's category 1 pain and it's in masticatory muscle disorders. In that we have muscle pain. So muscle pains could be myalgias, which could be a local myalgia, which you all know means which is localized to a single area, or myofascial pain, which is a pain of in a region within continuity, and you have a myofascial pain with referral, which is there is no continuous pain. Okay, and you could also have tendonitis, myositis, which is inflammation of the muscle, and spasm of the muscle. So what are the clinical features that you should be looking to, or how will the patient present to you when the patient is going to have a myofascial pain? So Laskin has given certain criteria, which is known as Laskin's criteria. Earlier, this was commonly referred to as myofascial pain dysfunction syndrome or MPDS. So there would be a pain or discomfort in the muscle or in the preauricular region. The patient will have a limited opening of jaw, and there would be a clicking or a joint noise on the side of the region of pain. And on palpating the muscles of mastication, you would have tenderness of at least one muscle of palpation. Okay, that is, it could be a masseter, temporalis, medial or lateral pterygoids, the SCM, the infrahyoid muscles, and the suprahyoid muscles, or the upper traps and the cervical muscles as well. Another one most important point that you most of the time that we is included in the positive points of Laskin's criteria is the jaw deviation. So there could be a deviation while opening and closing the mouth. It's a deviation, it's not a deflection. The patient follows the same path of opening and closure. So it comes back to the midline. So what is the pathogenesis of the myofascial pain or the myofascial pain dysfunction syndrome? So it is being taught about as a stress pain stress cycle. So whenever you have a stress, you go on to clenching or grinding habits, and this causes muscle fatigue. And when there is muscle fatigue, it goes on to the spasm of the muscles of mastication, and this in turn goes on to pain. So all of you by now would be knowing something called DCTMD or RDCTMD. RDCTMD was the diagnostic research criteria for TMDs, and this is what is followed for as a to come to a clinical diagnosis, which is a bit complicated and may not be actually applicable in our clinical scenario, day-to-day clinical scenario. So later on, the research criteria was then modified as a DCTMD, which is a diagnostic criteria for TMDs. And in this one, you have axis 1 and axis 2. So axis 1 is a somatic one, and the axis 2 comes to the psychological one. Okay. In axis 1 clinical TMD conditions, you have the group 1. In group 1, you have the muscle disorders, in which you have the 1A is the myofascial pain, 1B is the myofascial pain with lifted opening, 1C is myofascial pain with referral, and 1D is the temporalis tendinitis. So you also have a DC-TMD examination form or a screening questionnaire, which is available online. So I would encourage all the youngsters and the researchers to utilize this form. So whenever you are doing a study or a research related to myofascial pain or TMDs, always follow the DC-TMD questionnaire. There is a screening questionnaire, there is an examination form. So utilize this form and use this as your, it's a validated questionnaire. So use this as your questionnaire rather than creating your own forms. And based on this, proceed with your research study. So this is the examination, DC-TMD examination form. And this DC-TMD comes out with the various descriptions based on which the ICD, the International Classification of Disease Criteria, has been marked. For instance, for myofascial pain, it is ICD 9 729.1 and ICD 10 M79.1. So what are the descriptions they include? They don't not only include clinical, they include history, clinical, examination, and to some extent, they also sometimes include radiological. And they also talk to you about the sensitivity and the specificity of this diagnostic tool with in correspondence to each and every diagnostic criteria that they are talking about, or the ICD that you are taking into inclusion. So here, if it's myofascial pain, the description is it's a pain of muscle origin as described for myalgia, with pain spreading beyond the site of palpation but within the boundary of the muscle when using the myofascial examination protocol. So as you know, it means that it is within the boundary, that is, it is in continuity of the muscle and it is in the myofascial pain protocol. So what is the positive history that you have to note? It will have positive for both the following, that is pain in the jaw, temple, that is the temporalis area, in the ear, in preauricular region, and pain modified. So whenever there is a functional movement of the jaw, the pain gets elevated, and when you give a rest, the pain comes down. So pain modified with jaw movements, that is either it could be a functional movement or it could be a parafunctional movement. So on examination, what do you look for? There will be positivity for all the following. That is, you will have confirmation of pain location in the temporalis or the masseter muscle. So you could be able to locate the familiar pain that the patient complains or comes to you with in either the temporalis or in one of the muscles of mastication. There will be report of familiar pain on palpation of the temporalis or the masseter muscle, and report of pain spreading beyond the site of palpation but within the boundary of the muscle. So the validity and the specificity for this has not been established. The pain is, when you come into comments, the pain is not better accounted by any other pain diagnosis. Other masticatory muscles may be examined as directed by clinical circumstances, but the sensitivity and specificity for this diagnosis is based on the findings that have not been established. That is, it means that there is no other positive pain other than the pain of the muscle. This is myofascial pain. Now you come to myofascial pain with referral. So in myofascial pain with referral, there's pain of the muscle origin as described for myalgia with referral of pain beyond the boundary. Here there is no muscular, there is no anatomic continuity. So beyond the muscle, boundary of the muscle, the pain gets referred to, being palpated when using the myofascial examination protocol. The spreading pain may also be present. So what do you look for in history? The positivity of pain in the jaw, temple area, the ear, preauricular region, and pain modified with jaw movements, function or parafunction. But the positivity for examination is confirmation of local pain location in the temporalis or masseter muscle, and report of familiar pain with palpation of temporalis or masseter muscle, and report of pain at a site. So when I palpate the masseter, okay, I have pain in the pain is felt in the tooth, the mandibular teeth, or when I palpate the temporalis, I have pain in the maxillary premolars. So the pain is felt in a site beyond the boundary of the muscle being palpated. So here there was a sensitivity of 0.86 and a specificity of 0.98. So a little bit to brush upon the trigger point referrals. So these are the referral points that I'm talking to you about. So myofascial pain with referral means, so when the familiar pain that the patient is experiencing with, the patient is complaining to you with a toothache, but this familiar pain is elicited on palpating the muscles, one of the muscles. So what are the muscles which refer to various regions or the various tooth areas or the odontogenic or the head and neck area? So in this picture, you could see the muscle, and the red region or the spots which are highlighted with red are the areas that the pain spreads to. So a masseter muscle, especially the superficial masseter, you can see that spreads pain to the malar region, to the maxillary molars, the lower aspect spreads to the mandible, the mandibular teeth, okay? And the deep masseter, you have the pain going on to the ear, the tapetum joint region, okay, and also to the forehead. So this is the trigger point referrals from the upper traps. Okay, you could see the trap muscles when you palpate them, and the suboccipitalis, the pain goes on to the head. Okay, that is the neck region, the posterior cervicalis region, the nape and the posterior back of the neck, and also to the shoulders. This is the trigger point referrals from the temporalis. So the anterior temporalis, this follows an anatomical representation. The anterior temporalis to the anterior tooth, the middle temporalis to the premolars, and the posterior temporalis to the maxillary molar regions or the maxillary posterior teeth. So this is another important muscle, that is the sternocleidomastoid muscle, which we have all read in our first year of BDS in anatomy. So, sorry. I'm sorry about that. So you have a sternal division and a clavicular division. So in the sternal division, you could see that the pain from the sternal division of the sternocleidomastoid radiates around the ear, okay, then to the vertex, the posterior part of the head, and also to the submandibular region, and some amount to the chin. And the clavicular region, you have a bilateral pain of the forehead. This is very, very classic. Somebody comes to you with a bilateral pain of the forehead, headache, you should examine the clavicular branch division of the SCM. And also pain radiates into the ear and postauricular region. So now we have an idea about what is myofascial pain, okay, what is the etiopathogenesis, and how does it clinically present to you with the DC-TMD classification, and what are the referral points. Now we should also have an idea of how do we go about managing it. So when we talk about pain, remember one thing, don't use the word treatment. You cannot treat a pain, you can only manage a pain. So make it very clear to the patient that you are trying to manage the pain. So somebody who comes to you with a 9 on 10 pain or an 8 on 10 pain, tell them that if you get the pain down to a 4 on 10 or a 3 on 10, that's a really great thing that you have done. Don't expect that all your pain patients should become 0 out of 10, which is not possible in all cases, because we are dealing with a chronic pain which the patient has been suffering from a long time, and it is not a single thing that people would have talked to you about the pathology of the etiopathology, the physiology of pain, the neurophysiology, the neuroanatomy. So it's a very complex thing. So don't expect that with some pills or some medicines or some kind of treatment don't promise a patient that it's going to become complete. You're going to treat him. You're going to manage his pain, and you're going to take him to a point that he's going to be having a better quality of life. So what are the modalities that we usually use for muscular pain management or the myofascial pain management? One is the therapeutic ultrasound, the trigger point injections, the low-level laser therapy, which is still in part of research, but people do use it as an adjunct therapy to pain. The TENS, or the transcutaneous electrical nerve stimulation, acupuncture therapy, hypnosis, the therapeutic modalities in which NSAIDs play a very important role, followed by centrally acting muscle relaxants. Coolant therapy, that is fluoromethane refrigerant and ethyl chloride spray. Phonopheresis with the use of ultrasound therapy and a topical NSAID. Iontophoresis, in which we use electrical along with the medication, and we use electrical conduction to make the NSAID penetrate deeper, so iontophoresis, muscle stretching, and cognitive behavioral therapy. So always remember, one modality of treatment may not give you a complete relief in myofascial pain. You may have to use a combined modality. So to go on with my current study or the original study, we thought of conducting this study mainly because some patients came out well with TENS, some people were very comfortable with trigger point injections, and some people again came back after a few weeks. So we thought an idea of, we started doing the study with the aim to compare the efficacy of therapeutic ultrasound, transcutaneous electrical nerve stimulation, that is TENS, and trigger point injections in the management of pain with myofascial pain. As you can see that I have not used the therapeutic modality, which is the NSAIDs and the centrally acting muscle relaxants, like cyclobenzapine and baclofen, and even clonazepam does have, in lower doses, does have a centrally acting muscle relaxant function. The reason being that it's all proven that definitely when you go on to therapeutic modalities, you will be able to give some amount of pain relief. But that doesn't complement the patient's quality of life, because you have a lot of side effects as well. And you cannot keep putting somebody on therapeutic medications like NSAIDs and muscle relaxants for a long term. So we made sure that we kept all our patients free of therapeutic dosage and only compared the efficacy of pain relief with these three modalities. So the objective of our study is to evaluate the efficacy of the therapeutic ultrasound in the management of patient with myofascial pain. Also to evaluate if there was an efficacy for TENS in the management of pain with myofascial pain, and to efficacy of trigger point injections in the management of patients with myofascial pain. First, we found the efficacy of each and every individual modality. Then we went on to comparing these three modalities among each other to see which was the best modality among the three. So we compared the efficacies of therapeutic ultrasound, TENS, and trigger point injections. The materials, the patients who reported to the outpatient department of oral medicine and radiology in Seema Dental College at Rishikesh, and we took a sample size of 27 patients who satisfied the DCTMD. So that is why I gave you a brief introduction about the DCTMD. So when you want to go on doing any research with respect to TMDs or myofascial pain, I would always advise all of you to keep the DCTMD as your baseline or the gold standard to go on for the sample selection, for with respect to what is the criteria or what is the group that you are taking in. So with 27 patients were selected with satisfying the DCTMD criteria for group 1 axis 1 myofascial pain, and the age range was 20 to 70 years, and they were further assigned in 3 different groups with 9 patients each. This was random allocation with blinding. So both the examiner as well as the person whose allocation were not aware of which group, and the patient. So it was a double blinded study. The patient, nobody knew that which group of study that he is going to be allocated to. So random allocation was followed. The inclusion criteria was history of persistent, recurrent, or chronic myofascial pain for more than 1 month, which was not relieved by analgesic. So some of our patients had already been on therapeutic medication, and they had tried it, and they did not get complete relief with the medications. So they should have been at least not an acute pain, but I could not say it would be chronic also, because the chronic criteria is 3 months and over. But at least there were a lot of patients with years together of pain, but at least in the last 1 month they should have been having pain, and which was not relieved by analgesics. The patients falling in DCTMD criteria in group 1 axis 1, and patients who have not gone for any medical or pharmacological treatment other than NSAIDs for the last 1 month. So they had not gone for any other pharmacological modalities like centrally acting muscle relaxants or any other Botox or any other medications, but they had just taken NSAIDs, and they were not relieved with NSAIDs and were having pain for the last 1 month. The exclusion criteria, we excluded all patients who who are medically compromised, patients who are allergic to the adhesives that we have to use when we tape these modalities, and to any material of adhesive tape or electrodes of TENS machine. And patients who have already been treated by any one of these modalities were also not included. So in the past, if they had undergone treatment with TENS or ultrasound or with any other, we never included those patients. So methodology, the group A patients were the therapeutic ultrasound patients. The ultrasound frequency that was used was 1 to 3 megahertz, and the duration was 5 minutes each session for 14 days. So we had gone through the literature, and we had picked up certain systematic reviews with respect to each and every modality, and followed that methodology. So based on the systematic review studies, we came out that for therapeutic ultrasound, there were studies which mentioned that it had come out that a minimum of 14 days, continuous 14 days, is required to see pain relief. So we had followed this methodology, and 5 minutes per session. And the mode that was used for the ultrasound was continuous method. Okay. The group B was the TENS patients who were treated with TENS, transcutaneous electric nerve stimulation. The frequency used was 70 to 80 hertz. As you all know that high threshold is used for muscles, and low threshold is used for nerves. And duration was 20 minutes, and each again here was 14 continuous day, and the mode used was pulse mode. And the group C was the patients who were treated with trigger point injections. It was wet needling, so it's not dry needling, and we used 0.5 ml of plain lignocaine without adrenaline, that is on trigger point, and it was given once a week for 3 weeks. And following this, all the 3 group of patients were followed up post-therapy. That is, if it is 14 days, after you complete 14 days, we followed up the patients for the next 3 consecutive weeks. Similarly, for if it's the trigger point injections, after 3 weeks, we followed them for the next following 3 weeks, once a week for 3 weeks, following the completion of therapy. So this is some of the pictures showing you the ultrasound, therapeutic ultrasound given in relation to the right sternocleidomastoid muscle. And this is a patient who is undergoing TENS therapy in relation to left and right superficial masseter and the upper traps. And this was a patient who underwent trigger point injections given in the right superficial masseter. So the data which accumulated was subjected to statistical analysis. So it was done using the SPSS 22, and it was assessed using the Kolmogorov-Smirnov test. And we also went in for descriptive statistics was performed using data summarization. Group comparison was done using one-way ANOVA, and Criswell-Coelus test with post-hoc was also done, and Mann-Whitney test was also used. And the follow-up analysis was done. There was a repeated measures of ANOVA and Friedman test for comparison was done over time. And we kept the statistical significance of P less than or equivalent to 0.05. And I would also like to mention that 10% of the patients were also done by, for the reliability of the study, we had we had repeated the test so that we will not have any bias. So the results, this was just the demographic data. So it was observed that the ultrasound group comprised of around 55% of females and 44% of males. And you can see in the TENS group, since it was I already told you it was random allocation. The TENS and trigger point injection group had more females and than compared to males. And this distribution of gender between the groups was not, obviously it was not statistically significant, that you could see that. Because we went in for a random allocation. So the results, here you could see that it was determined that 66.67% of 7% and 55.6 and 55.6% of participants in the ultrasound, TENS and trigger point injection groups were diagnosed with myofascial pain. So we followed the DCTMD axis 1 category group 1, which you know, which is myofascial pain with referral, and the other one is myofascial pain with limited mouth opening. So if you see, okay, the blue bar, that is the maximum So in all the three groups, we had maximum patient was myofascial pain. Okay, and approximately 22.2%, 44.4 and 44.4 are patients with myofascial pain with referral. So the amount of patient with limited mouth opening was very, very less. So most of our patients, as per the DCTMD, were in the myofascial pain group or in the myofascial pain with referral group. So this was the results. So you can see the results at none, week 1, week 2 and week 3. So at week 1, approximately 55.6% of participants had 3 trigger points. Okay, so while 33.3 had 1 trigger point. So majority of the patients had 3 trigger points at week 1, and a minority of them had 1 trigger point. By week 2, 44.4% of participants had either 1 or 2 trigger points, and around 11% you could say had no trigger points at all. And in week 3, 55.6% of participants, that is more than 50% of the group, had no longer had any trigger points. But however, 44% you could say had 1 trigger point as compared to the initial amount that they had. And this distribution was statistically significant. So this meant that all the 3 modalities, okay, after 3 weeks, so definitely had a good pain relief. That is the 3 weeks following that treatment, week 1, week 2 and week 3. Okay, and majority, I would say, had very good relief at the end of 3 weeks. So this is the individual division of week 1, week 2 and week 3. So if you can see ultrasound, TENS and TENS trigger point injections. So in this table, so we have the inference says that the participants in the ultrasound group, if you could see, had the highest VAS scores. So you all know VAS score is a visual analog scale in which you have the pain, and followed by the TENS, while the trigger point injection group had the lowest. So difference that is following the treatment. I'm telling about the following the treatment. So difference in mean VAS scores was statistically significant, or the P of equivalent to 0.39. When we did a post-hoc 2K test, following the trigger point injections were more effective than ultrasound, and the P was also significant. So however, that is when you compared the trigger point injections with the ultrasound and the TENS, okay, it definitely showed that the trigger point injection had a better, this is I'm telling in the clinical way rather than in the research methodology way, had a better outcome or the better pain relief or better diminution of the VAS score as compared to the other 2 modalities, and it was statistically significant. But when we compared the ultrasound and the TENS, which are both a therapeutic modality or a physical therapy modality, there was no significant difference between the VAS score after the treatment between ultrasound and TENS, okay, or between TENS and the trigger point injections.
Ma'am, 30 minutes mark, ma'am.
Yeah, just 2 minutes, I'm winding it up. So when comparing the analysis of the literature, this is comparing the analysis of our study, the present study, with the previous study in the literature, you could see that these are the various studies. There has been studies which have compared TENS only, and the next study is comparing only ultrasound therapy, the efficacy of ultrasound therapy. And this was one which used the trigger point injections, in which they compared lidocaine, dry needling and Botox. And there was a study which compared continuous and pulse ultrasound. And this study in 2019 is the study which had compared ultrasound, TENS and trigger point injections but using steroid. So as per literature, till our present study in 2025, there was no study in literature which had compared ultrasound, TENS and trigger point injections using plain saline. Okay, and our study, the outcome was the trigger point injection provided the most immediate pain relief. So remember this word, very important, the immediate pain relief. So when patient comes to you in week 1, most of the time the patient is free of pain. So to get a rapid pain relief or an immediate pain relief, trigger point injection had a very good role. But when it comes to long-term relief, it was similar across all the 3 treatment modalities, meaning that for a long-term pain treatment, long-term pain relief, both ultrasound, trigger point, and TENS had given us the same outcome. But if you want to make the patient go away of the pain immediately for an immediate pain relief, definitely trigger point had a very good outcome. So the conclusion of my study is that myofascial pain can affect any patients, including children, regardless of age or gender, with varying signs and symptoms. It is one major cause of musculoskeletal system disability, as it occurs in 37% of males and 65% of females at an age range of 30 to 60 years as per the epidemiological literature. No single best treatment. So again, I would like to stress it here that no single best treatment is I would advocate. So it is a multimodality approach which utilizes multiple modes of treatment modalities and also requires a personal touch as per each and every patient. It has to be personalized as per the diagnosis and your treatment planning for each and every individual. So the trigger point injections definitely has a fastest relief but temporary, requiring a long-term strategies. The TENS and ultrasound gives a slower onset of pain relief, but it is effective for long-term pain relief. So the conclusion of my study would say that do a combination therapy, that is, use trigger point injections for quick relief, and along with it use one modality, either TENS or ultrasound, for a sustained benefit plus physical therapy. Okay, a combined individualized approach is a key to effective long-term myofascial pain management. These are my references, and I cannot go away without thanking my guru and my mentor, Dr. Davis Thomas, because of whom all of us in this forum would agree that because of him and Dr. Shankar Iyer sir, that orofacial pain has stepped into the Asian continent and also into India today. And I'm very blessed and proud and privileged to say that I am one of his mentees, and I'm really thankful to you, sir. And my special thanks to Dr. Sonal Lerpudi and Dr. Norul for having me here today for the third consecutive time in IOPCON as a part of your speakers. And I'm thankful to all my postgraduate students who had helped me in the study, and to the patients who have been a part of it, and to my family and to my friends. And thank you all for a patient listening.
Thank you so much, ma'am. That was really a very well documented study, and it takes. I can understand the effort it takes in making these studies and documenting it so well. I would love to learn more about it in near future, like once you have completed the whole setup. So thank you so much, and it's always a pleasure hosting you in International Official Pain Congress. This is our third year together, and if you can stop sharing screen, yes. Now let me just introduce the next speaker. Dr. Dhruv, can you say hello to the camera?
Okay, ma'am.
Thank
Yeah.
you, Dr. Sonal, and thank you
Thank
all.
you so much, ma'am.
Yes. Dr. Dhruv, you started sharing the screen, is it?
Yes, ma'am.
Okay, can you increase the volume a bit, your mic?
Yeah, ma'am. Am I audible, visible,
Yeah,
ma'am?
better. Visible, I mean, I can see your screen now. So
Hmm.
you can start with the presentation. I'll take the picture and I'll ask the question later then.
No, that's
Let me
okay.
just
Anytime.
introduce you to the audience here. Dr. Dhruv Bibra is a international interventional pain physician, and he has multiple centers in Delhi for pain management. When I asked him for his bio, he said he's just an errant student of pain medicine. That is the apt bio I have ever received, because that's what we are. So welcome, Dr. Dhruv, to this International Orofacial Pain Congress. This is, I guess, our first year together, or maybe you were a part of some other conferences with the National Health Academy and MedSkills.
Yes,
Welcome
ma'am.
to
I
International.
was. Yeah. Thank you
Yes.
so much, ma'am. Thank you so much for the warm, kind invitation and a warm welcome. Dr. Sonal, ma'am, and Dr. Nurul, thank you so much for this. And with your permission, can I start, ma'am?
Yes, please go ahead, sir.
Thank you so much. So, few things before I start is one, I don't believe in the concept which is advanced. So, the easiest example that I can do is, for example, I come from a medical fraternity. So, for me, the biggest thing that I can do for a basic dental hygiene would be brushing and flossing. And for my friends who are coming from orofacial background, for them, and for me, an advanced would be an RCT or a root canal. That would be a super advanced because I have never done it. But for my for my colleagues who are coming from the orofacial background or who are oral surgeons, for them it is very basic. So because this topic was given to me, so I've tried to approach it in such a way. But trust me, all interventions uh, is based on your teaching, learning, uh, and the experience that you have. That's all. That is one. Second thing, why I feel that this kind of a topic is necessary, because as all of us have one motive, that is to take care of our patients who are suffering from any sort of an orofacial pain. Therefore, we should know the entire spectrum of things that we can do as clinicians to take care of their pain and improve their quality of life. With that, let us start. So there are certain basic principles of interventional pain that I tend to follow. Therefore, to be a dhurandhar of pain interventions, you need to follow a few principles. One is a sniper theory. Now, this is one thing which is often asked to me, that doc, why are we using fluoroscopy, ultrasound, dye? Why are we using all of this? But when I have been using the blind technique or paresthesia technique for nerve blocks for such a long time, because you need to understand that pain medicine is all about precision. We are taking help of all the available technology, whether it is fluoroscopy, whether it is ultrasound, whether it is a dye, anything, everything which science has to offer, just to make sure that we are able to take that sniper shot at the pain generator without causing any collateral damage. So it increases our efficacy, and secondly, it increases and reduces the side effects. So therefore, you need to be all of us need to be snipers. Second is, the often I'm asked, which intervention what? See, intervention never fails if we follow the triple R principle: right candidate, right intervention, right timing. If you follow these interventions, this principle, you can increase the efficacy of your interventions close to 80 to 90%. 100 is definitely a dream that we all try to pursue, but we have to be realistic uh, in order to minimize the failures and maximize our outputs. Try to follow these two principles. Now, I will be covering, though there are few things where we will be discussing. So advanced or intervention that we can do is, one is a regenerative thing, which I think has been covered by Dr. Meenal. I was through a talk, beautiful talk. Second is an ablative technique. So now in ablative technique is uh, basically, if we have any sort of a orofacial pain, there is there is a malfunctioning of the nerve. By ablative techniques, we can actually block the conduction of the nerve. Now that can be done by chemical, which is very old, radio frequency, and cryoablation. The basic uh, physiological change that is happening is that the conduction of the nerve is being blocked without causing any major structural damage. Now, how we can do that? We can definitely use chemicals, which are alcohol, phenol, glycerol, cost effective. They do have a role in today's time and in our country, where cost crunch is definitely an issue. Disadvantage, because it is like spreading water in a room, you can never be sure what all collateral damage can happen. Second is radio frequency ablation. In radio frequency ablation, we are using radio frequency waves to increase the temperature and cause a denaturation of protein. More precise, more targeted. Then we have cryoablation. In cryoablation, what we are doing is we are dropping the temperature, causing the denaturation of protein, and blocking the transmission of impulses from the nerve. Same objective, three technologies. Now, what all things we can block? We can block the somatic nerves. We can block the ganglion. Then we can even go for the autonomic ganglion. So we can go for Gazerian trigeminal nerve, supraorbital, supratrochlear. I think during the course of 3 days, it would have been covered. Mental, lingual, glossopharyngeal nerve. Now, glossopharyngeal where it's basically a neck pain which is more mild deglutition, but still it can have radiation up to the face. Then you have autonomic sphenopalatine ganglion and the greater occipital nerve, where the pain is mostly on the posterior aspect. So I will be covering few of them. So what is the basic principle of radio frequency? As I told you, so in radio frequency, what we are trying to achieve is we are trying to increase the temperature going beyond 42 degrees, so that making sure that there is denaturation of proteins which will interrupt the transmission of pain. This we have done. So how do we do it? So basically we have got a radio frequency generator through which we have a radio frequency probe. Then we have a needle through which the probe passes. Then once the probe is passed, we have a dispersing pad, so that in order to complete the circuit, because when you are doing radio frequency, it is using something like electrocautery. So if there is not proper earthing, the chances of burns is there. So this is the electrode that you can see. This is the needle. Now this is the active, the exposed part. So now if you closely see, this radio frequency needle is black. It is basically an insulated needle. The heating part will only happen in the exposed part. This is the electrode that we will be introducing in it. That is one. Now important part. Now we just concentrate on the active tip. Now when we are using radio frequency, the active tip gets heated up and there is a dissipation of heat. So we all know the heat tends to separate from the center and moves towards the periphery. So the part which is going to be close to the tip will have temperature going up to 80 degrees. Then as we move to 65 and 40. Now for any procedure to be active or for any denaturation of protein, the temperature needs to go to beyond 45 degrees. For that, the needle, so then that for that particular reason, the needle has to be close enough to our target nerve to cause a damage. Therefore, the target nerve one has to be placed parallel, so that it is causing this, because in this kind of a lesion we are creating a candle shaped lesion. So because it's an oval or a candle shape, the nerve has to be in the active part. So if you are in zone yellow and orange, then only you would be able to carry out an effective ablation of the nerve. Therefore, as I told you, coming to the first principle of being a sniper, therefore, based on history identification, you find out which nerve is causing an issue. Here we are talking about trigeminal. So therefore, the biggest challenge is in that kind is based on history. So how I try to identify it, taking a detailed history, making sure, showing them diagrams and asking them to color the area where they are having pain. Uh, that if you are still not sure, you can go for a peripheral diagnostic block and see how you are able to identify which nerve is causing the problem. That is one. Second is taking appropriate position of the needle. The needle has to be parallel to that nerve. Then only lesion can happen. Confirmation is the key. So these are, when before lesioning, we always stimulate to be sure. That is also one of the reason when we are doing this intervention in the OPD, when I'm talking to the patient, I make sure I tell them what kind of a cooperation is expected during the procedure. So once I get close to the nerve, I elicit paresthesia, and it has to correspond to the nerve division which I am trying to target. I make sure the patient is mildly sedated, awake, coherent, and able to communicate, that the patient is uh, experiencing paresthesia in the same region where he is having pain. It is a patience game, but till you are sure, till there is adequate satisfactory paresthesia, you won't be able to achieve anesthesia or blockage of the pain. You can go for motor stimulation also, but if we restrict our because we are, if we restrict ourselves to the trigeminal, only mandibular nerve, as we all know, has a motor branch. Therefore, when you are doing for a V3, then you will be able to get a contraction. So that is a positive thing, that yes, we have hit the V3, whereas in cases of maxillary, that would be a negative. So it will require a certain amount of repositioning. So these three things, identification of the nerve, needle, proper and paresthesia, will hold the key for doing a successful block. Now coming to the Gazerian ganglion. Now Gazerian ganglion is present in the Meckel's cave. That is one. They are placed one over the other, starts from V3, V2 and V1. Now there are two things there is two things that we need to understand. Because when we are doing fluoroscopy, what we are doing is we are converting a 3-dimension into 2-dimension. So the direction of these three routes are like, what we tend to do is from medial to lateral. So this is medial. We are going to lateral. So it is both 1, 2, 3, medial, V1, V2, V3. Along with that, it is um, arranged in a caudal to cranial. So it is going to be like this. Apart from medial to lateral, it is going to be medial, slightly up, slightly up, slightly up. So this is how it is going to be. So that is why we need to be very sure when you are introducing the needle. So this is exactly what I was trying to say. Not only from they are arranged from medial to lateral, they are also arranged from inferior to superior. How do we enter? Now we enter through the foramen ovale. Now foramen ovale is present in the posterior part of the sphenoid bone. What is coming out of it? It is the mandibular nerve, artery and lesser petrosal nerve. That is the entry point. Therefore, technically speaking, the first ganglion, the first root that we are going to come across is going to be the third nerve or the third root. So doing a V3 is relatively easier because we get it at the entry. As we start moving up, we come across V2 and then we come across V1. Generally, we tend to avoid V1 because it causes corneal anesthesia and a foreign body sensation to the patient, which can be quite troubling. But the entry point is the foramen ovale. As I told you, this procedure has to be done under fluoroscopy. When we are doing fluoroscopy, without going into the details, simply put, whenever we are setting a fluoroscopy, imagine fluoroscopy as your eye. So if we have to enter something here, the C-arm position has to be in a submental view, which is slightly oblique and caudally tilted. Plus, there has to be a neck extension, making sure that we get a clear view of the foramen ovale. Once we have introduced the needle, whenever we are doing fluoroscopy, as I told earlier also, we are converting a 2-dimensional structure into a 3-dimensional structure. Therefore, the needle position has to be confirmed in 2 positions. Minimum, you can go for multiple positions. What I generally tend to do is I tend to do in multiple positions or views, because once I'm sure, if I am at that point, whatever is the number of views that I take, I will be at that point. Easiest example to explain is that if I'm touching I'm trying to touch the nose. If you see right from the anterior posterior, you might get an illusion that I'm hitting the tip, but if you go through the lateral, there is a difference. So, but if I am touching it, whether it is AP, whether it is craniocaudal or lateral, you can be sure that I'm at the right spot. So once we have identified, as I told you, lateral is the mandibular, middle is the maxillary, and the medial most is ophthalmic. And at the same time, mandibular, because it is right at the anterior. So you have mandibular, then maxillary, and then ophthalmic. So moving from lateral to medial, along with that, you go from caudal to cranial. So these are the two images that you would be confirming. What I generally tend to do is whenever I am doing any fluoroscopy guided interventions, I tend to bend the tip of the needle so that I am able to appreciate the needle direction. And it helps in maneuvering also when we are doing the procedure. as I told that there is going to be paresthesia and sensory and motor stimulation. So we go for a sensory motor stimulation at 50 to 100 hertz, whereas we go for motor at 2 hertz. And as you can see, there is going to be a muscle contraction that helps us to identify that we are at the right spot. Once we have done it, we go for an ablative procedure. The temperatures that I generally tend to use is around 70, 80, 90. The time period is 60 to 90 seconds, 2 to 3 cycles. Patient selection, obviously, it is the most important thing when we would be using it. First is that there has to be a failure of the conservative management. So we start with oxcarbazepine and other neuropathic agents. The patient is giving us good relief. The patient has relief, able to carry on day-to-day activities. We don't rush for the intervention. That is one. Secondly, when we go at higher doses of carbamazepine or oxcarbazepine, there is a chance of sedation. If the patient is not able to tolerate that sedation, then we introduce interventions to that patient. A patient is not a candidate for MVD, which is a microvascular decompression. So therefore, any patients of trigeminal neuralgia, please ask the patient for a basic MRI. If you might be, or you might have done a lot of cases, you know that the diagnosis, but still, please go for an MVD. That is one. Secondly, anytime you see a bilateral trigeminal, then also there can be other systemic rare causes which might be causing this. Then there are recurrent TN symptoms despite previous MVDs. Complications can be paresthesia, anesthesia dolorosa, some sort of masseter weakness, nothing of concern. Corneal impairment can be there if we are targeting V2. So practically speaking, what we generally tend to do is we do an RFA of V2, V3 and give peripheral nerve blocks for V1. Regarding cryoablation, now in cryoablation, what we are using is a combination of argon and nitrous, where we drop the temperature. We drop the temperature to around 60 degrees. Therefore, we are able to bring about Wallerian degeneration, which stops the conduction of the nerve. Quickly moving on to one another ganglion block, which is the sphenopalatine ganglion block. Now, where we are using, definitely a choice for cluster neuralgia, cluster headache, atypical headache, for neuralgia, CRPS, other various neuralgias where you feel that there is some sort of a sympathetic overactivity. How do we know about it? That the patient will have any sort of what you say jalan, typical burning sensation, hyperalgesia, and allodynia, which would be in that particular area, and then you can have cancers. Now, for sphenopalatine, if the patient is having cluster headaches, they can be effectively managed by simple giving of oxygen or doing a intranasal sphenopalatine ganglion block. It is only in resistant cases where the frequency has increased or the patient is not responding that we go for this block. So how do we enter it? Though it's present in the fossa, which is present between the pterygoid process and the maxillary sinus. Now it is like a flask. The lateral entry is a fissure, spheropalatine fissure. Medially, it is bounded by the palatine bone. Opening, it has an opening into the sphenopalatine foramen. Now, in the nasal cavity, that is exactly what we target when we are going for a intranasal approach. So, any patient who comes where you feel that you have to do an ablative procedure of sphenopalatine, go for a diagnostic block. Easiest thing is just have some cotton soaked in local anesthetic. Ask them to go in an extended position, place it inside the nose. If the patient has relief after this, you know that whatever for the pain condition that the patient has come to you, this sphenopalatine ganglion is going to give you relief. Now here you can appreciate this flask shaped space which is present. Now interestingly, the ganglion is present in the upper part. So whenever you are trying to introduce the needle, it has to be done in the upper 1/3 part. So now again, here fluoroscopy comes in a big way. This is a technician's block. Why I say so is because it is a very simple, easy procedure to do. Only thing is that you need to get a perfect lateral image. Without going into a jargon of how to get a perfect lateral image, any structure which is on the left, on the right has to overlap. Right. So whether it is you take the mastoid, you take the what you say external auditory canal, anything, or even for that the angles of the mandible, it has to be perfect. So once you get that, what you will be doing is both the spheropalatine fossas will align, and then you can just enter in lateral position. Once you are inside it, you make it AP, making sure it doesn't cross the palatine bone, because that bone is very thin and it has a tendency of piercing even with a small little bit of pressure. So here you can appreciate again a small tip. People who are starting off or who are using, always try, bend a tip. That is one. And in fluoroscopy, bone is your friend. So rather than going inside, because the depth is always a challenge, try to hit the bony part. So try to hit the maxillary sinus. So once you hit it, you are sure, you just redirect it and go inside. Again, you need to get paresthesia and appreciate whether the patient will have generally and sort of a abnormal sensation, not typical paresthesia in and around the eye. This we have discussed. The needle has to be at the lateral part of the nasal fossa at the level. Fluoroscopic perfect lateral image, there is no about it. So people who are doing their initial few cases, what I'll request, both in cases of Gazerian and sphenopalatine, do a check scan. So for example, if you are planning a procedure after 5 days, take the patient in the OT, ask your technician to identify foramen ovale, ask your technician to get a perfect lateral spheropalatine fossa images, special lateral images, because that will help you when you are doing a procedure. Now coming to one more thing, greater occipital nerve. We know that it is a first line treatment for occipital neuralgia, chronic resistant headaches that are there. We can do a pulse radio frequency. Now pulse radio frequency, I think it was discussed in earlier talks as well. But in this pulse radio frequencies, rather than being ablative, it is neuromodulatory in nature. We all know the distribution of the occipital nerve. The patient will have classically pain in the back of the neck. This could be because of facet also coming from the cervical spine, but sometimes it can be because of occipital neuralgias. One more thing, with and I think the audience will also agree that for any neuralgia, specifically any entrapment based neuralgias, we need to identify the gold standard for any entrapment neuralgia or neuropathy is a diagnostic block. So whether it is carpal tunnel, whether it is occipital, go for a diagnostic block. If the patient has relief, then you can be assured that yes, we are dealing with nerve distribution from that area. How do we do it? We were using blind, the easiest way, palpate the artery, go lateral. But we have moved on. Now we are doing it in ultrasound, because in fluoroscopy, bone is our friend. In ultrasound, bone and artery are our friend. They help us locate it. Simple, you place it in. There are two approaches. One is you place the ultrasound in the occiput and you palpate, you move it lateral, you appreciate the artery, and you just go lateral. Now that is one. Second thing, but what we found out that there were a lot of variations which were there, and there the entrapment could have been present proximally. So what we devised was that now we have a posterior approach also. We start from the occiput, we scan it down. Once we have scanned it down, we see the bifid spinous process of axis. Once we have moved it, we just slightly tilt the probe towards the ear, and then or the transverse process of the atlas, and then we are able to appreciate the semispinalis and capitis muscle, and between these two muscles is the nerve. So you can appreciate we have this semispinalis capitis and inferior oblique muscles. Most of the times you will not be able to appreciate the nerve, but what you will be able to appreciate is one, a pulsating structure, which is an artery. That is one. Second, when we're doing what, whenever we are doing ultrasound, what we try to do is we try to appreciate the structures which are there. So in this is present between the semispinalis and muscle. So once we appreciate this is a bone, this is one, what you say, muscle. So this is one soft tissue. There is another soft tissue, and between the fascia is the um, artery and the nerve, and the entrapment of the nerve generally happens in these kind of fascias. So you can go inside, elicit paresthesia. The patient will have paresthesia in the distribution of the occipital nerve and would be there. So just to end, what would be strict asepsis monitoring, standard monitoring? That is one. We do all these procedures that we do it in an OT. Counsel the patient properly. Don't be in a rush. Do not over sedate the patient. The best thing about doing any intervention is that patient is awake. You cannot do anything wrong if the patient is awake. The patient is the best monitor. So do not try to over sedate the patient. Uh, Identification and obviously the targeting has to be there. Post procedure pain is common. Do not worry so much about the complications. They are relatively safe interventions. Uh, if we move on and have some in person, then we can have some live cases or something where we, and this is a good starting point. Proper counseling is the key. Trust me, the magic doesn't happen in OT or a procedure room. The magic happens in an OPD. And thank you once again for giving me this opportunity. It was a wonderful, it's a wonderful platform. A lot of things that even I learned. So thank you
Thank
so
you.
much. Feel free to ask any questions, anything. My presentation would be live, or if you want my presentation, nothing new, you can always have it. Not an issue.
Thank you
Thank
so
you.
much, Doctor, for that wonderful presentation. And actually, it is an eye opener for us also, where what is our limitation as a dental surgeon and when to approach you guys or refer for your referral.
Yes, ma'am.
Yeah, ma'am, sir, can you just stop sharing your screen so that we can take the mandatory photograph with the speaker?
Okay. Okay.
Yes, can you smile for the camera? Yes, Dr. Dhruv, you were open enough to say, ask me anything and I'll answer that. So, what message that you would be giving to your younger self? Rewind the clock maybe 10, 15, 20 years back. And what message would you want to give to your younger self?
So
In one
I'll
line.
take it. So sorry to interrupt you in your question, ma'am. Two selves I will talk to. One would be when I was just doing the med school thing. Everything will fall into place. Don't worry too much. Sabka ho, matlab everybody has a way. It will happen to you also. Some early, some late. Everything will happen. Don't stress yourself up. That would be one. Second would be when I started my pain career, first 5 years. I have no shame in admitting that I was a cocky pain physician who felt that answer to any chronic pain was a needle. If I put in a needle, the pain will go. But trust me, decade later, I have not only in pain, but also as a person, I have become a very humble person. I started believing more in the body and everything, that even if you do the best of the interventions, it is bound to fail. So you should be humble enough if you want to practice pain. So though that would be my message, not only to my younger self, but everybody who's starting off, be humble. Pain will make you, any person practicing chronic pain, any specialty, has to be humble, and everybody would agree to that also.
Yes,
Thank
sir,
you so much.
definitely. Because the kind of pain patients we
Huh?
are seeing, they are humbling us. And
Exactly.
I myself am a chronic pancreatitis pain patient, so I know what pain is. So thank you so much, Dr. Dhruv, and it
Thank
was
you so
it
much.
was really a pleasure talking to
Thank you
you.
so much, man.
We
Thank you.
will definitely interact in future also because I'll be
Thank you.
sharing my cases to you in future.
Sure. Thank you
Thank
so
you
much.
so much, sir. Thank
Thank
you.
you. Thank
And
you.
on that note, I would like to welcome our next speaker, Dr. S. Rajesh. Hello, Dr. Rajesh. Say hello to the screen, sir. Can you unmute yourself? Yeah.
Am I audible?
Yes, please smile for the camera. Dr. Rajesh, I'll be asking you the same question I'm asking Dr. Dhruv, that what is that one message you would like to give it to your younger self?
Maybe in the short duration of my orofacial pain career, I feel like never jump on the patient to treat the pain. First, without knowing what is the cause of the pain, and
Yes,
my advice will be to thoroughly undergo all the diagnostic procedures, because most of this orofacial pain may be having some kind of systemic symptoms, and it may be mimicking, and it may be indicating some systemic disease. So always look for systemic causes, and then try to treat the patient.
definitely, sir. So let me introduce you. Your Dr. S. Rajesh has completed his fellowship in orofacial pain (TMD), and he is also an associate professor in Department of Prosthodontics, MGPGIDS, Puducherry. I would say I would talk about the place you're practicing more about than anything else, because Pondicherry is one of my favorite go-to destination when it comes to holidaying. We have 3 days, and me and my husband will pack our bags and we are going to Pondicherry. We love that place. So you come from a very beautiful, serene, and a calm place. I'm sure I still don't understand. There are pain patients there also, because it's such a calm place. So, and still you're getting pain patient. That means location. The pain is it has nothing to do with the location. So as it has the biggest masquerade, what we say. So welcome to International Orofacial Pain Congress, Dr. Rajesh. This is your first session with us, and the stage is all set for you. Can you just start with sharing your screen, Doctor?
My screen visible?
Yeah, it's getting loaded. We'll wait for a minute. Yeah. Can you go on the presenters mode?
Yeah.
Yes, please go ahead.
Yeah. Thank you, Sonal. Thank you for your introduction. Good afternoon to everyone. First of all, I would like to thank the organizers and my mentor, Dr. Davis Thomas, sir, for providing me an opportunity to be present in this platform. And I'm very happy and honored to be part of this International Orofacial Pain Congress 2025. So today I'll be briefing on a topic, temporal artery tears and the pulse tells a story, which is basically about the giant cell arteritis that has a frequent involvement of the temporal artery in the head. And it also has a characteristic pulse which is associated with the GCA. Previously, this GCA was called as temporal arteritis, but the name is a misnomer because as it is a systemic vasculitis condition which can affect many medium and large arteries. So what is this giant cell arteritis or GCA? So it is a chronic inflammatory condition primarily affecting the medium and large arteries, usually in the patients older than 50 years of age. So it is a granulomatous vasculitis of the medium and large vessels where you have a lot of lymphocytes, macrophages, and giant cells which get accumulated, and you will have generalized inflammation of the affected vessels. So the coming on to the epidemiology, according to the Orphanet database, it is classified as a rare pain disorder with an annual incidence of 1 in 5,000 to 1 in 17,000 people, with a vast variation with the geographical location. So it commonly affects the female in the ratio of 2.5 to 3 is to 1, and it is usually seen in people over 50 years of age, with a peak incidence seen in 70 to 80 years. Coming on to the etiology, as such, the exact etiology is unknown. Researchers have associated the disease with several genetic and environmental factors, and large-scale genetic analysis reveal a strong association between the GCA and specific polymorphism between the human leukocyte antigen HLA-DRB104. So it is basically a cell-mediated immune damage which results in an intense active inflammatory response of the affected vessel. Multiple environmental and genetic factors may trigger this type of autoimmune type of inflammatory reaction. What are the risk factors for this GCA? As I've told, age, adults are the most commonly above age of 50 years are more commonly affected with this condition, with the signs and symptoms being developed and seen mostly in the age group of 70 to 80 years. Sex, female patients are more predominantly affected. One common characteristic of GCA is it is most commonly and it has a strong association with polymyalgia rheumatica, which is an inflammatory condition that causes the joint and muscle pain and stiffness, mainly the shoulder, neck, and hips. And 50% of the patients who have GCA will also have polymyalgia rheumatica. And very rarely the condition can run in families. And another important study is like increased diastolic blood pressure and smoking increases the risk of onset of GCA. What are the clinical features or most common associated features of the GCA? You have new onset headache of the temporal region over the 50 years of age patient. Scalp tenderness. Patients will demonstrate severe tenderness of the scalp patients will usually avoid combing their hair or brushing their hair, wearing headgears, or even resting their head on the pillow will be avoided because of the extreme tenderness. And another important clinical feature of GCA is jaw claudication. Jaw claudication occurs in usually 50% of the patients with GCA, which manifests as pain or fatigue in the mandible, and it's usually triggered by chewing and typically subsides upon cessation of chewing. Because this jaw pain or this jaw claudication mimics temporomandibular joint pain, GCA patients may be often seen initially by the dentist or orofacial pain clinic. And another important characteristic is minor jaw movements will not initiate any pain, whereas prolonged use of the jaw will cause the pain to increase significantly. And visual disturbances are also noted in GCA, which ranges from diplopia, transient monocular vision loss, ischemic optic neuropathy, and central retinal artery occlusion, which can lead to permanent blindness if it is not promptly intervened. Coming on to now let's discuss the characteristic of according to the pain mnemonic. The onset of the pain, the headache, the temporal headache will usually be of sudden onset in the temporal region, whereas the jaw pain, neck pain, and shoulder pain will usually be of a slow onset nature. Location, it is usually affecting only one artery, and very rarely it can be affected bilaterally. The frequency and duration, the temporal pain is usually continuous in nature with varying intensity from moderate to severe pain, whereas the temporomandibular joint and neck pain can be intermittent with 3 to 4 episodes per day, which is common. The type and intensity of the pain, as I told, it is moderate to severe. Another important characteristic is palpation of the temporal region. Will usually find a prominent, tortuous, very tender and enlarged temporal artery with reduced or no pulse being felt in the affected vessel. The quality of pain is in intense pulsating throbbing, whereas the other pain like temporomandibular joint and shoulder and neck pain can be sometimes burning and dull aching. What are the aggravating factors? The usual aggravating factors are chewing, pressure over the temporal artery, and physical exertion. So chewing, talking, or prolonged mouth opening, everything which increases the jaw movement and activity will aggravate the pain. The relieving factors are usually the medication, rest, and any proper head support. Thereby, the involved vessels are not compressed. So these are all the associated features which have been summarized in one slide, along with the primary symptom of sudden onset temporal headache. You will have ophthalmic changes, as I told, you will have diplopia, transient monocular vision loss, or ischemic optic neuropathy. And patients will also have systemic symptoms, which includes fever of unknown origin, weight loss, and symptoms of polymyalgia rheumatica can be seen. Patients may also have vertigo, ataxia, numbness, jaw claudication. As I told, patients will also complain of aching cramps in the masseter and temporalis. Another important characteristic of the temporal artery pulse is the pulse will be either reduced or no pulse will be felt. So coming on to the investigation, once the basic diagnosis has been done, a thorough investigation has to be done to diagnose the GCA. The three usual investigation which are done is the blood test. Blood test, the entire MAJA protocol will be followed. So thereby, you can usually see the ESR and CRP which are elevated. Imaging, we will be doing the color Dopplex, ultrasonography, MRI sequence, and fluorodeoxyglucose PET scans, which is the recently introduced advanced scanning technique, which will show thickened arterial wall, and histology of the temporal artery biopsy, which is the confirmative diagnosis for GCA, which will show panarteritis, that is inflammation of all the three layers of the vessels. Along with the inflammatory mediators like lymphocytes, plasma cells, macrophages, and interruption of the internal elastic lamina can be seen. So this is the blood test. Usually the ESR and CRP are elevated due to the reactive response to the underlying systemic inflammation. And also thrombocytosis, that is platelets, high platelets can be seen, which is mainly because of the interleukin 6 which is present, that stimulates the platelet production and releases from the bone marrow, which leads to the increased platelet as the body tries to heal the inflamed blood vessels. These are the imaging technique, the ultrasound, which shows the characteristic thickened arterial wall and narrowing of the lumen. So you can see the arterial wall thickness with the narrowing of the lumen. And this is in the transverse section. And the first slide is in along the longitudinal section where you can see the narrowing of the lumen in between the uh, pathway of the arteries. So whenever you have a suspicion of involvement of visual symptoms or any large vessel involvement, MRI and MRE are suggested to rule out the involvement of large vessels. The latest scanning image is the fluorodeoxyglucose PET scans, which when the larger arteries like aorta and major branches are being involved. So this is the imaging technique with fluorodeoxyglucose PET scans, where the inflammatory mediators will take up more of this fluorodeoxyglucose, thereby the affected vessels can be seen in the imaging. Next, the more confirmative diagnosis is the temporal artery biopsy, which remains the primary modality for the diagnosis of GCA. So the temporal artery biopsy is characterized by segmental and focal panarteritis. That is, as I told, all the three layers of the vessels, the tunica, adventitia, media, and intima will be involved with all the granulomatous inflammation with multinucleated giant cells. And then you can see this internal elastic lamina have been disrupted. Thereby, the lumen of the vessel is getting narrowed. Next, coming on to the management, one important emphasis here is that is the dentist or the orofacial pain, do not do any management. Once you have a suspicion of GCA, we immediately refer the patient to a rheumatologist and ophthalmologist so that prompt treatment can be initiated. Because the goal in GCA management is reduction in the ongoing inflammation, thereby preventing the ischemic organ damage. So in case if there is any vision disturbances, then you will have to start immediately with IV methylprednisolone, 1000 milligram per day for 3 days. And if the visual symptoms subsides later on, then we can switch on to the oral steroids of 40 to 60 milligram per day. Because of the significant common side effects with the high dosage of steroids like weight gain, glucose intolerance, diabetes mellitus, hypertension, opportunistic infection, and osteoporosis, newer drugs have been developed which are considered to be steroid sparing agents. So the two most common steroid sparing agents are the tocilizumab and methotrexate. Tocilizumab is a monoclonal antibody which acts against the interleukin 6 receptors, thereby it interferes with the pathway of your inflammation, thereby subsiding the inflammation. Methotrexate is also an immunomodulator which will reduce the inflammation, overall inflammation. And an important thing is this tocilizumab is the first FDA approved drug other than the steroid for the treatment of the GCA. Along with that, the EULAR criteria to GCA is immediately start with corticosteroids, and then we can add adjuvant therapies with tocilizumab or methotrexate so that you will be avoiding any refractory or relapsing disease. Emerging therapies other than this, you have a newer biomolecules like abatacept and ustekinumab, which are in the trial phases, and further studies have to be done for their efficacy. Then once the disease is under control, we'll have to go for thorough regular monitoring with ESR and CRP. Then we'll have to monitor the blood pressure, glucose, bone health, especially because of the osteoporosis risks. And we'll have to have a surveillance for any aortic aneurysm. So this is the flow chart for the treatment of management of GCA. So any visual symptoms, you immediately start with IV methylprednisolone. If it is improved, then you taper the steroid and maintain the condition with methotrexate so that you don't have recurrence. If there is no any vision loss, then you can start with oral steroids. If it is if the condition is still persisting, then you continue the steroids. Once it is improved, you taper the steroid and stop. If it is not giving any positive response, you cannot continue the steroid for a very long time. Then we can go with methotrexate so that you can control the disease to some extent. So what are all the differential diagnosis for GCA? As we have told, polymyalgia rheumatica is associated in almost 50% of the GCA patients. And then you have something called as Takayasu arteritis, which is also an inflammatory condition of blood vessels, mainly the larger blood vessels. And it also usually involves patients who are younger, that is less than 50 years. Then you'll have to rule out the trigeminal neuralgia, carotid artery dissections, temporomandibular joint disorder. So most of these patients will also have some kind of temporomandibular joint pain, because of which they may come to our help. So we should be very clear in identifying the disease and promptly referring the patient rather than treating unnecessarily. So what are the basic complications, various complications because of if the GCA is not treated properly and taken care properly? The first major complication is your irreversible vision loss because of your ischemic optic neuropathy. The arterial supply to the retina and the nerves are affected, because of this you can have permanent vision loss. Other rare complications when any large artery is involved is myocardial infarction, cerebral infarctions, aortic aneurysm, pericardial infarctions can be seen, and very rarely sometimes the tongue and scalp necrosis can occur. So I just want to conclude by just briefing about a report of a case of an young female patient presenting with symptoms with severe temporal unilateral headache. The patient had all the symptoms of suggestive of giant cell arteritis with associated red flags like numbness in the forehead and feet. So the patient had a temporal headache from last 5 weeks. On close inspection, you can see some slight swelling, which looks like along the course of the temporal artery. So this is the exact location where the patient was having pain. So a thorough, detailed case history was taken which showed some red flag signs like sudden headache on the left side from past 5 weeks, numbness on the right hand, and from 4 weeks, which is usually transient. Patient also complained like patient had numbness on the forehead and parietal region during the severe episode of pain. An important history of presenting illness was patient had some kind of influenza 5 weeks back, and the headache started immediately after the influenza episode. So, which suggests that something has triggered after the influenza, something has triggered, and the patient is having a moderate to severe pain of 8 to 10 in the VAS score. The patient had a pulsatile type of pain in the temporal region. So, a headache screening history also was taken, and this was all the summary of all the features which the patient showed, which suggested the symptoms of giant cell arteritis, but we cannot conclude as a definitive diagnosis because biopsy is the confirmative diagnosis. And as soon as we see the symptoms of GCA, we should promptly refer the patient to the further management. Only the one criteria which did not fit into this, all the giant cell arteritis, was the age of the patient. This patient was an younger patient who was having all these features of giant cell arteritis. So this is the OPG of the patient who came to us mainly for a referral for an opinion regarding this supraerupted third molar. She had visited a dentist and they told like this may be because of this supraerupted third molar. The lower teeth, the lower wisdom tooth were extracted a long time back because of the impaction. And she wanted to get a second opinion before proceeding on to the further treatment. So, considering all the clinical features, the patient was sent for blood investigation. A complete myalgia protocol was done for the patient, which showed an elevated ESR and C-reactive protein level, which indicated that some kind of systemic vasculitis is going on in the patient. And the vitamin D level was also severely low, which may be the cause of a severe myalgia. So this is the patient was referred to an ophthalmologist and rheumatologist without any further consideration. Because of her visual symptoms, the patient was immediately admitted in a tertiary care center. And considering the age of the patient and because of her visual symptoms involvement, MRI and MRA was suggested for the patient to rule out the involvement of large arteries. So these are the important key findings what they had found. Like they also found that it's a headache with red flag signs, with continuous relentless headache, with involvement of left eye pain. She also had temporal tenderness and diplopia, history of claudication and hypertension. So the physicians wanted to rule out the large vessel vasculitis or any pseudotumor. So they had taken an MRI of this is the T2 coronal T1 sagittal with diffuse white imaging was done. So in the imaging, the major finding of the MRI of the brain was they found out that something called as partial empty sella was noticed with mild vertical tortuosity of the bilateral optic nerve and mildly prominent perioptic space. The MRA, that is magnetic resonance angiography of the circle of Willis, and MRV, which is nothing but your magnetic resonance venography, everything was normal without any significant finding. So they came to a conclusion that it can be a benign intracranial hypertension. Along with that, they wanted to consider the correlate with the clinical correlation. But usually in benign intracranial hypertension, the inflammatory biomarkers will not be raised. So the patient is still admitted in the ward and she is undergoing further investigation. She has been asked to refer an neuroendocrinologist for further opinion and coming to the final diagnosis. So the success for me in this case is that even without the confirmed definitive diagnosis, because of the suspicion of the GCA, I have promptly referred the patient, which was the pivotal for the successful in management of this giant cell arteritis case. So we'll have to distinguish GCA symptoms from dental or temporomandibular joint cause and refer the patient immediately to rheumatology and ophthalmology before any permanent visual damage or any other systemic complications can occur. So the clinical pearl is think beyond the dental or non-dental cause and think systemic, especially if it is a new onset temporal headache, facial pain, or jaw claudication with visual symptoms are there. Thank you all. Thank you for your attention.
Thank you so much, sir. And it was really a very life-altering case that you have shared, because GCA, as we say, the case doesn't fall under GCA purview because the case is quite young. The patient is quite young. Still, your diligence has helped the patient. Whatever it is, we wish you much more success, and the patient also will recover, because it is the third molars were not the cause for it. They were referred to you. She was referred for third molar. So your knowledge about GCA, at least we could get her admitted to some facility where she'll be treated for the same.
Properly, yeah.
And prompt attention is needed, because we have seen a couple of cases wherein they have lost the eyesight also. And a few in COVID time, definitely we could not save many of the patients, because the symptoms were all mixed. And now the awareness is also increased in amongst dentists. So thank you so much for bringing up such a case, that it is age no bar is and location no bar. So in Pondicherry also we are seeing pain patients.
Yes.
Yeah, yes.
Thank
And just smile for the camera again, sir. Okay, thank you so much. And it's time to call your better half now, Dr. Aparna. Dr. Aparna, say hello to the screen, ma'am, and just switch on your camera. So we have a husband-wife duo who are into pain management. Both of them are studying together now, and they are into mastership for orofacial pain study. And Dr. Aparna, can you switch on your camera and your mic?
Yes, Dr. Sonal, I'm
Hello.
here.
Yeah.
We are just switching over.
Yes. Smile for the camera. Thank you. Dr. Aparna, what is that one book that you would say has inspired you or changed your thought process?
I'm a great fan of Dr. Abdul Kalam. So
Okay.
I like his autobiography, that is Wings of Fire. So when a small boy from Rameshwaram, the coastal village, can achieve this much because of his hard work and diligence and discipline, like that inspired me a lot. And I have met Dr. Kalam twice. So during my undergraduation, I had an opportunity to interact with Dr. Kalam, and also he came for my convocation, which I consider as a great blessing.
Wow, wonderful. That's actually a blessing to me, Dr. Kalam,
Yes.
twice, and that too for your convocation. That's wonderful. Dr. Aparna Natarajan is a associate professor of prosthodontics with 16 years of distinguished academic, clinical, and research experience. She has completed advanced fellowship training in orofacial pain, temporomandibular joint disorder, and dental sleep medicine, and is known for her evidence-based interdisciplinary approach to diagnosis and patient care. More than that, Dr. Aparna is a very, very kind and very, very soft soul I have met in just recent time. I love the way she dresses up. Her saris are beautiful,
Thank you so
and
much.
the combinations are beautiful. And more than anything else, the place where you're coming from, maybe the calm and the poise that you two carry is also because Pondicherry is very close to my heart,
Yes.
as I said.
Yes.
So maybe I'll be visiting next month,
Please,
most
please do
probably.
come. We'll be happy to
I'll
have you here.
Yeah, on that note, we would like you to start sharing your screen, ma'am.
Yes.
Yes, your screen is visible. Go on the presenters mode.
1 second.
Yeah. Yeah, please go.
Can I start now?
Yes, please go ahead.
So, hi everyone. I'm Dr. Aparna, Associate Professor, Department of Prosthodontics, and the Orofacial Pain Specialist of NGPGIDS Puducherry. Today, I'm before you to present a topic on the ninth nerve silent whispers, unmasking glossopharyngeal neuralgia. I'm immensely thankful to the organizing committee, especially to Dr. Nurul and Dr. Sonal for having given me this wonderful opportunity. With a deep gratitude to my mentor, Dr. Davis Thomas, sir, I'm starting my presentation on glossopharyngeal neuralgia. Imagine you taking a sip of water and a bit of bolt of lightning is hitting your throat. After a few seconds, it vanishes and it's all back again with the next sip, the next swallow, and the next yawn. This is the everyday scenario of a glossopharyngeal neuralgia patient. So, for convenience, I'll be addressing glossopharyngeal neuralgia as GPN. So GPN is a very rare type of cranial neuralgia affecting the sensory distribution of the ninth cranial nerve. And this nerve is considered as the most neglected cranial nerve because of its smaller size, deeper anatomic location, the rarity of the disease, and the difficulty in the diagnosis. So I have taken three definitions across the literature. The first definition is all about the International Association of Study of Pain, so which focuses mainly on the quality of pain and its location. So as per this definition, GPN is a unilateral brief electric shocky pain which is localized to the nerve distribution, sensory distribution of the ninth cranial nerve, which is sudden in onset and termination. Being a rare cranial neuralgia, Orphanet defines it based on the following parameters like the duration, triggers, clustering pattern, and the autonomic features. So, as per Orphanet, GPN is a paroxysmal pain, that is, pain is never continuous and it has a stabbing nature. Moreover, it lasts only for few seconds to minutes and it has a clustered appearance. And this pain is always associated with vagal symptoms like severe bradycardia and syncope. And the ICD-11 and the ICHT-3 definitions basically focus on the operational criteria based on the duration and the specific triggers. So to summarize, all these three definitions, they just present GPN as a relapsing remitting type of pain. Moving on to the epidemiology, according to the International Association of Study of Pain, GPN is a very rare type of pain disorder, which is having an incidence rate of 0.2 per 1 lakh people per year. The male and the females are affected equally, but the women experience more orofacial pain compared to the men. And as far as the side is concerned, the left to right ratio is 3:2, and as such, there is no discernible side-wise preferences. But this pain disorder is very common in people above 50 years of age. And as the age increases, the incidence of GPN also increases. So age is considered as a primary risk factor in GPN.
But why this GPN is often under-recognized? Because of the rarity. So the Orphanet has given an Orpha code of 221098 and the ICD code is 8B87. So according to Orphanet, it's a very rare cranial neuralgia with an incidence rate of 0.7 per 1 lakh people in the US. And it is considered to be the rarest of all the cranial neuralgias, forming less than 1%. So because of its rarity, it is a very, because of its rarity, GPN is always having a low clinical suspicion. This will delay the diagnosis. Added to that, the lot of triggers like swallowing, talking, chewing, yawning, all this will be present in the areas that are commonly shared by ENT, dental, TMD, and the trigeminal disorders, leading to lots and lots of symptom overlap. As a result, you will do a wrong referral, misdiagnosis, and even unnecessary treatments can be done. Also, GPN is characterized as a clustered pattern of pain. So you get a cluster of pain. After that, there is a total remission phase. After that, you get a cluster of pain. So the in-between episodes, the patient, the clinician will 100% miss the diagnosis, leading to a delay in the diagnosis. And very often, vagal symptoms occur with GPN, but we clinicians rarely link it to the disease. And as a result, we will end up in lots of diagnostic delays. So vascular compression is considered to be one of the important cause for glossopharyngeal neuralgia, which is very often missed on a standard MRI because of its poor resolution. And moreover, this nerve is so small and it is placed in a very deeper location. Added to that, it is present in an area which is more prone for movement artifacts. So because of all these situations, we just don't need a standard MRI. We need a three-dimensional, high-resolution CIS and Fiesta MRI. So before moving into the depth of the subject, I will just give a very brief anatomic review. So the ninth cranial nerve starts or originates from the medulla oblongata, and through the jugular foramen, it exits the cranial fossa. So this is the internal carotid artery and this is the internal jugular vein. In between, the nerve courses down and right in front of the throat, it arches towards the throat, and where it gives the following 6 branches. That is the tympanic branch, stylopharyngeal branch, carotid sinus branch, pharyngeal branch, tonsillar, and the lingual branch. The tympanic branch gives the general sensation to the middle ear cavity and the tympanic membrane. The general sensation to the throat is given by the pharyngeal branch. Special sensation to the posterior 1/3 of the tongue is given by the lingual branch. And the parotid gets its parasympathetic innervation through the ninth cranial nerve. The motor innervation to the stylopharyngeal branch and the superior constrictor of pharynx is also through the stylopharyngeal branch. The visceral sensation to the carotid sinus is provided by the carotid sinus branch. So this picture clearly explains the mechanism behind the referred ear pain that is very commonly associated with GPN. So this is a sensory input from the posterior 1/3 of the tongue and the inferior nasopharynx. They are carried by the pharyngeal, lingual, and the tonsillar branches. Same way from the middle ear cavity, the tympanic branch carries the sensory input. So these two branches, they converge and pass through the superior glossopharyngeal ganglion, and from there on, they share a common neural pathway. Because of this convergence mechanism, the pain in the posterior aspect of the oral cavity is perceived as referred otalgia. So moving on to the classification, GPN is classified based on 3 parameters, one based on the anatomy, the etiology, and the International Headache Society. The anatomic location is based where exactly the pain is located. That is, either it is located to the ear, we call it as otitic type, and if it is localized to the oropharynx, we call it as the oropharyngeal type. And etiology, if there is no underlying cause or the demonstrable lesion present, we call it as idiopathic. And if there is some underlying cause, we call it as a secondary type of GPN. And idiopathic, most common reason is neurovascular compression. And for secondary, the most common reason is any lesion in the cerebellopontine angle of the brainstem. The International Headache Society classifies GPN into classic and symptomatic, which is nothing but classic is idiopathic, symptomatic is secondary. And in classic, you have the episodic pain. Pain is never continuous and there is no neurologic deficit. Whereas in symptomatic, there is always a continuous background pain with sensory impairments. Moving on to the pathophysiology. What actually causes idiopathic GPN is the neurovascular compression, especially of the ninth cranial nerve at the root exit zone. So when a nerve is compressed, it causes twisting of the nerve fibers, causing microvascular ischemia, causing secondary demyelination. And whenever there is a secondary demyelination, the nerve goes for a ephaptic transmission, that is nothing but a crosstalk between the A beta, A delta, and the C fibers. All this are leading to the high frequency electric shocky pain. Various reasons are there for the secondary GPN, like trauma, neoplasms, especially in the cerebellopontine region, various type of infections, surgery, AV malformations, demyelinating conditions like multiple sclerosis, and the miscellaneous conditions. So this is a picture which I have made based on the pain mnemonics. The onset is sudden, and when it comes to the location, the pain is always localized to the sensory distribution of the ninth nerve as well as the pharyngeal and the auricular branches of the 10th nerve. So pain is most often localized to the posterior one-third of the tongue, pharynx, the tonsillar fossa, ear, as well as the angle of the mandible. It's a chronic pain which is moderate to severe in intensity. Quality-wise, the pain is very sharp, stabbing, shooting, or lancinating. In other words, the patient will always give a history that a fishbone stuck in the throat feel is always there for him. The pain is there for few seconds to 2 minutes. This is the duration of one episode. Like this, per hour, you get 5 to 12 paroxysms. And following active pain periods, you get total remission, which can happen even for weeks or months. The triggers are usually swallowing, coughing, talking, yawning, etc. Even touching the throat is a trigger. The relieving factors is usually the pharmacological therapy using anti-epileptic drugs and the glossopharyngeal nerve block. Associated features, it is very often associated with vagal symptoms like syncope, severe bradycardia, dysrhythmia, etc. And the one important point to remember is always GPN occurs or coexist with trigeminal neuralgia, which you have to always bear in mind as a clinician. Moving on to the temporal characteristics, I will explain what relapsing and remitting type is. Per day, I said a maximum of 150 to 200 attacks can happen. And like this, it can go on for few days or weeks. Following this, there will be a refractory period for the nerve, which means the nerve cannot be fired anymore. So ultimately, the nerve enters a spontaneous remission period wherein the patient is totally free of pain. So if a patient comes to you during this period, you as a clinician cannot diagnose the patient as a GPN patient. So what happens is, this is again a take-home point. There is always clustering during the active pain period and the pain remits completely in between the flares. So if the glossopharyngeal neuralgia is associated with vagally mediated symptoms, we call it as the vagoglossopharyngeal neuralgia. The symptoms are severe bradycardia, syncope, seizures, cardiac dysrhythmias, and even asystole. So what is the mechanism? Actual mechanism, we are not, it's not clear. So the possible mechanism could be the close proximity of the glossopharyngeal and the vagus nerve, which could form the vagoglosopharyngeal reflex arc that could stimulate the carotid sinus, causing all these vagally mediated symptoms. The common comorbidities are tinnitus, vertigo, and neurovegetative symptoms like tearing, sweating, salivation, coughing, and unilateral mydriasis. Moving on to the diagnostic criteria for GPN. So this is by ICHT-11 criteria. The code is 13.2.1. This I have already clearly explained how the onset, location, and the quality of the pain is. The pain is described as unilateral and paroxysmal attack. If it is bilateral and continuous pain, it is definitely a secondary glossopharyngeal neuralgia. This is again a take-home point. Location-wise, we know that it is localized to the sensory nerve distribution of the ninth nerve. Triggers are given below. So if a patient has at least 3 attacks of the unilateral pain fulfilling all the above criteria, you can call it as a classic glossopharyngeal neuralgia, which very often coexists with classical trigeminal neuralgia. So because of this, there is a lot of symptom overlap, which we have to bear in mind while treating a trigeminal neuralgia patient also. All the attacks are stereotyped and they look alike in almost all the patients, and no clinically evident neurologic deficit is present in these patients. And this pain episode cannot be attributable to any other disease. If you are able to attribute it to any other disease, it's not a classic GPN, it's a secondary GPN. But how to diagnose GPN? It's most often based on the comprehensive medical grounds, and there is no specific test for this. This is a diagnostic algorithm I have created based on the chief complaint. Patient says the pain in the lower half of the face, almost in the throat or ear region. You get a detailed history and you find a relapsing remitting type. If it is the history is not positive, it may not be a GPN case. So if the history is positive, now classify it based on whether it is classic or idiopathic, atypical or oropharyngeal. So whichever classification you want to put, classify them and find out the trigger, what is actually causing the trigger. Then you want to further confirm the diagnosis, go for a GPN nerve block with 2% lidocaine or 0.5% bupivacaine, which will confirm the probable GPN. Also, it will give a immediate symptomatic relief. And the diagnostic, the final diagnosis or the definitive diagnosis, we have to do a MRI, not a, what is that, a T2 weighted MRI with contrast. Also, we have to go for the 3D CIS and Fiesta MRI also. So to rule out classic GPN as well as the secondary GPN. The red flags, based on the nature of pain, if the pain is continuous and bilateral, it's a red flag. If the pain is pain is associated with neurologic deficit or sensory loss, it is a red flag. And if there are associated vagal symptoms, it's a sure red flag. And if there are lesions in the cerebellopontine angle, then it's a red flag. And moreover, one more take-home point is, if the patient, GPN patient, is not responding to our treatment, or if the patient is not having any trigger, then my advice is please go back and redo the diagnosis. There are so many differential diagnoses, but I have just enumerated very few which are very commonly confusing the diagnosis of GPN. The trigeminal neuralgia usually will have the facial triggers, never in the throat or in the ear. TMD, pain will always be reproducible by the jaw movements. Secondaries, if present, will have continuous pain. Also, there will be persistent pain with neurodeficits. If the pain is because of nervous intermedius neuralgia, then the pain will be centered deep in the ear canal, which you can clinically examine by inserting a cotton wick into the ear. The patient will have excruciating pain. Also, there will not be any vagal or autonomic symptoms associated with nervous intermedius neuralgia. As far as keratodynia is associated, you get vascular tenderness, which is associated with neck movement, and the pain will not be shocky in nature. Moving on to the investigations, GPN is 100% a clinical diagnosis, and these lab tests like CBC, ESR, CRP, ANA assay, vitamin assays, infectious workshop are all done to rule out the secondary causes like infection, inflammation, also the autonomic parameters. Moving on to the radiographic investigations. The important radiographic diagnostic criteria is vascular compression of the ninth nerve at the root exit zone. So the common offending vessels are posterior inferior cerebellar artery, followed by vertebral artery and the anterior inferior cerebellar artery. So what do we check in the MRI is high origin PICA, the PICA making an upward loop and the PICA coursing and compressing the supraolivary fossa. So this slide shows a picture of a high resolution 3-dimensional T2 weighted CIS MRI. Here, this is the vertebral artery and this is the posterior inferior cerebellar artery, both are sandwiching the glossopharyngeal nerve at the root exit zone. So this is the area of neurovascular compression. And this is contrast enhanced magnetic resonance angiography. You're able to see the neurovascular compression here. So these MRI are done for the standard of reference for the diagnosis and the surgical planning. Then we also need the T2 weighted MRI with gadolinium contrast, especially of the posterior fossa of the brainstem, especially in the CPA angle, the ninth nerve root exit zone, jugular foramen, skull base, parapharyngeal space, etc., to rule out the secondary causes. This is a picture showing the three-dimensional fusion images from the MRI and high-resolution CT angiography. This is the nerve, and this is the vessel, offending vessel, causing the neurovascular conflict here. And this is the nerve here, and the nerve has been transpositioned. So the management strategies, I'm giving you a decision tree. Once after you confirm the diagnosis, you find out it is GPN, which is, if it is unilateral, then it is called classic GPN. There are no sensory deficits. The first line of treatment is carbamazepine and the gabapentinoids. So after a few months, the patients will develop tolerance to the drug, where you have to step up the dose or add the other pharmacotherapeutic agents like valproic acid and lamotrigine. You can go for a confirmative glossopharyngeal nerve block, and added to this first line therapy, you can go for physical therapy or psychotherapy, and adjuvant therapy with vitamin B12, SSRI, TCAs can also be given. And if you feel that the GPN is bilateral with sensory deficit, go for a MRI, CIS and Fiesta MRI, confirm the diagnosis and treat the underlying cause. The non-pharmacological management, pharmacologic management here is the pharmacotherapy is to alleviate the neuropathic pain, and this is not meant to attempt a cure. The optimal dose is individually titrated and adjusted, and NSAIDs are not for treating the neuralgic pain. So you can go for opioids, but there is no additional benefit. Rather, it will only cause addiction. So if there is a cardiovascular presentation, get a medical consult and you can go for atropine. Moving on to the neurosurgical management, microvascular decompression is the gold standard treatment, and followed by gamma knife surgery or nerve rhizotomy at the CPA angle. Other techniques include percutaneous procedures like radiofrequency, thermal rhizotomy, tractotomy, nucleotomy, and nucleus caudalis surgery. So these are few techniques of microvascular decompression. We have interposed insulating materials like Teflon and Iblon. And this picture, it's a recent advance where the simple transposition is done using a glue-coated Teflon made as a sling. And this picture is all about a fully endoscopic microvascular decompression that provides a multimodal image fusion, which gives us a composite image with the complementary information. The other ways whereby you can transpose the nerve is using aneurysm clip, fascia strips, Gore-Tex tape, and Dacron sutures. The clinical pearls include, there will always be a symptom overlap with GPN. Please bear this in mind and confirm the diagnosis before starting the management. Always evaluate for the vagal symptoms and try to correlate it with GPN. PICA compression is the most important cause, and this can be confirmed with CIS and Fiesta MRI. The first line of management is carbamazepine and gabapentinoids. Microvascular decompression is the gold standard treatment with around 85 to 90% of long-term success. The interdisciplinary team we have to form is OFP specialists who will do the sensory testing and rule out the TMD causes. The neurologist will confirm the diagnosis and treat the patient pharmacologically. Dentist and ENT surgeon will rule out the dental and ENT mimics respectively. And the neurosurgeon will treat the refractory cases by performing microvascular decompression. These are my references. And let's all join hands to change lives. Thank you all.
Thank you, Dr. Aparna. Just a second, hold on. Yeah. And Dr. Aparna, just smile for the camera again. Lovely presentation, Doctor, and it was a pleasure hosting you in International Orofacial Pain Congress Season 3. And we look forward to seeing you again in the next season, and keep doing the good work. And it was a very thoroughly presented case. And you were asking me for some inputs here. I have received some inputs from you. So thank you so much. And it's been a pleasure hosting you today. Thank you,
Thank you,
ma'am.
Dr. Sonal. Thanks for the opportunity. I have been pestering you for past few days. Thanks for the patience. Thank you so
I
much.
wouldn't call it pestering, but I would say it's a group activity when we are doing it as a team. So thank you so much, and for all the help you've been helping me out in backstage also. So thank you for that. Thank you
It's a
so much.
pleasure. Thank you. Thank you.
Yeah. On that note, I would like to welcome our next speaker, Dr. Ahana.
Hi, am I audible?
Yes, you are audible. Can you smile for the camera, doctor? Dr. Ahana is actually my mentor also, because she'll be mentoring the master's batch, and I am a master student for so Dr. Ahana, it's a pleasure to welcome you to International Orofacial Pain Congress. This is our first year with you in the
Yes,
Congress, is it?
this is my
Yeah.
first time, and thank you so much for the invite.
Yeah, thank you so much for joining us, and you could find time to join us here. So, Dr. Ahana is actually a diplomate in American Board of Orofacial Pain from ABOP, and she is an executive committee member of Indian Orofacial Pain Association. I see her actively participating and making sure that everybody receives all the recordings, and she's
Yeah,
been diligent in that.
you can say I am the Sonal there.
So I have made
I
clones.
manage all. Yes.
That's nice. That's nice. Dr. Anna, welcome to International Orofacial Pain Congress. And there's one question I've been asking each and every speaker. So I would like you to tell me if there is one message that you would be give. You are very young. Actually, this question I should not be asking you, but maybe just rewind the clock few hours and then let me know what message you will be giving to your younger self.
I'm 36 and I've been practicing for 13 years.
You don't have to specify all that. You broke so many
So,
people's heart over
so
here.
I can tell, like, because 8 years back I started practicing OFP, and what scared me the most was my age. Definitely, my young-looking face was what intimidated me and the seniors around me. So, what I would say to my younger self is that it is not the number of cases that define your career. It is your courage to keep on learning, your humility to learn new things and unlearn the old things, and the resilience you get from the setbacks in your career. That is what should define your career. That's what I believe. And that's what I think I should tell my younger self too.
Wonderful. I'm quite surprised that you let me ask this question because you still are a baby. So one habit or mistake that transformed you to in your clinical approach, like what was that habit or mistake that you changed?
Okay, I would let's just come up with one mistake I did. I think that's better
Yeah.
because I treated one patient for like sensitivity of tooth. Patient's complaint was sensitivity and pain of 136 lower left molar. I treated that tooth by endodontic treatment, occlusal reduction, crown. Still, the patient was coming back with the same complaint. And then I joined this course. Not for this, but I just like kind of told the patient that this is like a feeling that you have. I've treated everything, or even the additional canal is obturated. You won't have any problem from that tooth. But once I started getting my classes under Dr. Thomas, and he injected this concept of non-odontogenic pain into our brains from the first module. And I was shocked. I went back and I looked into that case. And that case is exactly my first case of fibromyalgia.
Oh.
That was my, and that's why still I love talking about fibromyalgia, and I've researched a lot in the management modalities of fibromyalgia. I have 6 to 7 ongoing patients fibromyalgia, though like through the lecture I'll tell you how to go forth with fibromyalgia cases, but that was the first case I would say. That mistake wanted me to invest more time in learning OFP, more time in learning pain and how to manage pain. Like Valli ma'am said, never treating pain, how to manage pain.
Wonderful. And you'll be surprised that your mentor is listening to you.
Oh, yes, he joined.
Hello, Dr.
Yes,
T.
good afternoon.
Dr.
It's
T. Good morning.
4:30 a.m. So I thought,
Yes,
okay, I'll
yes,
join. What else
replacement
to do at
meridian time.
4:30? Yeah. Fine.
What else to
Continue,
do at
continue.
4:30? Wonderful. This is the mentor we have. Then the basement, what was that? Basement meridian
Basement
time?
meridian time,
Yeah.
BMT we call.
Ranga made that
Ranga
up.
sir termed that.
Yes, yes, yes.
Okay.
So, Dr. Ahana, welcome to International Orofacial Pain Congress. And
Thank you
can
so
you start
much.
with sharing your screen, ma'am?
Yes, yes.
Yes, please go on the presenter's mode. Yes, please go ahead.
Okay. It's completely no black boxes, anything, right?
No, please go ahead.
Okay. Thank you. First of all, thank you so much, Sonal and IOPCON and the organizers for inviting me for this first talk. I think this is my first talk with IOPCON. So I would like to start with a full disclosure statement. Uh, Give me a moment. Some boxes, dialog boxes are coming. I'm just closing that. I'm sorry.
You could just move it aside so it won't come again.
Uh,
Just close it, close it.
how it's not, it is only minimizing.
Okay, just raise it up as much as
Okay,
possible.
is it gone now?
Maybe you can raise it a little bit more, then it will be okay.
Give me a moment. I'm sorry.
No, leave it, leave it. You're okay with that also, I guess. Yeah, that will cover in your logo. No problem.
Okay, it's okay now, right?
Yeah, please go ahead.
Okay, I would start with a full disclosure. I'm not talking for any institutions. I won't be prescribing any off-label medications. I have a full disclosure, and I'll just stop sharing and share again.
Okay. Yes, please go ahead, doctor.
Yes. Okay. Yeah, because my screen is stuck. That's why I had to stop. Sorry for all the technical glitches that happened.
Happens to
I
best.
always start my presentations with this one slide. Like intellectual growth commences at birth and cease only at death. We start learning from the moment we open our eyes, right? Because the moment we come out, we start learning how to see things, how to roll around in a bed, and how to talk. Everything comes from the moment we are born till the last day of in our deathbed, where we learn that all this luxury that we earned through this life was just too like momentary. We cannot take all that to grave. Till that moment we keep on learning. So these kind of initiatives are very useful for people who would love to keep learning. And thank you so much once again for inviting me. So today we are talking basically about fibromyalgia. I won't be going through the clinical features or all the comorbidities and all. You had a very good, nice lecture from Dr. Tanvi Somaya, about all the clinical features and comorbidities and diagnostic methods. You should know that fibromyalgia is like a silent storm beneath the skin, like where aching whispers never end. It's always there. We cannot cure or treat fibromyalgia, but we can help our patient manage through that one word that we have been talking from the day one: empathy. We should have empathy. We should be good listeners. We should listen to our patient and try to manage fibromyalgia. So, in this talk, we'll be majorly dealing with the contemporary management methods, not just the pharmacological methods, but we'll go through different shades of the nuances, like all the nuances of contemporary management. It can be non-pharmacological and pharmacological, how to combine these and make it patient tailored in each cases. We can do that through this talk. So from 1904, physicians have been noticing this condition of fibromyalgia. They initially thought it was some kind of a muscle inflammation, like inflammation of the fibrous tissues, and hence they termed it fibrositis. And when it reached 2016, the ACR came up with a criteria for diagnosing exactly how, like what all conditions should fall under, so that you can call it fibromyalgia. And they also identified it as a central sensitization syndrome. I'll give a gist of what central sensitization means in coming slides. And why are we concerned about fibromyalgia is because almost 4 million American population is affected by fibromyalgia, and almost 4.1 crore population of Indian population is supposed to be diagnosed by as fibromyalgia. I would stress on the word supposed, because diagnosis of fibromyalgia is not something that you can get by a blood test or by doing a genetic testing. Diagnosis of fibromyalgia is by exclusion. Fibromyalgia itself is a disease diagnosed by exclusion. You have to rule out all other conditions, from toenail fungus to scalp dandruff. Every systemic conditions have to be ruled out. Let's say any rheumatological conditions, I'll put it under a broader term, any autoimmune conditions, any local conditions, all those systemic conditions have to be ruled out before you reach a diagnosis of fibromyalgia. And even through the course, maybe after a few years, some other condition might rise up. This is what Dr. Thomas has been injecting into our brains for like 8 years. I've been with him for past 8 years, and this is what I've been learning for past 8 years. And I'm currently trying to pursue more and more into the management modalities of fibromyalgia. So before going to management, you should have a clear idea of what are the basic things or what are the basic pathophysiological factors happening in fibromyalgia. Majorly, we can like, as there are not just OFP specialists here, we have also the beginners here. I would go in simpler terms rather than going with like difficult terms, and so that it doesn't go over their heads. So I'll start with the term central sensitization. In pathophysiology, the major factor we have to consider is that fibromyalgia is a central sensitization syndrome. In like 1 minute, I can put to you what central sensitization is. Initially, let's say what's peripheral sensitization. You keep on poking your hand with a blunt nail for like 5 minutes. Let's say 5 minutes, 10 minutes. You keep on poking continuously. Okay. So once you stop that stimulus, not just the site you instigated, but the whole area around it will start hurting. Like you won't be able to brush your hand at even a 2 centimeter away from that point of poking. So that is what we can call, in simple terms, I'm putting it in simple terms, what you can call peripheral sensitization. Just imagine some kind of a deep input or any stimulus happening for days, weeks, months, years, going on and on, which will completely change even the way how the neuronal signaling is happening, and the whole central system is changed. There are so many particular terms that we use. I'm not going into all that. Let's say that central change that occurs is what we call central sensitization. Basically, the temporal summation of all these irritating or deep input factors is what we can call central sensitization. So one, we know central sensitization problems happening. Next, there is a reduction in serotonin and norepinephrine, which is very important for pain inhibition. Increased substance P. Every dentist hates two things: substance P, prostaglandins. We know this is the reason. Even if we don't know any other pathophysiological factors, even if we don't know anything in biochemistry or physiology, we know these two things: substance P, prostaglandins, because all literature says increased prostaglandins, extraction becomes difficult, and you stop for some time. We say, oh, prostaglandins are gone down. That's why then after some time, when you were able to extract, patient didn't feel pain. So many things that are like injected into your brains from when we were like in first year about prostaglandins and substance P. We know all that. Next is disrupted pain modulation. The as descending pain modulation is what we call. In simpler terms, when a stimulus is there and a pain pathway is progressing, there should be something to calm down that. And that is what we call the descending pain modulation or the descending pain pathway. The descending pain pathway is also disrupted in these cases. So we should have an idea about all this. So why are these happening? So I'm a little interested in genetics because from my first article or my first publication was primary Ellis Van Creveld syndrome. I was working with Dr. T and a genetist, Dr. Janani. So I always go back to the genetics of each condition, and that is when there is a ink mark on my screen. I think it's an annotation from some of the viewers, but it's okay. I hope it's not disrupting the view of the slide.
No, no, no. Nothing.
Okay. So there are a few genes. As they see, fibromyalgia is not yet confirmed. There is no hard and fast rule for diagnosing fibromyalgia. Still, physicians and researchers don't know how to diagnose fibromyalgia. So studies are still going on, and few genetic studies revealed the candidate genes, like the ones that inhibit reuptake of serotonin, pain perception increase ones, neurodevelopment. See, when we talk about neurodevelopment impairments, the major feature that a fibromyalgia patient has is brain fog, difficulty in cognition. Brain fog is very important in fibromyalgia. Similarly, synaptic signaling and cell adhesion issues, cell signaling issues, So all this causes, have you ever noticed that a fibromyalgia diagnosed patients won't be able to sit still? Like for 5 minutes, we are sitting like 15 minutes, half an hour, 1 hour in the same position. We can listen to a lecture without moving around for 1 hour. But a fibromyalgia patient cannot sit in the same position for like 5 minutes. They experience what they cannot tolerate neuropraxia. They will keep on rejecting, they'll keep on moving. That's the major reason for that is the synaptic signaling issue in these patients. And definitely involvement of dopamine and serotonin synthesis, reduced dopamine and serotonin. We need dopamine and serotonin. Dopamine, instant gratification hormones, these are dopamine we need. That's why we love scrolling through our Instagram reels, our YouTube shorts. It's instant gratification, dopamine release. We love to do that, we need that. And if there is any problem with the synthesis, just imagine why that patient would be going to depression. And definitely COMT. Anyone dealing with pain research should look into this gene. COMT is huge, is humongous in pain. Anywhere you see increased response to stress and pain, that is your COMT gene. So keeping in light all this, so now we know what all are the factors we have to deal with in management. We have to deal with central sensitization, the reduced dopamine and serotonin, the synaptic signaling issue, increased pain perception issue. These are the major things that we have to deal with in management. And clinical features. Because of these, what all will be the major clinical features that happen? Myalgia, chemical sensitivity, depression, stiffness, tenderness, sensitivity to sunlight, alpha wave intrusions. Alpha wave intrusions, if you are a new person to OFP, I'll say you can simply call it sleep fragmentations. That is, once the patient won't be able to go to their normal rest sleep or reparative sleep, they'll come back to their first stage of sleep. That's what we call it. You can simply call it sleep fragmentation, dysmenorrhea. And there are comorbidities like tinnitus, cognitive dysfunction, keratoconjunctivitis sicca, and TMDs, PTSD. These are comorbidities. As a clinician, you should know very well to differentiate between symptoms, clinical symptoms or clinical presentations, and comorbidities of a condition. So why do you think I have just bombed bubbles of clinical symptoms and comorbidities on a slide rather than giving a linear list of things? That's majorly because we cannot put the symptoms of fibromyalgia or clinical features of fibromyalgia in a single box. We cannot define a fibromyalgia patient, and no two patients will present to you with same clinical features. It will be just like this. It will be all over. Their features, their history, everything will be all over the place, just like how the slide is presented. So with this note, let's move on to the management of fibromyalgia, not treatment, management. Let's be empathetic. Let's be a good listener. Let's be patient with the patient and start how we can manage the patient. The method should start with patient tailoring of the treatment. It should be custom made for that patient. You cannot follow same treatment plan for two patients. You should follow interdisciplinary and multimodal care. It should be evidence based. You cannot do any and every treatment that any guy comes up with. You cannot do that. It should be evidence based. You should have literature support. And current day is that of AI. You should integrate technology into any treatment modality you have, or any let it not be just fibromyalgia, any case, let it be just a dental case, a filling or anything. We have to incorporate or integrate technology to our treatment plan currently. So let's see how to patient tailor. It can be done only by taking a full thorough case history. We have a 12-page, 13-page OFP form that we take for this. It should majorly include first all the psychosocial characters of that patient, how the patient is living, who all are there in the family, what are the work conditions, what is the conditions at home, what all does the patient go through every day. Everything should be there in that case history. All the systemic factors, anything that you can start, like from skin to internal organs, any systemic factor should be there in your case history. Thorough physical examination, you should not leave out any point. You should do a thorough physical examination and a complete case history. Sleep history, that sleep and pain has an integral role in this, so you have to have a thorough sleep history also. Then once you have a full case history and you know your patient and what is what is going on with your patient, then you go to the treatment modalities, starting with interdisciplinary. Interdisciplinary means nothing but combining all the groups of physicians that you have. Let it be a specialist physician, general medicine, neurologist, ENT, rheumatologist, whoever you have, combining different disciplines into one treatment is what we can mention as interdisciplinary. And multimodal is combining two or more treatment modalities to one condition. Normally, like how, for example, we say combining pharmacological, in simple terms, combining pharmacological and non-pharmacological conditions. And in case of a diagnosed fibromyalgia, by exclusion, let's say you diagnosed fibromyalgia, and from here we start the proper management. In your interdisciplinary care, you should have a rheumatologist, majorly to rule out all the musculoskeletal symptoms, all the any autoimmune conditions, everything. You need the help of a rheumatologist. You need a neurologist to rule out and manage any neuropathic comorbidities or any neuropathic condition underlying. You need a psychiatrist. Why do we need a psychiatrist? Because pain is a normal acute pain is different. Like 2 days, since 2 days patient is having pain, okay, we can manage with some drugs, maybe injections, or any modality. Let's try to manage that patient. Fibromyalgia is kind of a chronic pain. And no patient in chronic pain will be in their normal state of mind. I am not saying that they'll be clinically depressed. It can be even subclinical depression. That normal disorientation from their surroundings, trying to isolate themselves from others, and or even hiding their pain and acting as if nothing is happening. So to help patients in that conditions, they need a good counseling or they need a psychological support, and in our team we should have a psychiatrist or a clinical psychologist. And definitely an orofacial pain specialist is from where all this starts, right? And now, when we move on to the management methods, we said multimodal management. Multimodal management is non-pharmacological plus pharmacological. Pharmacological I'll deal with at the end because you can even Google it, but I'll be giving the details of what all drugs you should be using. Non-pharmacological and or any treatment should start with patient education. And any pain patient, before you prescribe the drug to that patient, you should try to manage their current psychological state. That can be just the patient may be sad. You just sit there with that patient for half an hour, talk to them. Just talk to them. Don't dig out their past or past issues. Just talk to them, talk happily to them, and just make them understand that you are with them. You understand their pain. That is the first step you should do before starting to prescribe drugs. Then non-pharmacological methods will include exercise, physical therapies, and there are a few innovative therapies which you already saw in the past 2 days lectures. I'll just brush through those also. Patient education, when you start with, you should give the following points without omission. You should give all the following points. You should explain to the patient what fibromyalgia is and how you came to that diagnosis of fibromyalgia. And you should make them aware about their symptom triggers, which you already got from their case history. Ask them not to be overactive or do things like gym or anything over activities like that, but pace their activities. Give them achievable, realistic goals of how you're going to manage that condition. Teach them like coping strategies, not the one that we are going to do in detail with cognitive behavior therapy, simple coping therapies. And always remember, when there is a pain patient on your chair, patient autonomy is very important. Patient is God. If the patient is telling you, doctor, this drug is not working, I was okay with other drug. Oh, okay, let's go on with that drug. Listen to your patient. Let them know that they are God and we are listening to them. That's very important. Now, in psychological management, majorly CBT, cognitive behavioral therapy. It is a very beautiful management modality in not just fibromyalgia, any chronic pain condition, because it improves the coping skills of the patient, enhances their depressive mood. They learn to learn to relearn their cognitive skills and emotional problems. It can even reduce symptoms of distress, and it also improves the overall mood of the patient. Maybe in one stage of a time, you'll get a talk on CBT, which will be very nice. If you're interested in learning, you should learn CBT. I urge every pain specialist to have at least basic coaching on CBT. It's very good. And definitely psychotherapy and counseling is important. Your patient has to open up, not to us. to a psychologist, because if we are not trained in managing the past trauma that they reveal to you, then that's going to be dangerous. If you are trained, a clinical psychologist, trained one, then they know how to dig out the past trauma and also how to help the patient in managing that in few days. So psychological management is very important. Next, we come to the exercise and physical therapy. We majorly talk about short burst aerobic exercises. What does it do? So we have to relate this scientifically, right? I cannot just tell you, just you go or do walk in a treadmill, do short burst aerobic exercises. You're all physicians. I have to tell you why short burst aerobic exercises work. Majorly because it is like how TENS work, I can say. Endorphin release, endogenous release of morphins. Endogenous morphins are released, and also there is descending pain modulation. Similarly, physical therapy. Physical therapy doesn't mean that extensive manual reduction physical therapies. Mild therapies like TENS, ultrasound, low-level lasers. You got detailed lectures on all this in the past 2 days, so I won't be detailing on that. Also, in the hands of an expert physician, acupuncture also has some evidence. I won't say it is completely scientific. There is still evidence that acupuncture is effective, but if you ask if acupuncture and dry needling, that kind of all that things, acupuncture, dry needling, I would say TENS, USG, low level laser therapy, according to current evidence, all this have the same results. That's what I would like to tell you. But remember the term short burst aerobic exercises. That is what you exactly advise your patient, not to go to the gym and work out for 1 to 2 hours. Okay, that is not going to help your fibromyalgia patient, but it's going to worsen their problem. Next is something I love, the mind body approaches. These are gentle movement and mindfulness steps, a holistic step. Like you can prescribe medication for a patient like for 4 months, 6 months, that's it. Then the patient should have a peace of mind. They should get a holistic management strategy to control or manage their pain. Mind body approaches include methods like yoga. Tai Chi is a stretching exercise. See, yoga and Tai Chi again works in the same principle, stretching, right? Stretching again is release of any if in case patient has a comorbidity of myofascial syndrome with fibromyalgia. Yoga and Tai Chi helps because the muscles are stretched. Stretching is the treatment for myofascial trigger points. And increased blood flow, ischemia of muscles can be corrected when the muscles are stretched and activity is increased in mild way, not increased activity. Minor increase in activity and stretching will increase the blood flow. Ischemia is corrected. Then slow and brisk walking. Combine slow and brisk walking, not slow walking for hours and not brisk walking for 10 minutes. Combine slow and brisk walking for 10 to 15 minutes. That helps a lot. And I've mentioned with or without a pet because watching a pet play like our kid, small babies, it's dopamine release for us. Like watching cute babies is like dopamine release. So I ask my patients even to read comic books, watch videos of small babies. All this releases dopamine and help them in coping with their chronic pain or intense pain they are facing. Breathing exercises, obviously breathing exercise. All this reduces pain, improves their sleep quality. It doesn't mean that do not do any of your workouts towards your time of sleep, okay? Always do that early mornings. No late evening workouts because that will again impair your sleep. All these holistic methods you should follow to help your patient. You should have in mind all the holistic steps so that you can combine with the pharmacological methods. Then one helpful method is biofeedback. Biofeedback is nothing, it's just connecting wires and tapes to a patient and to the monitor. And you give them positive things like music, good music, dance, like baby faces video, and you can see on the monitor how they are responding. The patient itself can see on the monitor how their biological system is responding to particular stimuluses. So that will help them to cope with their pain, that will help them to avoid their triggers, and that will help them to do more positive things, more helpful things in their function. Then I mentioned about yoga, Tai Chi, all the walking, dancing, everything, that kind of things. But where should you be vigilant when you are prescribing non-pharmacological methods? if the patient is a joint hyperflexible patient, be very careful. Your yoga instructor, your gym trainer should be aware that the patient is flexible and do not stretch more that flexible patient. Then in cases of osteoporosis, diagnosed osteoporosis, be careful when you're doing stretching exercises or when you're advising hyperflexibility exercises like yoga and Tai Chi for the patient. Childbearing phase, definitely we all know to be careful. And in case of past psychological trauma, be very careful while dealing with that patient. Let it be meditation. If you are not trained to instruct the patient to do meditation, do not ask them to sit and do meditation, because the moment they close their eyes and start to try to concentrate on one thing, all their past traumas will come back to their mind. If you are not trained, please refer the patient to whoever is trained and let them manage that patient. Definitely sleep hygiene. Sleep hygiene and nutrition is very, very, very important. Sleep hygiene methods are nothing but consistently going to bed at same time, avoiding blue screens an hour or more before the bed, practicing relaxation techniques like breathing, meditation, gentle stretching and all before going to sleep. Not strenuous exercise, gentle things. And avoiding anti-inflammatory foods, incorporating more omega-3 fatty acids into their diet, magnesium, vitamin D supplements, and definitely lifestyle adjustments. Reduce stressful things. There are certain stressful things we cannot avoid, like we are married, we have kids, we have in-laws, we have stressful jobs. There are things that we cannot avoid from our day-to-day life, but we have to help the patient manage the stresses in their life. That's very important in managing chronic pain. Then when we move on to pharmacological methods. Pharmacological methods, if you try to Google, you will get so many drugs. Like with brand names, you'll get so many drugs. But the major ones, we looked into the pathophysiology, right? So what all are the things that we have to manage? The serotonin uptake problem, the norepinephrine issue. These are the major things that we have to manage. Then the majorly, most usually in 80% of cases, we have seen the patient showing depression symptoms. That's not a clinical diagnosed depression, but due to all these pain and the suffering they have been going through, they'll have a subclinical depression kind of situation. So the major drugs we'll be concentrating on are tricyclic antidepressants, not in the dose that's given for depression, but usually in 10 mg, 10 milligram doses, which is considered anti-pain, which is very effective in any neuropathic pain conditions and especially in fibromyalgia cases. If the fibromyalgia has a comorbidity with TMD, if the fibromyalgia is having a comorbidity with any other myofascial pain syndromes or any other conditions, like let's say the patient is having migraine, TMD, and fibromyalgia. Let's start with TCAs, right? Tricyclic antidepressants, which is very effective. That's how you tailor the medication or tailor the treatment or management for a particular patient. Then SNRIs, duloxetine, milnacipran. If you are equipped, if it is within your purview, please prescribe. Otherwise, please remember you have to follow interdisciplinary care. SSRIs, be very careful if the patient has any movement disorder or if the patient just complains about bruxism, you have to be careful while prescribing SSRIs. Usually, we have seen the tendency of prescribing centrally acting muscle relaxants. It might give a little relief with the muscle stiffness and all that they are having associated with fibromyalgia, not exactly as a treatment modality. And tetracyclic antidepressants like mirtazapine is prescribed by the psychologist or the psychiatrist when major depressive disorder is diagnosed as a comorbidity with fibromyalgia. They can prescribe. It is way beyond our purview to prescribe. And definitely we said there is increased pain perception, increased cell signaling issue. So the drug that should come to our mind is anticonvulsants. Pregabalin and gabapentin are very effective in managing chronic pains. Opioids, though other countries prescribe opioids, there is currently no evidence. And usually pain physicians have a tendency to prescribe muscle relaxants and NSAIDs, any and every patients that come. But in case of fibromyalgia, currently there is no evidence that fibromyalgia can be managed with muscle relaxants and NSAIDs. If the patient has associated muscle stiffness, like we said earlier, if that is there, then okay, we can give an additional drug to what we are already prescribing for the patient. There are innovative therapies, like newer therapies that are currently under investigation, like naltrexone and cannabinoids, low dose naltrexone and cannabinoids. But we try not to prescribe them because of the misuse of prescription and addiction problem. Another very good method, or an uprising method in managing chronic pain in fibromyalgia, is neuromodulation. I think 2 lectures back, you had a full session on neuromodulation methods. All those methods are uprising but very useful in managing chronic pain patients, by reducing, and with these methods we can reduce the drug dosages, reduce the number of drugs we prescribe for this patient also. So you should read upon neuromodulation technique. You should find who is helpful for that in your neighboring locality, so that you can refer this patient, and you can have, or you can have that patient come, that person come to you for managing your patient. If you're planning to give appliances, occlusal correction, or any prosthetic rehabilitation for your fibromyalgia patient, please remember, stop. Do not do that, because fibromyalgia patients usually present with the condition known as occlusal dysesthesia, like a difference in feeling, not normal feeling if you change anything normal in their mouth. Let it be just a class 1 feeling. If you change that, the patient will never be happy. You'll be married to that patient. Even if you make the best crown that a dentist can do on that patient, that patient will never be happy, never be satisfied. It is a somatic symptom disorder, by the way, that is a comorbidity of fibromyalgia. Be very careful, and if you're doing a filling of an already diagnosed filling, crown, or any prosthetic rehabilitation of an already diagnosed fibromyalgia patient, use the stamp techniques. Reciprocate what was already there. That will help you in with the dental aspect. And what about the technology integration? What technology are we talking about in this case? Nothing but, yes, our favorite, AI innovations. There are apps that help physicians in diagnosing fibromyalgia. And like, you enter all the medical test reports to that, you just enter that case history to that app, and you just enter the clinical features of that patient, and the app will diagnose the condition for you. Though we don't like AI and apps for managing our diagnosing our patient, patients love AI nowadays. Only the OG doesn't like the AI. OG patients don't like AI, but the current patient line, the newer generation, they love AI. They'll believe if our diagnosis is similar to what the AI gave them. They trust AI more. So I won't say you should completely move on to that, but you should know how to do your AI, how to manage your AI innovations also. You should be technique savvy in current day scenario. There are also apps that help the patient. These are few apps available in India and internationally. Doctrine, Bearable, Fibromap. I'm not sponsored by any of any of these apps. I'm not talking for any of these apps. I just listed out few examples of the apps. Some of them are like peer support apps alone. Like they have a peer group. They can chat with their peer group. They can discuss like what they suffered that day. When other person, like just like how that power cut phenomena works, right? If we have like if there is no power supply in our home, the first thing we want to know is if that patient, if the other neighboring home is also off power supply. If the neighboring home is also off power supply, then we are happy. Okay, let's wait. Everything will be okay. If the neighboring home is not having power supply, then we'll be like panicked. Why are we the only people having issue with power supply? Similarly, if the patient is complaining of like depression or brain fog in on their own, and they have a peer group and that says, oh, I also have brain fog and like headaches and all that, with you also have, right? Yeah, I also have. We will manage this together. We will do something. This is what they usually do, right? If they have someone to share with, if they have someone who has the same conditions, they'll be more happy. Okay, so I'm not the only one. I'm not the red horse here. That's what they'll feel. So these apps will help them track their symptoms. It'll help them track their triggers also. If something is exacerbating their pain, all those things also will be tracked in these apps. So I hope all of you know Morgan Freeman. He was a diagnosed fibromyalgia patient, and he decided not to let fibromyalgia take away the joy from his living. He was actually a very versatile and known for his authoritative roles and for his subtle humors too. I love this person, and to know that he fought this condition alone was a great inspiration. But let us not let our patients fight alone. Let's help them. Within our purview, let's make an interdisciplinary group, listen to our patients empathetically, and try to manage their problem. So, as a conclusion, I would urge you to take a detailed case history. You should be thorough with your WPI-SS criteria for diagnosis. Patient education is the key. You have to educate your patient. You have to befriend your patient. Multimodal and interdisciplinary approach, and definitely stay within your purview. If it's not within your purview, please refer or please take help. Do not take risks while managing pain. You cannot be the Superman for all the conditions. Though I have a Superman in my pain career, and the person who changed my complete perspective of how to manage pain, or I should say, even how my practice should go, how I should see a patient. And it's a huge thank you to Dr. T. I never end a presentation without the slide. I never end without saying my acknowledgement to Dr. T. And thank you so much, Dr. T, for being there with me for past 8 years. You're tolerating me for the past 8 years. And I'm also super proud to be a part of two major orofacial pain organizations. Show TMJ, founded by Dr. T, Dr. Davis Thomas. This is our Instagram page of Show TMJ. If you would like to follow up for cases or any future programs, please do scan and follow our Instagram page. And also, this is our Show TMJ team. This is just few of them. Few are in there international, also in US, and we have in multiple nations. We have team members. And also the Indian Orofacial Pain Association, founded by the vision of Dr. Rangarajan sir. It was under his vision it was formed. I'm also an administrative team member, proud administrative team member of IOPA. And I'm so happy to be working with all these legends and pioneers. And thank you so much again, IOPCON and Sonal, for inviting me for this talk. And this is my mail ID and WhatsApp number. If you have any queries, anything you want to talk with me, you can either WhatsApp me or email to me. Thank you so much, everyone.
Thank you, Dr. Ahana. Dr. Davis Thomas has to say something for you. Dr. T.
No, I just want to say beautiful presentation. Slides are fantastic. It's just always, I remember you from the first fellowship month to now. What a change in terms of the confidence in speaking about pain. And it's not easy.
Thank you,
So
Dr. Thank you so much.
fantastically done. Beautiful presentation.
Thank you, Dr. T.
Thank you, Dr. T. Okay, on that note, I'll invite our next speaker. He's also one of Dr. T's student, Dr. J. Selva Kumar. Say hello to the screen. Can you unmute yourself, doctor?
Yeah.
Hello,
madam.
Yes,
Hello,
smile for
sir.
the camera first. Yes. Okay, Dr. J. Selva Kumar, he's given a very short introduction for himself, and that is that he is an orofacial pain specialist from Chennai. That's it, is his definition of, that's what we got in his bio, and that's how he identifies himself. Dr. T, it's an honor because he calls himself now an orofacial pain specialist, and that identity is enough for him. Thank you so much for joining International Orofacial Pain Congress, Dr. Selva Kumar. And as is the mandatory question, I'm asking each and every part speaker here. So, what is that one habit or one mistake or one change in your practice that pushed you to become a pain specialist, other than Dr. T's teaching?
One is treat the patient empathetically. That is, I encountered two patients. One is neuralgic patient, and one more is a squamous cell carcinoma patient who I found it difficult to manage. Actually, this prompted me that what I studied in my dental colleges were not sufficient. So I ventured into this field, and it was quite informative. Even for all the youngsters, I would say, think beyond the tooth. As Dr. T always says, think systemically, think tooth as a part of the body. So just don't treat only the tooth, as a body as a whole. That's what the learning I got from sir.
Wonderful, doctor. So, welcome to International Orofacial Pain Congress Season 3, and this is our first lecture together. So, I hope you are enjoying the sessions and you have been a part of the sessions. On that note,
Yes.
I would like you to share the screen, doctor. And if you can remove the hand from your face, so that
Yeah.
will the voice will
Was
be
it
much
visible?
clearer. Yeah, it's visible. Can you start the presentation? Gonna presenters mode, doctor?
Yes, ma'am. Was it visible, madam?
Yes, please go ahead. Take.
Good evening, all. My thanks to Dr. T for giving some knowledge on orofacial pain. I learned a lot from him. I'm a alien from his students because I now moved on to sleep. Since they told this conference is only for orofacial pain, I thought what I should talk about it. Then I thought I will share few of the cases due to lot of struggle I had for past few days. Kindly bear with me with my presentation. It's a short presentation. It is just the clinical tip, whatever I learned it. So I'm just sharing with you. So with a quote of for the day, if you light a lamp for someone else, it will also brighten your path. So keeping this as laser as the light will also brighten somebody's patient's prognosis of the treatment, etc. With the blessings of my late parents and my guru, mentor, and whatever we can say, Dr. We are all proud to be a part of Dr. Davis Thomas Parivar. We are full-fledged students of Sir, and we always were students, even though we are in different specialty, different category in the colleges, but we are always students. Disclaimer. Sorry, once more, I want to say sorry because due to the last minute presentation, today, just 1 hour back only, I reached Chennai due to the flight delay and other problems. And I was in Delhi for my conference. Today only I reached. And I'm sharing my clinical experience in this field of photobiomodulation. I got a patient, one of my friends, uncle, who had a tooth extraction done in Chennai. Then he's a diabetic patient, has the tooth extraction done in some other clinic, and he went to Australia. There he was diagnosed for squamous cell carcinoma. Then he called me up and I asked him to come to Chennai. I interacted with the oncologists, surgeons, and other people, and I facilitated the treatment for him. But sad thing is, after 6 months of the therapy, I can't identify that person because he has lost weight, he is not eating anything. And the surgeons have told me, the head and neck oncology surgeons have told me he is doing fine, his reports are normal. But this patient died after 8 months, exactly before this Christmas time. It triggered me. What should I have done better for? Because I asked him to come from Australia. I put him into one of the best surgeons in Chennai. Why this has happened? Then the problem with him is he was given the surgery, he was done the chemotherapy, radiotherapy, everything, but he was not having the food. He is having dysphagia. Because of that, he had a weight loss. Because of oral mucositis, he was having ulcers all over the mouth. He don't know what he died because of that. Then I had a pity for him. Then I went through the literatures. That time I was doing my laser course. Then I was thinking, what are the treatment options available? Then when I went through my case, this, as Dr. T always says, we used to go back to the literature review and see what is the treatment modality available. Then I understood certain treatments are available which dentists can only do it. That is, one therapy is photobiomodulation. So I started going to various oncologists in Chennai on the hospitals. I tell them, you send the patient to me, I'll do some palliative care for them. They should not suffer with this oral mucositis or anything. They can't even have the food. It's like famous saying in Tamil, the surgery is successful, but the patient died. Same thing should not happen. I voluntarily did some camps and started seeing the patients. So I was doing photodynamic therapy. As Sir always used to say, was there any evidence-based approach? I'm trying to give whatever the evidence. This is the patient case sheet. So then I changed my mindset. As Mahatma Gandhi used to say, you must be the change you wish to see in the world. Simply not putting the blame on others. I want to get into that and see what is the best I can do for my patients. Patient pay for me. I have to give the value for that money, what they are giving it to me. So I changed my mindset. I was when there is a treatment protocol available, why I should not do it? PBM for management of oral mucositis and TMD. So normally what happens is, for the youngsters, whoever is attending here, laser means it is only, we are thinking only cutting the tissue. It is not that. There is something, there are laser has wide range of application. Three principles it works. One is photothermal, that is cutting. Photobiomodulation, that is biomodulates the tissue, cells, etc. Photodynamic therapy, with the photosensitizer, it acts and do. All these are the healing triangle for the patient. So first of all, we have to know the difference between what is the thermal sense, photothermal effect of laser, that is alternative for surgical procedures. Effects are visible immediately, but scarring will be there. Discomfort will be there for the patient. But what about the low-level laser therapy? It's a biostimulation. It stimulates the cell. After it doesn't comes in one sitting. It needs numerous application. Side effects are very minimal or less. Discomfort is less for the patient. It's mainly the palliative care for the patient what has been done. Just a minute. So, this Mr. Dr. Henry Muster in 1968 used LLT and biostimulation with 694 nanometer ruby laser and discovered LLT can accelerate soft tissue healing. And N.R. Feinstein, father of modern physiotherapy, described low-level laser in the treatment of lupus vulgaris. Then lot of in vitro studies, cell cultures were done, and they found out generally you should operate in the range of 1 to 500 milliwatts. The laser nanometer wavelength is very important for this. So that is why it is called as low-level laser, or it is called as therapeutic laser. If we generally we operate in the visible or infrared spectrum, that is 660 nanometer or in the 810 nanometer. This is what has to be used, and you have to be indicated how many joules you are using, which I'll be telling it about. So we have helium, neon, these lasers have been used for low-level laser therapy. As I'm a periodontist, these are the various mechanisms in perio the laser was useful. The same thing applies for this low-level lasers for oral mucositis and TMD. See how it works. Suppose if the plant is there, if the leaves of the plant, it has chlorophyll, it absorbs the sunlight and produce energy. That is the food for the leaves. Same thing for the cell to function, we need ATP. But what happens is, when the cells are stressed, when there is an ulcer, when there is an mucositis, the cells are stressed. So what happens? Nitric oxide is produced. This nitric oxide inhibits the oxygen consumption by mitochondrial cytochrome C oxidase. This is very important substance in mitochondria, which is important for the production of ATP. So what happens? Ultimately, it reduces the production of ATP and leads to oxidative stress, leads to increased inflammation and reduced production of ATP. Now, what does this LLT does? It displaces nitrous oxide from cytochrome C oxidase and unclogging the electronic transport chain or respiratory chain, restoring the ATP production. It increases the ATP production, gene signaling, growth factors, thereby reducing the inflammation and increases the pro-inflammatory, reduces the pro-inflammatory cytokines and helping the tissue to heal more quickly. This is what happens in the mitochondria. In the mitochondria itself, the cell, the mitochondria, the cytochrome C oxidase, all this process, this is how. Now, like your chlorophyll, cytochrome C oxidase, to be energetic and to be active, it needs light at a particular wavelength. This is what we call it as low-level laser therapy. You can't just do the cell activation by any wavelength, not with 980 nanometer or anything. If it is in 660, the cell can accept for that and the cell can get activated. So it requires the wavelength, correct dosage, it has to be given. So we have seen three important things: adenosine triphosphate, ATP, ROS, reactive oxygen species, and nitrous oxide. These plays a vital role. So we know the functions of ATP, how it helps in normal cellular function. If there is no ATP, all these are going to reverse. So we need ATP for good function of the things. Not only that, not only biostimulation, regeneration, for various purposes, the photobiomodulation is used. So ultimately what it does is it reduces the pain, reduces the inflammation, increase the range of motion, helping the body heal by itself. So this is the process: analgesic effect, neuropathic pain, reducing the pain. All these things takes place. Not only that, it increases angiogenesis, increases neovascularization, increases collagen production, increases muscle regeneration, muscle atrophy, decreases the inflammation and edema, increases the nerve regeneration, increases cartilage production, increases the bone formation. All these things were there. Then a lot of in vitro studies have shown that its effect on fibroblast, on bone regeneration, and as well as the bone tissues, as well as how it causes nuclear alternations in mesenchymal cells and laser irradiations. So ultimately, the evidences are, as sir is always asked for the evidence, there should be reduction of discomfort or pain, promotion of wound healing, bone generation, suppression of inflammatory process. All these things are taking place in this. So I have about three units. I don't want the clinicians or the students who are watching it do the same mistake what I had. Initially, I got this Zolar laser machine, which is of the company people will come and just sell it off. You buy it and it goes as a waste. So I had this laser machine, which is 980 nanometer, which cannot, they say that you can use it for biostimulation, but it is not for biostimulation. So I got the second laser, the Heal laser, I got it. It is both, it can be used for photobiomodulation, photodynamic therapy. What you have to understand is 980 nanometer wavelength laser should not be used for photobiomodulation. Keep this in your mind. Even I never knew it when I was first doing the laser. Here there will be some settings will be there. The company, the engineer, the company would have set the settings that biostimulation 0.1 watt, something like that, it will be there. But that is not to be. You have either 660 nanometer, this is a dual wavelength, 660 nanometer or 810 nanometer. If you are going to treat for oral mucositis, I always use 660 nanometer. You have 25 watts, milliwatts, or 50, 75, 100 milli. Suppose if it is 100 milliwatts, that is 0.1 watts if you are using. You have to use it for oral mucositis for 2 minutes. 1 minute you can use it maximum. And it will tell you how many joules. Since it's 3 minutes, it is 18 joules. If it is 1 minute, it is 6 joules. 6 joules is fine. So you can use that frequency you have to maintain. If it is going to be 810 nanometer for TM joint problem, I set it at 810 nanometer. I use it for 100 milliwatts and I do it for 45 seconds. Not for 1 minute, 45 seconds I alter the thing and I do the treatment. This is how this basic knowledge about laser dosimetry should be there. I will teach you how to do that laser dosimetry. So these are the various functions of photobiomodulation: increase cell respiration, increase cell energy production, increase lymphatic. All these things are proven this. They have a decrease of pain fiber transmission, that is nerve ending transmission, decrease of post-op pain, stimulates formation of capillaries or odontoblast nerve regeneration. Always we have to keep in mind when the cell, you have to have how much amount of energy you are going to give. That is 2 to 4 joules is ideal for our oral cells, etc. If it is more than 6 joules, it can go for cell inhibition. For growth and healing, we need cell stimulation. For that, it should be around 2 to 4, maximum 2 to 6. It could be there for 6 joules per centimeter square. That has to be, you have to calculate the area and you have to keep in mind. So 2 points I made it. One is the amount of joules. The other one is the wavelength. That is very important. So based on this, we can do the treatment. So I already told the wavelength, importance of the wavelength. If it is going to be a superficial lesion like oral mucositis or aphthous ulcer, it could be of low level laser, that is 660 nanometer is enough. So it will have a short wavelength and you can see here the penetration is less. Whereas in the case of TM joint problem, laser probe with long wavelength should be used, and the light is scattered in a elliptical pattern. Here it is circular, here it is in the elliptical pattern, and it goes deeper. So this basic concept you have to, if it is the deeper the tissue, better to use the longer wavelength. So the ideal wavelength is again not 980 nanometers, it is 810 nanometers. That you have to keep in mind. So the correct wavelength is very important for the target cells or chromophores, because we as a photobiomodulation, when you are using the target cells and the chromophores, how much it needs energy, that is very important. If you are using curcumin as a photosensitizer, you can use it at 440 nanometers. If you are using indomethacin green, then you have to use it at 810 nanometers. I'm telling for photodynamic therapy. If it is for methylene blue, it has to be 660 nanometer. This dyes will absorb the light only at that wavelength. That basic knowledge we should have it. So power density should be adequate, and the amount of area you are going to do the stimulation, that is very important. So this is what I told about the joules. Normally 1 joule is 1000 millijoules. 1 watt is equal to 1000 milliwatts. So if you calculate 100 milliwatts into 60 seconds, that is for 1 minute, it is 6000 milliwatts. That is equivalent to 6 watts, which is equivalent to 6 joules. So this 6 joules per centimeter square is the ideal for any oral. All the calculations you are going to do based on this. So basically you have to know these are the photodynamic wavelength, 610, 660 nanometer, 810 okay for maximum depth of penetration like TM joint. For 980, it is only for thermal pain and photobiomodulation, collateral damage it causes. So this is how the red light, that is your 660 nanometer works. And this is how the blue light, that near infrared or near infrared works. And this is how the mechanism takes place. This is during the COVID time, which I was treating the patient. You have to wear the glasses. The main idea, you have to properly, adequately, you have to take the disinfectant and covered when you're doing that therapy. You can watch, I put the glass for the patient as well as myself. So that is very important. So oral mucositis, reduce incident, duration, severity, it will be stuff. So now coming on to the oral mucositis, how it starts. It starts as a erythema, then it goes for mucosal atrophy, which progresses to ulceration. These ulceration, when there is a free nerve endings are there, the pain starts. Sometimes even the infection bacteria penetrates into the connective tissue and it leads to more problem. So infections can be the problem. So location is cheek lining, mouth floor, soft palate, tongue edges. These are the areas commonly happen. Other than that, the patient has intense pain, difficulty in eating, that dysphagia, weight loss, decrease in quality of life, local infection, odontophagia, all these things happens. Why there is an initiation of it? There is direct damage of radiation or chemotherapy to the DNA strand. I mean, oral mucositis due to chemotherapy or radiotherapy. That is what I'm dealing now. This leads to the apoptosis because of the double strand breaks. Then what happens? This leads to release of ROS, which is the primary damage response. Various transcription factors like nuclear factor, all these things are produced, and there is a cyclic of events taking place. Pro-inflammatory cytokines are produced, increase the production of pro-inflammatory cytokines. Cascades of events are taking place that leads to signal amplification. Then it leads to the ulceration, and there is an exposure of the nerve ending leading to the pain of the patient. Now, where does this LLT comes into play? Before that, before going for oral mucositis, there is various classification which have been given by WHO or RTOG. RTOG is nothing but a registered radiotherapy and oncology group. And there is a CTCAE, that is a consensus of terminal criteria of advanced cases. And our NCI is their Indian board, where you do that, they categorize this. But basically, we have to know under what category our oral mucositis has come. So when you are going, now you are diagnosed the case, now you are going to do the therapy. What is your target length and everything. So based on that, you have to give whether it's going to be in the whether in the floor of the mouth or in the cheek mucosa, all those things. So what you have to keep in mind, 100 milliwatts should be your temperature, or 0.1 watts could be there. It could be maximum 2 to 4 joules per centimeter square, 20 to 60 seconds per site, per point you have to do. This can be done for twice or thrice a week. It can be done on the first day, fourth day, seventh day mostly, and most probably in the first to seventh day itself it tends to heal. If the ulceration is superficial or if it is not much of ulceration, it will heal after the seventh day. If it doesn't heal after the seventh day, maybe you might recur. So what you do the biostimulation tip without contact mode, just away from the tissue. You just hover the tissue like that and you do the treatment. So this is how the laser has been done. Especially I want to give you a point here. For chemotherapeutic patient, immediately within 5 weeks, they'll develop oral mucositis. For radiotherapy patient, it will take 6 weeks. Most probably this are associated with chemotherapeutic patient. And pain is initially it is nociceptive, then it becomes a neuropathic pain. So from erythema, as you know already, as I told you, ulceration then leads to the infection. So PBM, you know the effects of PBM. So as I mentioned already, erythema, mucosal atrophy, then photomodulation can prevent all this. So whether the dosage can be done daily, it is good, but due to the cost factor of the patient, alternative therapy is better. Timing is maximum is it can be done as 4 minutes. It depends on the other areas. You also have non-thermal carbon dioxide lasers also were been available, which have been used regularly. There were in non-thermal carbon dioxide lasers are prone to be somewhat effective, but photobiomodulation and photodynamic therapy has been combined, which is also shown to be effective in some cases. But when you're doing the procedure, it should be either you can do it intraoral or extraoral. If the patient is having dysphagia treatment, intraoral, or mostly it is done extraoral, or it depends on the condition. So this is how it is done. Sorry. So this is how it is done: extraoral, intraoral, the amount of temperature needed. If it is extraoral, the intraoral, it is 630, 660 nanometer. So before you can do, even prior to the therapy also you can do, or one day, first day of radiotherapy or prior to radiotherapy you can do it. Continuous treatment at least 3 times a week it can be done. So this is how the protocol has to be followed. 3 joules. So various cases which I done. This has been taken from the book. I'll put the courtesy at the end. These are for your understanding I'm putting. There is one concern it is there. There is, will it cause tumor, or it has its effect on tumor cells? Some studies have shown the PBM could enhance the malignant cell proliferation, suggesting it may not have protective effect and could potentially stimulate the tumor growth. This has led to a lot of controversy. I hope in future with Sir, if possible, I would be happy to do some study, or if somebody is ready to do the study, it will be interesting. But the problem here is, in these studies, whatever this is a systemic review, they have shown that the controversy is due to the carcinogenic potential of PBM, especially in the patients who have a resident malignant cell. After cancer therapy, they have a resident malignant cell that can lead into the tumor growth. But they have not standardized any laser dosage in that. That's the problem. If it is according to the 2018 World Council of Laser Therapy, WCLT, they saw 5 joules per centimeter square will not cause tumor growth. Anything less than 5 joules per centimeter square will not cause any problem. So and so in that controversy, they said PBM may potentially damage the healthy cells alongside the cancer cells also, they said. But it has shown that the correct dosage is very important for the therapy. Coming on to the temporomandibular joint.
It is 30-minute mark, doctor.
Okay, madam. Just 2 minutes, madam.
Yeah.
temporomandibular joint disorders. You know, MPDS it is done, TM joint disorders also it is done. On the extraoral applications that has been done. Again, what you have to keep in mind is 810 nanometer for 45 seconds, 0.1 milliwatts. That will give you a value of around 4 to 5 joules per centimeter square. So initially you can point the area like this, and then it can be used as a laser acute therapy. It can be used as well as for you. Patient wide range of problems from headache, ear pain, tinnitus, dizziness, lack of sensation, allodynia, chronic tiredness, sleep disorders have a very good effect after this laser therapy. What you have to keep in mind is only two things: whether the pain is arthrogenic or is it myogenic. If it is going to be myogenic, you can give 810 nanometer, 45 seconds, 0.1 milliwatts. This is sufficient. After going through various journals and systemic reviews, I'm giving this. This has not been taught by many. Only in my course, I have learned it. So this is what I'm telling it. 100 milliwatts, 3 to 8 joules, maximum 5. 45 seconds per site, 2 or 3 times a week for 8 to 12 weeks. So myogenic, it is 810. If it is arthrogenic, it could be 660 nanometer. Again, biostimulation unit can be done. So short-term effects, it has an effect on transient axonal vesiculation, production and release of this thing. These are the various long-term effects on it. Due to the lack of time, I'm just rushing to it. Local immune response is stimulated and all those things. So joint disc displacement, can it be given? But I'm not sure about it. I've heard through my mentor that they have given it for the laser people who have taught me that they do it for ND arc laser, but I have only low level laser as well as diode laser. I have 3 machines, but only these things. I don't have ND arc laser. This flat tip of ND arc lasers of 1064 nanometer can be used for disc displacement, and they showed the result. So finally, this is what I want to say. Still, there are a lot of controversies regarding photobiomodulation in the treatment of mucositis and TM joint problem. But there is no steady design, there is no standard power settings, no standardized energy, no standardized spot size, focus mode or defocus mode, contact or non-contact mode, nothing was given so far. So with this, I'm saying there are a lot of scope for this branch of, but palliatively patient is benefited by the treatment. These are my references. These are my references for mucositis, and these are my references for TM joint. Sorry for the poor quality of the slide. Thank you all. This is my contact number. Anything regarding laser, I can help you out. It's indeed an honor presenting in front of my mentor. In my life, never I have presented, except for the case sheet discussion, I've never presented in front of sir. It's in a short duration. I want to join. So join IOPA as I'm a treasurer of IOPA. Join IOPA through www.iopa.in. You can see lot of lectures like this and all or most of sir's students, and to all the organizing committee of IOPCON. Last time I was listening to the lecture for all the 3 days. I don't know whether I had that capacity to speak at that forum, but I would have been happy if it has been sleep. Anyway, I hope I did my best. I shared my experience. That's what I want to say. This basic knowledge of laser wavelength energy, this is very important when you are doing the treatment. I don't say the photobiomodulation is the treatment. It's an adjunct to other treatment. It is a palliative care for the patient. That's why I told you at least the emergency treatment, you can do a palliative care, reduce the pain for the patient. Thank you so much for giving me this opportunity.
Thank you so much, Dr. Selva Kumar. And it humbles me that you have summed up the topic, such a difficult topic, in fact, in such a nice way. And still you are humble enough to say that you are doing your diligence in a very short, small span of time. Thank you so much. And Dr. Davis Thomas, sir, if you have some inputs for Dr. Selva Kumar.
Shelva, beautifully presented as always. Very proud of you. Again, I look at the screen every time. I'm just like, 2/3 of the screen will be our mentees. So God's grace. Thank you.
Thank you, sir.
Beautifully
Thank you,
done.
sir.
I'll see you
Dr.
soon.
Thank you, sir.
Selva Kumar, take it as a compliment because you have received maximum
sir.
number of reactions here in the
Okay,
chat
sir.
room as well as the reactions I'm getting as a feedback.
Thank you.
So congratulations, sir.
Okay. Thank
And
you, ma'am.
please rest. I know that Indigo has made your day a jet lag day, though you were traveling within India. So please do rest now. On that
Thank you,
note, I
ma'am.
would like to welcome our next speaker, Dr. Selva Kumar. Can you stop sharing the screen, sir?
Yes, ma'am. Yes, ma'am.
Thank you, sir. Dr. Shelly Mahajan, can you say hello to the camera by unmuting yourself, ma'am, please?
Yeah, hello.
Hello, just a second. I'll take the mandatory photograph with all the speakers and I'll just a second. Okay. Smile for the camera, ma'am. Thank you. Dr. Shelly Mahajan, she's been a part of most of our congresses, be it pain management, be it oral cancer, or any other congresses. She's been an active participant and she's completed MDS in orthodontics and then she calls herself a laser specialist, professor and in dentistry in Dr. RMLIMS College, Lucknow. And she's going to be talking about an extension to what Dr. Selva Kumar presented, that is photobiomodulation of temporomandibular joint disorders, bridging the research and real world practices. Yes, ma'am. I can see your screen. Can you go to the presenters mode?
Yeah, I'm just, yes, I hope it is fine.
Yes, ma'am. Please go ahead, ma'am.
Yeah. First of all, at the outset, I would like to thank National Health Academy, MedSkill, my dynamic, vivacious, passionate friend, Dr. Sonal, ever smiling and working round the clock to make this conference such a success. Visionary Dr. Nurul and my gratitude to Dr. Thomas for sir for being there and the whole organizing committee of IOPCON 2025 for inviting me and letting me share my thoughts on this beautiful topic which I'm really passionate about, and that is lasers. Dr. Sleev Kumar has already spoken so much about it, so I think it has made my journey a little more, easier. So let's talk about the today, that is photobiomodulation for temporomandibular disorders, bridging research and real work scenarios. So greetings from my institute, which is based in Lucknow, Dr. Ram Manohar Lohia Institute of Medical Sciences. And also I owe a lot to my specialty for which I've been working for like 14 years in one of the poshest clinic in Lucknow, and which is having state-of-the-art equipment. Dr. Vipul Srivastav is one of the mentors who have also guided me throughout. And also I've been I'd completed my standard proficiency and standard competency in laser dentistry from both ALD as well as UCSF USA. And we were also the laser educators for quite a long time since now. So the journey has been there, and founder member of ALD Affiliate India. So coming to the introduction of today's topic, first is like temporomandibular disorders. So they are the things which are being spoken about in past 2-3 days actually. And it is one of the most non-dental causes, for the orofacial pain. It's of musculoskeletal condition, which is associated with your either TMJ, myofascial muscles, and various other associated structures. It's complex in etiology and has multifaceted, presentations like you may have, a myofascial pain, a joint arthralgia. There may be disc displacement, a deviation, or a deflection in the mandible, restricted mouth opening. There have been conservative management and conventional managements as well, like splints we were talking about, and many speakers have really beautifully highlighted. There are stabilization splints, pivot splints, which have been there. Pharmacotherapy has been there, where we use analgesics, and there have been many of the physical therapy, occlusal adjustments, like we were talking about in just two lectures back. So cognitive therapy and invasive treatments like, arthrocentesis and arthroscopy and arthrography, other things. There are many NSAIDs and other medications which have, side effects. Like we have spoken about leukopenia, neutropenia is there, then anemia is there. And most of the patients are having these kind of medicines for a chronic time. So why consider photobiomodulation for temporomandibular joint? So there are many patients who are on polypharmy, like they are Mostly they are geriatric patients or medically compromised patients, but these therapies have to be given, for a longer duration of time, and most of the patients are reluctant for having a long-term treatment. So given the chronicity and the variability and the risk of side effects with the medication, non-invasive approaches are more desirable and actually nicely acceptable by the patients. So here is what we are fitting into. So what is photobiomodulation? The whole of electromagnetic spectrum is actually guarded with lot of radiation. So there can be ionizing radiations and non-ionizing radiations. There are gamma radiations which we use for radiation exposure for the radiographs, and there are non-ionizing radiation which have got a whole spectrum of ultraviolet rays, then your infrared rays which are near, mid, and far infrared, and others. So lasers are the ones which we usually use, as Dr. Sleevraj sir was also speaking about, that basically before it was just used for surgical aspect of it, but now the another aspect, that is the photothermal aspect of it, is also being used. So usually they fall into the group of somewhere around 600 to 1200 nanometers in the red or infrared zone. So this was the classification which we had, as a clinician point of view, we had formulated, and it was published in one of the prestigious Springer book on lasers. So we had classified as surgical and non-surgical lasers. So hard tissue lasers, which were comprising of erbium and erbium YSGG, and soft tissue lasers were diode, Nd:YAG, and carbon dioxide lasers. So the non-surgical part, where it was basically, this was categorized as low level laser therapy, and also the PDT, which sir was talking about, Dr. Sleevraj, and thank you for putting those topics, because I've been doing a lot about mucositis and the patient with the post rehabilitation processes. We have an onco department. I completely resonate with you, like what difference we can make with such a technology. So as already spoken about, like, because infrared lasers are between the aspect of 800 to 1064, and diode lasers are also now being made, for 1064. There are multiple wavelengths of the laser. So there are surgical part as well. We can use it for pad, and many of them have been used for even diagnosing, whether an area which has to be categorized for biopsy area or not. Because most of the time when we take any tissue, so there are chances that we can, have a normal tissue rather than being the one which has got a metastatic effect. So there are many multiple wavelength where we can invest ourselves. So this is one of the parameters where 800 to 1064 have got a deeper penetration, and 1064 is also the Nd:YAG lasers. But now diode lasers are also one which have got. So they are the ones which go deeper into the dermis and the blood vessels. So they can have, hyperemia and other mechanical aspects as well. Coming to the mechanisms, there are, as sir had already spoken about, that when you have a mitochondria in the cell which has cytochrome C oxidase, so when the laser light is actually absorbed, because they are all the chromatophores which are there in the body. So when they absorb laser light, so there are various, interactions which happens. So it can be either release of ATP, which is also the powerhouse of the cell. They increase or improve the cellular metabolism. Then there are anti-inflammatory effects and vasodilation because of the nitrous oxide which is released. Cytokinins are there. They are also the inflammatory markers, so that is reduced. Then there are also modulators of these cells which can, have like the opioids which are there. They are decreased, and also it helps in reduction of the oxidative stress. So these are the inflammatory markers which are reduced, and they help in healing of the tissue. There are also muscle hyperactivity, which is increased because of reduced inflammation, and anti-inflammatory. I would not go into the details of it because it has already been dealt, and improved mandibular mobility because of the vasodilation, and there are muscle spasms which have been decreased. So this also helps in remodeling. So coming to the further clinical applications, first is diagnosis. Diagnosis is the bread and butter of any kind of case. There are so many times when the patient speaks to you, the diagnosis is right on your plate. We just have to fish out. Then there are treatment parameters which have to be taken care of, the safety measures, like with the lasers, because every wavelength has got some or the other, because even in our body we have chromatophores, your eye has pigments, you have, so that can be absorbed, and they have not been any evidence as such, but it can accidentally fire into your pupil of the eye and can make you blind. So there are settings which have to be there, then the treatment and the follow-up, because follow-up is very important in such patients because it's a long-term treatment. Pain assessment has already been spoken about. There are pain, then the patient comes to you, they either come, most of the time, like it is so disheartening, because most of the time when the patient comes to you, it has, because I'm now in a government setup, I get references from ENT people, I get references from patients from the psychiatry department, and most of them have already gone through the pain process, and they are on antibiotic analgesics and antipsychotic drugs, because the pain has not been referred to most of the time, because it is associated with the ear and other in and around the associated factors, the eye. So ophthal and other people, like, and they have already taken polypharmacy for around 6 to 8 months, and then they say, okay, maybe it is because of related to maybe a tooth, because they fail to acknowledge that it can be because of the joint order also disorder. So patients do refer with pain, stiffness, spasm in chewing, and then there is a clicking or popping sound. Sometimes patients have got a deviation mandible or a lockjaw for that matter, or maybe pain can be referred to either your eyes, head, neck area. So, and it can be associated with bruxism as parafunctional habits, because most of the time in my area, there are a lot of pan chewers. So they have areca, which is one of the more, or supari is the one which they keep on chewing. So there's a lot of clenching which happens. And there are major triggers, which can perpetuate the stress and anxiety. So coming to, we have to analyze all of them, and then the parameters and the protocols, what we use is like laser. Diode laser, why diode laser I'm stressing upon is because it is more compact, portable, and most of the time it is there in everyone's clinic, most of the time, because NDAG has got certain, limitation that it is only for the deeper penetration, and most of the surgical procedures basically for the periodontal things. But when you have a multiple wavelength laser, so you can do most of the surgical part, as well as this is also the photobiomodulation can also be done with the same unit. So wavelength, as I told you, it is from 808 to 1064 nanometer. The application sites, you just have to palpate where the tender areas are there. So mostly it is in the preauricular region or the post-auricular region, the masseter muscle, temporalis muscle, or if it is like intraorally, if you want to go, you can go ahead and palpate the pterygoid muscles, medial and the lateral pterygoid muscles as well, if you can, like, do, because there is a lot of times when we have an evaluation pattern which can be seen. The dosage, mostly 0.5 to 1 watt is the one which is advised, and even on the, when we go for the extra oral, it can go up to 3 watt also. Then the energy density, as we were talking about, 4 joules to 6 joules is the one which is per square centimeters is the one, but there have been multiple evidences where 3 to 12 joules per centimeter square have also been imparted. And the time is 30 minutes, 30 seconds to 60 seconds. So every point has to be given the energy of that. Then extraorally and intraorally, there are different probes. I have highlighted on the screen. There are 2 probes which are there. So they are used for the extraoral is the one, and the intraoral. So usually it is used to be used in the contact mode. So when you already have a contact mode, so there is a space which is there in between, a 1 centimeter space which is there in between the probe and the laser light. So that's why we always say that it has to be used in the contact mode, whether we are using it extraorally or intraorally. And most of the time we tell the patient to slightly open the mouth when the TMJ radiation is taking place. So most of the time 2 to 3 sessions are there per week. So what we do is we impart laser energy for 1 minute. We give the rest to the area. In the meantime, we are doing, laser energy, imparting laser energy to another area. So we, if it is a masseter muscle, we will allocate those points, maybe 7 to 8 or 9 points we will be putting it. And depending on the areas where the patient is actually having those trigger points, we impart this laser energy. And in a in one sitting, you can impart 2 to 3 times, and usually 48 hours gap. If it can be given like every day, it is very nice, but most of the time the patients are not very much, handy with coming to the clinic every now and then and every day. So usually we say that we divide it after every, so 3 sessions in a week, and it is calculated, and the energy what we calculate is around 257 joules per session. So into 5, it'll be coming around somewhere around 1200 to 1500 joules per total. So laser safety is very important. So there are specific dedicated glasses or goggles which are given in the unit itself. There are 3 of them. One is for the operators, one is for the patient, and the other is for your assistant. And there are other things like foot control is there. Your smoke evacuators should be there. There shouldn't be any inflammable things. Most of the time we have, fire extinguishers. So these things should not be there. So looking at those parameters, we have made a small video where I would say how we are imparting the laser energy. So coming to the clinical procedure. So when you have a patient, you just hear their history and then see for the tenderness of the muscles. So here we are having it on the masseter muscle. So we are imparting the laser irradiation, and then for 1 minute, we will be doing that. I'll be just putting that. And here, because we had a little more on the submandibular region and mental region, so we will be imparting the laser irradiation on that area. We shall also be going for the pre-auricular and the post-auricular area. And sorry, I think on the temporal region. So the tip is that your unit should move. Your probe or your handpiece should keep on moving, because if you have like a stagnant probe, then most of the patients have developed hyperemia and they may have a little burn. So you just have to keep on moving your probe. And from the intraoral one, which I had shown you, there you can palpate your lateral pterygoid muscle and can impart laser irradiation in those areas as well. So repeat for 2 to 3 times for the patient. And previously, before starting the treatment, you have to have, a visual analog scale, which you can measure for the pain. So you just have to ask the patient to, rationalize from 1 to 10, how much of it is hurting. So if it is around 7 or so, and post-treatment also, you have to have visual analog scale where you have to have the pain measurement. Then maximum mouth opening before and after the treatment. And it is for the every session you have to write down. Then lateral protrusive movements, we have these terabytes, these range of motion are there. So these are the scales which can help you in that. And pressure pain threshold, they are also the ones which you just have to have it on your skin or the area which is the trigger point. And you can see how much amount of pressure that area is being illustrated. If it is EMG is there possible, then you can go ahead with that also. So you have to plan it, follow up. How do you follow up? We have to have that weekly schedule, and when the patient is coming, if it is coming on Sunday or Monday, Wednesday, then Friday, or if it is Sunday, then Tuesday and Thursday. So these are the things what we will be talking about. And 1 month, 3 months, 6 months to assess the amount of duration. There are MRI, which is the gold standard. I would also like to stress upon this. Dr. Sleeve also had the same from I had taken it from a journal. So most of the time I always say that we have to have a blood test, because most of the time I have seen that the patients have got there is decreased calcium and even vitamin D3, vitamin B12. So most of the patients are anemic. It is because of the reduced blood supply also. These things are there. So these tests are mandatory. So I always ask my patients for these tests where we can have a complete CBC and other parameters which can be taken care of. And if you do photobiomodulation with these parameters and you have like a proper supplement to that, I think they'd work wonders. MRI is gold standard. So if it can be procured, so just have it before and initial after the treatment, so you can see like what impact it has taken, change it has made. There's a good amount of now soft tissue healing and other parameters have been taken out in the both open and closed mouth. CT scans can also be done. So in our hospital, we have MIPSI unit. So this is minimum invasive unit, which is with the anesthesia. And we keep on holding some of the seminars where we talk about, what orofacial pains are there and what all TMJ problems. And they do more of the spinal and other neuropathic pains also they are dealing with. So there are enough evidence-based research which is there in 2022, like there were 40 studies which were there, and where patients had demonstrated like, maximum mouth opening and lateral protrusive movements were improved. Then there are enough meta-analysis. Now, if you just go through the random articles, you can see that there are many of them and they are all like, free to read. And in 2025, there is a systemic review also for 44 RCTs which were conducted. They have like spoken about that, there have been 60 to 70% of the pain which has been reduced, and for 4 weeks if we give them continuously, then there are some good benefit of better results which we can have. So now coming to my patients, I have like 3 patients which I have kept. So I would like you to hear, what the patient is saying. So this is first patient, Shashi Bala. She's 53-year-old.
अच्छा, क्या दिक्कत थी जो यहाँ पे आए आप? मस्कुर में दर्द है, मस्क करें हमेशा आता है, आपका सर लेके यहाँ.
Doctor, if you could reiterate what she's saying because it's in a local language.
Yeah, it is in Hindi. So she's, you can just hear her expression. So she's telling that I'm having problem and there is the pain, it comes and goes, and the whole area is painful.
हमेशा के डर बाहर आता है कि हमारे अंदर क्या कमी हो गया जो हमारे तरह.
So I just want to see her eyes. I know the language is different and most of you wouldn't be. So what she's telling is there is a pain which goes on and she's doubting herself. Like, what is the problem with me that the awful thing has gone? A lot of people, they go to other places also that maybe someone has done something to them because they were all fine and there is no as such an evidence. They do not have any dental pain and they would be just going around in and around and having a lot of medication, but still the pain is not going. When we had gone through the past medical history, she was a hypertensive patient, diabetic, osteoarthritis because the postmenopausal had occurred. Vitamin D3 were also less. So the pain was very gradual onset and progressive and dull aching, and it was occupying her most of the things that she was not able to concentrate well. It was aggravated during the opening of the mouth and chewing and yawning. So both normal functioning was also restricted. And the relieving factors, the medicine when she's taking, it is fine. After the medication, again, she develops the pain. So there is on physical examination, we noticed that there was a restricted mouth opening and there was a little deviation of the mandible. Both the temporalis muscle and the masseter muscle were also tender. There was no sign of swelling, no inflammation was there as such, but the mandibular motion was 20 mm mouth opening. And differential diagnosis were TMJ arthralgia and degenerative disorders, where early osteoarthritis, but final diagnosis when we reached was TMJ arthralgia and early osteoarthritic changes. We had put her on vitamin D3 as well and calcium and vitamin B12 also. So why photobiomodulation was taken care of was thought is because it was a non-invasive, safe in hypertensive patients. We couldn't go for any invasive treatments, and the patient also was very reluctant, and anti-inflammatory and joint mobility was also improved. So the treatment we went ahead with the diode lasers with 1 milliwatt irradiation, and the power density was 6 joules per centimeter square, 30 to 60 seconds per point, and the total sessions were 6 with some amount of NSAIDs which were also prescribed, the mild NSAIDs which were prescribed, and the pain was decreased and the range of motion was also improved. Coming to my second patient, she's Poonam, and you can also see sometimes language is not, I believe language is not the barrier. Once you just see their expressions, what she is talking about is she's having some pain in the ear from the last 8 to 9 months. So she says that I couldn't know that
और जब पेन खत्म होना होता है या कभी कभी स्टार्टिंग में इस पॉइंट पे बहुत ज्यादा दर्द होता है, फिर आंखों पे ऐसे होके धीरे धीरे फिर नॉर्मल होके खत्म होता है। ये मैम 8-9 महीने से लगातार, और ये आंखों पे भी रहता है। मैं चश्मा नहीं लगा पा रही पिछले 2 महीने से।
ये लगातार पेन रहता है कि कभी कभी आता है या हमेशा खाने के टाइम पे?
मैम ये कभी कभी आता है। और
तो कैसा होता है, जैसे मतलब एक्यूट पेन होता है, जैसे एकदम से कोई चुभो रहा है कुछ और फिर खत्म हो जाता है, कि ये चलता रहता है?
मैम चलता रहता है, फिर आराम आराम से स्लोली स्लोली खत्म होता है।
अच्छा, और दवा कुछ ले रहे थे?
हाँ, दवा पहले से ले रहे थे, तो उससे बस जब तक पेन किलर लेते थे जब तक ठीक रहता था। बाकी अभी थोड़ा बहुत रिलीफ है, लेकिन एकदम से नहीं है। और जमाई लेने पे इधर कट से आवाज आती, केवल राइट साइड, लेफ्ट भी। इस पेन के बाद 1 महीने से मुझे कभी कभी लेफ्ट साइड भी पेन होता है।
So it is basically pain in the ear which is radiating, and she cannot make out. She's not able to wear her specs because it is radiating to her eyes. And while eating, yawning and clicking sounds are also heard. And it was on right side, but now she says like she feels that it is there on the left side also. It's gradual in onset, progressive, dull aching, and when she takes medicines, it subsides for some time and again reappears. So there is chewing and everything is getting affected. So we diagnosed it as a temporal headache with TMJ arthralgia and DD with reduction because it was going away. And she could manage to, like, have a clicking sound, but it could deviate itself. So the sessions, what we did, we could do only was 2 because she is still ongoing, and mild analgesics were given. And the headache had reduced to 80%, and she was even able to wear her, spectacles.
क्या दिक्कत?
So coming to the third patient, Prema, she is 58-year-old,
तो क्या दिक्कत क्या
coming
थी आप
to
जहाँ पे?
limited mouth opening. She says that she had difficulty in opening of the mouth.
कितनी उंगली जा रही है?
Hardly 2 fingers.
कब से
She
शुरू
could.
हुआ ये दिक्कत? हाँ,
She says that she could remember that she had got her tooth extracted, and from there on, the problem had started. So from her place, she went into another place, Sultanpur, which is around 100 kilometers away from her area. So they told that it can be because
कहाँ
of
दिक्कत कहाँ आ
some
रही है? आप
nerve
बताओ, छू
problem.
के दिखाइए कहाँ दिक्कत आती है आपको?
So I told her to palpate those areas.
खाना चबाने में भी दिक्कत है?
This is basically masseter muscle.
में दिक्कत है। अभी हम क्या करेंगे, हम लेजर से आपकी थेरेपी करेंगे, ठीक है?
So it is a continuous dull pain on the left side. It increased with the clenching, chewing, and tenderness. And she has like shoulder stiffness as well. So we imparted like laser sessions for 6 were there. 6 therapies were given, and NSAIDs with the matter of like 3 days. We had just given her that. And pain decreased by the 4th visit, and the range of motion also improved. So these are
तो उसमें क्या?
So these are the the post-session results. So this is the first patient, if you can remember, the Shashi Bala, she's the one.
पहले से अच्छा है? अब खाना पीना खा पा रहे हैं? हाँ, खाना खा रहे हैं। अच्छा,
I'm asking her whether you're able
follow-up
to
के लिए
eat
आए हैं,
food. So
दिखाने
she's
के
like, I'm able to eat food. So she has
लिए।
just come for
अभी
the follow-up.
कोई परेशानी?
Any problem?
कितनी उंगली जा रही है? ये आराम से आपकी इशारा बहुत ठीक। अरे बाप रे!
Sorry. So, and when I asked her to open her mouth, she could open 3. She was the one who was crying that I don't know what has happened to me. Maybe some other problem has happened to me and I'm not good enough. So
पहले से अच्छा।
this is the second patient who was not able to wear her spectacles. It's like when I used to touch before, it used to pain, but now I can touch properly.
जैसे चश्मा भी नहीं पहन पाते थे।
You are not able to wear specs. She's like, yes, I can. So there are only 2 therapies which were given, and she's like, I can, but I cannot wear it for a longer time, but then I can wear now. And this patient, the third patient, I asked her how many. So she's like, I can have like 3 fingers in my mouth, but 4 also I can. So I'm like, no, no need for 4 these.
3 ही जाता है। अब आप बताइए कितना जा रहा है, दिखाइए। कहीं झूठ तो नहीं बोल रहे हो? अरे वेरी गुड। और पहले कितनी जा रही थी? पहले तो ये नहीं, पर अब ध्यान रखना है इसका, ठीक है? और एक्सरसाइजेस करते रहना है।
So I had
बहुत
given her
बढ़िया,
some
बहुत बढ़िया। खुश हो?
mouth opening
आप
exercises as well.
नहीं तुम समझ लो 8-9 महीने से गांव में दवा करा के एकदम परेशान हूँ।
So this is her, daughter-in-law, and she's like, from past 8 to 9 months, we were roaming around here and there and not getting any relief. So these are the expressions, these are the things which keeps you motivated, and these are the testimonials which actually gives you, the constant thrust to keep on going. So advantages of photobiomodulation in TMD management is they are non-invasive and effective for chronic patients. Most of the time it is elderly patients, so they're on polypharmacy, they are hypertensive, they are diabetic, they have got some cardiac issues. Like the previous patient which I had, she had a cardiac issue, so they were not ready for any invasive treatments. So it has got anti-inflammatory, analgesic and neural modulation. Biostimulation is also done, so no drug interaction as is there, so improves the jaw function and have high patient acceptance. It is repeatable and can be combined with the splints, physiotherapy, as well as patient counseling. So I would again like to stress that it is not just one armamentarium where you have like a photobiomodulation thing and you run away from all the therapies. No, it is just an adjunct with other therapies. It can be used as a multimodal, therapy, adjunct to the occlusal splints, your physiotherapy, behavior modification, TENS. You can use in combination with them also, so that they can have, it works as a magic bullet. Training is very important, as everyone goes through these. So there are various, and I'm learning even now, and most of the time my patients only teach me. So there are still research and gap and future directions that there needs to be standardized, conscious, data-based things where there should be randomized control trials, which should be highly effective. The studies which are comparing, photobiomodulation with other conservative treatments, and also in collaboration with that, when you have like multiple combinations as such, how it is beneficial. Then investigating through MRI, through other, these biomarkers, we can have like a molecular level, we can have, and real world clinical registries should be there, so that we can monitor such cases of safety, effectiveness, compliance and cost effectiveness also for the patients. And also it can be included, in Ayushman Bharat and other schemes as well, because it is one of the prime important thing where we can go for the rehabilitation of such patients. So coming to the conclusion, it represents a safe, conservative and promising evidence support and patient-friendly therapeutic modality for patients who are chronically suffering from pain, which is of such an origin only the one who goes through it would be able to make out. All specialists in oral facial pain and TMJ disorders embracing photobiomodulation within a comprehensive multimodal treatment framework, and continued research and collaborated efforts are needed to standardize these protocols where we can have the maximum benefit of these therapeutic outcomes. Thank you so much. And I would like to thank again Dr. Sonal and the whole team, the organizing team, for letting me be a part of it. I am really privileged, and thank you so much.
Thank you, Dr. Shelley. And can you just stop sharing your screen so that we can take the mandatory photograph again? Dr. Shelley has been associated with many of the NGO work also. And what actually is the humanitarian aspect of Dr. Shelley, not many of them know. So if you can follow her page, you will know that she's been associated with many of the NGOs and helping the rural ladies have a better life. So, Dr. Shelly, congratulations on that. And I
Oh,
know
no,
you
thank
were
you.
the last minute entrant for the Congress, but thank you. And I'm so proud that we could adjust you somewhere in between the
No, no, I
sessions.
grabbed it. I was like, want to be a part of it. I was
Yes.
traveling and I didn't know. And the moment I came to know, I was like, please, please, please let me be in. And you all were so kind, Dr. Nural, you and the whole team, because I
You're
really feel
always
like a
welcome.
family. And if
It's
I
a
can,
family. It's a family.
yeah,
Yes.
and you get to
Dr.
learn
Davis
so
Thomas sir is
much.
also here. I think if he can say a few words for you, I doubt he may be having his breakfast. Yeah, he said
No,
nicely present.
I did have my breakfast, so
Yeah.
nicely presented. And Shally, if you are interested in real research on it, let us know, and maybe we can work something together.
Yes, sir. So
That
I've been
level of
doing on
research.
biopsies and other things also, and also the post rehabilitation of onco patients. So I have done a couple of cases where even mucositis and other dermal conditions where they have skin erythemas and other things. I've been
Sure.
working on them, and hopefully, thank you.
All right, nicely presented. Thank you.
Yes. Thank you, Dr. T. Thank you, Dr. Shelly. On that note, I would like to welcome our next speaker, Dr. Venkatesh Hange. Dr. Hange, yeah, can you unmute yourself and say hi to the audience here? And I'm grateful to the audience on the YouTube as well as here on a Sunday evening. It's difficult to leave your family and then join us for this Congress. So thank you so much. Dr. Hange, say hello to the audience so that you can come on the screen.
Hello, everyone.
Yeah, just smile for the camera, doctor. Thank you. Dr. Venkatesh Hange is an oral and maxillofacial surgeon, reader at MIDSR Dental College, innovator of patented VBH Trinity mini plate, and lead author of Immediate Implant Placement Success Index. With 25 plus publication and editorial contribution advancing maxillofacial implantology. Dr. Hange, we would like to know about this patent because it very short abbreviation given us, so we would also like to know about your patent. So welcome to International Orofacial Pain Congress. Doctor, this is your first Congress with us, I guess, but with Dr. Nural, you've been a part of other Congresses.
No, this is my first time.
Okay. Dr. Hange, we have always had a question that I've been intruding into speakers' life and wanting to know what changed, what motivated you to become a pain specialist or the specialist you are into right now, or specialty you are into right now.
Yes, in oral and maxillofacial surgery, we face patients with a severe orofacial pain, and we try to minimize their pain and resolve it, because in some cases the patient have a grave pain, in such as trigeminal neuralgia or this TMJ dislocation. So we try to help them in reducing their pain.
Okay, great, sir. Can you start sharing your screen, sir?
Yes, yes.
Can you go on the presenters mode?
Yes. One minute, please.
Yeah, take your time, doctor.
So this is my institution. I am an associate professor at MIDSR Dental College in Oral and Maxillofacial Surgery Department in Latur, Maharashtra. And today's topic of my presentation is autohemotherapy in treatment of chronic recurrent TMJ dislocation. It is an innovative prolotherapy approach. So this is my presentation agenda. So it includes the problem. What is the problem? The TMJ dislocation is a problem. And what are the pathophysiology, epidemiology, and what are the various treatment modalities, and how the prolotherapy and autotherapy mechanism acts and helps in the TMJ dislocation patients. So, what is TMJ dislocation? I will briefly introduce. So, condyle fix in an anterior superior aspect of the articular eminence. It is represents the 3% of the all dislocated joints in the body. It can be acute, chronic, unilateral, or bilateral. So, if it is acute, it is of shorter duration, but acute episode comes periodically, then it becomes so chronic, and it might be unilateral or bilateral. So the often causes excruciating pain and functional disability. Patient may hamper their normal functioning because of the severe excruciating pain, and it can be triggered due to regular activities such as yawning, laughing, and other dental procedures. Because in such cases, there are prolonged mouth opening is there, and which triggers this mechanism, dislocation mechanism. So I want to briefly introduce to the terms subluxation and dislocation. So what is subluxation? So subluxation is a condyle travels beyond articular eminence but can return spontaneously. Hmm? But if it doesn't return spontaneously to its original position and continuously dislocates in the glenoid fossa, the mandible locks and cannot be closed. So in such cases, it is considered as a dislocation. So in this image, we can see the normal position of the condyle versus position of condyle in dislocation. So in second image, in the dislocation image, it is the condyle is beyond the articular eminence. It has moved beyond articular eminence, and it cannot be comes to its normal position without external intervention. So so in this image, you can in the CVCT section, you can see the TMJ subluxation, which is self-reducing. It comes beyond the articular eminence, and it comes spontaneously to its original position. So this is the main difference between your TMJ subluxation and TMJ dislocation. So what are the causative factors? The causative factors are laxity of the TMJ ligaments and capsule fragility, abnormal size of the articular eminence. Sometimes the articular eminence is have larger volume, so it can causes the movement of the TMJ beyond the articular eminence condyle. Excessive muscle activity spasm, as discussed earlier by the speakers, it can be due to the muscle activity, MPDS. Trauma to the joints, any history of trauma may leads to the TMJ dislocation. Because of the uneven union or malunion. Next, unusual chewing pattern, parafunctional habits. If a patient has a parafunctional habits, there are chances that it may develop TMJ problems. Next, progressive internal dearrangement of the TMJ. These are the causative factors which may lead to prolonged and continuous dislocation. So what happens if the dislocation is continuous? What are the pathological consequences of TMJ dislocation? First of all, it will cause the injury to the TMJ disc, capsule, and ligaments. And if the injury is continued for a longer period of time, it may progresses into the degenerative. That means there are destruction of the TMJ disc, capsule, and ligaments. Then chondrocytes apoptosis. That means chondrocytes are the cells which undergo spontaneous cell death and cartilage degeneration. That means the cartilage producing cells and cartilage undergoes degenerative procedure due to the progressive internal dearrangement, due to the injury and degenerative changes, and there is chance of permanent joint destruction. So in some cases, there is totally destruction of the joint. The capsule is degenerated, the shape of the condyle is changed, and it becomes progressively severe pain in this condition. So there are various treatment options available. We go only for the conservative in this discussion because we want minimal invasive surgical procedure. We want to avoid the surgical procedures such as condylectomy, and the conservative procedures includes physiotherapy, occlusal splint, muscle relaxant, sclerosing agent, botulism toxin, and prolotherapy. So physiotherapy can be done. Occlusal splint are given in primary stages. Muscle relaxant can be given in acute cases. The sclerosing agent botulinum toxins are given in a chronic dislocation cases along with the prolotherapy. So what is the prolotherapy? The prolotherapy includes introduction of the various materials into the joint capsule and pericapsular cavity, so that it might reduces the inflammation, or it might produces fibrosis, that it in turn causes less displacement of the condyle beyond the articular eminence. So what is the prolotherapy? It is the method of strengthening the lax ligaments by injecting sclerosing agent or proliferating solution. So also known as procreation injection therapy, regenerative injection therapy, and capsular sclerotherapy. So these are alternative names of this. So the historical evaluation. In 1937, the Louis Schultz popularized prolotherapy for the TMJ subluxation patient. So initially it was for TMJ subluxation patient, but later as it becomes more popular and multiple studies have been done, it is shifted from subluxation to dislocation cases. In 1964, Brackman first described autologous blood injection for TMJ, and Schultz first reported autologous blood injection for recurrent TMJ dislocation. So, the 1973 Schultz gave a first reported case of autologous blood injection into the TMJ dislocation cases, and recent emergence as a effective non-surgical management option. So, what are the mechanism of action of this autologous blood injection? So how it works? It creates a controlled injury. So as we pierce the needle into the joint capsule and the pericapsular tissues, so it will create an injury mimicking natural wound healing, and so it mimics natural wound healing by producing a bleeding in that point. So inflammatory cascade activation. So the inflammatory cascade or the healing cascade activated, then there is fibrosis, adhesion formation, and a periarticular soft tissue scarring. So the main purpose of this is to create a fibrosis, to create a barrier to move the condyle beyond do not move the condyle beyond the articular eminence, pericapsular soft tissue scarring, and restriction of the mandibular motion, because in these cases there are excessive, the mandibular motion is there, so it restricts the mandibular motion to its normal motion, and prevention of condylar displacement, so it ultimately prevents the condylar displacement. So the injection technique, I will share my patient photo to briefly explain the injection technique. So coming to the injection technique, there are certain landmarks present in the autologous blood injection. The first landmarks is outer canthus of the eye. So this is the outer canthus of the eye. And second landmark is the pinna of the ear. So a line drawn between the outer canthus of the eye and pinna of the ear. It is marked with a marker, and after the marking the line from the pinna of the ear, 10 mm anterior and 2 mm inferior, this is the point for entry into the TMJ capsule, because at this point various studies have been previously done. At this point we will mostly in a this capsule, TMJ capsule and joint space. So it is given. So in this before doing this technique, we have to give a periauricular block. So we have to inject the around the pinna of the ear 1 or 1.5 ml of local anesthetic. Topical anesthetic is given previously first, and then local anesthetic is given to reduce the pain. And after this, we have to mark this area, and we have to take a 5 ml, at least 5 ml of blood from patient's own blood, and immediately after withdrawing, we have to immediately insert into the joint capsule, because if we wait for much of the time, the blood gets coagulated. So immediately we have to start. And what are the criteria to inject into the first? We have to divide the 5 ml drawn blood into two parts, 2.5 ml each for the right and left joint. And within the 2.5 ml, we have to divide again 1.5 ml for the capsule and 1 ml for pericapsular tissues. So the blood collection, as we discussed earlier, the 19 gauge needle is used for the joint capsular access. And we have to inject it. And after injecting, we have to give a immobilization. So why immobilization is needed? Immobilization means we have to restrict the joint activity. So how can we restrict the joint activity? By either doing the barrel bandage. That means placing a bandage over a face. So tighten it in such way that there will be no motion of the joint. Or in some cases, if patient is non-cooperative, you have to go for intermaxillary fixation using arch bar. So injection technique recommended 2 ml in the superior joint space, that is in the joint capsule, and 1 ml in pericapsular tissue. Alternative 2 to 4 ml in the upper joint space and 1 to 1.5 ml. But usually the 2 ml in superior joint space and 1 ml in pericapsular is sufficient. Concurrent manipulation, open and manipulative mandible forward. So after giving injection, we have to tell the patient to open the mouth and help the mandible to gain its normal position. And barrel bandage is given for 1 to 3 weeks. So the duration for the immobilization is typically 3 weeks. It may range between 1 week to 1 month. And barrel bandage or intermaxillary fixation, as discussed earlier, the methods. And what are the benefits? It accelerates fibrosis. As there is no movement of the joint, the blood injected will causes accelerated fibrosis in both joints. So what are the criteria to repeat this treatment? So there are two main given criteria. One, by the McCohen et al., repeat only if a recurrence of subluxation occurs. So this is the common. And again, repeat twice weekly for 3 weeks regardless of the occurrence. This is more accepted by Schultz et al. But in my cases, I have in 2 cases I have done only 2 settings within 3 weeks of time. I don't need a third session for the same, because the symptoms subsided of both this patient, which I will show in the next case report cases. So this is the case 1. So this is the 18-year-old female patient. It is the patient was mentally unstable. The patient coming to our department came with the various reports in which it is shown that the patient has a calcifications in the brain. So it is mentally disabled patient. And the chief complaint was patient was unable to close her mouth. Sometimes because of the yawning, laughing, the TMJ dislocation is triggered, and after triggering the dislocation, their patient was unable to close her mouth. And on multiple occasions, it was shown to the general practitioner. It was sent to the general physician, dentist, but all they tried was failed. So after that, patient came to our department, and the chief complaint was repeated locking of the lower jaw, inability to close mouth, mental disability with difficulty in following instruction. Associated findings were deformed thoracic vertebra, brain calcification foci, and disease duration is of 4 to 5 years. The previous management, as discussed earlier, was with manual reduction without any success. So this is the case 2. So this is the 18-year-old female patient. It is the patient was mentally unstable. The patient was unable to close the on the clinical and radiographic findings, we advise OPG and TMJ open and close method TMJ view for this patient. And on the TMJ OPG, we can see that there is anterior open bite and posterior premature contact is there in molar area, and there is prominent gonial angle and blunting of the articular eminence seen both sides. So in this image, you can see the blunting of the articular eminence was seen both sides, and the prominent gonial angle is seen. And there is anterior open bite and posterior premature contact. And based upon these findings, we came to the conclusion of the chronic recurrent TMJ dislocation. So what are the challenges in this case? Was first, the patient was mentally disabled, the patient was not cooperative, and the second things was there was a recurrent episodes for a long period of time, and all the other the manual reduction techniques were failed. So based upon this, we come to the conclusion that we will perform a autohemotherapy, as patient is not unfit for the surgical procedure because of the mental disability and age. So the intermaxillary fixation, patient is unable to cooperate. It was avoided. Surgical procedure because of the poor compliance risk. Prolotherapy was our decided treatment. Non-invasive, minimal patient, the cooperation is needed, and autohemotherapy, effective, simple, and safe alternative. So this was the injection technique as we discussed earlier. So we give a 2.5 ml on both sides. And this was the post-op result. In this case, you can see patient is able to close her jaw, lower jaw, spontaneously on its own. No external pressure, nothing, no manual reduction is required. And in these images, you can see, and in this image, patient is happy, although it is mentally disabled, because she can close her mouth. It is seeing happy. Okay. So what are the clinical outcomes results we get? Complete resolution of the dislocation episode. The dislocation episode was resolved. Significant tightening of the TMJ is seen. Reduced mandibular opening range. The excess mouth opening is also reduced. Voluntary mouth closure without any external support. This was the prominent finding. Resolution of the associated pain. Again, the pain is resolved, and no complications were observed during and after the follow-up period. And this patient was follow-up done for at least 1 year, and after 1 year, patient was not able to come for the follow-up. Till 1 year, there were no episodes, repeated episode of this dislocation. And this was the article published in the Journal of Oral Disease Markers. So this is the another modification of this technique. So in this case, not only we can do the autoimmunotherapy, we can adjunct it with the arthrocentesis. The arthrocentesis technique is nothing but getting into the joint space and flushing out of the saline. So flushing of the saline will cause all the inflammatory mediators and inflammatory exudate will come out from the joint, and it will help in the reducing the pain. So along with this arthrocentesis, we can also perform the autohemotherapy. So it will give a synergistic effect in reducing the pain and dislocation. So as the follow-up is weekly during first 2 weeks or 3 weeks. And after that, the bi-weekly follow-up is done, and minimum 1 year monitoring should be done. And this one is another case of this same technique, autohemotherapy for treatment of recurrent TMJ dislocation, published in the University of Journal of Dental Science, Aligarh Muslim University. So the patient we advise with the TMJ view. In that TMJ view, they are showing dislocation of the condyle beyond the articular eminence. So in this TMJ view, we photograph the joint space of right and left on open and close of the opening and closing of the mouth. So the patient presentation, the patient complains of recurrent spontaneous TMJ dislocation, the chronic recurring episode affecting the quality of life, failed conservative management previously, and anterior mandibular positioning with locked jaw during the episodes. So in this patient, in this case, the patient was a 25 years of male patient with a complaint of recurrent DMJ dislocation, which are not self-reducing, and patient has to take a medical help to maintain its normal position, and the mandible becomes anteriorly. The anterior mandibular positioning was there and with locked jaw. So this was the OPG showing the dislocation of condyle beyond the articular eminence. So the diagnosis and clinical assessment, the clinical examination was done, and radiographic examination we did a OPG and TMJ view, and differential diagnosis we ruled out the any neuromuscular or structural abnormalities such as MPDS, etc. And treatment decision, as the patient was young and not willing for the surgical procedure, we have to go for autoimmunotherapy. So in this case, same. We first of all mark, and after marking, we insert the blood into the joint space. So the post-operative phase, the mouth opening was the excessive mouth opening was reduced to the normal mouth opening. And the deviation of mandible was there reported pre-operatively, which was reduced upon the post-operative time period. So the primary outcome was complete resolution of the recurrent dislocation episodes, functional, restored normal jaw opening and mandibular movement, and significant improvement in quality of life and functional capacity. The establishes autoimmunotherapy as an effective, minimally invasive option for recurrent TMJ dislocation. So it was because it reclaims the original joints position. So it was also called as reclamation autoimmunotherapy. So key advantage of this technique is it is simple, minimally invasive technique, no serious complications. Sometimes the complication which will you see was this swelling or pain complaint for a shorter period of time, 50 to 20 minutes post operatively. After that, patient complaints are nothing reported till now. Suitable for all patient types, including mentally challenged. Effective as a primary therapy for pre-surgical option. So before turning towards the surgical option, we can always go for this minimally invasive surgical technique. Autologous material, no foreign body reactions were seen, and it is cost effective. It is cost effective. You can done under local anesthesia in your dental clinic setting. So it is a good option. Application in special populations such as mentally challenged patient with a systemic comorbidity, it is unfit for the surgery. So patient which has systemic disorder which cannot be operated, this is the option. Patient who refuses invasive surgical intervention, cases requiring early non-surgical intervention before surgery. So it can improve the symptoms before going to planning for the surgery. And in pediatric and geriatric population, with contraindication, this can be used. So there are various controversies, but which I'll explain brief. The controversy regarding permanent joint destruction. There are few reported cases that it might damage the disc, but overall the scientific review literature is towards the this autoimmunotherapy that it is sufficient. and there are no severe destruction of the joint. In vivo, animal studies suggest no permanent damage. Need for standardized dosage. It is lacking. Some variable dosage are given in the review literature. Limited long-term follow. So long-term follow-up is required, and further clinical studies and evidence synthesis is needed. So, what are the future direction? It can be autologous blood can be replaced with PRP for joint space reduction dislocation cases, or it can be given with ethanolamine oleate. And long-term follow-up is required, and multi-center clinical trials will give evidence-based guidelines. So it is a effective, minimally invasive prolotherapy option for chronic recurrent DMJ dislocation. It is non-surgical modality with minimal complication and serves as an excellent primary treatment choice for patient unsuitable for conventional therapy and those demanding conservative management. It application in special population like mentally challenged individual demonstrate its versatility in safety profile. And further research establish a standardized protocol and expand the evidence base for evidence-based clinical guidelines.
Thank you, Dr. Hange. And that was really an different aspect of management. And a truly, your cases speak a lot about your management skills, sir. So thank you so much for sharing this with our audience here. I would like you to visit the chat box before you log out, because once you log out, all the chats, you will not be able to see them again. So please visit the chat box. If there are any questions, you can just answer them in the chat box. And thank you so much for bringing this therapy here, because I think this was the first time this therapy has been demonstrated in Indian Orofacial Pain Congress. Thank you so much, sir, and we look forward to your patent lecture on your patent also later on some other congresses. Thank you so much. And on that note, can you stop sharing your screen, doctor? I think your screen is still on. Yeah. I'm quite surprised that at Latur also you're managing such lovely cases over there. So hats off to you guys, sir. There.
I'm done with
No, so the screen
ending
is
the
still.
share.
Just stop screen share.
Okay. One minute, please.
Yeah, take your time.
Okay. Done.
Yeah, thank you so much, sir. And you can just visit the chat box and answer the questions over there. On that note, I would like to welcome our next speaker and the last speaker on the speakers panel. Thereafter, we have a paper presentation from faculties and students all over India. Dr. Rajesh Ravindranathan, or we always call him Dr. Raj. So, frankly speaking, Dr. Raj, this is the first time I'm saying your name loud out loud. I would say it's always been Dr. Raj to all of us. And yeah, hello, sir. Just say hello to the.
Hello, namaste from India. Salam alaikum from Dubai. I'm really happy to be here. It's my
Dr.
first
Raj,
time here
just
as
smile for
well.
the camera first.
Oh,
I
okay.
always like to take before and after lecture pictures. Smile. Thank you, sir. Thank you, sir. And see, I'll tell
The
you what,
before
Dr.
and
Raj,
after are going to look the same.
if I start introducing you, I think we will need one more lecture for that. But you are known as the right bite guy, like the person who is introduced right bite to India, the right bite sleep and TMJ pain care. And wherever I go to any congresses or any conferences, there's always a mention of Dr. Raj. So it's first time I think we have been face to face. It's always been on social media. So thank you, sir, for gracing this International Orofacial Pain Congress. And I guess this is our first event together in the Orofacial Pain summary. So thank you, sir. This is our third International Orofacial Pain
I've
Congress.
heard.
And Welcome to International Orofacial Pain Congress. Instead of me telling or our audience, I think audience know about you. So stage is all set for you. And I know
Okay.
you have some time constraint also, so I will not waste time in that. And apologies on the delay, sir.
No worries. It's okay. Can I start sharing my screen?
Yeah, please, sir. That's a lovely background every dentist would want to have, sir. So many accolades and awards.
Yes, my office is pretty cool, actually.
Yeah. Yeah,
Even
your
if I'm
skill.
not sounding humble. Okay, let me start my presentation. Okay,
It's all.
is it clear? Can you see it?
Yes, sir. Please go ahead.
Okay, great. First of all, thanks for having me here. I'd like to thank Dr. Nurul and Dr. Sonal for hosting me at this conference. My name is Dr. Raj. I'm not going to speak too much about myself, but I'm proud of being a pioneer in neuromuscular dentistry to help treat TMJ and sleep disorders. And I've entered the arena of sports dentistry like 10 years ago. I lecture all over the world. Actually, I'm a little late. I got to go fly to Warsaw tonight. But I'd like to say that the whole reason that I'm here is I believe uh, people need to understand the importance of the physiology of occlusion, not just with respect to TMJ disorders, but with any dental treatment that we do to maintain the balance and symmetry of muscle function. The Right Bite is an organization, is a company that I'm the chairman of. We have 4 centers in India. We have 6 centers outside of India. I keep traveling to all these centers. We have teams that follow the protocol that I have copyrighted. It's known as the Aerodontics protocol, which I'll be showing today. And I also head an organization called the ICMO. It's the International College of Craniomandibular Orthopedics. It's a very small organization. It's a very niche organization for dentists who are interested in furthering the science of neuromuscular dentistry. I am currently the international secretary of that organization. These are all the stuff that I've done. I finished my dentistry in Chennai. I was born and brought up in Bahrain, actually, and I finished my dentistry in 1997. So I'm kind of old, and I've done all of this over the past 30 years that I've been practicing TMJ and sleep. So my practice is 100% TMJ, sleep, and posture, and now sports as well, sports dentistry. And unfortunately, I have to say this because most of your dentists here, 95% of my patients are post dentistry. Unfortunately, it is very disheartening to see that we as dentists are not taught enough about the importance of occlusion and how, if you don't take care of the occlusion, everything over here, that's what you think, not just here, but all over the body goes into a toss. Since I have only half an hour, let me try my best to cram up everything. Normally my course is like for 5 days. I have to cram all that up into half an hour. It's a tough task, but I'll try my best. The science is known as neuromuscular dentistry. The protocol that I preach is the Aerodontics protocol, basically airway dentistry. I started this in 2006. It's all about data. It's data-driven, digital precision in diagnosis and treatment planning. Occlusion. Boring, right? No one likes occlusion, which is why it's so difficult to get this message across to everyone. But if you're talking about occlusion, if I have to make it interesting, there are a few questions that I need to be putting across. Let me see if how you can answer these. Sorry for that. So, first question. What do we do? What do we use to check occlusion? Generally, a 120 micron articulating paper, 140 micron, 200 micron, Raj articulating paper, Vijay articulating paper, in spite of knowing that the occlusal proprioception starts at 5 microns. That if there is a bite perception at 6 microns, it's going to cascade into a dysfunction all over the body. We don't realize this. Why? Because generally, the first symptom would be a headache or a neck pain, and the patient wouldn't come to you. He would go to an ENT. Why would a patient with a migraine come to you? Hence, most of our patients are just simple occlusal issues. Okay? And there are equipments out there which can measure from 4 microns. And when we register a bite, is it 3-dimensionally perfect? All we've been taught about during dental school is what is the vertical, which we call the pitch. What about the yaw? What about the roll? The mandible sits in a 3-dimensional space. Actually, the maxillomandibular complex sits in a 3-dimensional space, not in just 1 dimension. We can't just look at the pitch. You got to look at the yaw and the roll. What controls all these? The muscles. So if the muscles are not symmetric on both sides, there's going to be a problem. Next, does muscle physiology have anything to do with occlusion? Holistic physiological dentistry aims to achieve physiological occlusion. Simple. The masticatory muscles, which position and connect the mandible to the skull, should be the focal point of correct occlusion. So we correct the muscles, correct the jaw, and then correct the teeth to maintain that muscle physiology and the jaw position. Centric relation. Even when I was studying, it's the same thing. It just keeps changing. When we were taught, it was the most retruded position of the mandible. Then it became more anterior and superior. Then it became more physiological. All the way back in 1987, Dawson himself has come and said, no, it has changed. Yet, we still continue to teach the same thing. Whenever we ask to register the bite, what do we tell? Go back, go back. Imagine when you're going back, what are you actually doing? You're pushing the condyle into the TMJ complex. That's going to cause pressure in there. Wouldn't that hurt the complex? And hence the stomatognathing system? This is where NMD and its muscle physiology concepts come to the fore. So what is the stomatognathing quad? It consists of the muscles, joints, airway, and teeth. So the primary aim for any dentist is to make sure that these 4 components are in harmony with each other. So why does it have to be that? Unlike the other joints, with this complex and this joint, the teeth decide where the jaw has to go. In short, the occlusion decide where the jaw has to move. So if the teeth are this way, the jaw has to go that way. If the teeth are this way, the jaw will find its own habitual occlusion, which over a period of time would cause the muscles to become imbalanced, asymmetric. There are research papers that show that a normal human being swallows about 10 to 15,000 times a day. And the only time you go into centric occlusion is when you swallow. So imagine going 15,000 times this way to get into centric occlusion, to avoid that malocclusion. It's going to cause an imbalance in the muscle. We are not thinking in those terms, unfortunately. So no matter how malpositioned the teeth, the muscles will struggle to create a centric occlusion. Period. I have a very good illustration for this, and I like showing this a lot. Look at this guy. His one arm, his one bicep is bigger than the other. Why? He may be using it more. He may be lifting dumbbells more with that arm. The same thing on the face. It's not different. It's just muscle physiology. It's the same all over the body. If this lady has the missing tooth on the left side, she's going to be chewing on one side, which is almost 99% of all our patients. What's going to happen over a period of time? Those muscles will become hypertrophy. They start hyperfunctioning. And when that lady comes to you to replace that missing tooth on the left side, we shoot the bite on the same faulty habitual occlusion. We got them thinking. And these are my everyday patients. It's very simple. I just correct the occlusion. I correct the muscle, correct the occlusion, bam, they're fine. No more pain. I don't have to give Botox. I don't have to give PRP. I just correct the occlusion. Well, diagnosis is very important. A couple of lectures previously, previous to mine, one doctor mentioned about diagnosis. Yes, it's the most important. Even if the patient doesn't have TMD. I can tell you this as well, 20 to 30% of my patients don't even have TMD, but they have pain. Okay, so I'm not getting into all of that because there's no time. So this is the protocol, a detailed questionnaire, radiology, palpations, examinations, cranial nerve screening, heart rate, voltage, and capnography, mainly for my sports clients. The stop band questionnaire and an ENT and chiropractic consultation is very, very important. And to top it all, the sleep study. I'll get to that as well. We used to do a lot of two-dimensional imaging with OPGs and other stuff. We don't do those anymore because we have the CBCT. We're looking for example, the joint space. It needs to be at least 2.5 millimeters. Here you can see it's less on the left side. We're looking at the shape of the condyle. We're looking for degenerative changes within the condyle. This is what I've understood over my years of practice. You can use the principles of neuromuscular dentistry until adhesions form. Any sort of ankylotic changes, bam, done. I can't touch that patient anymore. But till then, do not let the patient walk off if you hear a clicking. Don't tell it's normal. Because the clicking would go. Once they get into IDD without derangement, without reduction, the clicking would go, but then the mouth opening starts reducing. I'm not getting into all of those as well, because I'm sure someone else will have covered all of that. I hope so. Another important image that we look at is the airway. So we measure from the PNS, the posterior nasal spine, to the epiglottis. That entire space, the volume, three-dimensional, has to be at least 25 cc. If it's less, then the tongue, while sleeping, because this is taken when they're standing up, awake, and erect. When they go to sleep, when the muscles go to atonia, the tongue goes to sleep as well. The tongue will drop even more back, blocking the airway, leading to sleep apnea. Another image that I like showing, we don't understand the importance of the tongue, and there's no specialist for the tongue. Most of these patients, they have faulty tongue posturing, maybe because of poor breastfeeding techniques, maybe oral habits, maybe even a tongue tie. So if the tongue is not on the palate at rest, then, and if this has happened during the growth phase, the tongue helps the jaws to grow three-dimensionally. If the tongue is out of the palate, it's not going to grow three-dimensionally. The third dimension is compensated by going in, the palate goes in deep. When it goes deep, what's sitting on the palate? The septum. The septum bends. And the septum bends, the nasal airway bends, the nasal airway gets congested, inflammation, allergies, And these patients are lifelong on medicines, on steroids. Why? Because even if the patient does a septoplasty, it's going to relapse because the cause is still there, which is the palate. The ENT knows this, but he doesn't know which dentist to send to because dentists are stuck on teeth, unfortunately. So my whole lecture here is to make sure you understand that you are not just tooth doctors. Okay. Sleep, very important for me. Almost 90% of my patients with TMD have some sort of a sleep disturbance, sleep breathing disorder. Okay. We do a simple stop bank questionnaire, which includes snoring, tiredness, awakenings, all of that. I don't have the time to explain all of it. If you're interested, please get in touch with me and you can join one of our courses. Again, it's all about data. The best way to get data from sleep is by doing a polysomnograph, but it's so complicated. To do a sleep study, you got to sleep. You can't go to sleep with all those, equipments on you, which is why the watch pad and the level 3 sleep study, the home sleep tests have become very popular nowadays. And this is what we do. So why sleep? What is sleep apnea? Obstructive sleep apnea. An obstruction during sleep that causes an apnea event where you can't breathe. No one's going to accept this, even if they are snoring. Snoring is the first symptom, but no one, because it's a point of ridicule. It's in our part of the world, it's classified according to the volume. If it's heard across buildings and corridors, then you're snoring. No. Snoring is because the tongue has gone backwards because it's not on the palate. If the tongue goes backwards, it hits the small uvula behind, and the vibration is the snoring noise. Which is why I always wonder what a pulmonologist is doing treating sleep apnea. The obstruction is in the nose, in the nasopharynx, and in the oropharynx. An ENT and a dentist have to be treating obstructive sleep apnea, period. Why am I even talking about OSA? In dental school, we have been taught sleep bruxism is 95% biopsychosocial, which is a psychological disorder, mental stress, and 5% everything else. But over the years, ever since I've been practicing, I've noticed that it's 95% airway. And 5% it becomes mental stress because the airway stress is not getting treated. It's being looked beyond. No one's even looking into it. Unfortunately, again, this is what a typical sleep study looks like. We're looking at the index you can see in the blue box, in the blue circle, AHI. I also look at the number of desaturations, 89. Why am I looking at that? Every time you go to sleep and the tongue falls back, the airway gets blocked. There's no oxygen going in. The body has to respond. Otherwise, you're dead, right? So how does the body respond? The awakening center, the sleep center in your hypothalamus, it literally tells your tongue to move forward. As it moves forward, it drags the lower jaw along with it because it's connected to the genial tubercles. And the malocclusion creates the bruxism. And this is all proven. It's not just hearsay. I'm not just putting some fairy tale out there. So literally, every time there is an oxygen desaturation because of a block, there is a clenching event. The clench is a physiological, the bruxism is a physiological response of your body to keep you alive. It's a good thing at the expense of the muscles and the TMJ. Because the body doesn't care about the TMJ. It needs you to breathe to be alive. So this is the hypothesis that we put across. Now, I don't just stop at that. I'm a boy. I love my toys. So this is another equipment that I have because I want to measure each bruxing event. You can see in the red box on the right side top, 1,138 microvolts. So muscle tonicity is measured in microvolts. Any muscle at rest is about 1 to 2 microvolts. Muscles during chewing, heavy chewing, or even mental stress related clenching, like with anger, is about 200 to 300 microvolts. These are all measured. We measure each and every patient of ours. But during sleep, every time there is so we do the SpO2 analysis on the site. It's together, it's done together. Every time there's an oxygen desaturation, bam, the night max force goes up. It's almost 20, 30 times more than the daytime clenching force. And what do we provide to our patients? Night guards, mouth guards. It's not going to help. Again, you're thinking like a dentist. All that the night guard does is protect the teeth from further wear and tear. It is not stopping the clenching, because even the night guard is going to get the jaw back. You need to wear a sleep appliance that will keep the jaw forward and the tongue forward. We need to understand this more and more. Okay. So what all are we looking for? We're looking for rotations, palpation. These are the muscles that we palpate. We look at the extraoral palpations, intraoral findings, extraoral findings. I always wonder why this slide was never shown to us during dental school. The C1, C2 plane has to be in line with the occlusal plane. Any change within that, there's going to be a descending factor or even an ascending factor that will relate to pain anywhere in the body, which is why diagnosis is very important. For example, if the jaw, the lower jaw, because of a malocclusion, shifts to one side, there is going to be an automatic compensation in the head position. The head would shift, the shoulder would droop, the hip would rotate, the feet will pronate, and then you're going to end up with pain anywhere in the body. So unless you diagnose the whole thing, so let us dentists not be lazy. You got to be more active. You got to look for things. You got to be an oral physician and not just a tooth doctor. Oh, I didn't know I had this slide here. So, for example, this patient, I did not do anything on his body. I just corrected his jaw position, and his chest became normal. This is something that I really enjoy doing. Something new in our protocol. Oh, new meaning like 7-8 years ago. Cranial nerve screening. We were all taught in anatomy about the 12 sets of cranial nerves. Do we even look at them? What do we even do with them? As an example, every one of these cranial nerves has a function with jaw position, with muscle function. As an example, the uvula. What is the job of the uvula? Do we think it's a vestigial organ? No, it has a function. One function is to help with nasal drip, postnasal drip. What is the second function? It shows us how the vagal tone is. Cranial nerve number 10. So if the uvula is deviated to one side, that means the vagus nerve is not functioning on the other side, on that same side, ipsilateral side. How do you fix it? Take a long cotton bud or a Q-tip, go to the uvula and go tickle, 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 tickle. 20 times, 2 months, the vagal tone improves, patient is breathing better. Because the vagal tone is improving, the motility improves. And guess what? The jaw position is even better. We do a screening of all 12 cranial nerves for all patients. It doesn't take too much time, 6 minutes. That's all. That's all it takes. But why weren't we taught any of these? So, keeping all this in mind, what do we do? Sorry, what do we do? Any dental patient that comes into our office, we make sure that we go through the entire diagnostic protocol. We find out what all the problems are. And we first get them into first phase, which is to make sure that the muscles are isotonic, bilaterally symmetric. How do we do that? By applying a very specific, very specific TENS unit, confirming it with axiography and kinesiography. What is kinesiography? Jaw movements. What is axiography? Condylar movements. And all of this digitally recorded. So there's proof. Every patient, every step is proof. And based on that jaw position, we give an orthotic on which we do digital microocclusion, which means to the 5-micron level. So what are the TENS? Transcutaneous electric neural stimulation plus EMG. Now, I believe my other two colleagues, Dr. Tatu and Dr. Varun, also might have spoken about this. They're also members of our great ICMO organization. So I'm sure they've covered all of this. So that's why I'm just running through. Unlike the normal TENS units, these TENS units are very specific. Why? They disperse ultra low frequency, 1 to 2 hertz. They're antidromic. They don't go straight to the muscle. They go to the nerve. And then through the efferent and afferent fibers, supplies all the muscles by that nerve. They're bilaterally simultaneous because they have an earth. It doesn't go from the right to the left, which would then create an imbalanced pulse production. So it's bilaterally simultaneous at exactly 1.44 seconds, because that is the time interval required for a muscle to achieve its ideal resting length. And all of this in one unit. There are only 2 units in the world that has this. One is the J5 by Myotronics, and one is the ProTens by and one is the ProTens by SDI Matrix. Oops, sorry. Okay, so sorry. Okay. This is what the patient would look like during treatment. I know it looks scary, but it's not. It's not scary, but and it's not painful as well. You need what the SDI myoaxiography does is you can incorporate the CBCT, you can incorporate the intraoral photographs, the intraoral scans, the face scans with just a phone. They have software for that. And you can decide where the jaw, because you can segment the mandible from the CBCT and decide where you want the mandible to be within permissible limits. We're using the scale on the right side. So we teach all of this during our course. So you can see here with the CBCT and using their digital articulator, you can reposition the condyle to see which position would be better. And using the AI technology, the apt trajectory is also can also be seen. And on that position, we export it as an STL file straight to the lab. We design the orthotic. We also design sleep appliances. We 3D print our sleep appliances as well. We use the Accurata 3D printers because they have a nitrogen chamber so that they're stronger and all the oxides are also removed during the curing process. The patient wears these appliances and we look for the remaining causes like tongue ties, posture, myofunctional therapy, mewing, ENT, biweekly corrections. Now, with corrections, it's most important to make sure it's digital. So there are 2 equipments for this. One is occlusence from Bosch, and the other one is T-scan from TechScan. I'm sure everyone's heard of these equipments. They're both almost the same. T-scan has an added advantage because it measures time. Both of them, the sensors are like 60 and 90 microns, but that doesn't matter. Why? Because the sensors within the sensor starts measuring from 4 microns. That's the advantage. They both do the same images, same figure. The advantage with occlusance, however, is that, first of all, it's hands-free, it's Bluetooth. But for me, as far as I'm concerned, is the sensor is colored. So if the sensor is colored, you can see the image on the iPad, but you can also see at the same time the smudge on the tooth. So you know where exactly to reduce. We do a lot of disclusion time reduction using the occlusion. It won't be as precise as T-scan, but what is disclusion time reduction? It's all about making sure that during canine disclusion, it shouldn't take more than 0.4 seconds. It's impossible to use your stopwatch and just your eye to look at it and measure that. You need equipment. We do a lot of myofunctional therapy before and after the frenuloplasties. We do a lot of photobiomodulation. Because of the lack of chiropractors and good physiotherapists in India, and even in Dubai, or even in the countries that I work, I myself went and learned from Mariano Roccabado how to do the distraction exercises. A lot of our members in ICMO follow the same protocols. Now, the orthotic has to be worn for about 6 to 8 months. They keep doing the corrections, the tongue, all of that is done during that time. They cannot wear it lifelong. So what do? If you remove it, the jaw is going to go back in again. So the wrong habitual position. So you got to stop that from happening. How do we do that? By now becoming tooth doctors. We can either, my favorite is orthodontics, cup the orthotic from behind, supra it up and expand, or smile design with crowns. The patient came with headaches for 20 years. She went a totally different woman. We do a lot of expansion. Now, the biggest problem with expansion is that I've heard from other people say is asymmetric expansion. Why? It's not just the force, it's also the muscles. Hence, all our patients, we make sure that they wear the orthotic for at least 2 or 3 months to ensure that the muscles are isotonic, symmetric, bilaterally, and then we do the expansion. There are physiological appliances like Vivos is the best. 3-dimensional expansion, even at the age of my oldest patient is 62. I use the ALF for kids. Then we do a lot of MARPE and MSc. Everyone knows what that is about. This is a good illustration as to how that is achieved. Again, all of these patients, we make sure that the neuromuscular orthotic is given first. And we incorporate all of this into sports dentistry. I'm really proud of this fact. Half the Indian cricket team wears our appliances. But sports dentistry is now coming huge, becoming really huge in India. IDA with Dr. Reena is doing a lot of sports work, and they represent India at different conferences across the world. I do a 2-day course every 6 months in the US at the Academy of Sports Dentistry. So if anyone's interested. So it's all about teamwork. You alone cannot help the patient. You as a dentist, you need a chiropractor, an ENT, a physiotherapist, a psychologist, and a psychiatrist, because this patient go crazy. It's not their fault. They are in pain. Someone has to help them. So it's always teamwork that's important. My final take-home message, we are not just two doctors. Arigato, dhanyawad, shukran, thank you very much. And if anyone wants to get in touch with me, I'm on Instagram, Doc Raj Rav is my handle. Dr. Sono, over to you.
Thank you, Dr. Raj. This was really a very eye-opening lecture, because this is what was the Congress theme, that we need to inculcate multidisciplinary practice in our care, and we are not two doctors. So that's what was my starting statement also when I started with this Congress. So
Wonderful.
yeah, so it was, I would say it was a very nice concluding lecture for everybody, because this is a conclusion of speaker's lecture, but we have paper presentation participants now. So if I know you have to rush to airport, but if you can listen through your phone, and
I will try my best,
you will be
yes.
intrigued by the young minds, how they are functioning now,
I
because
get it, yeah.
yeah, the whole theme of this Congress is to prepare and condition new dentists to develop their keen interest in temporomandibular joint disorder cases or neuropathic
Yeah.
cases, and stop drilling and grinding those teeth.
Yeah, exactly. Yeah, think
Thank you
beyond
so
the
much,
teeth.
doctor. Thank you
Yeah.
so much, doctor. And you've been
Thank you for
gracious.
having me. Thank you for
Great.
having me.
Thank you so much. And on that note, yeah, doctor, one thing did I ask you the question that what changed your practice to becoming an the pain specialist that you are today?
No, you
What
haven't asked, but I can answer it.
Yeah.
uh, I accidentally, it was an accident. I did my orthodontic training in Italy with Dr. Savastano, and he made me understand that orthodontics is not just moving teeth, it's actually fixing the face. Now, if
Yes.
you need to fix the face, you got to fix everything else, which is muscle, fascia, nerves, tissues, and not just teeth. And this I'm talking about 25 years ago. Unfortunately, we in India, we're still stuck with teeth. The education system, this is my personal opinion, education system in India is just brainwashing, vomiting it out at the exam, and forget whatever you've learned. So yeah, so what changed my mind was my experience with Dr. Fabio. And ever since I came back to India in 2011, after I finished my PhD, I'm like, wow, okay, let me give back to my country what because no one was doing it at that point of time. No one was doing this. So yeah, that's what got me here. Thank you for asking the question.
But it's the baby steps we take, like the organizations like yours or this conference. This is the theme behind it, that we have come out of our tunnel vision and look into dentistry as a whole. As you said, the stomatogathic system. So please, that word itself says it all. But understanding the basics of stomatogathic system is more important than anything else. So
Thank you,
no more the
Sonal. Thank
tooth
you so
doctor.
much.
No more the tooth doctor. So if you can, if you can be a part of our paper presentation team, that would be also great, doctor. If you can just
I
join.
will try my best. Yes, I have to rush now. Thank you again for having me, and all
Thank
the
you so
best for the future. Thank you.
Thank you.
Bye.
Thank you. Smile for the camera again, sir. After
Okay.
picture.
Okay.
Yeah, I like to take before and after pictures, so I'm documenting it very well.
Oh, okay. Because we look the same.
Thank you, sir. Thank you so
Thank
much.
you. Bye. Yeah.
Okay. On that note, this brings we are at the end of all the speakers session, but we have the most important session. Why this Congress has been put in place? That is for the paper presentation from our faculty, our students, PG students. Before I begin with the paper presentations, I would like to welcome our jury. They were our speakers for the Congress. That is Dr. Selva Kumar sir, who was a speaker just some few hours back, and Dr. Aparna. She also presented today, and I'm sure the way they presented, you all the paper presentation participants know now what kind of standard we are looking out for. I'm not here to scare you guys, but let me reiterate what I have been telling on the group. Also, we have a small little group of 4 paper presentation participants. We had around 29 or 30 paper presentation applications which were shortlisted amongst all of them. Later on, again, we refiltered a few of them, and now we have 15 paper presentation participants with us, out of which I guess category A are 7 of them. Category A will never be judged because they are our fellow colleagues in their faculty or maybe private practitioners. So I don't consider myself equipped enough to judge my faculty members. But definitely the category B, that starts with students, that is UG, PG, and the PhD students, they will be judged under 5 criteria, and we have already mentioned them, the criteria that they will be judged on. Dr. Harsimran was supposed to be a speaker as well for the Congress, but due to some reasons we could not accommodate her, mainly because of the time schedule. So Dr. Harsimran herself is a orofacial pain specialist, and AIMS, she's practicing at AIMS Delhi. She will be our first speaker for the day, but paper presentation participant, but I will not consider her as a paper presentation participant. She's a fellow and colleague of ours. So we will be giving her 20 minutes rest. All category A students, faculties will get 8 minutes. and thereafter question and answer sessions by the jury. And the category B will get 5 minutes, and thereafter 2 minutes of this thing, question and answer sessions. So Dr. Harsimran, can you switch on your camera and the mic and say hello to the audience?
Hello, good evening, everyone.
Yeah, hello.
Am I audible?
Yes, you are audible. And can you start sharing your screen?
Yeah, sure.
Dr. Harsimran is also a fellow in orofacial pain, and she's completing her master's now under Dr. Davis Thomas's guidance, and she's our colleague. Yeah, your screen is visible. Can you go on the presenters mode?
Yes.
Welcome to International Orofacial Pain Congress, Doctor. And next year we will welcome you as a speaker. I'm sure on that.
Thank you. Thank you so much. Is my screen visible, Dr. Sonal?
Yes, but there is an echo in your voice. Is there any device next to you which is
not really.
There's a slight echo. Everybody keep that these things in mind, that there should not be any echo. Secondly, all the cameras, I need them to be on, paper presentation participants.
Is it better now?
Yeah, you can continue, please.
Okay. So thank you, Dr. Sonal, for accommodating me at the last minute. And again, I'll start with a formal, wish. Good evening, everyone. It is truly an honor to be here today. And I would like to begin by thanking my mentor, Dr. Davis Thomas, IOP conference for having me here, and Dr. Sonal. And I'm delighted to have this opportunity to connect with such an esteemed group of professionals and peers today. And this picture, I would like to start with this particular picture today, what you are seeing on the screen. This picture shows some ancient scholars that are trying to untie a horrendously tied knot on a cartwheel. So this is actually happening way back during Alexander's era, and they are trying to actually open this knot, which is actually called as Gordian's knot, because this was all happening in the city of Gordium. And what Alexander did to this knot, I'll tell you later. But this is a little, background about the story and what these scholars are doing. And if you can see, this knot has multiple layers and complexities and intricacies. How to untie this particular knot is a big question. So likewise, non-odontogenic pains, often they present with overlapping symptoms and multifactorial etiologies and diagnostic ambiguity, which really make them a difficult area to understand and address, not only in dental practice, but even in medical practice. So today I'll be talking about the power of diagnosis that can help us to entangle these kind of complexities and move toward a more confident diagnosis and effective management for our patients. For this, actually, we need thinking that is something out of the box, and that is the key to unlock the orofacial pain. But solving them doesn't always need reinventing a wheel. Sometimes you just need a fresh perspective, or maybe some kind of understanding of the basics that can give you a better solution. By thinking creatively and staying grounded and staying connected with your principles of anatomy, physiology, biomechanics, and psychology can actually bring about a major change in our patient's life. So I have nothing to declare here. As a dental professional, and when we encounter patients of orofacial pain, there is a tendency that we attribute all the cause to a local area such as TMJ and associated structures. However, this focus on the joint or joint itself may lead to a very tunneled vision or limited diagnostic approach, whereby the underlying cause of pain is not thoroughly understood or investigated. The assumption that the TMJ and its related components are solely responsible for discomfort may result in actually overlooking other potential contributing factors. So that is why I'm putting a red flag over it. And I must say that these potential contributing factors can be something else than that local area. It can be a muscle tension or postural imbalance or some kind of systemic conditions. So always a comprehensive evaluation considering both local and systemic influence should be accurately identified before you actually go into rule out your differentials and to go into the detail of the root cause of the problem. Then I would like to mention over here that for the past 2 days or 3 days, I would say, we are listening to many lectures, and by now we are kind of very clear in our minds that we need to dug up literature. And it should be done in a way that it works for towards the betterment of your patients. So despite the volumes of literature, till date, etiology and pathology is poorly understood. That is why the treatment also remains highly palliative. So, when the etiological factors in the orofacial pain are not fully understood or addressed, I would say, it brings about a domino kind of effect. What exactly happens there is that one unresolved issue can actually trigger a cascade of secondary problems, and it can actually exacerbate the pain or discomfort for our patients. So, how to get to the right diagnosis is very important question. So it is important that we connect the dots at right place and right time. So for that, three important things we should not be missing is history, clinical examination, and investigations. So it is very rightly said that 70 to 80% of the information, it comes directly from your patient when you are diagnosing your TMD or orofacial pain patient. So there are various components to it, like chief complaint, past medical history, review of various systems, and then psychological assessment as well. I'll be here presenting like 2 or 3 cases of mine that actually really humbled me down. And, I look back to my basics of physiology, anatomy, biomechanics, and medicine to see that how small things are getting missed and we are just jumping onto big things. And we think that when we give some kind of a bigger diagnosis, we are doing a good practice for our patients. It's not like that. I think basics should never be ignored. So all clinical images, I would like to here also mention this thing that clinical images and videos, whatever I'm going to show, are obtained after patients' informed consent, and these are only used for educational purposes. So this is the first case. I have named it as pseudoneuralgia puzzle because this particular patient, who was 52 years old female, came to the department saying that she has pain in throat for past 6 months. And she also mentioned that this pain starts from the TMJ area and goes towards the neck region. Also, she says that sometimes I feel that something is stuck in my throat, accompanied with some kind of burning sensation that again starts in the ear region and goes to the jaw and the neck region. So she had visited the medicine department as well as ENT department, and these are the ENT notes that says that, okay, we feel that patient has Eagle syndrome, but she can go to the dental department and just show them once, and if they find any kind of dental reason to it, they can clear that thing first, and then maybe patient can come back for the styloidectomy. This was their oval plan. So if you can see here, I've marked it with a red line. Okay, I'll show you. So this is the right styloid process, and this is the left one. And if you can see, the left one is longer than the right one, but still the right styloid process, excision or removal was advised to the patient. So anyway, I dug up the literature, and also in the meantime, I advised her to go in for some kind of blood investigations. Few of the parameters which I found that are deranged were vitamin B12, then serum ferritin levels and TIBCs, and unsaturated binding capacity of iron as well. So after taking up the literature, I came to know that such kind of burning and radiating pain, especially that's traveling from ear, jaw, neck, that can be neuropathic, and the main reason can be vitamin B12 deficiency. And after reading the literature, I came to know that demyelination of the peripheral sensory nerves can happen because of vitamin B12 deficiency. Then dysfunction of cranial nerves, especially 9, 10, and 5, that are the major nerves in this particular complex area, can get affected by this deficiency. And the other important thing was referred otalgia and burning sensation, which the patient complained of. Apart from that, she also mentioned that she feels that something is stuck in the throat. That can be because of low ferritin and iron deficiency. So it is very well mentioned in the literature that atrophic changes in oral and pharyngeal mucosa can happen because of this: glossophonia, pharyngeal burning sensation, and globus sensation. Globus sensation is nothing but something stuck in the throat kind of a feeling. And additively, vitamin B12 can also cause persistent throat irritation and foreign body sensation. So everything was pointing towards the deficiency part of the micronutrients in the body. So immediately the patient was referred for vitamin B12 injections, and I asked her to take 5 injections at alternate days for the over a period of 10 days. She took those injections, and this is the prescription that said that okay, she can start taking oral iron with the vitamin C, ascorbic acid. Some vitamin D was also deranged. So basically, all the micronutrients were replenished in her body. And for 8 weeks, she was kept on the follow up. And you won't believe that when she came back for the follow up after 8 weeks, she had a major improvement. On almost 80% of her symptoms were not there. So physiological reasons for this improvement can be remyelination of the sensory nerves, improved neurotransmitter synthesis, restoration of the mucosa, and then reduction in the neuropathic burning and the burning pain and otalgia. So this is just a small video that this is in local language. I don't know how many of you will be able to understand, but she's just telling her story that she used to have this pain earlier.
Doctor, the video is muted, so you reiterate what she's saying.
Okay, sorry. So she's just mentioning that when she reported, she had that burning kind of a sensation, and also that something is stuck. And after she got these deficient stores in her body replenished, everything got changed. And after 8 weeks, she had a major dramatic improvement in her pain, and also the burning sensation got down. So at the end of this particular case, I came to know that we just look on the big things and try to find out that what best can be done for this patient, but we just keep on ignoring the small things. And it's time that we should go back to physiology and anatomy and everything what we learned long back. So this is case number 2, and I have named it as unresolved pain and because of unexpected cause. So this 50-year-old female presented with a persistent pain in left cheek following the extraction of left maxillary second premolar. She said that she doesn't have any other medical issues. So she went to the medicine department first, and they didn't find any relevant reason for her to be there, and they just referred the case to the dental department. I took a thorough history, and as I mentioned, no medical history was there. And when I examined the local area, it seemed okay. Like it was the mucosa over the site where the extraction was done was looking kind of okay. I asked her to get some blood investigations done. And in the meantime, when I was taking the complete history of hers, I came to know that 6 months back, the extraction was done. And the symptoms did not, improve after the extraction. And that tooth was actually curious. Because of that, she got the tooth extracted. And that made sense. Okay, she was having problems, she got it extracted. But after the tooth extraction, the pain did not subside. So eventually, she went back to the doctor, and doctor said that the tooth in front, that is the first premolar, is also carious. Maybe she needs that extraction also. So he went ahead with that extraction, and now she has 2 teeth gone, but no pain relief. And when she went back to the doctor again, he put him on Tegretol and some kind of pain medications, and also referred her to the neurologist. So when she went to the neurologist, he made multiple differential diagnosis for her, saying that she can be having atypical body positional paroxysmal vertigo. This was for the first time I also learned this kind of terminology. Then in his differential diagnosis, he said she might be having migraine also, she might be having trigeminal neuralgia or some kind of tooth pain or sudden loss of consciousness or something. So multiple drugs were actually prescribed to her, starting from pregabalin to triptans to gepants to Vertin to Spinfree and whatnot. So anyway, already we had told her to get the investigations done, and when everything looked okay except for CRP. So CRP was 24 when the reference range was 0 to 6. I was kind of little surprised why it is so, and I thought there must be some kind of inflammation going on in the body, and why not to look for the local area where the extraction was done. So we went ahead with the CBCT of that localized area, and if you can see, I was like kind of shocked that after after 6 months of the extraction, the healing had not taken place even a bit. So we thought, let's open that site. And when we opened that area, to our surprise, this kind of a cotton came out with the medication wrapped over it. And I was really surprised that, okay, this foreign body was the reason of the pain what she was suffering for the past 6 months. So we just removed that area, curated that area well, and lavaged that area, put back this flap with proper sutures, and after 3 days of medication, and we called her back. And again, this is the patient who was trying to tell that what all happened in 6 months, and then eventually when the foreign body came out, she was at ease, and now she's like 90% pain is relieved, and maybe we had revisited that area. The lingering pain of 5 to 10% can be because of that. So I was happy that after 3 days, she was like pretty okay. And this is the last case I would like to discuss. I have named it as Tracing the Unseen.
Doctor, your screen is stuck. Dr. Aparna, can you see your screen moving?
No, Sonal, she's frozen.
Dr. Harsimran, your screen is stuck. I think there's some network issue. Okay, we'll give her 1 minute more, and then later on we'll go on with the next the first participant, Dr. Yeah, I think her screen is stuck and there's some reason behind it.
Okay.
Okay. Dr. Sukhpal Kaur, are you there, doctor? Dr.
Yes, ma'am. Good evening, ma'am.
Can you switch on the camera, madam, please?
Yes, ma'am.
All the paper presentation participant, please switch on the camera. Yes. Can you be at a stable position wherein I can, yeah, fine.
Yes, ma'am. Yes, ma'am.
Start sharing your screen. The moment you share your screen, your time starts immediately.
Yes, ma'am.
Yeah. Dr. Sukhpal Kaur is in category A. We are not judging the participant, but we will be timing the participant for 8 minutes.
Okay.
Okay, ma'am.
Yeah, please start sharing your screen, doctor.
Yes, ma'am. Yes, ma'am.
Are you presenting from mobile?
Yes, ma'am.
Next year, please try getting a laptop presentation, because mobile presentation, when we are watching it on a laptop, practically the slides are it appears more like a website, not a presentation then in that scenario.
Yes, ma'am. Actually, I am out of station. I have to.
I understand that. The dates are declared way in advance, madam.
Yes, ma'am. Ma'am, my screen is visible?
Yes, it is visible. You can go on the presenters mode. Your time starts now, madam.
Yes, ma'am. Good evening, jury members. Thank you for the organizing team for giving me this opportunity. And the topic of my presentation is why the face hurts, demystifying orofacial pain. Now, what is pain? Any pain felt in the area of mouth, jaws, and face is called as orofacial pain. And according to the George Redox, it is experienced only intermittently in the life of healthy. Its neural mechanism lying dormant but vigilant, ready to be awakened if the tissues of the body are threatened. And the second definition was given by Mirsky, and he described pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or the terms of such damage. Now, what can be the causes of the orofacial pain? The etiology is multifactorial, and the most common cause is dental conditions that may be toothache, pulpitis, or the abscess, and they contribute the 95% of the conditions to the orofacial pain. And the second most common condition for causing the temporomandibular joint dysfunction. And the other causes can be postoperative pain, pain associated with malignancy, neuropathic pain, or the headaches. As the orofacial pain, it is very vast topic. So in this presentation, I will briefly discuss about the TMDs, that is temporomandibular joint disorders. And according to the American Academy of Orofacial Pain, TMD is a collective term embracing a number of clinical problems that involve the masticatory musculature, TMJ, and the associated structures or both. And now, what can be the causes of the TMDs? The etiological factors of TMD, they are classified into three categories, that is predisposing factors, initiating factors, and the perpetuating factors. Predisposing factors that increase the risk of TMD, and these include the systemic factors, psychological factors, or the structural and genetic factors. The initiating factors, they cause the onset of the disorder, and these include trauma and the parafunctional habits. And the perpetuating factors, they interfere with the healing and complicate the management process. And these include mechanical and muscular stress factors and the metabolic problems. Now, the classification of the TMDs as given by the IOPCON, they are divided into 5 types. First is the masticatory muscle disorders. These include muscle splinting, myospasm, myositis, and the myofascial trigger point pain. Second are the disc interference disorders. These include derangements of the condyle complex that include disc displacement with and without reduction. Then the subluxations and the spontaneous dislocations. And the third category is inflammatory disorders that include synovitis, rhabdomyolysis, degenerative joint disease, and the inflammatory arthritis. And the fourth category is chronic mandibular hypomobility that include muscle contractures, capsular fibrosis, coronoid impedance, and ankylosis. And the next is growth disorders that include hypoplasia, hyperplasia, and the neoplasia. And now the symptoms of the TMDs. The most common symptom is pain in the area of masticatory muscles and the jaw. And the pain may be spreading to the surrounding areas of the face and neck. And there is jaw stiffness that leads to the limited jaw movement. And there can be painful clicking or popping sounds when the patient opens and closes the mouth. And there is ringing in the ears or dizziness may be felt by the patient. And there is also can be change in the occlusion, that is fitting of the upper and lower dentition. Another diagnosis of the TMDs. First is the clinical examination, that is clinically, the patient examined to localize the location of the pain and also to find out whether the pain is localized or it spreads to the surrounding areas. And the palpation of the masticatory muscles and the TMJ joint is also done. And there is evaluation for the clicking sounds in the TMJ is also performed. And the range of mouth opening measured that should include the pain-free maximum mouth opening, maximum unassisted mouth opening, and the maximum assisted mouth opening. And then the any deviation of the mandible during the opening and closing of the mouth is also evaluated. The intraoral examination is also done to rule out any mucosal pathologies of the oral cavity or a pharyngeal area, as well as to assess the status of dentition. Now, other recommended imaging for the TMDs. First is panoramic view that is used to compare both sides of the mandible and the glenoid fossa. It evaluates maxilla and mandible bilaterally, and it is cost-effective technique. And then the MRI, it evaluates both the joints at the same time, and it also helps in evaluation of the mandibular movements in the video form. And then the CT scan, it helps in recognition of the bony abnormalities, but it is costly and it doesn't give the proper evaluation of the soft tissues. And then the arthrography, the injection of radio opaque contrast medium is given into the joint spaces and to evaluate the intracapsular soft tissues. And it helps in diagnosis of disc dislocation with reduction and without reduction, and also for the perforations and adhesion in the disc area. And disadvantages of this technique is, as it is minimally invasive technique, so it may result in infection, hematoma, disc injury, or there may be hypersensitivity to the medium injected into the joint space. Now, next evaluation is mental and social behavior evaluation. These factors may result in initiation or exaggeration of the disorder. On the other hand, long-term chronic pains may result in mental changes that result in anxiety or depression. So these factors should be evaluated with the help of simple questions asked from the patient. And the additional tests include the biopsy, which helpful in diagnosis of the benign and malignant tumors of the TMJ. Now coming to the management of the TMD.
Last 30 seconds.
It includes the physical therapy, and the goal of this is to improve the muscle strength, coordination, and relaxation. And it includes use of ultrasound interferometry, electrotherapy, level laser therapy. Then the adjunct measures include the jaw rest, soft tissue balm, moist application, and the passive stretching exercises. Occlusal splints can also be given. And then the acupuncture therapy and biofeedback therapy, which include the behavior modification to eliminate the parafunctional habits and to avoid the extreme opening of the mandible. The next is surgical management. It is rarely recommended for the TMD patients. It is only recommended in the cases where there is TMJ inflammation, there is acute TMJ disc displacement without reduction, TMJ ankylosis, or there is any fracture or neoplastic growth. The surgical procedures include the TMJ arthroscopy, which is non-invasive procedure, and then the arthrocentosis, and next is are injections and open joint surgery. Conclusion. In the conclusion, we can say that the TMD is most common condition of causing the orofacial pain that negatively impact the individual's life. So early diagnosis and appropriate management can be done to improve the quality of the life, and also by increasing the awareness and promoting the timely care can manage the TMDs very easily. So these are my references, and thank you.
Thank you, Dr. Sukhpal. And can you elaborate about soft end and hard end feel in diagnosing?
Yes, ma'am.
Can you elaborate about soft and hard end feel during diagnosis?
Soft and, sorry, ma'am, please repeat the question.
Soft and hard end feel.
During the palpation, like during the, if we palpate the masticatory muscles, and at that time, there can be a restriction to the movement, and we can feel the tightness in the muscles or in the joint area.
Okay, so is that is there a diagnostic criteria for a soft and hard end feel? Is it any differential diagnosis for us? Does it work for a differential diagnosis? Ma'am, okay. No problem. Thank you, doctor. Next year, I would appreciate if we have a laptop presentation in a stable location wherein we have good connectivity.
Yes,
Thank you for joining International Official Pain Congress Season 3 and good presentation. But next time, a laptop presentation would do much better. Thank you for being a part.
I want it. Yes, ma'am. Yes, ma'am. Sure, ma'am.
Yes.
Thank you, ma'am.
Next speaker.
Hi, Dr. Sonal. I'm so
Hello.
sorry. I don't know what happened, and I just got
I
disconnected.
cannot see. Who is this?
I'm
Yeah.
Harsimran.
Yeah. Dr.
Can you see
Harsimran.
me?
Yeah. I can guess it. No problem, madam. We will continue later on, maybe some
No
other
worries.
time.
No
No problem.
worries.
Okay, we'll
Thank
take
you.
in the next speaker because I can see only the next person joining. Dr. Megha B. Dr.
Yes,
Megha,
ma'am.
can you just switch on your camera, madam?
It's on, ma'am.
Yes. Okay, Dr. Megha, start sharing your screen, and the moment you start sharing, the time starts.
Okay, ma'am. Is it fine, ma'am?
Yes, please go ahead.
Okay, ma'am. Good evening, everyone. My topic is prevalence of temporomandibular joint disorder symptoms and associated factors among dental students and institutional study. Temporomandibular joint disorders or TMDs are one of the most common chronic orificial pain condition, and the etiology is of course poorly understood, and it is said to be multifactorial. And the role of cognitive, social, and biological factors in the etiology of TMD has been reported earlier. TMDs have a substantial impact on quality of life and continue to pose a diagnostic and therapeutic challenge despite extensive clinical researches. The diagnostic criteria for temporomandibular joint disorders, that is DCTMD, developed in 2014, represent the current gold standard for TMD assessment. It is actually a dual axis model which include axis 1 and axis 2, which assess physical and psychosocial status and functional impact of TMD. So dental students, they represent a population exposed to a significant academic pressure and psychosocial stress. And the literature suggests that such stress might cause an increased risk of temporomandibular joint disorders. So hence, assessing the prevalence and profile of TMD in this group is therefore relevant for designing preventive or supportive interventions, including stress management strategies. Coming to the aims and objective of the study, to evaluate the prevalence and characteristics of self-reported temporomandibular joint disorders symptoms among dental students, and also to explore the association of psychosocial factors in temporomandibular joint disorders. Coming to material and method, sample size determination was done, and 259 was the sample size given. Inclusion criteria, all the students from BD students from first year to internship was included in the study, and students who had history of any previously diagnosed psychological conditions or history of any trauma in the orofacial region was excluded from the study. It was a cross-sectional study, and 306 participants, BDS students had participated in the study, which is again from first year to internship. Study was conducted after attaining the ethical committee clearance and after attaining informed consent from each participant. Participants who were voluntarily willing to participate in the studies were included, which ranged from 18 to 26 years of age. And the questionnaire was provided via Google form. Questionnaire incorporated DCTMD diagnostic criteria, which included Axis 1, which is screening questions, and Axis 2, which included pain scales and patient health questionnaire, which notices anxiety and depressive scales. Coming to the result, the data was analyzed by IBM SPSS software. And more of the patients were female patients, which included 249 participants, and male patients were 57. 33 participants, that is 10.8% participants, had experienced TMJ pain or pain while opening mouth or locked jaw. And 53 participants, that is 17.3 participants, had experienced clicking sound while opening the mouth. The duration of pain and clicking sound was evaluated, but 6.9% participants had experienced pain from 6 months to 1 year duration, and 19% participants had experienced more pain since more than 1 year. And clicking sound also, 36.2 participants had experienced clicking sound for more than 1 year. And the triggering factors associated with the clicking sound and pain was also evaluated. And 44.8 participants had percent of participants had experienced a pain or clicking sound while opening mouth. And 22.4 participants had issues while yawning, and 13.8 participants had TMJ pain or clicking sound while chewing hard food. Characteristic of pain was also evaluated, and constant pain was noticed in 5.2% participants and intermittent pain in 51.7 participants. And pain while opening mouth and lateral movement, locked jaw and headache and interference of pain to daily activity was also evaluated, and these are the results for those. Coming to the pain scale, the pain was scaled in the from 0 to 10, and 8 being the most severe scale, which was severe pain, which was noticed in our participants. Only one participant had experienced a score of 8, and 3 participants had experienced a score of 7. And difficulty in opening mouth was also evaluated and under the score from 0 to 10, 10 being the most severe. And in our participants in our study, 7 participants had experienced, 2 participants had experienced a score of 7 and 2 a score of 6. And difficulty in chewing food was also evaluated, and 8 was the maximum score received only in 1 patient, and 7 score was seen in 3 patients. Difficulty in biting food was also evaluated, and these are the values. And 8 was again 8 was the most severe value that was noticed in 1 patient, and 7 was noticed in 2 participants. And 21 participants had only 1 point. And while yarning also difficulty was evaluated, and it was scored also from 0 to 10, and 9 was the most severe score received, which was in only 1 patient. Difficulty in smiling also again only 8 score till 8 was received. That was the most severe score, and only 1 person had experienced a score of 8. Difficulty in facial expression, 6 was the maximum score. 2 participants had experienced a score of 6. The anxiety of the participants were also evaluated, and responses were nearly every day pain was noticed in 12.1% participants. And in 31 participants, that is 53.4% participants, pain was experienced once in a while or sometimes. And PHQ scale was also used to evaluate the depressive symptoms. In PHQ, scores included 9 questions, which were scored from 0 to 3, and 0 being no pain at all, and 3 being pain in nearly every day. And these scores were calculated for each patient. 9 questions score were calculated, and these score were evaluated as 0 to 4 score, which is minimal, 5 to 9, which is mild, 10 to 14, which is moderate, and 15 to 19, moderately severe, and 20 to 27, severe. And this is the result which we had got. 13.8% participants had experienced severe, that is, the score was 20 to 27, that is severe depressive symptoms. And even 13.8 participants had experienced moderately severe, and 19% participate had experienced a moderate depressive symptoms. Also, parafunctional habits were also evaluated. Patients were asked about their clenching habit or tooth grinding habit. And here also 3 participants, that is 5.2% participants had given always they had experienced tooth grinding or clenching. And 20.7 participants sometimes, and 16.9 participants rarely.
Time is up, madam. Already 8 minutes. You
Okay,
can take
ma'am.
another 30 seconds from your question
Okay,
and
ma'am.
answer.
I'll just, yes, ma'am. In
Rapid.
present study, the prevalence was noticed was 18.9% participants had TMD symptoms, and which is similar to the studies conducted earlier. And an essential finding in the study was the psychosocial factors which was associated with TMD patients. So, result of the study confirmed the validity of biopsychosocial model of TMD etiology. Not only local physical factors, but also general emotional state contributes to the TMJ dysfunction manifestation. So, since it is done in dental students, it also stresses the need for curriculum modification coupled with more awareness and education, which is recommended to achieve early diagnosis and help in reducing the incidence among TMD among this population. Thank you.
Yeah, Dr.
Yes,
Aparna,
ma'am.
do you have any question for Dr. Megha?
Yes, Dr. Sonal. Dr.
Yes, ma'am.
Megha, your presentation was really good. I
Thank
have
you.
few queries.
Yes, ma'am.
What type of study have you done? You just mentioned that it is an institutional study.
Yes, ma'am. It was a questionnaire was distributed via Google Form to all the from first year BDA students to internship students. We had distributed the questionnaire, ma'am. And all the initially TMD prevalence was noticed in 306 participants had enrolled in the study, and we had asked about the clicking sound and pain and all locking, all whatever TMJ pain manifestations and all we had asked. And in that 58 participants, we had noticed some signs of TMJ disorders. Okay. And in those patients, we had assessed PHQ score, that is depressive symptoms and anxiety, parafunctional habit. All those things were assessed only in those patients who had shown some signs of TMJ disorders.
Fine.
So in those people, we had found actually a very high level of score in depressive symptoms and all we had noticed.
Okay. So what is your opinion about the coping strategies in management of students who are stressed? What type of coping strategies will you suggest?
More amount of counseling sessions and all should be given for students, and we should be more student friendly and should be assessing each students for differently. We should be assess each students differently. Some may be having some such psychological disorders. Such students should be given more care.
Okay. Okay, doctor. Thank you.
Okay.
Thank
Yes.
you.
Stop sharing your screen, madam. And request to all the participants immediately after your presentation, stop sharing the screen. Okay. And next, Dr. Aparna, should we go ahead with the next one? You're done,
Yes,
right?
Sonal. Yes, yes, you can proceed.
Dr. Megha?
Yes, ma'am.
Yeah, you're there, right? Hello, Dr. Megha. Yeah.
Hi,
Dr.
ma'am.
Megha, you can start sharing your screen.
What category of presentation, A or
It's
B?
A. I will let you know about the B presentation.
Okay.
Yeah, Dr. Megha had not mentioned A or B category. Doctor, still I have allowed your paper, but next time please mention the categories.
Yes, ma'am.
Please go ahead on the presenter's mode. Your time starts now.
Ma'am, are my slides visible, ma'am?
Yes, madam.
Shall I start, ma'am?
Madam, you're wasting your time. Your time has already started.
Okay, ma'am. There is no change or growth which takes place independently. Everything is interrelated. Therefore, any change in the craniocervical region can alter the biomechanics of the stomatognathic system. It is on this context I would like to present my paper titled Analysis of Cervicovertebral Relationship and the Position of Hyoid Bone in Patients with TMJ Disorders, a CBCT-based retrospective study. A very good evening to all. Coming to the introduction, the hyoid bone has a very unique relation with the muscles, ligaments, fascia of the pharynx, mandible, cranium, and the cervical spine. Therefore, any tension can alter the position of the hyoid bone and the posture of the patient. So, when the head relies on equal anterior and posterior muscle tension, the TMJ remains balanced and the hyoid bone is placed between the body of C3 and the superior half of C4. But in patients with temporomandibular joint disorders, there are changes in the condylar morphology which can alter the muscle tension in the neck and also the position of hyoid bone. Hence, studying the hyoid bone and its angular position could be a reliable predictor in evaluation of the cervical dysfunction in temporomandibular joint disorders. Coming to the background of the study, it was in 1981, Bibi proposed the hyoid triangle connecting the hyoid bone with the cervical vertebrae. Later, Mariano Robocado proposed that the sphenometric tracing, including the cranium, cervical spine, and mandible, and the hyoid bone functions as a biomechanical functioning unit. Unlike the past, now we have CBCT and we can visualize the structures in a 3D mode. Moving into the objective of the study was to assess the position of the hyoid bone, the hyoid angle, and the craniocervical relationship in patients with TMJ disorders. The study design was retrospective and observational. The inclusion criteria were pain, headache, TMJ clicking, locking, and restricted mouth opening. The exclusion criteria included previous orthodontic or TMJ treatment, pregnant women, orthodontic surgeries, and associated craniofacial syndromes. The studied variables included the morphological changes in the condyle, position of the hyoid bone, the hyoid angle, and the craniovertebral relationship. Out of the 21 participants, 7 were male and 14 were female. Moving on to the materials and methods, patients who were aged more than 15 years who had pain, clicking, locking, or difficulty in mouth opening entered into the study. A routine examination was done, a detailed history was taken, recording of the symptoms were done with RDCTMD criteria, and evaluation of the alteration of the condyle was done on a CBCT, assessment of the hyoid bone, and the cervicovertebral relationship was also done on the scans. As we can see in the picture, the different osteoarthritic changes which we had taken into consideration were flattening, sclerosis, osteophytes, and erosion. Moving on to the assessment of hyoid triangle, the hyoid triangle is basically formed by the retornathion, the C3, and the hyoid A. The other parameters which we had seen were the H dash, that is the height of the triangle. In the first CBCT scan here, we can see that the hyoid bone lies below the base of the hyoid triangle. That means the hyoid bone is not under so much of tension or pull. But in the second image, we can see that the hyoid bone lies above the hyoid plate. That means the hyoid bone is basically pulled up, and also the lordosis is changed and the airway is restricted or constricted in this patient. So the first one is the normal hyoid triangle and the second one is an inverted hyoid triangle. The statistical analysis was done using an SPSS software, a Pearson correlation coefficient, and one sample t-test was used. The results showed that there were 14 males and 7 females, 14 females and 7 males. And the severity of the osteoarthritic changes, when it was increased, there was inversion of the triangle, which was noticed. The H to C3 distance was inversely correlated with the hyoid angle. The H dash, that is the height of the triangle, and the hyoid angle was also inversely correlated. Coming to the discussion, we know that the stomatognathous system or the masticatory system has a very complex functional, anatomical, and pathophysiology in it. And the hyoid triangle can be used to assess the position of the hyoid bone, as well as it can be used to know how the biomechanics of the stomatognathous system works. Ishida et al. Had suggested that hyoid displacement is related to the various events in the oral cavity and pharyngeal area. In our study, we had found that the analysis of the hyoid triangle can help us to know the biomechanics of the stomatognathous system. And as the osteoarthritic changes had increased, the reversion or inversion of the hyoid triangle was also noticed, which was in par with Matthews et al. And Flores et al. The hyoid angle was decreased both in patients who had an inverted triangle as well as an ideal hyoid triangle. The study also revealed that there was a decrease in the H dash, that is height of the triangle, in patients with chronic temporomandibular joint disorders, which was in par with Chengosomava et al. We could also derive that the cervicovertebral position or the posture of the patient was also impaired and the airway was also compromised. Concluding in a nutshell, I would like to reiterate that the hyoid triangle allows determination of the hyoid bone position in 3 directions. Hyoid triangle is altered in temporomandibular joint disorders, and the hyoid angle is decreased in patients who are severe TMJ disorders. Therefore, let me conclude by telling that hyoid bone and its angular position could be a reliable predictor in evaluation of the cervical dysfunction in temporomandibular joint disorders. These are my references, and thank you.
Beautiful presentation, Dr. Megha, and very well timed. So, Dr. Aparna, you have any questions for her?
Yes, Dr. Sonal. What is the clinical correlation of this cervicovertebral alignment with TMD? How are you going to manage if there is a reversal of the triangle?
Ma'am, basically, we have muscular TMDs and we have also osteoarthritic type of TMDs, ma'am. When there are more muscle tension or because we know that the muscles, the hyoid bone is always support. It is a very a bond which is not supported by any other bonds, ma'am. It is all with the ligaments and the muscles. So any muscular pull can be noticed in the hyoid bone position. So basically, we can correlate telling that there is a lot of muscle stress or the muscles are firing a lot in that patient with the reversion of the hyoid triangle, ma'am. This is something radiographic. With the help of an EMG and a T-scan, clinically also we can make it out, ma'am.
Okay, doctor. Thank you. That was a nice presentation.
Yeah, very nice presentation. Dr. Selva Kumar, do you have any question?
It was a wonderful presentation, madam.
Thank you, sir.
Great. So should we move on with the next participant?
Yes.
Yes. So we have Dr. Madhura Mahajan. Dr. Madhura.
Yes, ma'am. Am I audible?
Yeah, but can you switch on your camera? Yes, dear. Start sharing your screen, and the time starts immediately after sharing your screen.
Is it visible, ma'am?
Yeah, go on the presenters mode.
Yes. Okay. So good evening, respected judges.
Not on presenters mode yet.
Sorry?
Go on a presenters mode, slide share mode.
Yes, ma'am. I've done that. I will reshare
No, it's still not there.
It's still not there, dear. Okay, do one thing. Can you manually present from the PPT itself?
Yes.
Okay, go ahead. Your time starts now, doctor.
Is my screen visible, ma'am?
Yes, madam. Your presentation is visible. You'll have to present from the manual mode. We can see your whole presentation.
I am not able to see my
Okay, do one thing, Dr. Madhura, we call in
Yeah.
the next participant. We take your presentation after this participant. Who is the next in line? We have Dr. Malik.
Dr. Altaf, yeah, ma'am.
You are there. Dr. Madhura, stop sharing the screen, please. Yes, Dr.
Yes,
Altaf,
ma'am.
there is something hiding your face, maybe your hand itself. Yeah, can you remove the hand? Yeah. Dr. Altaf, can you start sharing your screen, please?
Yes, ma'am. Yes, ma'am.
Dr. Madhura will get back to you. Have a sip of water. Maybe next time it will be a better presentation. So something happens for good. Okay. Dr. Altaf, can you start sharing the screen, sir?
Yes, ma'am. Yes, ma'am.
It's taking a while to. Is the network properly aligned with the?
I'm on Wi-Fi. Yes, ma'am.
I cannot still see.
It is not.
It's not shared. I cannot see the screen. I can see the. You're sharing the screen, but yeah, go on the presentation.
Yes, ma'am.
Okay.
Is it?
Yes, your time starts now, doctor.
Yeah, ma'am. I'm Dr. Altaf Hussain Malik. Thank you, Sunil ma'am and Tomsi. Thank you, jury. I'm talking about early orthosynthesis as an intervention measure for internal derangement of the joint. I have no conflict of interest. The study is self-supported and cleared by Ethical Committee of Common Dental College, Srinagar. We know that internal derangement is second most common disorder after low back pain, and it is very common, and it is actually straight away disc and this condyle derangement in the capsule, wherein the arrangement whereas there is mechanical fault of the joint which interferes with its smooth function. So what is the pathophysiology? Most of the basic derangements start with any sort of trauma, which leads to the inflammation or biochemical changes in the synovial fluid, maladaptive to tissue response, altered joint biomechanics, and reduced motion and pain. So this is the normal joint wherein we see the disc movement, the condyle. This is disc displacement without reduction, and this is displacement without reduction. The middle one is disc displacement with reduction. Prevalence, it is found in 5 to 10% of the world population, and it's 5 to 10% of the world population. Second most musculoskeletal condition, more common in it's more common in females compared to males. And what were the these clinical features? Pain, limited mouth opening, clicking, and anxiety. Treatment options: conservative, minimally invasive management, and the invasive treatments, which are in the form of the surgical procedures. The desirable in this is that mild or no pain with VAS scores of less than 3 as per American Association of Oral and Maxillofacial Surgeons, and desirable after any treatment should be the mouth opening greater than 35 mm. And the treatment options range from conservative, they range to minimal invasive, and the invasive ones. Now, what is minimally invasive? That is in the form of orthosynthesis and arthroscopy done in stage 2 and stage 3 of the disease with mouth opening less than 30 mm. Arthrosynthesis is a reliable diagnostic tool. Since the aspirate from the joints are invaluable, it can be a diagnostic also. It has proved to provide excellent results in closed lock conditions and minimally invasive procedure, minimal complications. We have used in this study Messina. What is Messina? It's 2-mercaptoethene sulfonate. It's a coenzyme in methanogenesis of anaerobic archaeobacteria. It is protective, antioxidant, and mucolytic. It breaks disulfide bonds in mucous polypeptide. The aim of the study was to compare and emulate the effect of Messina injection with orthosynthesis to compare with conventional orthosynthesis for the treatment of stage 3 and stage 4 of internal derangement. Is orthosynthesis a viable operation for improving joint option and imperative treatment of internal derangement in stage 3 and 4? These were the objectives. Is Messina injection superior to orthosynthesis alone? This was an intervention study carried in the patient between 16 to 45 years of the age, with the duration of the study about 6 months. This is how we calculate the sample. We didn't do this procedure in any wherein the earlier TMJ procedures in the form of surgery or any intervention. These were our variables which we found: TMJ sound, interincisal opening, pain intensity, lateral moments, and we did it with pre-operative and post-operative MRI. We randomized 100 patients. In 50 patients we did conventional orthosynthesis. In 50 we added Messina injection, evaluate them for mouth opening and the pain. This is the depiction of the standard orthosynthetic procedure, and this is the Messina injection. We also did in certain patients computer-guided orthosynthesis, where we fabricated a splint from the computer, wherein with the needle locations of the needle entry and exit points were depicted by the software. This is initial 3 months follow-up and post-month 9-month follow-up patients wherein we did the treatment. What did we found? We found in orthosynthesis and orthosynthesis Messina, both the things, pre-operative mouth opening and post-operative, both the thing was increasing significantly on the follow-up, but intergroup comparison, there was no much difference between the two. However, in pain, we found significant this improvement in the Messina group compared to the orthosynthesis alone. And in lateral moments also, we found in Messina group, they were doing better than the orthosynthesis alone. In computer-guided orthosynthesis, we didn't find that split, which we actually manufactured through a software, had any help in improving this. So coming down to the discussion, orthosynthesis is includes, which is actually a lavage of the upper joint space, the hydraulic pressure and the manipulation releases the adhesion by a suction cup effect and improves motion. Mafferani compared all the 6 protocols with different also with different types of the additions like PRP, other things, some drugs and all that. They didn't find any superiority of the addition of anything. So orthosynthesis, the findings did not say superiority of one addition to other intervention, but they said that okay, orthosynthesis is a better alternative for managing TMJ internal derangement, and using a Mesna injection can help in improving the pain reduction compared to the orthosynthesis alone. The orthosynthesis, rather being an alternative to arthroscopic surgery, would be indicated for patients with acute TMJ closed lock refractory to medication and mandibular manipulation. So TMJ orthosynthesis is the least invasive and simplest of all surgical techniques, proven to be highly successful in re-establishing a normal range of mouth opening in patients with closed lock. In our series of studied patients, improved after orthosynthesis compared to the patients who opted out. The addition of an adjuvant does not improve any results compared to orthosynthesis alone. Orthosynthesis is least expensive procedure for TMJ disorders. Mesna group does not reduce pain more than conventional orthosynthesis due to total electric effect and more improvement of lateral movements. Thank you.
Thank you, Dr. Altaf. That was a quite good summary about the procedure and the investigation that you did. Dr. Selva Kumar has a question for you. Dr. Selva Kumar?
How painful was this injection?
Oh, ma'am, no, sir. The injection, first thing, we always give first local anesthesia in the form of this auriculotemporal nerve block and local infiltration. Mesna is at all, it is not painful at all in the patients in which it helped in improving the pain of the patients. The mouth opening and the lateral movements were more in the Mesna group than the orthosynthesis alone because of the more proteolytic effect of the Mesna injection. That is actually the contribution to the literature. So Mesna is used in neurosurgery in reducing the for example, who have got chronic these obstructive pulmonary disease, it is used over there to break those adhesions so that they can have better ventilation to the alveoli. So Mesna is now actually, this is almost a second study in the world wherein we have used Mesna in the TMJ. The first one has been done in the Europe, and we are actually coming up with the conclusion that Mesna can break up the adhesions which are there in internal derangement of the joint in stage 3 and stage 4, sir.
Okay. So, Dr. Aparna, do you have any? Dr. Altaf, can you stop sharing the screen first?
Yeah, ma'am. Yeah, ma'am. I will stop sharing.
All the participants, please stop sharing the screen. And yeah, Dr. Aparna, do you have any question for Dr. Altaf?
Yes, doctor. Dr. Altaf, I have one question. So you said in stage 2 and stage 3 TMD, you can move to minimally invasive technique. So what do you mean by stage 2 and stage 3? Which classification?
I talk about stage 3 and stage 4, not stage 1 and 2.
Okay, stage 3 and stage 4.
Stage 3 and stage 4 means usually the disc is not reducible by whatever means the disc is stuck somewhere in the glenoid fossa or with the articular eminence, or the lateral pterygoid is also quite fibrous. So that is stage 3 and 4. They are having pain, limited mouth opening, and decreased lateral movements, and disc is not recapturatable back. So that is stage 3 and stage 4.
Okay, sir. That was a real good presentation.
Thank you, ma'am. Thank you very much.
Congratulations on the doctor.
Thank you very much.
We'll call in the earlier participant, Dr. Madhura. Are you there?
Yes, ma'am. Yes, I'm there.
Now start sharing your screen, dear. Did you have water first? Tell me that.
Yes, ma'am.
Thank you.
Thank you. Okay, so
yeah.
Should I start?
Please go ahead. Please go ahead.
Yes. So good evening, respected judges, organizing team members, and all dear participants. And sorry for the inconvenience caused earlier. I am Dr. Madhura Mahajan, an assistant professor from SDS Karad, and today I'll be discussing about comparative spatial and positional analysis of mandibular condyle in TMD patients versus healthy controls. These will be the contents. So after listening to all the lectures, we have understood that orofacial pain is where structure, function, and perception intersect. And mandibular condyle is not merely a hinge. It is a dynamic structure that reflects the functional harmony of TMJ. So subtle alterations in its spatial orientation and position can translate into significant clinical dysfunction. So TMD is becoming increasingly prevalent, affecting 5 to 15% of the population, and is one of the leading causes of non-odontogenic pain. In spite of its increasing prevalence, the underlying causes and pathophysiology remain poorly understood. Given the multidimensional nature of TMD, both clinical and radiographic evaluation should be considered for its diagnosis. Numerous studies are continued to identify the best method for detecting the ideal position of condyle in glenoid fossa. But still, we haven't found the ideal condylar position. Also, clear definitive norms for identifying TMJ disorders with the help of CBCT are lacking. Recognizing radiographic findings and their correlation with clinical parameters will be the crucial parameters in treatment planning. If a relationship between condylar position and TMD is established, future treatment planning would prioritize assessing how condylar position changes following the treatment. So aim of my study was to evaluate spatial and positional changes in mandibular condyle using CBCT in TMD patients and compare it with control groups. Here I have used Helkimo's Clinical Dysfunction Index. This is not commonly used. IC clearance was obtained. Then inclusion criteria, patients were assessed using Helkimo's Clinical Dysfunction Index, and those with having score more than 0 were included in disease group. Then those with having score 0 were included as controls. And patients with history of trauma or TMJ surgery, congenital abnormalities, trismus, or who were undergoing occlusal derangement corrections were excluded from the study. So this is the Helkimo's Clinical Dysfunction Index. Here we have considered 5 parameters. Muscle tenderness, TMJ pain, pain during mandibular movement, TMJ function impairment, and range of mandibular mobility. And after summing up scores obtained in all the 5 parameters, we can derive the clinical severity of the patient. So here, as we can see in first picture, the measurement of interincisal distance with metal scale when mouth is opened at maximum comfortable opening. Then at maximum protrusive movement, the interincisal distance at maximum laterotrusive movement on the right side and left side. As we can see in the picture. Also here, we have assessed deviation and deflection to check the functionality of condyle. Here we can see the popping out of condyle. Okay. Later we have done the radiological assessment. Here we have assessed the TMJ in all 3 planes. In sagittal plane, we have checked anterior joint space, posterior joint space, and superior joint space. In coronal plane, medial and lateral joint space were assessed. Later, we have derived the condylar position using this formula, and the TMJ was classified as centric, having centric position, anterior or posterior position. Also, in axial plane, we have considered the axial condylar angle, the angle between mid-sagittal plane and long axis of the condyle. Okay, so what were the results? Here we can see the posterior joint space was highest, followed by superior joint space, followed by anterior joint space. But what was it only for the TMD group? No. The same finding was found in healthy controls also. When we measured the medial and lateral joint spaces, we found lateral joint space was little more than the medial joint space, but same as in asymptomatic and symptomatic individuals. When we compared the right and left side, there was no significant difference was seen. Also, the position of the condyle in normal patient, normal individual was more centric position, but the statistical significance was not observed here. So coming to the discussion, our study evaluated 37 TMD patients and 37 healthy controls. We diagnosed the patient using Helkimo's Clinical Dysfunction Index and found that 39% had mild symptoms, 33% had moderate symptoms, and 28% of the patients had severe symptoms. Here on CBCT evaluation, we found that posterior joint space was highest, followed by superior joint space, and followed by anterior joint space in both TMD and control group. Also here, we have considered the axial condyle angle. It is thought that the excessive pulling effect of the lateral pterygoid muscle initiates a loading effect on the lateral pole of the condyle, ultimately leading to an increased horizontal condyle angle. But here we couldn't find any correlation between horizontal condyle angle and severity of TM. So to conclude, this study provides normative data on mandibular condyle position and joint space dimensions. Sometimes it is a negative finding that refine our understanding and prevent over-attribution of disease to anatomy alone. So why this study stands out? Here we have considered correlation of clinical and radiographic findings. There was a use of Helkimo's Clinical Dysfunction Index, which is not commonly used. Then the TMJ was assessed in all the three planes. So future scope, more longitudinal and long-term follow-up studies are required. Then in future, studies should focus on evaluating how the morphology and position of the condyle will change after the treatment. These are my references. Thank you.
Yeah, thank you, doctor. There are certain questions in my mind that are coming up, but I will ask Dr. Aparna first.
Yes, doctor. So, Dr. Mathura, that was a real good presentation, but I have a few queries. Like
Yes,
you were talking about TMD cases. So, what type of TMD patients did you treat? Whether muscular problems or that was joint problem or degenerative joint disease?
ma'am, we divided the patients using the severity of the pain, severity of symptoms, using this Helkimo's clinical dysfunction.
Okay,
We didn't.
how did you classify your patients? You only classified it as severe, mild, moderate, severe,
Yes,
no?
yes, yes.
So, what is the nature of the problem?
It can be a joint pain or muscle pain.
Okay, no, my criteria, my problem is what was the age group that you have considered here, and systemic factors. Have you considered that fact?
Yes, ma'am.
What
We
was the age group?
excluded the patients having a systemic history.
Okay, but what was the age group that you were considering?
Above 18 and below 55 years.
Below
To
55
avoid
years,
the
right? But
degenerative.
yeah, so systemic factors. Okay, the degenerative part, the age group was very randomized, like 18 to 55, and male-female ratio.
No, it wasn't matched.
Okay, no worries. Dr. Selva Kumar, do you have any question for her? Can you
I
unmute
had
yourself?
the same doubt, madam. Madam has asked.
Yeah, similar one. Yeah, maybe next year you will have a better. We will also have a better understanding on this same topic then. So good presentation, in time presentation. Congratulations on that, and see you next year around.
Thank you, ma'am. Thank you.
Yeah, stop sharing your screen.
Yes.
Okay, we have our next participant, Dr. Lavina, I suppose.
Yes, ma'am.
Yeah, Dr. Lavina Arya.
Yes, ma'am.
Yeah, start sharing your screen, madam.
Yes, ma'am. Is it visible?
No, dear.
Now,
Now,
ma'am?
now it's a blank screen, but it started sharing. Yeah, go on the presenter's mode.
Yeah, sure, ma'am. Can I start now?
Please start.
A very good evening. The topic of my presentation is relationship of sleep and orofacial pain, a narrative review. I'm Dr. Lavina Arya, Associate Professor in Department of Oral Medicine and Radiology, PGIDS, Rohtak. We at our department have been regularly treating orofacial pain, but this aspect of sleep was something which I encountered in few of my patients, and that inquisitiveness made me to dwell into it. So, coming to the introduction, there's a high prevalence of sleep disturbance in chronic orofacial pain. The bidirectional influence amplifies symptoms. We, being the dental specialists, are often the first to recognize early signs, both of the TMD and sleep disorders, once trained. And this correlation should be kept in mind in addressing these patients. Sure. So, why we are talking about bidirectional nature? Because sleep loss has been said to increase pain sensitivity, and chronic pain itself reduces sleep quality. So, there's a self-perpetuating vicious pain-sleep cycle. Even literature is coming up with even a stronger effect of sleep, like this randomized control trial, which said the standard path of coefficient is higher from the cycle from sleep to pain. So, how the sleep loss increases pain? The pathophysiology is this arena of research, but few mechanisms which have been proposed, like impaired descending pain inhibition, the neuroinflammation like interleukin 6, TNF alpha, the involvement of HPA axis, limbic dysregulation, and reduced serotonin and dopamine, which are very essential for a proper sleep architecture. Moreover, the importance of glial cell have been emphasized, and we well know that they are very important in the central sensitization system of the chronic pain in amplifying the pain signal. Now, effect of orofacial pain on sleep. What all effect? Because sleep as such, we say this is a 90, 60, 120-minute cycle, repeated cycle, 3-4 cycle with various stage N1, N2, N3, and REM sleep. So the deep sleep, which is very important for overall relaxation of the body, is reduced. There's fragmented, rapid eye movement sleep. There are micro arousals which are seen. So what patient will complain of? With such coexisting relation, a non-restorative sleep, morning headaches at times, and morning jaw stiffness. So the literature says there are many orofacial conditions which are affected by sleep, like profile of the patient, like TMDs, both the myogenous and arthrogenous, myofascial pain, the headache disorders like migraines, neuropathic pains, and even the burning mouth syndrome. Now, how the sleep disorder per se is affecting the other way around, impacting the pain. The main disorders which have been implicated in this is, yes, we have secondary insomnia in these patients because of chronic pain effect. But even the primary insomnia incidents have been said to be very high in patients suffering from chronic orofacial pain. Obstructive sleep apnea, which is a sleep-related breathing disorder, even the bruxism, which is a sleep-related movement disorder. Now, we as orofacial pain, practitioner, many times prescribe many drugs other than those routine NSAIDs and all, which we have been using for dentistry, like tricyclic antidepressant and gabapentinoids. These are said to promote the slow wave sleep, so patient may have a better sleep profile. But there are certain drugs like we prescribe for them for orofacial pain. What I would like to emphasize here, obtaining a history of sleep here becomes very important, like benzodiazepines, cyclobenzaprine, which is a muscle relaxant now. These are not, or even opioids, if at all, is needed. They are known to cause, opioids are known to cause respiratory depression. So it can precipitate central OSA or obstructive sleep apnea. So screening our patients for all these existing pathologies, which can be concomitant, is very important for us in our prescription also. Even certain patient of bruxism, they are already taking SSRIs or SNRI, which can worsen bruxism. So probably we are trying to treat it, but the underlying pathology is the drug. So that needs to be addressed. So optimize pharmacotherapy for pain without compromising the sleep. That should be the target. Now, next. The clinical approach which we should have when correlating, understanding the correlation, that screen the sleep in all chronic pain patients. Whether it's by means of our standardized format like stop bang, sleepiness index, everything that should be done for our patient. We should be aware about it. Splints and physiotherapy, we do routinely prescribe for these patients, TMDs and all specialties. So in splints also, we should be aware if a patient has, concomitant OSA. The stabilization splint becomes a challenge. Giving that won't be that recommended. And the general instruction, recognizing the sleep disorder by means of simple screening like Malapati score, which is very much feasible in our dental setting, and giving the patient the sleep hygiene instruction from our side also, that reinforces for the patient. And even the CBTI, which is indicated in case of insomnias, for insomnia. And yes, CPAP is the standard therapy in a higher grade of OSA. But of course, we all can, with proper training, gives mandibular advancement devices. So it's a multidisciplinary care based on the grade, based on the presentation, and the correlation analyzed. We have to go about the treatment. To conclude, the sleep and orofacial pain are interconnected. Treatment requires integration of the knowledge of the both. Awareness and addressing of this interrelation can improvise the treatment outcome. These are my references. I tried to complete in time, and thank you for the patient hearing.
Presentation, doctor. Can you stop sharing your screen?
Yes, ma'am.
Dr. Aparna, do you have a question for Dr. Lavina? Yes, ma'am. Doctor, based on the current evidence, how do you justify that sleep disturbances are going to affect the pain modulation and central sensitization?
Ma'am, basically the pathophysiology, though it's a new arena of research, the pathology, like the way it is affect this the serotonin and dopamine, the two very important mediator for sleep, their disturbance, the HPA axis, because it emotional disturbance basis in anxiety and depression are concomitant factor with all this, and the pain modulation, like the glial cell involvement, microglial cell involvement, that can affect the modulation of the pain and sleep per se. The new neurological pathways which are created are in overall affecting both of them.
That was a nice presentation. Thank you, doctor.
Yeah, thank you so much.
Yeah, Dr. Selvakumar, you have a question?
Yes. Regarding this sleep, madam was telling, if the patient is having TMD, what is the relationship between TMD and sleep?
Yes, sir.
TMD pain due to TMD.
Yes, sir. Sir, TMD per se, at times, yes, there are certain, we previously used to correlate a lot with bruxism, though the latest literature is slightly, the PhD studies are saying like there is no clear cut. I came across few latest literature that bruxism may not be as important a factor as we used to think. And when we have, say, so TMD is a broad spectrum, so we have the muscular aspect also. And when it comes to the muscle pain, MPDS and all that, trigger point, myalgias and all, so the emotional excess, many times we get that history. And the sleep disturbance, I have found in my patient, majority of them gives history, key sleep is also disturbed along. So from my angle, if I want to treat, I will mandatorily ask for a sleep history also and try to address that excess also.
If the patient is having restricted mouth opening, in that case, you have to give sleep problem. Patient is having mild or moderate OSA. You want to give an MAD for that patient. How you are going to address that issue?
Sir, as of now, I personally have not given MADs. I am in a process of learning about it. But yes, since general, I have given, sir, whether it is stabilization, but in OSA, I won't go for a stabilization.
Okay. Thank you, ma'am.
Thank you, sir.
Okay, thank you so much, Doctor. And with this, we conclude the category A. We'll be starting with category B, and these will be the judged ones. So these are the students, PG and UG, and as well as PhD student also we have. So we'll be starting with Dr. Samruti, and we are very, very strict regarding the timings, madam. So please be very vigilant about the timings. Your time is only 5 minutes per student. Okay, and your time starts now. Dr. Samruti, welcome.
Good evening, everyone. Today's my topic is about strategy in diagnosis and management of trigeminal neuralgia, a case interview review for the modern treatment plan. How to? So 45 years old patient came to the Department of Oromaxillofacial Surgery with the primary chief complaint with severe facial pain on the left side of his face for the severe month. So patient is experiencing like electric shock like episode of pain localized from primary from maxillary and mandible division from trigeminal nerve. The pain was unilateral on the left side, lasts for few seconds and occur in the crustals. Recurrence multiple time per day and was trigger factors like walking, chewing, brushing, touching or eating hot and cold or mild exposed to the air. There was no history of trauma, no associated sensory loss, no swelling, and it also described like electrical shock or the lighting on his face. This got progress worst over the time, and patient has also developed anxiety due to the severe triggers. Extraorally, there was no abnormality seen. Intraorally, there was no evidence of ulceration, caries, periodontal disease, or periapical pathogenesis. Cranial nerve assessment was also done with no motor weakness was observed in the muscle of mastication. Trigger zone was noticed along the nasolabial fold of left side to the left alveolar ridge. There was no tenderness on palpation. MRI was suggested to the patient where we have found out the neurovascular conflicts caused by the left superior artery compressing the trigeminal nerve. The final diagnosis for this patient was given as class 1, typical classic class 1 trigeminal neuralgia on left side of division. V2 and V3 was involved. So for this patient, we have gone treatment for the first line pharmacology, carbamazepine, 100 mg. It is gold standard. So basically what this trigeminal neuralgia means, according to international classification of headache disorder, it is defined as a recurrence unilateral brief episodes of severe electrical shock like stubbing pain which is distributed in one or more branches of trigeminal nerve. The pain is being stimulated lasts for fraction or the second or the minute and occurs without any clinical evidence of neurological defect. It has been classified in the 3 major groups as you can see in the screen. So what I would like to discuss is many publications and many research has been done where they have found like carbamazepine and oxycarbazepine is the first choice of drug of line where surgical is indicated when drugs fails and no tolerance or drugs tolerance level has been seen. Most important in trigeminal neuralgia is it has been misdiagnosed as a dental pain or sinusitis or other different pains, and this diagnosis can lead to unnecessary extraction and opioid use to the patient. General practitioner misguide has been rate about 48% in 2011 by Cookman. So my aim study of presentation is current approach for the proper diagnosis and the management for this condition. So what are the different diagnoses we can differential diagnosis we can see? So most important is that careful assessment of the pain characters, duration and the trigger and associated feature can help you for the accurate diagnosis. Like for example in the trigeminal neuralgia, the pain will give like electrical shock like stubbing, duration will be 1 to 60 seconds. Pulpitis, it will be sharp stubbing and tooth related, it will be for minute to hour. Then TMD, you can see dull and aching kind of pain where it is for hour to days. Neuropathic trigeminal pain will be for continue burning kind of sensation which is for daily. And sinusitis is like stubbing burning but it is for like 5 to 240 seconds only. So what are the management for trigeminal neuralgia? There are major two management. One is medical time management. As you can see, carbamazepine is the first choice of drug, first line, and oxycarbazepine is an alternate first line. Then lamborghini is the second choice of drugs or the additional drugs you can choose. Then baclofen is an adjacent drugs, and this gabapine and pregabapine is in both an alternate option drug of choice after the tolerance level has been increased. So most important in the medical management is that the drug should be started in the lower dose and has to be increased in the interval period of time, so that the patient may not get tolerance to the drugs easily. If local anesthesia injection can be used in the trigger zone for the temporary pain relief. If there is a fail in the medical management, then we have to go for the surgical management. There are many surgical management. First is a type surgical management is a microvascular decompressor, which is non-destructive procedure. But in this, the pain relief is only 7 to 80% pain relief after 5 to 10 years. Periphery neurology, common target nerves are infraorbital nerve, mental nerve, infraalveolar nerve, supraorbital nerve. Here you can say pain relief is typical 6 months to 2 years. Then there are distracting techniques where radiotherapy and balloon compression techniques are there. When pain relief is 90 to 50. And gamma knife radio surgery is also there, which is mostly used in highly risk surgical patient, where it is on delay onset, week to month it take. But
time up, madam. You can stop your presentation here itself. Thank you so much. Yeah, I guess that was the last slide, but it was a good summary, and you rushed through some of your slides. I can understand that, but next time we will be prepared for 5-minute presentation again. Okay, thank you so much. Dr. Selva Kumar, do you have any question for Dr. Samruddhi?
What is the difference between pre-trigeminal neuralgia and trigeminal neuralgia? Post-trigeminal. What is the difference between the three?
So the symptoms, the duration times and the symptoms will be less. In pre, we can't get exactly electric like shock like pain, where post we can get electric shock like pain. And in that diagnosis, many times we misguide as like a peripheral neurology disorder also, where we see for any caries is there or any vitamins we prescribe to the patient. So that's the different.
You said when to refer those when medical management fails, go for surgical intervention. How long you'll wait to go for surgical intervention?
Till that patient feel relief after the medication we prescribe the medical. If that tolerance level has been over, then we have to go for the surgical.
Okay.
Dr. Aparna?
Yes, ma'am. If the trigeminal neuralgia is bilateral along with some neurologic deficits, what will be your diagnosis?
Ma'am, mostly trigeminal neuralgia is unilateral. If it is a bilateral, then we have to see if it is been related to any cranial nerve disease also, where that nerve has been get compressed, or it can be due to some vitamin deficiency where peripheral nerve can be also get involved.
Mostly it may be because of secondaries or demyelinating diseases like MS. Your presentation was really good. The slides were good.
Yes, slides were good. You just take care about the timing part. Next presenter, please. Dr. Rutvi. Unmute yourself, doctor. Dr. Rutvi, can you unmute yourself? Yes, and start sharing your screen. Say hello first.
Hello, ma'am.
Yeah,
1
and
minute,
start
ma'am.
sharing screen. Hello, I see myself. Thank you.
Ma'am, is it visible?
Yeah, go on the presentation. Where is your presentation? Yeah, please go on the presenters mode.
Ma'am, it's in presenter mode only.
Okay, start with your presentation. Time starts now.
Uh, Good evening, all respected faculty members. Today I am going to present the paper on the role of the cognitive behavioral therapy in psychosomatic orofacial pain, a comprehensive review. As all we know, chronic orofacial pain represents as the most challenging condition in day-to-day daily dental practice that persists for months and years. Chronic orofacial pain that encompass the group of disorder like the temporomandibular disease, atypical myofascial pain, and burning mouth syndrome. Despite we using the conventional treatment like the occlusal splints, analgesic, physiotherapy, still patient continue to experience pain and functional limitation. So, chronic orofacial pain is best understood as a biopsychosocial condition with the psychological factor like the catastrophizing, maladapting coping strategies, and stress play a crucial role in pain persistence and amplification. Cognitive behavioral therapy is evidence based, safe, and psychological intervention that targets the maladaptive thoughts, behaviors, and emotional response related to the pain, thereby improving the pain coping skill and reducing pain related distresses. I done the comprehensive review to conduct to determine the whether CBT is more effective than control in reducing pain intensity and psychological problems in patient with orofacial problems.
I think there is some glitch in the presentation. Dr. Aparna, are you able to see her?
No, doctor.
Okay, we'll go ahead with the next speaker, Dr. Shreya. Dr. Ruthvi, we will consider in case if she joined back, we will check later. Dr. Ruthvi, what happened?
Ma'am, it's not visible.
No, dear. You went. Oh, do one thing. You come back in some time because now we'll take in the next speaker. There was some technical glitch. We'll get back to you today. Okay, because your topic is very nice. Okay, Dr. Shreya, are you there?
Good evening, ma'am.
Yeah, please start with your presentation. Dr. Ruthvi, please have a glass of water. Check your connectivity. Okay, and there is a halo of light around you. Please stop that because it is really disturbing our eyes here. So if you can stop that or just shift your location, maybe that will be a good sign also. Thank you so much, and we'll get back to you. Dr. Shreya, can you start sharing your screen, doctor? Dr. Shreya, can you say hello and switch on your camera? Yeah. See, I like seeing faces. I cannot talk to blank screens. So please switch on your cameras. And madam, please go on the presenters mode. Dr. Shreya?
My screen is visible.
It is visible, darling. But then can you go on the presenters mode, please?
Okay.
Please
Can
switch
I
on the
start?
camera also.
Yeah, please switch on the camera. I have requested her, but then I want the presentation more importantly. Okay, your time starts now, doctor.
Good evening, everyone. My topic is bone beam compared tomographic evaluation of anatomical variations in mandibular canal in observational study. Mandible is a complex bone, both in terms of its development and anatomy. The mandibular canal is one of the most crucial structures present within the mandible. Branching of inferior alveolar nerve canal is common and many anatomical variations have been reported. The incidence of these mandibular canal aberrations was underestimated in the panoramic imaging studies, whereas CBCT provided high resolution 3D imaging and was considered superior in identifying these variations and detecting narrow diameter canals. Although an infrequent anomaly, insight into the prevalence, location, and configuration of these canals are highly important as they can cause orofacial pain and neuralgia, complicate surgical and anesthetic procedures. The most common consequences linked with such injuries are extensive bleeding, traumatic neuroma, paresthesia, or extended anesthesia. With this context, the present study was conducted to evaluate the presence, frequency, and type of mandibular canal variations in either gender and sites using CBCT. The aim was to assess the prevalence and frequency of mandibular canal variations using CBCT with the objectives of to evaluate the different anatomical variations of mandibular canal in either gender and sites and to intercompare the different anatomical variations in either gender and sites using CBCT. The study duration was of 3 months, and all the CBCT scans available in the dental archive were evaluated. With the inclusion criteria is the CBCT scans of either gender above 15 years of age and the CBCT scans with adequate tomographic quality with mandible's complete extension were included in my study. CBCT images with the mandibular fracture, trauma, or surgery, patients undergone radiation therapy, benign and malignant bony pathologies, and any developmental deformity affecting the jaws were excluded from my study. Procedure was the present study was carried out using 134 CBCT scans and then it was evaluated. The left and right sides of the mandible were examined for the presence and type of mandibular canal alterations, and they were categorized using the standards put forth by Naito et al with modifications made by Rashuran et al. In 2014. The type 1 is the retromolar canal, type 2 the dental canal, type 3 the forward canal, type 4 the buccolingual canal, and type 5 the trifid canal. The data was entered in the Microsoft Excel spreadsheet analyzed using SPSS software, and for statistical analysis, one-way analysis, student independent t-tests, and chi-square tests were employed. The results were during in my study, the age group among 45 to 60 years were more, and the females were predominantly high. The in my study, the 11.94% of patients showed the variations. The right side was more involved than the left side, and uh, among 134 patients, our 37.50 patients showed type 1 canal variation and followed by type 2, that is 31.25%. The image is showing the type 1 retromoral canal. The yellow arrow is showing the variation. Type 2 dental canal, type 3 the forward canal, and type 5 the trifid canal. Coming on to the discussion, diagnosis these variation is of significant clinical relevance as unrecognized accessory canals can increase the risk of surgical complications, compromise local anesthesia effectiveness, impact the planning and placement of implant or execution of endodontic and orthodontic procedures. To confirm the variations of anatomical landmark, a comprehensive radiographic assessment is necessary before any surgical procedure. Therefore, the accurate detection of such variation using CBCT not only enhances the diagnostic precision, but also contributes to safer, more predictable, and better informed treatment outcomes. Numerous studies of variations of mandibular canal using CBCT are available in the literature. These are the studies that are contrasting and similar to my studies. Coming on to the conclusion, our study revealed the accessory mandibular canal variations are relatively common with observed prevalence of 11.9%. These anatomical variations were found to occur slightly more frequently in females and were more commonly located on the right side of the mandible. Among classified types, type 1 and type 2 variations were common. The identification and understanding of these accessory canals are of significant clinical importance, particularly in surgery, implant placement, and local anesthesia administration. Failure to recognize these variations can lead to orofacial pain, complications, unexpected bleeding, or nerve injury that can cause neuralgias. Therefore, through radiographic evaluation and awareness of possible mandibular canal variation should be an integral part of preoperative planning to ensure safe and effective treatment outcomes.
Thank
These
you,
are my
ma'am.
references.
Thank you. You're done,
Thank
done,
you.
done, done, done. Thank you so much. Yeah, Dr. Aparna, do you have any question for doctor?
Yes, ma'am. What type of mandibular canal variation you think will lead to more incidents of orofacial pain? Or how are you
I
going to
think that
correlate your topic with OFP?
when the anatomical the mandibular canal variations, mandibular nerve canal variations are very important to diagnose through radiographic assessment because if we cannot diagnose it, it can cause the paresthesia in the patients. It can cause the conditions like neuralgias in the patient.
Dr. Aparna's question was how do you correlate to orofacial pain? And secondly, what type of variation would matter the most? Dr. Shreya? I think we've lost her.
Yeah.
Dr. Selva Kumar, do we have any question for Dr. Shreya?
No, madam. No, madam. Same question only.
Okay,
Simple clinical diagnosis.
Yeah, Dr. Ruthvi, should we call her back again? Dr. Ruthvi, are you there? Yeah. So now all the best. This is your last chance for this presentation, and
Yes,
don't
ma'am. Thank you, ma'am.
mess it up. Okay. Chalo, start.
Ma'am, 1 second.
See, we'll try to be fair enough with everybody. I understand the situation is not same everywhere, but then try to understand our situation also, because we've been,
Yes, ma'am.
yeah.
Ma'am, is it visible?
No, darling.
Ma'am, can I do last in last?
Let me just see the time limit, because we have a Zoom meet here. Okay, Dr. Kavya, are you there?
Yes, ma'am.
Dr. Kavya, start presenting.
Yes, ma'am. Good evening, everyone.
Start sharing your screen, madam. That is more important.
Yes, ma'am.
Once you log in, start sharing your screen, and then you start your presentation.
Are you able to see the screen, ma'am?
No, dear. Start sharing the screen first.
Now, ma'am?
Yes, please go ahead. Your time starts now, doctor.
Yes, ma'am. Good evening, everyone. Today, I'm speaking about electric relief harnessing TENS for orofacial pain management. Pain has been one of the commonest torment since immortal. So, for pain relief, we had been using local anesthesia and analgesic. But now, in the modern times, to combat the pain, we are starting with TENS, one of modality transcutaneous electrical nerve stimulation or TENS. So, first, what is TENS therapy? It's a non-invasive method of pain relief in which low voltage electrical currents are applied through electrodes placed on the skin to stimulate peripheral nerves and thereby reduce pain perception. Historically, pain was relieved using electricity dates back to the ancient times. And modern civilization set in 20th century, TENS has been used in dentistry. So let me move on to mechanism of action. First mechanism of action is gate control theory. Here, large A beta fiber close the gate, inhibits small a delta and C fibers, reduces pain signals from TMJ and jaw muscles. Second one is endogenous opioid theory. In endogenous opioid theory, low frequency stimulation releases endorphins and encephalins, producing longer lasting pain relief. Thus, TENS modulates nerve signals and activates neural analgesic pathways. Moving on to components of TENS. These are the components: pulse generator, control unit, lead wires, electrodes, and power source. Based on the stimulation, modes of a TENS are classified into conventional, burst mode, acupuncture-like mode. So, benefits of using TENS. It's a non-invasive, safe, portable, and long-term solution. Patients having needle phobia the TENS is a very useful. Now, moving on to TENS for an acute pain. In acute pain, high frequency TENS uses gate control analgesia, whereas in chronic pain, low frequency or burst mode releases endorphin, rapid onset relief in acute condition, longer lasting analgesia in chronic pain, safe, non-invasive, adjacent to any medications. Moving on to TENS for neuralgic pain. TENS for neuralgic pain, especially trigeminal neuralgia, TENS reduces pain by inhibiting nociceptive transmission, releasing endogenous opioids, and suppressing atopic nerve discharge. Clinical studies have significant reduction with TENS therapy. Now, moving on to TENS in TMD. In TMD, TENS reduces myofunctional pain, improves mouth opening, and decreases muscle spasm. It is effective as an adjunct therapy and sometimes compatible to physiotherapy. TENS in myofascial syndrome. In myofascial pain dysfunction syndrome, muscle spasms plays a major role. TENS helps by relaxing muscles and reducing pain, especially when electrodes are placed extraorally. Next, in other dental applications of TENS are in orthodontic pain, post-herpetic neuralgia, xerostomia. In xerostomia, TENS increases salivary secretion. And what are the complications of TENS? It shouldn't be used in pacemakers, epilepsy, bleeding disorders, and also in pregnant women, improper electrode placement. Some of these cautions to be taken during skin irritations, dizziness, irritation, nausea, rare electrical burns, and these are reversible. Moving on to conclude, TENS is a safe, non-invasive, and effective adjunct in managing orofacial pain, particularly TMD. It reduces drug dependency, improves patient comfort, and can be self-administered. However, future research is required to standardize its protocols in dentistry. Lastly, I would like to say TENS bridges the gap between pharmacological therapy and patient comfort, making it a valuable tool in modern dentistry. Thank you.
Very well timed presentation, doctor. Your content was good, but I will urge you one thing. Go back home. When you go back, go to the YouTube and check all the presenters' presentation. None of them had an aeroplane flying here and there. The presentation has to be professional. I don't want you to make presentation which is a more of a cartoon type of presentation. You have used beautiful slides. This is a professional forum, so henceforth the transition has to be a professional transition. One. Secondly, I want you to go back and check your own presentation. Noise, there was a disturbance in the presentation, so that all these points are going to be considered, so that you become a good presenter. And some point in time I should be the one involving you in my as a speaker in my presentation group. So yes, I want you to go back, learn from that the earlier presentations or the speaker's presentation. There is a quality of PPT we want, and we want you to maintain. This is a professional forum. Dr. Selva Kumar, do you have any question for madam?
TENS is contraindicated in deep venous thrombosis. Why? Was it contraindicated?
I don't have idea about this, right?
Okay.
Dr. Aparna, do you have any question?
So I just wanted to tell one correction. So what we advise is per slide, the font size, it should be at least 28.
Yes.
It was too small. It was very difficult for us to read, and so many lines were there. So you should keep to least amount of lines as possible. We call it as rule of 6. Per line, you have to have 6 words or less, and per slide, only 6 lines. Definitely not more than that. And more of pictorial representation is appreciated. To present it well, the slides, the quality can be improved.
Yes, Kavya, we are here to guide you to become a good speaker. So in that scenario, the presentation matters, one, and secondly, how you present it, and most importantly, your slide should convey what you're saying. So right from the font, no multiple colors and flashy colors and flashy transitions will definitely take away the content from your PPT. Your content should be the king, not the transitions. Okay, so please go back, and it's a learning curve for all of us. I also did the same mistake in the past. So what I would suggest you is go back and check the YouTube links. You will definitely benefit from there. Let's call in our next speaker, Dr. Divya.
Yes, ma'am.
There's an echo, Dr. Divya. Please stop any other appliance or any other mobile handset next to you. And please switch on your cameras, dear. I don't like talking to blank screens. Yes, Dr. Divya. Hello. Which
Yes, ma'am.
Are you in your first year?
Sorry, ma'am.
Dr. Kavya, can you mute yourself, please? You're in the same room. Mute yourself. You guys are room partners?
Yes, ma'am.
It's a sweet gesture, but Dr. Kavya, mute yourself. Dr. Divya, start presenting your presentation. You guys are kids. Which year you are in, Divya?
Ma'am, third BTS.
Third year BTS. Good. Start with sharing your screen, dear.
Yes, ma'am.
Divya, unmute yourself first.
Is it visible?
No, not yet, but maybe it's taking time for browsing.
Now, ma'am?
No, dear. Dr. Aparna, can you see, or is it my side of
No, doctor. No, I'm not able to
blank screen, right? Dr. Divya? Yeah.
Yes.
Okay, fine. Yeah, I understand what has happened here. But anyway, start, open your presentation.
I have opened, ma'am.
Was it the same laptop, Dr. This one, what was the?
No, ma'am, it's different.
Okay, please.
I have shared the screen, ma'am.
Yeah, but then open your presentation. I can see myself and the.
Now, ma'am.
No, dear.
We'll come back.
Okay, we'll get back to you, Dr. Divya. Okay, Dr. Dhanlakshmi.
Yes, ma'am.
Okay, wait. I think I can see something. Is this your presentation, Healing with Light, Photobiomodulation?
Yes, ma'am. Yes, ma'am.
Okay, fine. Then go back to the first slide.
Yes, ma'am.
Go on the presenter's mode.
Yes, ma'am, it's on present.
I doubt. Do you know where the presenter's mode key is? Go on the extreme right, where you see the 40%.
It's on presenter.
Just press on it. Yeah, go ahead. Your time starts now, doctor.
Good evening, everyone. Lasers are like super precise light swords cutting through darkness with focus and power. Building on this perspective, I would like to introduce my topic today, that is healing with light photobiomodulation for orofacial pain. PBM offers dental practitioners a non-thermal and non-specific treatment modality that can be used and adjunct to traditional methods. PBM is a laser-based therapy increasingly used in dentistry, supported by solid cellular and clinical evidences. It provides analgesic, anti and biostimulating effects, tissue reducing inflammation. Applications include post-extraction healing, reduction of edema and muscle trismus, dental analgesia, and treatment of dentin hypersensitivity. These statistics reflect the significant global burden of orofacial pain, emphasizing its clinical relevance. About 1.1% of general adults suffer from burning mouth syndrome, and about 30% of adults suffer from TMD. About 20% of adults suffer from neuropathic orofacial pain, and in children, about 0.2% of children suffer from TMD disorders. Next, moving on to advantages of PBM, it offers non-invasive and painless, avoiding injections and surgeries, leading to high patient acceptance. Benefits include increased cellular energy production, improved blood circulation, reduced inflammation, tissue repair and regeneration, neuroprotection and neuromodulation. Moving on to mechanism of PBM, PBM works by absorption of light by mitochondrial chromophores, that is cytochrome C oxidase, leading to increased ATP production and modulation of inflammatory pathways. PBM is directly applied to the skin at the site to be treated. It reaches the underlying tissues, muscle cells, and mitochondria. Moving on to PBM parameters, the biological effects of PBM are governed by Anschutz law, which says that cells will respond differently to varying levels of irradiance. Lower dose of light stimulus leads to stimulation of fibroblast and osteoblast. Higher dose of light stimulation leads to reduction of nerve conduction,
or inflammatory mediators. The standard clinical parameters include wavelength. The wavelength is about 600 to 900 nanometer, and the power is 30 to 200 milliwatts, and energy density about 4 to 10 joule per centimeter square. Moving on to PBM after tooth extraction. Following tooth extraction, tissue injury occurs, PBM laser is applied, healing cells such as fibroblast bone cells are produced, and post-operative symptoms reduce pain, swelling, and stiffness. It leads to faster healing and reduced need for medicines. Moving on to PBM after dental infection, PBM does not directly eliminate bacteria and it is used only as an adjunct to antibiotics. It improves lymph flow and local circulation. It supports better antibiotic action and reduces tissue edema. Moving on to PBM in India, advantages include it provides significant pain reduction without pharmacological side effects. It is non-invasive and well tolerated. But challenges include lack of standardized PBM protocols and limited clinician awareness and training restriction widespread adoption in India. Moving on to PBM in dentin hypersensitivity, it decreases nerve conduction velocity and decreases sensitivity to thermal, increases odontoblast stimulation and tubule sealing. Moving on to PBM for TMJ disorders, it improves muscle microcirculation and relaxes muscles, easing pain. Treatment uses splints, occlusal adjustment, and drugs to reduce pain. Moving on to evidence from clinical trials, for myofascial temporomandibular disorders, PBM reduces pain and improves muscle tenderness more than a placebo. Trials for temporomandibular joint pain indicate better pain and mouth opening outcomes. It's a safe, non-invasive therapy with minimal adverse effects globally. It removes noxious or damage, disinfection, pain, inflammation, and immune response. Moving on to safety profile, PBM application is painless and well tolerated. Studies indicate no mucosal burns, tissue necrosis. But the operator should wear laser glasses, laser mask, and non-flammable prep. Moving on to limitations and challenges, it requires high cost of equipment, lack of standardization and awareness, regulatory hurdles and quality, import dependency, technical limitations. Moving on to conclusion and future scope, pain management and musculoskeletal care, supportive cancer care, dental and oral health, dermatology and cosmetic use, neurological rehabilitation. These are my references. Thank you.
Okay, just well within time, and the same maybe a same advice from my side also to you regarding the presentation skill. At
Yes.
third year, you are doing a good job learning about something which is really a need of our. And this topic expert is already with us,
Yes.
Dr. Selva Kumar sir. Do you have any question for her? Can you unmute
That-
yourself? Yeah. Any question for
Dr.
her?
Divya, have you
Yes,
used a low-level laser in your clinical practice?
No, sir, not yet, sir.
Third year student.
Okay. What wavelength it was given, the photobiomodulation you have used for
Sir,
various procedures?
visible light to near infrared light, that is 600 to 900 nanometer.
Okay. Okay. Thank you.
Dr. Aparna?
Thank you, sir.
No questions, Dr. Sonal. Whatever you said only, I want to reinforce. Content-wise, it was too good. You were well within the time, but the font size was too small. I was not able to read anything, so I was
Consider
just
us
listening to
blind.
it.
Consider us blind. And four maximum 4 or 5 points per slide. That should be your rule.
Yes.
And use colors which are very subtle. I mean, this is a professional forum, so please, whenever you are presenting in a professional forum, the colors have to be presentable in that sense. Anyways, a learning
Yes.
curve for everybody. And stop sharing your screen immediately, Doctor. Dr. Dhanlakshmi, are you
Yes.
ready?
Yes, ma'am.
Dhanlakshmi, say hello. And Dr. Divya, please mute your mic. Yes, thank you, Dr. Divya. Dr. Dhanlakshmi, say hello again.
Hello, ma'am. Good evening to one and all.
Yeah, please start sharing your screen, madam.
Is my screen visible, ma'am?
No, maybe it will take a little while. Yeah. Go on the presenter's mode. Yes. Time starts now.
Okay, so good evening, one and all. I'm Dhanlakshmi, and today I'll be speaking on the concept the jaw joint connection, understanding temporomandibular joint disorders with MRI. So, coming to the introduction, TMJ disorders refers to pain and dysfunction in the jaw joint, its surrounding muscle, causing symptoms like jaw pain, clicking or popping sound, headaches, etc. We'll also look onto the internal disc dearrangement. The internal disc dearrangement with reduction is the clicking sound, while the internal disc dearrangement without reduction is the closed lock and restricted movement. So before going to the dysfunction, we learn about the anatomy. So we all know the TMJ is a complex synovial joint. It consists of the condylar part, the articular disc, the supporting ligaments, the supporting muscles, and the joint capsule. So there are many imaging modalities which we can use for TMJ. For the bony part, bony thing, there are few TMJ specific like transcranial, transpharyngeal, etc. And the other methods are OPG, SMV, reverse tonus, and CBCT. For the soft tissue imaging modality, we have arthrography, MRI, and USG. So coming to the main point, why MRI is the gold standard. MRI uses a magnetic field and radio frequency pulses to obtain high resolution images. The images can be acquired in sagittal and coronal plane in both open and closed mouth position. So MRI has two phases, the T1 phase and the T2 phase. T1 is optimal for anatomical detail and disc visualization. T2 is superior for pathology, inflammation, and especially for joint effusion. So coming to the direct and indirect signs of TMJD. The direct signs, so first is the disc morphology. Here, the healthy disc is biconcave in shape. It might be then deformated into the crumpled, flat, perforated, or rounded. Second is the disc position. It might be superiorly, anteriorly, rotationally, or lateral, medial, etc. Third is the disc movement. In displacement with reduction, the disc lies between the articular eminence and the condyle during open and closed mouth. In this displacement without reduction, the disc remains anterior to the condylar head in the both open and closed mouth position, resulting in limited mandibular movement. Fourth is the degenerative changes of the condyle. It might be due to osteoarthrosis, osteoarthritis. This is an image of the normal degenerative changes occurring in the condyle. This is a CBCT image. So this one is the normal. Here we can see the flattening of the condyle, sclerosis, osteophytes, and then erosion. Now coming to the indirect signs, first is effusion. The joint effusion, like the T2 weighted scale sequences are ideal for displacing joint effusion, which appears on MRI imaging as areas of hyperintensity. Second is the retrodiscal layer, constant displacement of the disc. The retrodiscal layer tissue undergoes changes like tear, pseudodisc formation, and even the presence of effusion. Third is the changes of the lateral pterygoid muscle. The muscle may undergo contracture, hypertrophy, or atrophy. By this, I conclude my presentation saying MRI differentiates myogenic and arthrogenic causes of the TMG. And the T2 phase, it has hyperintensity, is a reliable radiological indicator for clinical pain and synovitis. For treatment planning, understanding disc position and lateral pterygoid muscle adaptation is essential for successful splint therapy or surgical intervention. The evaluation of both the direct and indirect signs of the TMJD on MRI is necessary for comprehensive assessment to diagnose the extent of the damage of the TMJ complex. These are the references. Thank you.
Very, very well timed presentation, Doctor. And Dr. Aparna, questions for Dr.
Presentation was really good. The way you presented, slides were good, and you were well within the time. And one question is, you were talking about MRI. So what is your opinion about MRI with contrast and without contrast?
Ma'am, you mean by the phases, ma'am? T1, T2 phases?
No, with contrast and without contrast.
I have no, I
No,
don't
no, no,
contrast.
no issues, no issues. You have done a good job. Yeah.
Okay, Dr. Selva Kumar, sir.
What is T2 weighted image?
So T2 weighted, we can see the effusion. It helps in the pathological and inflammation. We can see the things like on T2 phase.
Okay, ma'am.
Okay. Thank you, Dr. Dhanalakshmi. Congratulations that
Thank
you
you.
completed in time. Good presentation. Maybe we can study a little bit more and next year present little bit in depth. Okay. Good
Okay,
slide.
ma'am. Thank you. Thank
Okay.
you.
Next presenter, Dr. Chandana.
Yes, ma'am.
Yeah, I say hello and switch on your cameras, dear. Everybody, the last, Dr. Harshika, also please switch on the camera and keep it ready. Okay, Dr. Chandana.
Hello, ma'am.
Hello. Yeah, and go on the slide share mode, madam. Perfect.
Can I start now?
Yes.
As there is a rapid increase in number of temporomandibular joint disorders pattern in post-COVID era, I would like to talk about newer horizons of treating TMJ disorders, insights from neuromuscular dentistry. The lack of rational and systemic evaluation, diagnostic approach, and treatment planning have worsened the situation considerably. Temporomandibular joint disorders has an incidence of 5% to 12% and is the second most common musculoskeletal condition. It can affect the day-to-day activities of an individual, deranging the psychosocial functioning and altering the quality of life. Therefore, it is important to diagnose the disease at an early stage and which will provide the patient a comprehensive and better treatment. Anatomy of temporomandibular joint. It's a synovial joint of condylar variety. Only mobile joint of skull formed between head of the mandible and articular fossa of temporomandibular joint. Neuromuscular dentistry, which focuses on diagnosing and treating disorder related to alignment of and function of jaw, which involves the interaction of jaw muscles, joints, and teeth. Role of neuromuscular dentistry in treating temporomandibular joint disorders are it possesses diagnosis, muscle relaxation, correct jaw alignment, custom treatment plan, and symptom relief. From diagnosis to treatment are clinical examination, research diagnostic criteria for temporomandibular joint disorder criteria, CBCT, MRI, JVA, EMG, and treatment. Clinical examination causes are trauma, teeth clenching and grinding, arthritis. Signs and symptoms are pain, joint nose, jaw dysfunction, muscle tenderness, ear related symptoms like tinnitus. Role of T scanning diagnosing temporomandibular joint disorders are occlusal analysis, force and timing data, dynamic functional assessment. Diagnostic contribution of T scan, identification of occlusal imbalance, dynamic occlusion analysis, objective quantifiable data, complementary role in comprehensive diagnosis. Joint vibrational analysis is a non-invasive diagnostic tool increasingly used in dentistry to assess the condition of temporomandibular joint symptoms. It helps to detect issues like internal derangements, disc displacement, and degenerative changes by analyzing vibration generated during jaw movements, which helps in patient assessment, JVA procedure, data collection, intra-process diagnosis, and treatment follow-up. Electromyography is a diagnostic tool used to assess muscle activity and can provide valuable information when diagnosing temporomandibular joint disorder, assessing muscle function, identify trigger points, monitoring treatment progress, differentiating between conditions. Procedures are preparation surface electrodes are placed on the skin over the jaw, muscles such as masseter and temporalis, recording, resting, clenching, and sheathing, analyzing the EMG data and analyze to determine patterns of muscle activity and identify abnormalities. Jaw tracker. It's also known as mandibular tracking device, a diagnostic tool used to measure and analyze jaw movement. Purpose are assessment of jaw movement, which tracks the range of motion in jaw, example opening, closing, lateral movements. Data collection helps data irregularities such as limited range, joint noses, clicking, popping. Treatment planning helps clinician design customized treatments such as physical therapy, orthodontics, monitors progress during and after therapy. Importance of biometrics are objective diagnosis, analysis of mandibular movement, evaluation of muscle activity, occlusal force assessment, treatment planning, monitoring treatment outcome, documentation, and research. Advantages of biometrics are precision, non-invasive, early detection, adjuvant to imaging, quick, and limitations are cost and require skilled professional.
Treatment modalities for temporomandibular joint disorders are TENS, medication muscle relaxants, disocclusion time reduction, splints, Botox injection, arthrocentric arthroscopy, open joint surgery. I would like to conclude, incorrect diagnosis and delayed diagnosis can cause lesser prognosis. Neuromuscular dentistry restores the balance in stogonomatic system. We need to temporomandibular joint disorders from perspective of neuromuscular dentistry. In conclusion, the use of biometrics can provide practitioners with clear insight into patient stogonomatic system. These are my references, and thank you.
Yeah, very well presented, Doctor. Whatever content you had, you presented it very well. Your command on the topic was also very good. Congratulations for a well-timed and very well presented lecture. Dr. Aparna, do you have questions?
No, doctor. She did well.
Yeah. And it was just a review for the latest in newest in TMD management. Dr. Selva Kumar, do you have any questions?
Nothing, madam. I don't know much about this chart right here.
Okay, no problem, sir. So, Dr. Chandana, have you used any of these equipments on your own in your college practice or maybe later on?
No, ma'am, as I'm in still third year, I'm not using, but in the college, they are using, ma'am.
They are using. So please understand the mechanism very well because this is the future. And welcome to the complex world of orofacial pain. You have the potential to become a very good clinician in future also. Congratulations on that.
Thank you, ma'am.
Okay, on that, I would like to call in our last speaker for the day, Dr. Harshika.
Good evening, ma'am. Respected jury members, Sonal ma'am, and fellow listeners. Can you see my presentation?
Yeah. Can you start sharing the screen?
I have actually started.
We can see you.
I'll start again.
Please start again. Dr. Harshika is a PhD student.
Can you see, ma'am?
Nice. Yes, but yeah, go on the presenters mode.
Thank you so much for allowing me to present.
Please go on the presenters mode.
Yes. Okay. Can you see the presentation?
Yeah, time starts now.
Okay. So we all know that occlusal splints are popular, but yet the evidence are very selective. So why does that happen? So my presentation is basically evidence-based review that shows whether occlusal splint really work in myogenic TMT or not. So what we know, myogenic TMT is basically TMT of muscular origin with a dull pain triggered by function with tender masticatory muscles and sometimes painful limitations. It is well managed by reversible and conservative care like education and self-care, and then we add splint or adjuncts when symptom persist. So what are the right patients to treat them with occlusal splints? So splints work very best when the phenotype is truly myogenic. So in masseter and temporalis or any other masticatory muscle, there is pain which is reproduced on palpation and function with stress and function, parafunction patterns, and limitation in a mouth opening or any other limitations mainly due to pain. But we need to see that if there are any red flags like true locking, swelling, crepitus, trauma, systemic symptoms, neurogenic signs, malignancy, or intra-articular pathology, then we need to reassess and choose an alternative pathway. For this, we can use DCTMD guidelines. So jumping straight to the evidence. So I'm not leaning on a single trial, rather I'm using a high-level evidence with meta-analysis of RCTs. So the first study that I'm listing here is a 2020 network meta-analysis that shows the concretivity of using a full coverage hard disk splint which has the strongest evidence for pain relief. This study also showed that mini anterior splint has higher evidences, but the quality of the evidence was very low when we compare to hard disk stabilization splint. The next is the 2021 meta-analysis that with 52 RCTs that shows that occlusal splint are among the top options for pain relief. But when it comes to function like maximum mouth opening, the benefit is low. The next study is a 2024 systematic review and meta-analysis that shows that manual therapy wins when we talk about dysfunction or problem with maximum mouth opening. And the last study is a 2025, the most recent one study that shows that centric stabilization splint are the best when used for short time. So because the evidences were very vast, so I have used a simple analogy of traffic light signal to show the concretivity of evidence, which mostly split in the bucket of pain and function. So we get a green light. That means we are having a very solid evidence when it comes to using the occlusal splint for very short time, say less than 3 months. And which type of split? I already said that centric stabilization is split and hard split. Please remember that nighttime wearers have a longer benefit when compared to the full-time wearer as seen in the studies. But the scenario changes when we use them for more than 6 months, whereas the evidence certainty drops and we need better stabilization studies. And for the function, as I already said, that manual therapy is a comparative winner as compared to occlusal splint therapy. Based on the evidence shown so far, we can make the 6-week practical protocol, which can be shown as a simple two-phase plan. So here I'm using NHS guidelines for designing the practical plan. So the first 2 weeks we can give for simple confirming phenotype, taking the baseline measures like pain, disability, VAS score, then starting with the core care, which mostly include physiotherapy, counseling, and physical self-regulation, giving a short duration of analgesic. Then we do the checkpoint at 2 weeks. If the symptoms improve, we continue with the self-care. If it doesn't, we can start the physical splint trial. What kind of a splint to use, I've already suggested. And then which is very important that we mostly miss, is a 2-week review post-insertion for fit and retention, even contact, and symptom treat. At 6 weeks, it's very important to see if the symptoms better, we taper or we stop. And if no meaningful response is seen, it's better to stop and reassess the diagnosis. Most splint failures are usually unavoidable, but they happen. Why? Because first of all, there is no phenotyping. We treat all the TMD as one, using partial coverage as for a very long time, because there is bite change and safety risk. No early review for fit and contact, persisting with the treatment despite we see no effect, and skipping the rehabilitation altogether to restore function. And to sum it all, the take-home messages that I would say is that the evidence suggests that splint does modulate pain in true myogenous TMD, function improve, but not as we compare to the manual therapy. So not with the splint, the function are going to improve. And overall, the success depends upon right diagnosis, monitored trial, and planned exit. Thank you so much. These are my references, and thank you so much for listening.
Okay, Dr. Aparna, any questions for her?
This is actually my favorite topic. Recently, one of my article about occlusal splints I published in DCNA. So your take-home message was really good. So what is your favorite splint?
Ma'am, I am a prosthodontist and I have used stabilization splint, and I think that for most of the cases, hard stabilization splint works really best, and they are very good if used for, again, short times, what I have also seen. But then we need to assess the patients very carefully. Like if they are very useful in patients who are having parafunction or having some sign and symptoms that show that there is some stress loading a problem that is concerned with the occlusal pathway.
Okay, so my advice is you go for any splint. These are the words of my mentor, Dr. Davis Thomas sir. He will tell, like, you can go for any splint, but don't tell that is the treatment. And you have to assess the underlying cause. That's the thing.
Exactly.
Dr. Selva Kumar, any question for Dr. Harshika?
What is the treatment protocol for muscular co-contraction? The patient is having yeah.
Okay, sir, actually, if we go by so first, how to see if there is muscular co-contraction? I have, like, in practice, I've always been very Like it's very confusing to see if the patient actually belongs to splinting or local myalgia. So what I do now is that I follow DC-TMT protocol. And when we come to the treatment part, first, it's very important to diagnose कि हो क्यों रहा है, like if it's stress, if it is posture related, if there is any kind of occlusal symptoms that is related, we need to treat that. Second, what works best? We can start with a simple pharmacotherapy, counseling, physical self-regulation. It's important, and then we educate the patient. Then we can follow with the add-ons. We can use stents, we can use occlusal splints, and then there are newer protocol modalities also. Have not used them, laser therapy and all. But for a long-term maintenance, it is very important to go with a rehabilitation, and it is very important to see the underlying cause.
Dr. Rutvi, yeah, I think you can stop sharing, Dr. Harshika.
Okay.
Yeah, hello, ma'am.
Dr. Rutvi, are you still there?
Yes, ma'am. If
Are
you
you-
allowed me,
Yeah,
I will.
we'll allow you. Please start immediately because we are running out of time.
Yes,
And
ma'am.
yeah. Dr. Harshika, very good presentation.
Thank you so much, ma'am. Thank you so much.
Dr. Rutvi, say hello.
Yes, ma'am. Yes, ma'am. Yes. Ma'am, is it visible?
No, dear. I can still see you.
Ma'am, some
Okay,
error.
don't get disheartened. See, I'll tell you what, it happens to the best of us, and it maybe must have happened with me also a couple of times, so don't worry. I'll give you a chance next year, no problems with that. And Dr. Aparna and Dr. Selva Kumar, do you have any encouraging thoughts for the participants for paper presentation? They are kids.
I really felt so happy. Like third year students are coming and presenting. They need a great applause here because it's such a big forum. You are really not what to say. You have got the urge to come and participate among us. I'm very happy and proud of you all. So keep up the good work and please continue to do your diligence in the forthcoming years also.
Absolutely. And
Thank you, ma'am.
Dr. Rutvi, I think yeah, okay.
Ma'am, is it visible?
Yeah, you start your presentation. We'll give her 5 minutes.
Sure. Yes, ma'am. Thank you so much, ma'am. Good evening to all respected teachers. I'm going to present presentation on the topic of the role of the cognitive behavioral therapy in psychosomatic orofacial pain, a comprehensive review. As we all know, chronic orofacial pain represents as one of the most challenging problems in dental practice, persist for months or years, so for correlation with the clinical or radiographic finding. Chronic orofacial pain encompasses a group of the disorder like the temporomandibular disorder, atypical myofacial pain, and burning mouth syndrome. Despite conventional treatment that we use like occlusal splint, analgesic, or physiotherapy, continue to experience pain and functional limitation. Chronic orofacial pain is best understood as a biopsychosocial condition in which psychological factors such as catastrophizing, maladaptive coping strategies, and stress play a crucial role in pain persistence and amplification. Cognitive behavioral therapy is an evidence-based psychological intervention that targets the maladaptive thoughts, behavior, and emotional response related to pain, thereby improving pain coping skill and reducing pain-related distresses. I done the comprehensive review to determine whether cognitive behavior therapy is more effective than control in reducing pain intensity and psychological problem in patient with orofacial pain. The control group include usual treatment, no intervention, use of intraoral appliance, and self-care assessment. A literature search performed for study published between the February 1994 through July 2023. Total 8 study retrieved for the orofacial pain, and that summarize the temporomandibular disorder, burning mouth syndrome, and myofascial pain that include the orofacial pain symptoms, intervention, control, outcome variables, and main finding. These are the table, the research study for the cognitive behavior therapy for the temporomandibular disease and burning mouth syndrome and myofascial pain. The summary of that table that the Turner and colleague demonstrate that maladaptive coping, pain catastrophizing, and an ineffective coping strategy contribute to persistent and amplification of pain in temporomandibular disease patient. CBT that help in the cognitive and behavioral component, they're improving the pain perception and functional outcome and show both short-term and long-term improvement in pain severity and pain-related interference compared to the standard care. And that finding is consistent with the earlier work done by the Dworkin et al. McDillett and Patil et al. Research demonstrate that cognitive behavior therapy with standard therapy that reduce the anxiety and stress and improve therapeutic efficacy. In patients with myofascial pain, Bogart et al. Study suggested that cognitive behavior therapy shown to reduce muscle tension and improving pain coping skill. Gutschel et al. Reported that CBT-based intervention that focus on the stress management and relaxation technique that result in reduction in pain frequency and duration compared to the occlusal appliance if that given alone. Burning and the study by the Hitoshi et al. and Komiyama et al. For the burning mouth syndrome that demonstrate that CBT significantly reduced the burning sensation intensity and psychological distress in the burning mouth syndrome patient. So that this review indicated that cognitive behavior therapy is effective adjunctive treatment for the chronic orofacial pain. So I concluded this study with a comprehensive review that cognitive behavior therapy is a non-invasive, safe, and evidence-based modality for the chronic orofacial pain, and that reduce the pain intensity, frequency, and duration while improving psychosocial well-being and coping skill in chronic orofacial pain patients. So integration of the CBT in routine orofacial pain and promote the holistic care for the patients. And references for the review, and thank you so much.
Yeah, now I want you to take one glass of water and drink that glass full for me at least. Okay. Thank you so much,
Thank you,
dear.
ma'am.
For your resilience, you get half a mark more from me. For your persistence, you get half a mark more from me. And same would be with Dr. Aparna, and Dr. Selva Kumar would also say the same about you. This
Thank you,
says a
ma'am.
lot about you, doctor, and you will go a long, long, long way. I'm sure of that.
Thank you so much, ma'am.
Really, you really presented well. You didn't fumble. After so many trials, you did a great job.
Absolutely.
Very good.
Yes, ma'am. That's actually my first presentation on Zoom and first paper presentation. That's
Congratulations on the same.
Thank
Okay,
you,
and
ma'am. Thank you.
Your perseverance is to be applauded.
Yes, seriously. I mean, I'm very happy, Dr. Rutvi, and I'm glad that your presentation worked because this is my favorite topic, very close to my heart.
Yes, ma'am.
And Dr. Aparna and Dr. Selva Kumar, do you have questions for?
No, madam. No.
No, doctor. No.
Dr. Aparna?
No.
Okay. Dr. Rutvi and others, all the presenters today. Dr. Selva Kumar, any word
Yeah,
of?
just for the benefit of the students who have attended. I was really proud to see I'm almost 30 years of experience in my clinical practice, but I learned orofacial pain only four years back during the COVID time. See, you would have chosen dentistry by chance when you didn't get the choice of choosing medicine. This is the one field which is going to be the future. And this is the branch of dentistry which correlates with the medical practitioners. But the thing is, you have to learn a lot in orofacial pain, and all three categories are there: orofacial pain, TM joint, as well as sleep. You confine yourself to one topic and you can venture into that. There is a lot of things to be explored in this. This 3 days seminar, lot of things have been covered. If you have not watched it completely, go back to YouTube and watch these videos completely. You have voluminous informations available, which we didn't get it previously. You people are lucky with so much little amount of money for registration, and you get so much of knowledge. So I only request is, when somebody were doing some TMD treatment or diagnosing the case, stand by side and watch what they are doing when your mentor or guide. This is my humble request. So this value of, because it's a learning is a continuous process. You don't mean that we learned everything. We have to unlearn and learn, relearn. So this is what I want to tell the students, and there are plenty of scope, especially in the sleep. Also, I want to tell you, now the dentists were allowed to do polysonography interpretation. If you do polysonography interpretation, you will be paid 2,500 to 3,000 rupees per study, which will take 30 to 40 minutes. If you sit in front of the computer for 3 hours, 4 hours, if you can just interpret PSG, you will earn around 30,000 rupees per day, which none of the dental procedures will fetch you without any hard work. So but you have to read again. So there are plenty of scope for sleep medicine. Utilize the choices. And she told post-COVID era. I don't know why she used that word post-COVID era, but post-COVID, lot of sleep-related problems we are seeing. So this is my humble opinion. With 30 years of experience in clinical practice, this has increased my clinical practice by 3 times more what it was previously. So venture into this dentistry. Don't say dentistry it's growing like anything. So just this branch is, it's the future. Thank you, ma'am. And all these presenters, even the third year student was pitted against a PhD student, and all of them have presented well. Even I didn't do the proper presentation today, but due to my commitments, but these presentations were excellent. Follow whatever the organizers' protocols are there. That is the only request to be done. You people finished on time. This is awesome. I didn't see like this most of the time. Thank you.
Yes, yes. Dr. Aparna?
Same here, Doctor. Students have really done a commendable job. They were well within the time and the perseverance and the hard work behind this. First of all, they should have the real guts to take up such high funder topics, because that itself is really appreciable. And hearty congratulations to all the participants. And you are amazing. That's all.
Yes, truly said that. And actually, when we started this whole concept of organizing a conference for orofacial pain study, the concept was to standardize we should have a standardization of care for TMD practice or orofacial pain practice. And it is what Dr. Selva Kumar said. We walked through this journey very late into our career, but then you guys are you are fortunate enough to be handholding we will be there to handheld you guys, and you have the resources so that you can progress much more than what we have already achieved. So thank you so much, students, for giving us one more lesson in life, that we have yet to learn so many things. This conference was for the students, this conference was for the participants. Speakers are nothing. I always say all the speakers are nothing. It's only because of the participants that speakers are speakers. Mentors are mentors because of the mentees. Yes. So thank you so much. And with that, I think we have come to a conclusion of third day of our International Orofacial Pain Congress Season 3, 2025. And we were not sure how this Congress is going to go this year, because we were already delayed a lot. And on that note, I would like to conclude this whole Congress. I would like to thank the speakers, participants, and most importantly, the technical team who has worked dedicatedly. I am a taskmaster. If anybody knows what kind of a taskmaster I am, my husband has the first life experience with me, because I want certain things to be in precision. I cannot tolerate. I have in that OCD that I want things to be in that particular manner, and I have been behind the team religiously, relentlessly, and they have followed my instructions. And hats off to the technical team to sit with me for all these 3 days and flawlessly arranging this program. There was not even a single technical glitch. That says it all. Dr. Nurul, thank you for arranging this platform, National Health Academy and MedSkills. Thank you for providing this platform. Dr. Nurul has approached everybody on emails, and he is the mastermind behind the whole concepts of this Congress. I'm just the mediator, I would say, a nimitta to collect everybody in one forum and present to you all. Participants, thank you. I cannot thank you enough for the active participations. Thank you so much. And organizing team, is there somebody from the organizing team here? Can somebody take over? Dr.
No, Dr. Yeah, Dr. Sonal, I'm
Yeah.
just, joining from, outplace actually. So it's a very wonderful, and I was in and out actually, and I'm seeing that, the last time that the third year of final year students of, the dental surgery, they are giving such a, wonderful presentation and such a, with high confidence and all. So it gives confidence to us that yes, we are on the right track, and we are moving on this right direction actually, and we are able to make people aware. We entered into the actually dental schools actually when third or fourth year students are coming and presenting a topic related to orofacial pain. So I think we have almost sensitized the dental surgeons across India and across globe that how much important this whole segment would be. And just Dr. Selva Kumar is saying that this is the connecting bridge between medicine and dentistry. So it's a and Dr. T is saying it's an ocean actually. So we just do the tip of the ice actually. There are a lot many things we're supposed to do, and we'll do many more things in coming days. So with this note, I just would like to announce that for all participants, they would be getting their certificates in a 2 or 3 days. They would be getting the certificates on the portal only. They're supposed to just log in their email ID and they will get the certificate and they can download from there. So it's a great day, all 3 days, and hats off to Dr. Sonal for tirelessly a marathon. She is there actually, and she's anchored the ship, and she is steering it tirelessly and very in a precision actually. And she's also not lenient in terms of discipline and all. And be it anybody in our organization, she is after anybody to making the thing on time, and there is no any procrastination in her actually assignment or job actually. So it's motivating actually that a team member is disciplined and punctual and giving dedication, and also it motivates the whole team as well. So thanks, Dr. Sonal, for giving your time, your energy, everything. It's IOPCON is your baby actually. So it's how you are nurturing. It's up to you.
Thank you so much, Dr. Nurul. And with that, nevertheless, Dr. Aparna and Dr. Selva Kumar, actually, Dr. Aparna is sitting here since morning. She was there since yesterday also. Dr. Selva Kumar has not slept yesterday because he was actually in India, but he's jet lagged, I would say, thanks to Indigo. And he was trying to call me day before yesterday, saying that I hope I get my 12 midnight flight, I can reach Chennai. But unfortunately he reached at 12 noon, so that was a 12-hour delay flight. So I can understand what he's gone through, but it takes hard to sit here for students. And ultimately we say the same thing, it's all for the participants. And I hope you all have enjoyed this session. And the upcoming sessions are in February, that is for the Congress, the International Cancer Congress, that will be there in February and all. So please subscribe to National Health Academy. You will get the details of the next conference that they plan to hold. And on that note, and thank you to the team. Thank you for bearing with me. And if at all anybody is offended, that was never the intention. But things do happen when it comes to organizing something like this. So a heartfelt apologies on my side if I have crossed my limits anywhere. Thank you so much. And on that note, I will finally conclude International Orofacial Pain Congress Season 3, 2025, and we wait for the upcoming seasons. Good night. Take care.
Thank you, Dr.
We are
Sonal.
signing off.
Thank you,
Bye.
sir.